Hi guys, good morning. Good morning, good morning. I hope you're able to hear me. Good morning, guys. Okay, so this is dedicatedly a session that is designed for the FMG aspirants who are going to give the exam on 12th of Jan. It is going to be a super fast express. We'll try to cover as many points as possible and give you a wholesome point of it. Hi, Dr. Mukesh. Good morning. Okay. Hi, Abhi. Hi, Komal. Good morning, guys. Good morning, good morning, good morning. So, before wasting any further time, let's kickstart this session. Okay? So, pura session, it will be in a rapid revision format. I will give you all the important points. I'll mention you what were our previous exam questions and everything in a continuous trend. Good morning, guys. Good morning, Harsh. Good morning, Santosh. Good morning, Anish. Banu, good morning. Hi, good morning, Maz. Right, so let's kickstart this session. If you have any questions, any queries, feel free to ask in between. अगर समझ में नहीं आ रहा है तो बोलना है कि सर नहीं आया है तो I'll repeat it again, but we'll make sure we stick to the plan. ठीक है, चलो. So we'll be talking about the first topic. It will go into drains. We'll try to give you a basic objective. First is identify the drains and all that, and then based upon these are your image-based questions, right? So the first drain that you can see here, everybody knows it. The first drain that you can see here, it is what we call it as the corrugated drain. It is an example of a corrugated drain. Now, whenever they ask you, a corrugated drain will be something like this, which is left open. There is nothing which is going to get connected. It will be an open drain. Now, you need to understand if it is orange in color, it is made up of rubber. That is going to be, the material is going to be latex. It is going to be latex. Then you see a tube-like structure. There is no holes, nothing. It's a single tube. There is no connection, no bag. It was earlier used in abdominal surgeries. This is what we call it as, I hope everybody knows it. This is what we call it as the Penrose drain. ठीक है, अगर आपको ड्रेन खुला नजर आ रहा है, ऑरेंज कलर का है, कोई बैग लटका नहीं है, इट इज गोइंग टू बी अ corrugated drain. If you see a tube like drain जिसमें कोई holes, कोई fenestrations नहीं है, there is no attachment, nothing, it will be called as your Penrose drain. The Penrose drain is also made up of material that is rubber, so it is also a latex drain. Then you see ये pleats हैं, ठीक है. This is how a corrugated drain looks like, ठीक है. लेकिन अगर ये ट्रांसपेरेंट कलर में है, इफ इट इज लाइक दिस, इट इज अ सिलिकॉन बेस्ड corrugated drain. क्योंकि आजकल वी विल यूज बायोलॉजिकली इनर्ट मटेरियल. सिलिकॉन इज मोर बायोलॉजिकली इनर्ट व्हेन कंपेयर्ड टू रबर. रबर इज नॉट प्रेफर्ड बिकॉज इट causes more amount of inflammation and hence more foreign body sensation. Silicon on the other hand is biologically inert, so hence it causes lesser bioreaction, lesser inflammation and better tolerance from the patient. So कहीं पे भी हम drains use करेंगे, we will use only the silicon drains because they hold you well. Now this is what we call it as a corrugated drain. This is also an example of a corrugated drain, but this is silicon in nature. Now it is a silicon drain. Now why silicon is important? Because silicon is considered to be biological or biologically inert. So it has got lesser tissue reaction. It has got a lesser tissue reaction, as simple as that. Now this is पे चार चांद, पांच सितारे जो लगाने लगा लो. This is your repeat exam question. If they want to ask you one question in drains, this is what they'll ask you. And this is what we call it as a Romovac. This is what we call it as a Romovac negative suction drain. A Romovac negative suction drain. This is what we call it as the Romovac drain. Now this, I hope everybody knows it. Okay. Now this everybody knows it. It is what we call it as the Foley's catheter. This is what we call it as the Foley's catheter. Right. Now when you look at the Foley's catheter, now in your exams, if they want to ask you, they can ask you precise things. Okay. So this is the balloon inflating channel. From this is where we are going to inflate the balloon. This is the urine collection channel. We call it as the urine channel. Now this is somewhere you will see there's an opening. This is the eye of the Foley's catheter, from where the urine will pour in. And if you observe carefully, you will see there's a slighter color. This is where the balloon will be present. So this is going to be the balloon of the Foley's catheter. This is going to be the balloon of the Foley's catheter. Okay? Now, if they want to make your exam difficult, अगर exam में लग रहा है कि एक आधा bouncer डाल दे तो क्या दे देंगे? They'll ask you the color code of the Foley's catheter and the size. Remember, एक mnemonic है, that is गोरी. गोरी is very beautiful. बस ठीक है. I know all गोरियाज are not beautiful, लेकिन they tend to think they are beautiful. तो हम भी mnemonic ऐसे ही रखेंगे, कोई टेंशन है ही नहीं. ठीक है, imagine करो कि गोरी beautiful है. G stands for green colored Foley's catheter. The green Foley's catheter is going to be 14 French. The green Foley's catheter, it is going to be 14 French. Acha. Now there's a very important context that what is this French? Any idea? A quick feedback. What does French means? What does French means? Quick feedback. French. What does it French means? Now French basically means if you take this as the Foley's catheter's diameter. So this is the thickness of the tube that you will have, and there's a lumen which is present inside. Now this is what we call it as the inner diameter, and this is what we call it as the outer diameter. Now it is the outer diameter. This is the outer diameter of the Foley's catheter, which is defined as French. So bigger the number, much larger. Bigger the number, much larger is going to be size of the Foley's catheter. So you have the green Foley's catheter, O stands for orange, R is your red, Y happens to be your yellow, V stands for violet, and B, violet or purple you can say, and B stands for blue, right? So this is going to be 16 French. So as you continue to increase, it will become your 18 French. This will be your 20 French. This is your 22 French. And this is your 24 French, right? So as the number increases, the size of the catheter, or I can say the Foley's lumen, will also increase, right? So we looked up four important images that you have: the corrugated rubber drain, the Penrose drain, the silicon corrugated drain, the Romovac, the major drain that we are going to use, and this is your Foley's catheter. The other ones that you can see here, this is what we call it as the T-tube. This is what we call it as the T-tube drain. Now T-tube, because it is transparent, I can say this is made up of silicon. So this is your silicon drain. This is your silicon drain, right? Now remember, whenever they ask you, the only question that they ask you is, what is the T-tube removal period? Let's say you have put a T-tube for a CBD exploration. After how many days would you like to remove the T-tube? Remember, a minimum, it has to be removed. So T-tube removal. T-tube removal has to be done after 10 to 14 days. You want the tract to mature, right? So T-tube is used whenever you're doing a CBD exploration. So whenever there's a CBD exploration or a CBD injury and you're managing it, T-tube is usually placed in that particular status. As simple as that, correct? 16 or 18 catheter, what is the size means? It tells you the outer diameter, no? So French, I don't want to convert it into millimeters, but in just to give you an objective, a 14 French, when you measure the outer diameter, it will be approximately 4.7 millimeters. This will be approximately 4.7 millimeters. That means almost like a 5 millimeter, that is half a centimeter, right? So as it becomes bigger and bigger, for example, when you look at the blue, it is going to be approximately 8 millimeters in diameter. So the outer diameter, so we're giving you just an objective. I don't want you to remember these numbers. These are not important. Somebody asked me a question. So just to give you a clarity, कि जैसे जैसे number increase होगा वैसे वैसे outer diameter बढ़ेगा. That means the catheter size will become bigger. As simple as that. ठीक है? चलो. Now, this could be another bouncer if they want to ask you. I hope everybody will be able to easily duck it. This is what we call it as a 3-ways Foley's catheter. This is what we call it as a 3-ways Foley's catheter. Now, what is this 3-ways Foley's catheter is? You can see there are 3 components which are present. Okay? Now, what are the 3 components that you can look here? This is your balloon inflating channel. So the first one is your balloon channel. The biggest of all, this is the largest diameter. So this is your urine channel. And the last one that is present here, this is your irrigating channel. So the 3-ways Foley's catheter will be used whenever you would want to perform a bladder irrigation. Whenever you would want to perform a bladder irrigation, we'll be using a 3-ways Foley's catheter, as simple as that. So bladder irrigation is done whenever there's a bladder injury, bladder tumor, you have excised it. If you have done a TURP, that is for prostate BPH, all these you will be using bladder irrigation with 3-ways Foley's catheter. No points for guessing. I hope everybody knows it. What you're looking at, this is your pigtail catheter. The pigtail catheter will have a nice curvature. It will curve at the tip end. There'll be stillet inside. If you keep it, you draw it, it is going to coil. Now, because rather than saying curve, it is going to coil at the end. This is going to coil at the end. There will be presence of these holes which are called as fenestration. Any tube with hole would be called as fenestration. As simple as that, right? This is a pigtail catheter. This again is your exam question. Fir 4 chand ya fir 5 sitare, whatever you want, you keep it. But this is going to be our exam question. So what is this? This is what we call it as the nasogastric tube. This is what we call it as the nasogastric tube. Now this nasogastric tube is also commonly referred to as the Ryle's tube. Now the Ryle's tube is basically done, or it is performed to create a gastric aspiration or to feed via the tube, and that is going to be a Ryle's tube. Now the question that they ask you is, how do you measure the adequate length of the Ryle's tube to be inserted in the body? So how do you measure the adequate length of nasogastric tube to be pushed inside the body, or to be pushed into the let's say, okay, ideally how much you are going to push it into the body itself, or it is going to go into the lumen. Now there's something called as a next rule. Okay, we'll follow the next rule to measure the adequate length required. So let's say this is the patient. This is the neck of the patient. This is the thorax, and from here you have the abdomen, just for the sake of understanding, right? This is going to be the sternum. This is the xiphisternum. This is the diaphragm that is attaching, right? Now, according to the next rule, let's say if this is how the patient is depicted, you will take the tip of the nose to the ear, that is pinna, and from there to the xiphisternum. So nose to ear, ear to the xiphisternum. I'll take the tube, I'll measure from nose to ear pinna, from ear pinna to xiphisternum. Whatever length comes, that is the amount of length I'm going to insert, and this is what we call it as the next rule. So I'm going to insert the tube which will measure in accordance to the next rule and push that much amount of nasogastric tube into the stomach. As simple as that. Okay? Yeah. Tip of the nose to the ear pinna, from the ear pinna to the xiphisternum, right? So this is how you're going to measure it. Now another one, if they want to make your life a bit difficult, they will give you this one. What is this image? You can see there are 2 balloons which are present, right? Now the bigger balloon or a longer balloon is what we call it as the esophageal balloon. This will be called as an esophageal balloon. This is what we call it as the gastric balloon. The 2 balloons which are present, the 3 lumens that are present. So one is going to be your esophageal channel. We call it as the esophageal channel. One of this is going to be the esophageal channel, which you can see here. Another one is the gastric channel, which will be more distally attached because it is a distal tube. And this is going to be your suction channel. So whatever you want to aspirate, irrigate, you can give it to your suction channel, right? Now, somebody's given me correct. Shubham Ghai, you're absolutely spot on, beta. What is this catheter? This is your Sangaskin-Blakemore tube. This is your Sangaskin-Blakemore tube. Now, this Sangaskin-Blakemore tube is used for bleeding esophageal varices. Now, to control the bleeding from the bleeding esophageal varices, you can use Sangaskin-Blakemore tube. Remember, in this, as I told you, the two balloons, the esophageal. So, what does it cause? It causes a tamponade effect. Now, what is a tamponade effect? Do not worry about, listening to all these big words. Tamponade effect is to create pressure. Now, when you look at the Sangaskin-Blakemore tube, the concept is quite simple. If this is the esophagus and this happens to be stomach, right? And we know there are these bleeding esophageal varices which are present, usually present in the lower esophagus and the fundus of the stomach. I want these bleeders to stop. I want these bleeders to get controlled. So what am I going to do? I'm going to insert this Sangaskin-Blakemore tube. This Sangaskin-Blakemore tube will go inside. And there are two balloons. One is an esophageal balloon, another is gastric balloon. I will inflate the esophageal balloon. As I inflate the esophageal balloon, it is going to cause a lateral compression and the bleeding will stop. Then I will inflate the gastric balloon. As the gastric balloon inflates, it is going to exert pressure onto the lateral walls and it is going to stop the bleeding. So the Sangaskin-Blakemore tube is only going to cause a lateral pressure onto the wall. On exerting that lateral pressure onto the wall, the bleeding stops. As simple as that. Now the question that they will be interested in, that how much amount of air will you push in each of them. Remember, for esophageal balloon, I will inflate it to 40 millimeters of mercury pressure. And in gastric balloon, I will inflate with 300 ml. In both, I will only push air. Now, all the intelligent people who are thinking कि सर एक काम करते ना सलाइन से भर देते हैं क्योंकि वेट ज़्यादा होगा तो प्रेशर ज़्यादा होगा. अरे इतना सोचो, वेट ज़्यादा होगा तो वेट की वजह से बलून नीचे खिसक जाएगा ना. It will go down. If the weight is more, the balloon is going to slide down. If it slides down, it will not exert pressure where it is required. So what is going to happen? The desired pressure effect will not create. If it is not going to create, patient will continue to bleed. On the other hand, when you inflate it with air, because of the air, the balloon rises up. It exerts pressure onto the lateral wall. I am precisely exerting the pressure where it is required. Hence, air is the choice to inflate these balloons. Is that clear? Okay. So concepts, you cannot screw it up. You cannot mess it up. If you understand it, you will never go wrong. As simple as that. Okay. Okay. This, again, Sangaskin-Blakemore tube, I'll give 2 stars. It is more, it is asked in your INI as well as NEET PG. Apne exam mein pucha nahi hai, but very potential exam. This is again your repeat NEET PG question which has been asked. It has been asked in your INI also. In fact, FMG exam ko chhod ke baki 2 exams mein multiple pucha hua hai. Right? Now, thoda dhyan se dekho. There is a balloon, there is a tubing, there is this fenestration which are present. A balloon, a tubing, and a fenestration that is present. Now, this is what we call it as the Jackson-Pratt drain. This is what we call it as the Jackson-Pratt drain. Now, Jackson-Pratt drain is also a negative suction drain. It is also going to be a negative suction drain. As simple as that, right? Absolutely correct, Shubham, Harsh, Mangal, everybody got spot on. This is your Jackson-Pratt drain. Clear? Okay. So these are all the drains that you should know for your exams. If they want to make your life difficult, they can add one small concept. 2 minute बता देते हैं कि drains कैसे classify करते हैं. In terms of drains, I will classify drains into 2 categories. What are those 2 categories of drain? Either I can call them as an open drain or a closed system drain. The closed system drain is further classified based upon how it is going to be draining it, whether it will exert a negative pressure, which is called as an active drain, or whether it will only drain because of the capillary gradient, that is your passive drain. Here it is going to be because of gravity. What is the difference between an open and a closed drain system? Is an open drain, there is nothing which is going to collect. There is no bag, nothing, it just drains out, right? So what are the examples of the open drain that we just learned? The first and the best example is going to be your corrugated drain, right? Your corrugated drain is an example of an open drain. Another example of an open drain, it is going to be your Penrose drain. It is going to be a Penrose drain. Active drainage, which is going to exert negative pressure for suctioning it. So we know the best example that I can give you is going to be your Romo-Vac drain. Another one is going to be your Jackson-Pratt drain. Right. So Romo-Vac and Jackson-Pratt are the examples of the active drain. Passive drains, you can name them as N. For example, all, when talk about passive drains, you can talk about your Foley's drainage, your in terms of nasogastric tube drainage, in terms of your abdominal drains, in terms of the abdominal drain, your ICD bags or ICD, that intercostal drains, ICD drainage, right? Foley's catheter, nasogastric tube, abdominal drains, your ICD drains. For that matter, anything the T-tube drain, all these will be considered as a closed system but passive drainage. Okay? So exam में बस maximum आपको ये याद नहीं रखना है. Passive drainage, you don't need to remember. You have to remember which of them is open, which of them is an active drainage. दो examples है. Open is corrugated Penrose, active is Romo-Vac and Jackson-Pratt. That's all that you should know. Clear है? Sorted? ठीक है? So far, any doubts? Quick feedback. Quick feedback. Guys, you need to be active on the chat box. It is going to be a dialect. It is not a one-way street. You give, I give. You want more, I provide more. Okay? So be active on the chat box. So, moving down, we're talking about the size. Now again, ये आपका 4 चांद 5 सितारे वाला example है. Repeatedly asked in your exam. Okay? So you have the color codes and everything. So for cannula, we basically follow up very small mnemonic to understand the color codes and the flow rate. So the core of the earth is made up of lava. Lava is orange in color. Okay? On top of the lava, you have the soil. The soil is gray in color. On top of this soil, you have this green trees which are going to grow. On top of these green trees, you have this beautiful pink flowers which are there. Right? On top of this pink flower, what do you have? You have Nila Nila Asman. So that is your blue sky which is present here. Right? Or is blue sky mein like you ever shining? There is the sun. Okay? So this is the sun which is present in the sky. अब नीले आसमान के आगे क्या है? नीले आसमान के आगे you have the universe. Universe थोड़ा dark होता है. तो I'll give you the purple or the violet color. ठीक है? Right? Yes. So this is how you remember it. Orange color. It is going to be, you start from here and then you move across here. This is a 14 gauge needle. Gray is 16 gauge needle. Green is 18 gauge needle. Pink flower is 20 gauge. Nila Nila Asman is 22 gauge. Sun remains 24 gauge. And this is your 26 gauge. If you don't feel it is looking like a universe, just for your own sake, I'm going to put some stars so that you have the feel of this entire mnemonic that we have created. And this is how you remember the size and the color code. Okay? So you have 14 gauge orange, 16 is gray, 18 is green, 20 is pink, 22 is blue, 24 is going to be sun, and 26 is going to be your purple or the violet one. Now when it comes down to here, this is how these cannulas will look like. We know the orange colored cannula is how much? It is a 14 gauge needle. How much will be the flow rate? It is going to be 240 ml per minute. Then you have gray colored cannula, which is going to be 16 gauge at a flow rate of 180 ml per minute. Remember, gray cannula is the most common, or I can say it is the preferred one in trauma. Preferred size of cannula in trauma resuscitation is going to be gray. Now then you have the green one. Green is 18 gauge. This is the minimum. This is the minimum size of cannula that you have to put in trauma resuscitation. If you're not able to get this green cannula, then you have to do a weenie section, or you have to go ahead. Yes, right. You do a weenie section or you go intraosseous needle insertion. So green is going to be 18 gauge at a flow rate of 90 ml per minute. Then you have the pink cannula, which is a 20 gauge, which is at 65 ml per minute. The 60 to 65. Then you have blue cannula, which is a 22 gauge, which is at 30 ml per minute. Then you have 24 gauge, which is a yellow cannula, which is at a 20 ml per minute. The last one is blue or the violet one, which is a 26 gauge at a flow rate of 12 ml per minute. Right. So size of the cannula and their flow rates are important. I've given you in an entire context. The easy way to remember is इतना याद रख लेना 240 है, सारे मल्टीपल्स ऑफ 12 की तरह ही नजर आएंगे, 6 की तरह ना. सो 240 हो गया, 180 का आधा 90, इसमें से अगेन 30 कम कर दिया 60, अगेन 30 कम कर दिया, इट इज गोइंग टू बी 30, देन फ्रॉम देयर 10 10 20 10 के हिसाब से. ठीक है. द इजीएस्ट वन टू रिमेंबर फ्रॉम आवर एग्जाम पर्सपेक्टिव as a carry home message is going to be your green cannula. It is going to be the green cannula that you have to remember. Remember this one for our exam purpose. It will be more than enough. ठीक है. तो green याद रख लेना, flow rate automatically ऊपर नीचे याद रहेगा, but this is the carry home message that you have to take across. ठीक है. Now again image based questions which are going to be from your minimal invasive surgery. बस इतना याद रख लेना, इसको identify कैसे करना है. Nothing more is important than this. You will see the first one. If you have a hollow structure, this hollow structure is what we call it as port, and this metallic, it's like a tubing which is present. It's like a metallic rod. This is what we call it as the trocar. Right. If it is a bigger in size, it is going to be a 10 millimeter port. A smaller one is what we call as a 5 millimeter port. This is a 5 millimeter trocar, and this will be a 5 millimeter. Sorry, this above is a 10 millimeter trocar, and each wala is a 5 millimeter trocar. Okay. So this is how you're going to identify the various components, whether it is a port or a trocar. That is the first thing that you should know. Then this is what we call it as the lens. The question that they can ask you with respect to lens is, what is the angle that you would use? Remember the angle that we use for the lens. It is going to be a wide viewing angle. This is going to be at 30 degrees, right? So we'll be using a 30 degrees lens. So you see, this is the angle that it creates with the lens one. So 30 degree lens is used because it creates a wide viewing angle, right? बेटा अजीमत एंगल ये नहीं होता है, मैं आपको समझा दूंगा अजीमत एंगल क्या होता है. Okay, we'll take another slide for it. But if I've asked you, see, azimuth angle was asked this year NEET PG exam, that is sorry INI-CET. Now what is this is, when you look at the port placement, this is the abdomen of the patient. Okay. Now from the abdomen we will put 3 different ports. One, you will put a camera port. The camera port is what we call it as optical axis. This is what we call it as an optical axis. This is where you put your camera. Now along with the optical axis, if I have to put working instruments, so this is, let's say, working instrument number 1, and this is the working instrument number 2, right? Now there are different angles which are present. Whatever angle any instrument that creates with the body, this is what we call it as the elevating angle. The angle between a working port and an optical, this is what we call it as an azimuth angle. And the angle between the 2 working ports, is what we call it as the manipulating angle. There are 3 angles that are present that we should know, right? So the first angle that you can see, this is what we call it as the elevating angle. This is what we call it as the elevating angle. This is what we call it as the azimuth angle, and this is what we call it as the manipulating angle. This is what we call it as the manipulating angle, right? So the angle from where it is going to be lifted up, it is what we call as elevating angle. Between the working port and the optical axis is what we call it as an azimuth angle. Between two working ports is what we call it as manipulating angle. Yes, the ideal angle of all these must be at 60 degrees. So you see the elevating angle is at 60 degrees. Azimuth will be 30 degrees. Manipulating angle will be 60 degrees. Now again, this is also azimuth only, no? So two azimuths which are going to be 30 degrees, together they form 60. So ideally all the angles must be at 60 degrees so that you have an adequate freedom of movement. Clear? Okay. So this is with respect to the lens. Now this is what we call it as an atraumatic port. This is what we call it as a Hansen's port. This is what we call it as a Hansen's port. Remember, Hansen's port is an atraumatic port. Hansen's port is an atraumatic port placement, right? Or atraumatic trocar that you have. Rather than saying port, it has an atraumatic trocar. So when I say an atraumatic trocar, you can see here, this is the blunt end that you have. This is having a blunt trocar. If you go down to our previous one, you can see these trocars are sharp, right? There's the sharp trocars, but when you come down to our Hansen's port, it has got a blunt trocar. Now a blunt trocar is going to have a very, it's a safety procedure. When you try to insert it in, it does not cause any injury per se. Now again, ये अपना 4 चांद 5 सितारा वाला है. So this is again your exam question. This is what we call it as the great Veress needle. This is what we call it as the Veress needle. Now this is going to help create, pneumoperitoneum. It is going to help you create the pneumoperitoneum. Now if they ask you what is the most common gas used to create pneumoperitoneum? What is the most common gas used to create pneumoperitoneum? Quick feedback. What is the most common gas used to create pneumoperitoneum? It is going to be carbon dioxide, right? Now, what should be the intra-abdominal pressure during the laparoscopic surgeries? Remember, it should be 12 to 15 millimeters of mercury. What is the initial flow rate in order to create a pneumoperitoneum? It is 1 to 4 liters per minute. What is the maximum flow rate? If you want to insufflate it at a rapid pace, the maximum flow rate that you can have is a 20 liter per minute. It is going to be a 20 liter per minute. Okay? Chalo. So all these are your exam questions. If you remember this, that is more than easy. If they ask you what is the angle between the needle and the body while insertion. So while insertion, there are two angles that you should know. The angle between needle and skin. The angle between the needle and skin will remain 90 degrees only. But if they ask you what is the angle between needle and body, what is the angle between needle and body, then the answer will become 45 degrees. Okay? It is going to be 45 degrees. Guys, the PDF will be provided to you. I do not want you to emphasize on writing right now. I want you to repeat, recite with me. ठीक है? मेरे साथ बोलना है, मेरे साथ देखना है, मेरे साथ analyze करना है. I will write. अगर मैं लिख रहा हूँ Veress needle, बोलो Veress needle. If you are saying it helps in creating pneumoperitoneum, it will have a visual impact. Yes, it helps in creating pneumoperitoneum. कौन सा गैस लगता है? कार्बन डाइऑक्साइड. कितना प्रेशर लगता है? 12 to 15 millimeters of mercury. कितना initial flow rate है? 1 to 4. Maximum flow rate कितना है? 20. Just keep repeating with me, and that is what you're supposed to do here. ठीक है? So nothing more than that. चलो. This is another important, I would say, the device, but not in terms of exam, but you will try to recognize it. It is called as the SILS. SILS का full form है Single Incision Laparoscopic Port Surgery. It is a single incision laparoscopic port surgery. Now, as you can see, there is only a single port. There's only one port that you can see, but there are 4 axes. So it has got 4 axes from a single port. So rather than putting 4 different holes, you can put only one hole and you can put all your instruments to that. But problem is it is very difficult to operate. There is no much maneuverability, and the cosmos is also not that great because you're giving a 2 centimeter incision just to put on it, right? Clear? Ambika, yes, the angle between the skin and the needle is different, and the skin and the body is different. Those who are not able to comprehend, how do we put a Veress needle is, let's say this is the abdomen. Let's say this is the abdomen. You want to insufflate it. For the sake of understanding, this is the foot end of the patient. This is the head of the patient. Now this is where you have, right? When you want to insert the needle, no, you don't directly go like this. So what I'm going to do is I'm going to pinch the abdominal wall and lift it up. Now, as I pinch the abdominal wall and I'm going to lift it up, the abdominal wall will be pinched, right? So I am holding with my hand and I am pulling the abdominal wall up. Now, as I pull the abdominal wall up, now my entry point for the Veress needle would be like this, right? This is how I'm going to put the Veress needle. Now, if you look at the angle, it is with the skin. What is the angle it is creating? With the skin, it is creating 90 degrees. Right? But when you look at the angle with what the body is going to have, this is the body axis. The body axis is going like this. This is the angle with the body. Right? So angle with the body is going to be 45 degrees. But angle with the skin would be your 90 degrees. आई बात समझ में? Clear है? ठीक है? Clear? Okay. So I hope you're sorted. So this concludes all the images that you should know in terms of drains as well as minimal access surgery. Okay? Now, moving further, if they want to make your life even a little bit more difficult, they'll ask you these components. Now, I've given you all 4 devices. Monopolar, you will have a single pole. Bipolar, you can have 2 poles that are present. This is harmonic, this is thunderbeat. How do you differentiate between harmonic and thunderbeat? देखो thunderbeat में आपको 2 buttons दिखेंगे. एक आपको सिर्फ seal का दिखेगा, एक cut and seal का दिखेगा. You have 2 buttons in the harmonic. One, it is only going to be seal. और जो दूसरा button है, it will have a combination of cut and seal. ठीक है? Harmonic में सिर्फ आपको component दिखता है. There are no buttons per se. Now, when you look at the components, how will you look at this? What is the principle on it works with? Remember, your monopolar works on the electrical energy. So there are 2 energy systems that you have. Either it has to be an electrical energy or a vibrating energy. Now, monopolar works only on the electrical, not on the vibrating. Bipolar also works on electrical, not on vibrating. Harmonic only works on vibrating energy. Thunderbeat works on both. So hence it is also commonly called as a combined energy source. This is what we call it as a combined energy source. Right? Now, yes, you have gotten it correct. So when you have the 2 buttons which are present on a monopolar cautery, the cautery buttons are important. You have 2 buttons. One is going to be yellow. Another one is going to be blue colored button. Yellow is to cut, blue is to coagulate. Yellow is to cut and blue is to coagulate. Okay? Now, they'll ask you, if you're talking about a vibrating energy, what is the frequency with which the harmonic scalpel is going to vibrate? It is going to be 20,000 to 50,000 hertz. It vibrates at a frequency of 20,000 to 50,000 hertz, right? Now, if they ask you what is the difference between the cut and the coagulating current, that is something that I can ask you, that when you look at a cut current, how do you differentiate between a cut current and a coagulating current? Now, in order to differentiate between the cut and the coagulating current, you can plot a graph between the voltage and the frequency. So we'll plot a graph between the voltage and the frequency. For a cut current, so you'll say y-axis is voltage, x is frequency, this is voltage, this is frequency. So in a cut current, you will see low voltage but very high frequency of current that is going to run, and it is going to cut through the tissue, right? In a coagulating current, you will see there is a high voltage, but it will have low frequency. There's an intermittent burst that you'll have. So it is going to be high voltage and low frequency. So cut current principle is quite simple. The cut current will have low voltage, but it is going to have high frequency. Whereas this is going to have, that is coagulating current is going to have high voltage, but it will have low frequency. It will have high voltage but low frequency. Okay? So this is with respect to all the energy devices that you should be knowing. As simple as that. Now let's come to the suturing rule. Now whenever you're going to suture, now this is quite important when we talk about from our exam perspective. This again is our char chand panch sitare wala jo concept hai. You need to get it quite simple and understand that when you talk about sutures, there are certain things which are going to be absolutely important. Number one is the suturing rule. What is the length of the suture material required to suture a wound? Remember the answer, it should be 4 times. It should be 4 times the length of the wound. That means if the wound is 10 centimeters, right? If the wound is 10 centimeters, you require a 40 centimeter thread to suture it. Now, what is the role of the depth of the wound? The depth, the X which I've written here, this determines the depth of the wound. What is the significance? The depth of the wound determines the entry and the exit of the needle, that is the distance from the edge. Needle का जो entry और exit है, needle का जो entry और exit है, exit edge से कितनी दूर है, that is determined by the depth. So depth of the wound, it determines entry and exit of needle from the edge of the wound. From the edge of the wound, so that it remains equidistant. What is the angle? This was your previous exam question. What is the angle between the needle and the skin? I just told you, no matter which needle you are putting, that is a Veress needle or normal needle or any needle, it has to be 90 degrees. It has to be 90 degrees and not less than that. Okay? What is the distance between the two sutures? How? Let's say you have put one suture here. Let's say you have put one suture, you have put here. Right? You have put another suture here. So what is the distance between these two sutures? It should be twice the depth of the wound. It is twice the depth of the wound. It is twice the depth of the wound. So whatever is the depth of the wound, twice that it is going to be, you're going to use it. Okay? Yes. What is the length of the suture ear? Remember, the length of the suture ear is going to be 1 to 2 millimeters. So when you look at after cutting the suture thread, now whatever is left behind, this is what we call it as suture ear, so that the knot remains stable, and tomorrow if you want to remove the knot or the thread, it should be easily holdable. Okay? Clear? So this is in terms of suturing rule. Okay? I hope everybody is pretty clear with this. Chalo. Now you have suturing techniques, quickly running through it. The first one, I hope everybody is able to recognize it. It is what we call it as a simple continuous running suture. It is a simple continuous running suture. The second one is, so this is the first one, this is the second one, this is the third one, this is the fourth one, and the last one is your fifth one. Okay? Now the second one is your simple interrupted sutures. It is your simple interrupted sutures. Now here you can see that 2 entry points and 2 exit points. So there are 2 points which are on one side, 2 on the other exit side as well, right? So this is what we call it as mattress suture. But every time we have a mattress suture, the confusion is whether it's a horizontal or a vertical mattress. All that you have to do is draw a line that goes through the wound, draw another line that goes through the suture line. If they're perpendicular to each other, this is what we call it as the vertical mattress. This is what we call it as a vertical mattress suture. On the other hand, this is the line of the wound and this is the line of the suture. If they run parallel to each other, if they run parallel to each other, this is what we call it as the horizontal mattress sutures. This is what we call it as horizontal mattress suture. And the last one is your subcuticular sutures. It is a subcuticular sutures. Right. Now remember, subcuticular sutures have the best cosmetic outcome. It has got the best cosmetic outcome, right? So these are how you identify each and independent your suturing techniques which are present. Clear? Somebody saying what? Kahan pada? Okay. But a suture material. Achha, whenever using a subcuticular sutures, it's a common sense you'll only be using absorbable suture materials. ठीक है, तो इसमें कोई बड़ा वो बात नहीं है. Every time you are going to use a subcuticular, we have to use absorbable suture material. You can use monocryl, you can use 𝐌𝐞𝐝, you can use let's say PDS. All these are there, right? Right. MCQ session is also there. There's a surprise session. We'll be doing your last 5 sessions of MCQs again on a rapid series. We'll announce soon. Okay? But today we'll focus on topics. All these are PYTs which we don't want to ignore. Okay? Now the knotting technique, again without wasting any further time, quickly. ये आपका first knotting technique है. This is the second one. This is the third one. This is the fourth one. What is your first knotting technique? This is what we call it as a half hitch. It's a single loop. Now this, when you look at it, this is what we call it as the granny's knot. This is what we call it as the granny's knot. This is what we call it as a reef knot. This is what we call it as a reef knot, or also called as a square knot. And the last one is what we call it as the surgeon's knot. Right? Now, obviously, the most confusing one is to differentiate between the grannies and the reef knot. Okay? So, how do you know? Look here. You see, this is the loop of a thread that is present, and you see one thread is going under the loop and one thread is going over the loop, right? If one thread goes under, one thread goes over, it is grannies. And when you come down here, look at the loop here. Either both the threads are going under, so they're traveling in the same direction. Either they're going under, or if you come here as a loop, you see both the threads are going over the loop. Either both of them going under or both of them are going over. They follow the same component. So this is going to be your reef knot, right? So if both goes up, both goes down, it is reef. If one goes up, one goes down, it is going to be your granny's knot. It is going to be granny. So granny एक ऊपर एक नीचे, reef में दोनों ऊपर दोनों नीचे, square में दोनों ऊपर दोनों नीचे. Surgeon's knot is going to have again 2 loops on bottom, 1 loop on top. It will also have the same finding, that will have the squaring phenomena that you will see. थोड़ा सा correction है यहाँ पे. So the surgeon's knot will also have the reef or a square knot at its end, and it will have 2 loops on bottom, 1 loop on top. Remember, surgeon's knot is the most stable knot. Surgeon's knot is the most stable knot. Right? Everything about surgeons is so stable, no? Level-headed. ठीक है? Clear? चलो, great. If they ask you reef knot or square knot, whether it's stable or unstable, remember reef knot is considered to be stable. Grannies is unstable. Grannies is going to be unstable. Half hitch is definitely unstable. Okay? So grannies are unstable. Your reef and the surgeon's knot are your stable. The most stable knot is your surgeon's knot. Now, when you look at the suture removal period, if you have put the suture on the face, when would you like to remove it? It is the most vascular area. I do not want any scars to happen. I will not leave it for longer period of time. So suture removal period of a face is going to be 3 to 5 days. The scalp and the arms, these are the 2 ones which I would like to remove it in 7 to 10 days. Now from trunk, If you look at trunk, the hands and the feet, all these three is going to be 10 to 14 days. So this will also be 10 to 14 days. And the last one, palms and sole, it is going to be 14 to 21 days. It's going to be 14 to 21 days. As simple as that. Okay? Okay? So suture removal period is again important. This has been a previous exam question. Okay? Now this is again char chand panch sitare wala topic. It is your pressure sores, bed sores or decubitus ulcer. Repeatedly asked. They have asked you n number of times. Now let's quickly go through and understand this. Okay? Now when you look at it, what is the criteria? Who are the patients who are going to develop pressure sores? Now those patients where you have the criteria is if there is a sustained pressure, if there is a sustained prolonged pressure over an area of the body, over an area of body, and this sustained pressure, if it is greater than capillary occlusive pressure, if it is greater than capillary occlusive pressure, this is what will result in your bed sore. Okay? So criteria is very simple. If the pressure exerted in a certain part of a body is more than that of a capillary occlusive pressure, that will cause decreased vascularity to that particular site, and that will cause hypoxia, ischemia, and then necrosis resulting in ulceration. तो सवाल ये है कि कितना कैपिलरी ओक्लूसिव प्रेशर होता है. कैपिलरी ओक्लूसिव प्रेशर is at 30 millimeters of mercury. If you exert more than that, the capillaries will get occluded, the blood supply to that area will get devoid of, hence the patient is going to develop into pressure sore or pressure ulcer. What is the risk factor? It is prolonged immobilization. It is prolonged immobilization. And on the other hand, I can say it is a bedridden status. Either a prolonged immobilization or a bedridden status can result. It is going to result in your pressure sores. What is the most common site? The most common site is going to be ischemia. Right? The most common site. The most common site for the development of pressure ulcer is going to be ischemia. Okay? Chalo. Now, when you look at this, you have the different grades and its management. So the grade 1, you can see there is presence of erythema, nothing else. So description is presence of non-blanching erythema. It is going to be a non-blanching erythema. Grade 2, you see some amount of skin is getting excoriated. So there is partial thickness skin loss. There is a partial thickness skin loss, that is grade 2. In grade 3, there is a full thickness skin loss. There is a full thickness skin loss. How do you know there is a full thickness skin loss? You will see subcutaneous fat is exposed. If the subcutaneous fat is exposed, this is what we call it as the grade 3 pressure ulcer. This is what we call it as a grade 3 pressure ulcer. The grade 4 is involvement of underlying structure. It is the involvement of underlying structure. Now this underlying structure could be a muscle, a vessel, a tendon, a nerve, anything, right? I can add another one which is called as US. US stands for unstageable. Now we consider unstageable if an ulcer is covered. If the ulcer is covered with slough or necrosis. Now because it is covered with slough as necrosis, alright guys, I think we're back on. Small technical glitch. Okay guys, give a thumbs up if you're there. Small technical glitch, it went off air. We are able to resume it back. All right. Okay. We think we're back on. We're back on. Okay. Can we start? Right. So as I was saying, grade 1, grade 2 pressure ulcers, it is a milder grade of pressure ulcers, so it is only going to be a conservative line of management. As is a conservative line of management, we'll start the patient on water or the air bed, give frequent change in position. Bedridden patient of every second hourly, wheelchair patient of every 10 minutes that you have to do. One important point before it went off air, it is to have skin care. So make sure the dependent areas are not moist, they are being dusted, cleaned on a daily basis. You put all the drying agents so that it does not have any problem thereafter. Now when it comes down to grade 3, grade 4, grade 5, these are high grade pressure ulcers including unstageable. So in this, what are you going to do? The first thing I'm going to do is to perform a cleaning and debridement. We'll do a cleaning and debridement of the ulcer. Now once you debride the ulcer, you will create a huge big wound which is present. In order to allow that wound to heal and does not, see, most of them is on the ischium and as well as the sacrum. It becomes very difficult for us to do dressings also. So in order to prevent that as well, you can go ahead with something called as 𝐻𝐿. 𝐻𝐿 is nothing but vacuum assisted closure. 𝐻𝐿 is nothing but vacuum assisted closure. Now the 𝐻𝐿 is an old term, we don't use it 𝐻𝐿 anymore. So the new term that we use, it is called as a negative pressure. It is a negative pressure wound closure system. So we use negative pressure wound closure. Remember the pressure exerted is minus 125 millimeters of mercury, and this is going to be an intermittent pressure. It is going to be an intermittent pressure. Okay. So again, this is a previous exam question. How much is the pressure in a 𝐻𝐿 system? It is minus 125 millimeters of mercury pressure. And the last point to be remembered, you will, after doing all this, still follow conservative protocol. Will still follow the conservative management protocol. Right. So we'll be talking about frequent change in position, daily dressings. If you've done 𝐻𝐿, you don't need it. Frequent change of position, air bed, water bed, skin care, all that will be taken into consideration without even a doubt. Okay. Clear? 1 second. Okay. Okay. Clear. Chalo. So this is with respect to this. Now, let's quickly go down to burns. Again, a very, very important topic from our exam point of view. So when you talk about the burns, we have the most common rule of assessment is what we call it as the Wallace rule, or also called as rule of 9. Now, according to Wallace rule, a quick component here. In the adults, the head and neck together. In adults, the head and neck together is going to account for 9%, right? The head and neck in total is going to account for 9%. The upper limb is going to account for 9%. When I say upper limb, it is all the way from the shoulder girdle to the tip of the finger. Then you have the anterior trunk, that is chest and thorax is 18. Posterior trunk, chest and thorax is going to be 18. Then you have the perineum, which is going to be 1%. The perineum is going to be 1%. The lower limb is all the way from the anterior superior iliac spine to the toes, and the lower limb is going to account for 18%. Altogether, it will be 100%, right? So head and neck is going to be 9%. Your upper limb is 9%. The perineum is 1%. Your anterior trunk is 18. The posterior trunk is 18. Your lower limb is going to be 18%, right? This is how, according to the Wallace rule, we know the patient is having what is the percentage of body surface area burned that is present. In children, there's a small change, the head and neck here. In children, the head and neck is going to account for 18%. The upper limb is going to account for 9%. The anterior trunk, posterior trunk is 18. There is no perineum. The only change that you have to remember is about the lower limb. Remember, the lower limb in children is going to be 14%. Now here is an interesting question. According to the ATLS, that is Advanced Trauma Life Support, what is adult, what is a child? It is not a regular definition. Adult is considered to be age above 14 years and child will be considered as age below 14 years, right? Age above 14, age below 14, that is your going to be, it is going to be your 14 years. Okay? Now, how do you know that what degree of burn? This again is going to be char chand panch sitare wala question. Again, very, very important from our exam perspective. Based upon the depth of the burn, you can, or the structures involved, you can assess the depth of the burn that is going to go across. Okay? So what is a first degree burn? A first degree burn is that burn where there is only involvement of the epidermis. If the epidermis of the skin is involved, it is first degree burn. What is a second degree superficial burn? There is an involvement of the epidermis. Along with epidermis, there will be involvement of papillary dermis. There is involvement of papillary dermis. Second degree deep is going to be involvement of the epidermis. Along with the epidermis, there is involvement of papillary dermis. Along with papillary dermis, it will also involve the reticularis dermis. Third degree is involvement of full thickness of the skin. Full thickness of the skin is burned, that is third degree. Fourth degree is involvement of underlying structures. If there is a burn that is involving an underlying structure, it will be called as a 4th degree burn. Underlying structure could be a muscle, a vessel, a tendon, a nerve, anything that is going to be your 4th degree burn. Now remember, the pain will only be there if the skin is present, and that too only to the level of papillary dermis. Reticularis dermis do not have the pain receptors. So when you talk about which of these burns are going to be painful, the first degree is extremely painful. The second degree superficial is also extremely painful. Secondary deep does not have any pain, but it has something called as pin prick sensation. That means if you touch, there will be no pain, but if you take a pin and sting it, the patient will have a pin prick sensation. There is no skin, no pain in 3rd and 4th degree burn. The blisters may or may not be there in the first degree. Second degree superficial will have blisters. Secondary deep may or may not have no skin, no blisters. So 3rd and 4th degree will not have blisters at all. The color here, it is going to be, there will be presence of erythema that you will see here. So the first degree will be having presence of erythema. The second degree superficial, it is going to be present to you as bright red. This is going to have a mottled pink or a pale waxy white. It is either going to be a mottled pink or a pale waxy white. Third degree, it is going to be like a leathery appearance. Fourth is like a burnt charcoal. It is going to be charred in appearance. If there is a skin, it will heal. This cannot heal without any intervention. There are no scars here, but rest of them will leave a scar. A scar is something that is going to be formed on top of a wound which is not going to heal. So a scar will be seen in the other 3 as well. Now this table summarizes the whole component. In our exam, they'll ask you a combination of this. If you have a burn which is having a pale waxy white, it is presented to you with blister, and then it will say that, there's no pain on touch. What is the depth of the burn, right? Yes, the 3rd degree and 4th degree will definitely heal with contracture, and that contractures are going to be a burn wound contracture. Shubham, you are absolutely correct, but not in this particular form of table that is included. Okay? Now, how do you calculate the burn fluid? We have 2 components. We have the ATLS and then you have the Parkland. Parkland is obsolete. We do not use Parkland anymore. It is only going to be ATLS. I've given you the entire component of ATLS. Remember, in ATLS, if it's a child, that is 2 ml, it is going to be a second degree burn. Rather than having this is for you to refer, I'll give you an easy version of this. If there is an adult, right? So rather than saying this, we'll start with the degree of burn. If there is a second degree or a 3rd degree burn, if it is an adult, then it is going to be 2 ml per kg per percentage of body surface area that is burnt. But if the same is a child, it is going to be 3 ml per kg per percentage of body surface area burnt. If it is a 4th degree burn or an electric burn, irrespective of adult or child, irrespective of adult or child, it will be 4 ml per kg per percentage of body surface area burnt. This is what you have to remember. That's it. If it is an adult, it is 2 ml per kg per percent of total body surface area burnt. If it is a child, it's 3 ml. If it is going to be an adult or a child, if it is an electric burn, it is or a 4th degree burn, it is going to be 4 ml per kg per body surface area burnt. Okay. The only thing that will concentrate in all electrical injury, what should be the urine output? It is 1 to 1.5 ml per kg per hour until the urine clears out. This is more important. I want the urine to be clear because electrical burns will cause myoglobinuria, which will cause acute tubular necrosis, causing a discolored urine. If the urine is clear, there is no acute tubular necrosis secondary to myoglobinuria, and that is a safe component that we have. Coming back to, if they ask you what is the fluid of choice in burns, again, repeat question, you don't need to think about it. The fluid of choice in a burn wound resuscitation, it is going to be ringer lactate, which is preferred over normal saline. It is a ringer lactate that is preferred over normal saline. Okay. Now, colloids, when it comes down to what is the most common colloid used in the burn resuscitation, the answer is HAS, that is your human albumin solution. That is going to be your human albumin solution. HAS stands for human albumin solution. What is the ideal time to administer the colloids? It is after 24 hours of the burn. How do you calculate the Muir and Barclay formula? It is 0.5 into weight in kilograms into percentage of total body surface area burnt into the percentage of the total body surface area burnt. Now the protocol for administration, whatever you have calculated, the protocol for administration, in the first 12 hours of administration, it has to be done every 4th hourly. In the second 12 hours of administration, it has to be done every 6th hourly. And from thereafter, if it is required, every 12th hourly. So for the first 12 hours, every 4th hourly you are going to administer. After the first 12 hours, the second 12 hours is every 6th hourly, and then after it is every 12th hourly. Why do we administer colloids in burns? We administer colloids in burns when the requirement of the fluid after 24 hours is still high. But I cannot give large volumes because it will cause hemodilution. Colloids will cause volume retention. So hence, if you give 1 ml of colloid, it is known to retain anywhere between 1.6 to 2.5 ml. That means 2.5 times of its initial value it can retain. So hence colloids are given. So after 24 hours, if the fluid requirement is still there, if the patient is not able to maintain the resuscitation on a maintenance protocol, then I would like to add colloids. Okay? And obviously colloids are also added because of excessive protein loss. There's a third space loss, endothelial injury, the proteins goes down. So hence, because of that, they will cause more edema. To compensate that loss of protein, you can also administer colloids. Okay? Chalo. In the burn wound management, this is important. Again, यही अपना इस topic में 4 चांद वाला है. ठीक है? Now, what are the topical agents? What are the effectiveness against the Pseudomonas gram-negative? Will they penetrate eschar or not? What are the side effects, right? So when you look at the first one, that is your silver sulfadiazine, it is extremely effective against Pseudomonas as well as gram-negative. It cannot penetrate eschar. It cannot penetrate eschar. So if there is an eschar that is already formed, this topical agent remains useless. There are no specific side effects. That is why silver sulfadiazine is the most common topical agent in burn wound management. Silver nitrate solution has a good action against your Pseudomonas, little action against gram-negative. It also cannot penetrate eschar. It cannot penetrate eschar, and there are only side effect, that is it results in blackening of skin. Now because it causes poor cosmetic outcome, this is not preferred. Mefenide acetate has a little action against Pseudomonas and gram-negative, but it is the only topical agent until now which has the ability that it can penetrate eschar. It can penetrate eschar, but the problem with this is, one, it increases pain on application. The burn is already so painful, and then you apply this, it causes more pain, so patient is very reluctant to do so. Apart from pain, it also results in metabolic acidosis. So hence mefenide acetate is discontinued. We don't use it any longer. Now your silver sulfadiazine with cerium nitrate, there's a misprint here. Just strike this off. It is silver sulfadiazine with cerium nitrate. It is extremely effective against gram-negative as well as pseudomonas. It can penetrate eschar and there are no side effects. So currently, if you say what is the best topical agent, it is silver sulfadiazine with cerium nitrate. It is a silver sulfadiazine with cerium nitrate has got the best outcome that is present. Okay? So this summarizes your initial first set in your general surgery about the various components from your picture-based or image-based session till your components, right? So we'll dig into more important ones from here on. So we'll be discussing the important topics in thyroid, which is repeatedly asked in our exam. Now, the first question that I would like to discuss here, or the first topic, which is repeatedly asked, is your optimum cytology criteria when you are going for a biopsy in a thyroid patient. Okay? Now, the size of the needle that you have to take is anywhere between a 22 to 26 gauge needle, but single best answer is going to be a 23 gauge needle, which is going to be an FNSC needle. There should be a minimum 2 aspirates. There should be 6 follicles per aspirate and 10 to 15 cells per follicle. You have to remember this, right? This is going to be, remember it. But Shubham, I'm not asking up. Xenograft is not a topical agent. It is a grafting. So if the component does not heal, then if you want to go and put, see, again, you have, rather than xenografts, the allografts are also quite good. It is not that necessary that xenograft is the best. Xenograft provides the best outcome in terms of management. That is agreed upon. Okay? Chalo. So size of the needle for optimum cytology is 23 gauge needle. The aspirate should be a minimum of 2. There should be 6 follicles per aspirate, and there should be 10 to 15 cells per follicle to call it as an optimum cytology criteria, right? Now, again, from our exam perspective, one of the important topics that you will see in thyroid is going to be your inflammatory thyroid swelling. We have 3 sets of inflammatory thyroid swellings. As we all know, we have the Hashimoto's thyroiditis, the decurvence, and the Riedel's thyroiditis. Now, could anybody tell me what type of inflammation do you have in Hashimoto's? There are 3 types of inflammation. They're acute, they're chronic, they're subacute. So which one do you think is the type of inflammation that you see in Hashimoto's? Hashimoto's is an example of, it is an example of chronic inflammation. It is an example of chronic inflammation. Decurvence is an example of subacute inflammation. It is an example of subacute inflammation. And Riedel's thyroiditis is again an example of a chronic inflammation. This itself is our exam question. What type of inflammation do you see in each one of them? Remember, with respect to Hashimoto's chronic, decurvence subacute, Riedel's is again chronic. Now, when it comes down to etiology, let's look at the etiological factors. Hashimoto's is usually an autoimmune disorder. It is usually an autoimmune disorder. Decurvence, it is your post-viral upper respiratory tract infection resulting in cross-reacting antibodies. And these cross-reacting antibodies will cause the damage or the injury. Riedel's, it is usually idiopathic. If not idiopathic, it can also be considered as autoimmune. Right? So this is the etiology in terms of each one of them. Now, what is the pathophysiology? Now, you will notice that all these will have certain specific components. For example, when I say specific components, in Hashimoto's thyroiditis, it will have a anti-thyroperoxidase antibody. Here, there will be presence of cross-reacting antibody. On the other hand, here it is idiopathic. If it is autoimmune, it is associated with IgG4 class of antibodies, right? So we all know all these components are present, correct? So when you talk about the IgG4, yes, Shubham has given us a component here. So IgG4 class of antibodies are also associated with. Now this is also associated with autoimmune pancreatitis. It is also associated with autoimmune pancreatitis. It is also associated with retroperitoneal fibrosis. It is also associated with retroperitoneal fibrosis. And this retroperitoneal fibrosis is usually what we call it as the Ormond's disease. Right? It is associated with IgG4 class of antibodies. Right? Yes. So when you talk about the pathophysiology, Hashimoto's, it is going to be CD4 activation for CD8 activation. This CD8 activation will cause activation of cytotoxic T cells, and these cytotoxic T cells are going to cause follicular damage. It is going to cause the follicular damage. Now the stories about the Hashimoto's is quite simple. The antibody that is formed, an anti-TPO antibody, the thyroperoxidase enzymes are present inside the thyroid follicular cell. They cannot go and destroy the follicle to get the thyroperoxidase enzyme, so they go to CD4 cells, they activate CD8 cells, they go and talk to T cells, they go damage the follicles, TPO is released, and hence it is going to be adherent to that. Decurvins, as you know, it is post-viral, so it's a cross-reacting antibody, so nothing spectacular about it. Riedels is usually idiopathic. So what are the HLAs which are involved? Somebody has given me an answer. It is a HLA-B8, HLA-DR3, as well as HLA-DR5. Here it is HLA-B35. There are no specific HLAs that are involved in your Riedels thyroiditis. Hashimoto's thyroiditis, it is seen in the age group between 30 to 40 years. Decurvin can be seen at any age group. There is no specific. Riedels is usually seen in elderly female, that is age above 50. All these disorders are more common in females when compared to males. Nothing spectacular about it, right? So what are the clinical features? Now, clinical features of Hashimoto's thyroiditis, it will present to you with midline neck swelling. It will present to you with midline neck swelling. Along with midline neck swelling, it is usually going to have signs and symptoms of hypothyroidism. Signs and symptoms of hypothyroidism, right? On the other hand, when you talk about the decurvins thyroiditis, in the decurvins thyroiditis, there will be midline neck fullness. There will be midline neck fullness. There is no swelling. That is because in your decurvins, that cross-reacting antibodies will go attack the follicles, causing inflammation, hence resulting in edema. Because of the edema, the gland enlarges. Swelling will have a uniform border. It's a demarcating borders, whereas edemas don't have. They are diffuse swelling. So you will see a midline neck fullness. Along with that, there will be presence of pain on swallowing. There will be presence of pain on swallowing. Decurvins will present to you as a massive midline neck swelling. This will have midline neck swelling. Along with that, it will also have severe pressure symptoms. I hope everybody knows the pressure symptoms associated with the thyroid gland are going to be dyspnea, dysphagia, hoarseness of voice. Dyspnea, dysphagia, hoarseness of voice. Dyspnea because in compression of trachea, dysphagia because of compression of esophagus, hoarseness of voice because of compression of recurrent laryngeal nerve that is traveling in the tracheo-esophageal groove. So this midline neck swellings will cause a compressive features, and that is your Riedels thyroiditis. And Riedels will present to you with signs and symptoms of hypothyroidism. It will have signs and symptoms of the hypothyroidism. Yes, it is hard and woody, right? What is the initial, when you talk about the thyroid status, this is important. Initially, in the Hashimoto's, when the follicles rupture, they cause excessive release of T3, T4, and excessive release of T3, T4 will cause increase in hormone release, that is hyperthyroid status. There is no intermediate. Eventually, the gland gets fibrous, it will become hypo. In decurvins, there is excessive irritation, so release increases. Once when the viral infection subsides, the antibody subsides, hence the irritation on the follicle will decrease. So what is going to happen? The follicle says, I'm now going to regroup and create the reservoir. There will be intermittent, which is going to become hypo, but eventually they become back normal. So it is euthyroid. Riedels from day one, it will remain hypothyroid. When it comes down to the investigation, for all of them, the investigation is same. You have to perform ultrasound because it is in hypo. You will do a USG. Along with that, you will do an FNSC, right? Here, you can also look for anti-TPO antibodies. Here, only the ultrasound of the neck. Yes, one more thing that I've missed out here, sorry. You have to do a thyroid function test. So, TFT is a must. Along with that, here anti-TPO antibody can be there. So here ultrasound with thyroid function test is enough. Here you would do all. Ultrasound will be done, FNSC would be done, along with that thyroid function test. Now, all these inflammatory disorders, they cause a lot of, because of repeated inflammation causes fibrosis, and there will be a lot of adherence to the surrounding tissues. So operations or surgical interventions are usually restricted. For Hashimoto's, it is going to be your lifelong thyroxine. Decurvins, it is self-limiting. We do not need to do anything specific. Here also, it is going to be lifelong thyroxine. Here also, it is going to be lifelong thyroxine. Okay? Clear? Now, the only thing that you can talk about in Riedl's as well as Hashimoto's is if a patient is having severe pressure symptom. If a patient is having a severe pressure symptom, then how would we manage? If a patient is having a severe pressure symptom, in such scenarios, patient having a severe pressure symptoms, here then the surgery of choice, it is going to be 𝐒𝐻𝐿emectomy. Then the surgery of choice, it is going to be 𝐒𝐻𝐿emectomy. As simple as that. Okay? Now this table, just revise it once. Every single exam question that they're going to frame is going to be from this particular table, right? So as we go down, see, surgeries are not done Hashimoto's as well as in renal thyroiditis because there's a lot of fibrosis with the surrounding tissues. If you try to go and dissect it, it will cause more damage. So the only surgery that is allowed for a severe pressure symptom is to divide the isthmus and remove it. So 𝐒𝐻𝐿emectomy is the surgery of choice. Clear? Chalo. Now, in the same context, again, हमारा 4 चांद 5 सितारे is about our thyroid cancer. Okay? So we're talking about same. 𝐒𝐻𝐿emectomy beta. Surgery, which surgery? It is 𝐒𝐻𝐿emectomy. अब आप बोलोगे सर ये 𝐒𝐻𝐻𝐻𝐻𝐻𝐻𝐻𝐻𝐻𝐻𝐻 क्या होता है? 𝐒𝐻𝐻emectomy is, if you take this is the isthmus of the thyroid gland, this is the thyroid gland that is present. 𝐒𝐻𝐻emectomy is basically to divide the isthmus of the thyroid gland and remove it. Now, why am I removing the isthmus? Because it is the isthmus that exerts pressure on the central part, that is the trachea and esophagus. Remove the isthmus, the lobes shifts laterally, and as the lobe shifts laterally, there is no pressure at all. Okay? So this is what we call it as 𝐒𝐻𝐻emectomy. Clear hai? Chalo. Right, so let's go with the malignancy part. So we have 4 different types or variants of malignancies that you have: the papillary cancer, the follicular, anaplastic, as well as medullary cancer thyroid. Now let's quickly again do a same recap. Papillary cancer is going to arise from the thyroid follicles. So it is follicular in origin. Follicular cancer, the name itself is telling it is also follicular in origin. Anaplastic is also going to be follicular in origin. Medullary cancer thyroid is going to be originating from parafollicular C cells. Now, one thing you have to remember is papillary are well differentiated tumors. Follicular is also well differentiated follicular origin tumors. Anaplastic, on the other hand, it is poorly differentiated tumors. These are poorly differentiated tumors, right? Now, what is the incidence? You know, the most, I don't need to talk about in terms of context here, but remember the most common thyroid cancers. The most common thyroid cancer is going to be papillary cancer thyroid. But if I put you a bouncer, no, if I ask you that which among the following is the most common type of malignancy in an ectopic thyroid gland, it is an ectopic thyroid gland. Okay, I'll use a darker color. I think somebody is saying, fine. Remember, your follicular cancer is the most common thyroid cancer. It is the most common thyroid cancer in ectopic thyroid gland. in an ectopic thyroid gland. Right? Now, which among the following is going to have a worse prognosis? Remember, anaplastic cancer, this is associated with the worst prognosis. This is associated with the worst prognosis, right? This is going to be associated with the worst prognosis. As in terms of papillary cancer thyroid, this is associated with the best prognosis. It is associated with the best prognosis. Okay? Now, when you talk about the age of presentation, again, to be very precise, all these malignancies, when they arise, they arise at a later part of life, except for the papillary cancer thyroid. The papillary cancer thyroid can be seen anywhere between 30 to 40 years. Folliculars are usually seen between 40 to 50 years. Anaplastic is usually seen in age above 50 years. Medullary cancer thyroid, if it is associated with MEN syndrome, that is a MEN2, then it is seen in age below 20 years. But if it is sporadic, that means if it is a general population, it is seen in age above 50. So we're talking about MEN2 usually here, right? So in that context, you will see that the patient is going to have medullary cancer thyroid. All these malignancies, needless to tell you, it is our poor females which are going to be more likely to be affected when compared to males. Okay? Now, the genes are important. Remember, the gene for papillary cancer thyroid is going to be BRAF mutation. For follicular, P10 gene mutation. RET gene mutation is for follicular cancer thyroid. There is no specific gene that you have to remember for anaplastic carcinoma. So when you talk about the risk factors, right, what are the risk factors that you're looking at? For a papillary cancer thyroid, the most important risk factor is going to be history of ionizing, or I can say in general sense, history of radiation exposure to the head and neck. History of radiation exposure to head and neck. These are the patients who have underwent treatment for lymphomas. Okay? So for lymphomas, for example, Hodgkin's lymphomas, actually, when they undergo radiotherapy at the early age of 5 to 6 years, at the age of 20 to 30, they start developing papillary cancer thyroid. So radiation exposure is quite important. Along with radiation exposure, it is the history of thyroglossal duct cyst. And again, the last one is your Hashimoto's thyroiditis. Now, Hashimoto's thyroiditis is a so-so risk factor, but yes, it is considered. For your follicular cancer thyroid, it is your long-standing. Untreated goiter. It is your long-standing untreated goiter. It is the long-standing untreated goiter that can result. Whereas when it comes down to anaplastic, there is no specific risk factor. But here it is associated with MEN2 syndrome. It is associated with MEN2 syndrome. I hope everybody knows about the MEN syndromes. Quick feedback. Do you want me to elaborate on MEN syndrome? Do you want me to elaborate on MEN syndrome? Yes, no, okay, bye, tata, kya hai? MEN syndrome, yes, no, quick feedback. Hi Mansoor, good afternoon. MEN syndrome, quick feedback. Shall we elaborate or not? Okay, a quick ticker. So quick succession on the MEN syndrome. MEN stands for multiple endocrine neoplasias. So when it comes down to MEN, there are three components that you have. We have the MEN1, we have the MEN2A, and when you have the MEN2B, right? We'll talk about the other factors also. In MEN1, it is associated from top to bottom, all three are associated P, and remember, it all starts with the same component. Number one is your pituitary adenoma. It is the pituitary adenoma. Then you have parathyroid adenoma. The parathyroid adenoma. And the last one, it is your pancreatic adenoma. It is what we call it as the pancreatic adenoma. What is MEN1 also known as? MEN1 is also known as. MEN1 is also known as. It is also known as Wermer syndrome. It is Wermer syndrome. MEN2A is what we call it as the Sippel syndrome. It is called as the Sippel syndrome. MEN2A is what we call it as the Sippel syndrome. ठीक है? हाँ, Werner is progeria beta. Ner is progeria. Mer is MEN syndrome. So that's why I've emphasized on the letter M. Wermer is your MEN syndrome. ठीक है? Now in the Sippel syndrome, what do you have? That is MEN2A. In MEN2A, you will have parathyroid adenoma. You have the parathyroid adenoma. You have medullary cancer thyroid. We call it as the MCT. That is the medullary cancer thyroid and pheochromocytoma. And the pheochromocytoma. MEN2B that you will see. MEN2B is going to have mucosal neuromas. Mucosal neuroma. Marfanoid habitus. Mucosal neuromas, marfanoid habitus, pheochromocytoma, and the medullary cancer thyroid. Right? Yeah, your mucosal neuromas are going to create into megacolons that are not important. Okay. Now, another thing, if anybody can tell me what is the latest addition in men, we now call it as the MEN4. So now the newer nomenclature is the MEN2A is MEN2, MEN2B is called as MEN3, and the latest one that you have is MEN4. Right? So what is MEN4's component? Any idea? MEN4 is nothing but MEN1 plus reproductive organ tumors. Plus reproductive organ tumors. Right? For example, ovarian cancers, uterine cancers, seminomas, all that. If that is there, it is going to be your MEN4. Okay? Chalo. So this is with respect to multiple endocrine neoplasias. Absolutely correct, guys. Right? Can we move on now? Okay? Chalo. Coming back to our original discussion of the comparative components that we have for the malignancies. For clinical features in terms of thyroid malignancies, in papillary cancer thyroid, so I'll give you the keywords to pick up in your MCQs. Papillary cancer thyroid will present to you with solitary thyroid nodule like presentation. With that, the patient can also have lateral aberrant thyroid. So lateral aberrant thyroid is actually secondaries to the cervical lymph nodes. So why we call it as lateral aberrant thyroid? Because there is no swelling in the thyroid gland, but there is already metastasis because papillary cancer thyroids are slow growing tumors. Okay? Chalo. So solitary thyroid nodule like presentation or lateral aberrant thyroid. Here in follicular cancer, it will present to you as goiter-like presentation. They'll have goiter-like presentation. Now, because it causes bony secondaries, it will have presence of pulsatile forehead bony swelling. It will have presence of pulsatile forehead bony swelling. It has got pulsatile forehead bony swelling. Anaplastic cancers are quite huge, so hence they cause a lot of pressure. So they present to you as huge midline neck swelling. Huge midline neck swelling. Along with this huge midline neck swelling, it is going to be associated with severe pressure symptoms. It is going to be associated with severe pressure symptoms. Medullary cancer thyroid, on the other hand, it produces a compound that is called as serotonin, and that serotonin causes excessive stimulation of GI mucosa, and that GI mucosal stimulation will result in diarrhea. So here you will have presence of solitary thyroid nodule-like presentation. It will have a solitary thyroid nodule-like presentation. Solitary thyroid nodule-like presentation. With that, the patient is going to have diarrhea. Right? So how do you pick up your exam points, right? So the first point, if you have solitary thyroid nodule-like presentation with lateral aberrant thyroid, that is your papillary cancer thyroid. Goiter with pulsatile forehead bony swelling, it is going to be follicular cancer. Huge neck swelling with severe pressure symptoms, it is anaplastic cancer. If it is solitary thyroid nodule with diarrhea, it is medullary cancer thyroid. As simple as that, right? So you know what point to concentrate when you're looking at a particular form of question. Now, what is the mode of spread that you're looking at? Remember, for papillary cancer thyroid, it usually spreads via lymphatics. Follicular is hematogenous. Anaplastic spreads via the direct route of spread. This is going to be both lymphatics as well as hematogenous. So medullary cancer spreads equally with that of the lymphatics, medullary cancer spreads with both lymphatics as well as hematogenous route of spread. Okay? Chalo. Now, what is the most common site for secondaries? When it comes down to the papillary cancer thyroid, remember the papillary cancer thyroid usually go down to the lungs. Follicular cancer thyroid, they go down to the bones, and the most common are flat bones, like your facial bones. And here they form what type of secondaries? They are associated with osteolytic secondaries. Anaplastic cancer also directly goes down into lungs. Your medullary cancer usually goes to liver, if not to the bones. Now, if it goes to bones, remember, if it goes to bones, what type of secondaries will it form? It is associated with osteoblastic secondaries. It will be associated with the osteoblastic secondaries. How do you remember it? Master blaster, medullary is blastic, follicular is lytic. Follicular lytic, you will have pulsatile forehead bony swelling. Why will a bony swelling become pulsatile? Because it is going to become thinned out bone cortex. That is because of osteolysis. Okay? That is because of osteolysis. Now, what is the investigation that you're going to look across here? Remember, for all of them, the standard investigation is going to be an ultrasound followed by thyroid function test. With respect to that, we will perform FNSE. So for all of them, the protocol remains the same: ultrasound with TFT and FNSE to know what are you dealing with. Right? Now, when it comes down to the follicular cancer thyroid, the minute you send it for FNSE, in the FNSE, my pathologist will give a report that is called as Thy3. Thy3, it is follicular origin, because FNSE cannot differentiate between follicular adenoma and follicular carcinoma. So what are you going to do? So what are you going to do here? The minute you get a Thy3, I have to take the patient for lobectomy with frozen section. So lobectomy with frozen section becomes the investigation of choice, because FNSE cannot differentiate between the follicular adenoma as well as follicular carcinoma. Shubham, there is no word called as hemithyroidectomy. That is an old term, obsolete. We have a newer protocols. We'll discuss about it. Now either we say lobectomy or total lobectomy. Okay? But there is no gold standard or confirmation for thyroid malignancies. You have to do ultrasound to assess the status of the gland as well as the nodularity to assess the status of the thyroid gland. The functional component is TFT, and FNSE is your cytological diagnosis. So when you come down to the FNSE, on a papillary cancer thyroid, I will come across pictures like this, right? So the first image that you can see here, this is your orphan Annie nuclei. So you see these empty vacuolated cells. The empty vacuolated cells is your orphan Annie nuclei. You see these whorls, these concentric whorls like an onion peel appearance. These are your Samoma bodies. These are your Samoma bodies, and these Samoma bodies are dystrophic calcifications. These Samoma bodies are an example of dystrophic calcifications. I hope everybody knows where do you see Samoma bodies. The common areas where you will come across the Samoma bodies can be remembered as your favorite subject as PSM. P stands for the papillary variant of renal cell carcinoma. S stands for the serous cyst adenoma of ovaries. The serous cyst adenoma of ovary. And M stands for meningioma. So this is your PSM. So papillary variant of RCC, serous cyst adenoma of ovaries, as well as meningioma, right? Now, when you see all these non-stained cells are called as oxyphilic cells, presence of abundant oxyphilic cells are also called as the Ashkenazi cells. So these indicates the patient is having Hürthle cell carcinoma. This indicates Hürthle cell carcinoma. So Hürthle cell cancer is nothing but an aggressive variant of follicular cancer thyroid, nothing more than that. Just you remember in that context. Yes, Hürthle cell cancers are an aggressive variant of your follicular cancer thyroid. And the last one that you can see, these muscular strands, these are nothing but presence of amyloid in stroma. Presence of amyloid within the tissue indicates of medullary cancer thyroid, right? So on a histopathological background, these are the images that you have to know. These are the components that you need to brush up across. Okay? So these are the important points that you remember in thyroid cancer. So I've given you all that is required here. Clear? Fine. So far, any questions? Quick feedback? Koi sawal, koi shak? Chale. Clear? So we'll talk about the breast next. So in the breast, we have again an important coefficient that you have. This would have been discussed in radiology also, but we'll just quickly cover here. That is your BIRAD system. बेटा annotated PDF मिलेगा. ये जो मैं लिख रहा हूँ मैं अपने लिए नहीं लिख रहा हूँ, मैं आपके लिए लिख रहा हूँ. ठीक है? थायराइड स्टेजिंग पढ़ा दो. ठीक है बेटा, आपने बोला तो हमने पढ़ा दिया. ठीक है? Now, when we talk about the protocols of staging, so we talk about thyroid cancer, TNM staging. देखिए इसमें ना TNM में only the T staging is important, not the N or M, because it is quite easy for us to know, right? अच्छा, ठीक है यार. See, Shubham, you need to understand that we have a very limited time in our hands. और अपनी वर्कबुक भी काफ़ी मोटी है यार. कितनी मोटी है? हम अभी हैं 16 पे और हमको जाना है 48 पे. तो टाइम कम है, ज़्यादा कवर करना है. ठीक है? ओके, इतने प्यार से पूछोगे तो यार मैं पूरा मतलब अच्छा फाइन पढ़ा तो दूंगा, मुझे कोई दिक्कत नहीं है. ठीक है, क्या ही करूँगा अपने पास रख के. बट यू नीड टू अंडरस्टैंड कि अपने पास थोड़ा लिमिटेड टाइम सोर्स है. अगर आपको बहुत डिटेल्ड में पढ़ना है ना, और इफ़ यू वांट टू गो विद द प्रोटोकॉल्स, you can just search BLS series by me only, that is Dr. Sandeep. YouTube चैनल पे ही है on our this thing PWK. उसमें आपको ना थायराइड के सारे लेक्चर्स मिल जाएंगे. तो थायराइड कैंसर मैनेजमेंट का आपको एक लेक्चर मिल जाएगा. अगर आपको इन डिटेल पढ़ना है तो वहाँ से एक बार देख लेना. अदरवाइज आई विल क्विकली कवर हियर ऑल्सो. ठीक है? सो TNM क्लासिफिकेशन में so we have T, it is based upon the size of tumor, N is the lymph node status, M is the metastasis, right? Now problem क्या है कि जब भी आप TNM पढ़ते हो, you try to mug and memorize. It is not how it is done. You need to understand and then try to understand, reciprocate it across. So for TNM के लिए T में देख लेंगे सबसे पहले क्या involvement है. The outermost layer is going to be skin. Skin के नीचे आपको subcutaneous fat मिलेगा. Under the subcutaneous fat, you have a muscle which is inseparable from that of the subcutaneous fat, and this is what we call it as platysma. Platysma के नीचे आपको strap muscles मिलेंगे. So strap muscles, if you look at from the midline, so this is the orientation of the strap muscles that are going to be present, right? So 3 sets of muscle we have discussed in detail in our BLS. अगर आपको वहाँ पे जाके strap muscles की anatomy देखनी है, you can go down and see there as well, right? So these are the strap muscles which are present, which is covering across here. Right in the center, अगर आप cross section लोगे, this is what we are talking about. This is the thyroid gland. ठीक है? This is the thyroid gland that you have, right? इसके पीछे you have थायराइड के पीछे क्या मिलेगा आपको? ट्रेकिया मिलेगा। ट्रेकिया के पीछे क्या मिलेगा? यू विल गेट द इसोफेगस व्हिच इज हियर। इसोफेगस के पीछे क्या मिलेगा? यू विल गेट द वर्टेब्रा। सो बिहाइंड द इसोफेगस यू विल फाइंड द वर्टेब्रा व्हिच इज हियर। वर्टेब्रा के आगे क्या मिलेगा? यू विल फाइंड अ प्री वर्टेब्रल फेशिया। सो इसके आगे आपको ये प्री वर्टेब्रल फेशिया मिलेगा, ठीक है। In the tracheo-esophageal groove, you will see a nerve that is present. This is your recurrent laryngeal nerve. इसके just lateral to that of the carotid lobe, your thyroid lobe, you have the carotid sheath that is present. Carotid sheath में आपको common carotid artery. This is your common carotid artery. Then you will find there is internal jugular vein. This is the internal jugular vein. And then you have a nerve that is your vagus nerve. ठीक है, this is the content of the carotid sheath. Clear? So look at these components. A quick recap also. The outermost is going to be skin. Skin के नीचे subcutaneous fat मिलेगा. Subcutaneous fat के नीचे एक आपको muscle मिलेगी. That is your platysma, which is inseparable. And these set of muscles that you can see which are oriented, this is what we call it as the strap muscles, ठीक है। So ये आपके जितने भी हैं, they are covering the over surface of the thyroid gland, and these are what we call it as the strap muscles, ठीक है। This is what we call it as strap muscles. Again, I'm telling you, strap muscles की anatomy is important from the exam perspective. So find some time to revise the anatomical orientation of the strap muscles. So these are what we call it as the strap muscles. Okay. Then this is your thyroid gland. Needless to tell you, this is your trachea, this is your esophagus. This happens to be recurrent laryngeal nerve. This is your common carotid. This is your internal jugular vein. This happens to be vagus, and this is the vertebra and the prevertebral fascia. इतना clear? ठीक है। अब let's look at the tumor status. ठीक है। So you have less than 2 centimeters, you have 2 to 4 centimeters, more than 4 centimeters confined to that of the thyroid gland, any size involving the strap muscles. ठीक है, तो यही आपके orientation हो गया. So if it is less than 2 centimeters, it is T1 disease, this is T2 disease, this is T3A disease. T1 is less than 2 centimeters. This is 2 to 4 centimeters. This is more than 4 centimeters confined to thyroid gland. T3B is involvement of strap muscles. If it is involving strap muscles, if it is involving strap muscles, it is T3B. Now what is T4A and T4B? And that is our bigger exam question. So T4A के लिए सब कुछ central. ठीक है, it is going to involve the subcutaneous fat. It is going to involve the trachea. It will involve the recurrent laryngeal nerve and the esophagus. Anything and everything, if it is involving in the midline, it is T3A. If it is involving laterally, that is the carotid vessels, the prevertebral fascia, and the mediastinal vessels, then it is going to be T4B. As simple as that. Okay? So here it is T4A and T4B. So ये जो central वाला है, this becomes T4A. Lateral वाला will become T4B. तो T4A में आपसे वही पूछेगा क्या क्या involved है. तो T4A में, just for the sake I'm writing here, it is going to involve the subcutaneous fat. It is going to involve the trachea. It will involve the larynx. It will involve the esophagus. It will involve the recurrent laryngeal nerve. Now trying to memorize and trying to remember it is going to be quite difficult. But if you understand how a tumor is, see, involvement of midline is easy to dissect, but it goes into lateral. No, what do you have in the lateral? Involvement of carotid artery, involvement of mediastinal vessels, involvement of prevertebral fascia. Anything of this will become T4B. As simple as that. Okay. So if you understand that how, see, the TNM is a very, very sought after thing. It has taken a lot of, research and time. It has gone into beautifully design this. So you कोई normally numbers नहीं है. It is to determine the operable status of the gland or the operable status of any tumor. चाहे आप कोई भी टीएनएम पढ़ लो ना, ऐसे ही दिखेगा। प्रॉब्लम क्या है कि आज तक हमने टीएनएम की तरह पढ़ा है, टीएनएम को देखा नहीं है। जब आप देखने लगोगे ना, सर्जरी इज अ ब्यूटीफुल टॉपिक है, मतलब सब्जेक्ट ऐसा है कि भाई पता चल जाएगा। देखो पता है कि इतना छोटा सा ट्यूमर है, ये ग्लैंड निकाल दो, खत्म। जैसे स्ट्रैप मसल में जा रहा है तो स्ट्रैप मसल भी खाली करना पड़ेगा। अगर आपको पता है कि पूरा मिड लाइन जा रहा है तो अगेन इनऑपरेबल स्टेटस डेवलप हो जाता है। तो क्यों बोलते हैं कि ऑपरेबल है कि इनऑपरेबल है? सर्जरी करते वक्त अगर मैं ट्रेकिया डैमेज कर रहा हूँ, इसोफेगस डैमेज कर रहा हूँ, रेक्टल लाइंज डैमेज कर रहा हूँ, क्वालिटी ऑफ लाइफ है ही नहीं। इट इज बेटर नॉट टू ऑपरेट ऑन दिस पेशेंट, दैट इज व्हाई वी से इट इज इनऑपरेबल। नो, इनऑपरेबिलिटी का स्टेटस क्या है? बेनिफिट टू रिस्क रेशियो। रिस्क आई अंडरस्टैंड, रिस्क है तो इश्क है, लेकिन प्रॉब्लम क्या है? इतना भी ना प्यार करो कि भगवान के पास चला जाए, ठीक है? तो यू नीड टू नो व्हेन नॉट टू ऑपरेट एंड दिस गिव्स यू इन दैट डिटर्मिनेशन, ठीक है? नाउ इन टर्म्स ऑफ द लिम्फ नोड स्टेटस, व्हेन यू टॉक अबाउट लिम्फ नोड स्टेटस, क्वाइट सिंपल अगेन। तो लिम्फ नोड में भी अगेन यू हैव टू विजुअलाइज इट। आई डोंट वांट यू टू, आई होप दिस इज क्लियर। ओके, beautifully explained, huh? Thank you guys. I take a little bit pride in all this now. If you understand something, you just put it across, ठीक है? ठीक है, I'm not gonna get deviated. I know if I pull up bit, no, आप ले जाओगे पूरी दुनिया कहीं और, ठीक है? चलो, so when it comes down to lymph nodes, again we'll talk about conceptually only. So the levels of lymph nodes are important. This is how the patient is going to be depicted. This is the head and neck that you have, right? So this happens to be the neck that you have. This is the suprasternal notch. And there's a muscle that is present here. That is your sternocleidomastoid muscle. So this is the muscle that you have. It is your sternocleidomastoid muscle. Okay. Now you need to understand thyroid gland की territory क्या है? When you look at the thyroid gland's territory, just for the sake of understanding, I'm just going to put it, this is the thyroid gland's territory. ठीक है? So obviously if the lymph nodes are involved at this area, it will be of lesser stage. If it is anywhere else, it is major stage. So when you look at the lymph node, no, this is level 1A, submental, submandibular, upper jugular, middle jugular, lower jugular, posterior triangle of neck, the central and the mediastinal nodes, right? So when you look at this, they are called as level 1A, this is level 1B, this is level 2, this is level 3, this is level 4, this is level 5, this is level 6, and this is level 7. Now, if you have a basic understanding, I hope you will understand if a patient develops thyroid cancer, which lymph node is more likely to be affected. कौन सा लिम्फ नोड जो यूजुअली आएगा अगर थायराइड कैंसर, उसकी टेरिटरी यहीं पे है, तो लेवल 6। तो हम बोलते हैं कि अगर लेवल 6 और लेवल 7 इन्वॉल्व है, इसको N1A बोलेंगे। बाकी कोई भी लेवल ऑफ लिम्फ नोड इन्वॉल्व हो गया, इसको N1B बोलेंगे, खत्म बात, ठीक है? सो द टेरिटरी विच इज देयर हियर, इट इज N1A, एनीथिंग बियॉन्ड दैट विल बिकम N1B, एज सिंपल एज दैट, ठीक है? सो दिस इज हाउ द स्टेटस ऑफ लिम्फ नोड्स आर गोइंग टू बी टेकन केयर ऑफ, ठीक है? So this is how the TNO M0, M1, no stand metastasis, presence of metastasis, it goes in that one. Okay? Clear. Pre-paratracheal is, see, whichever lymph nodes are present between two sternocleidomastoid muscles in front or around the trachea is level 6, or called as the central group of lymph nodes. Okay? Can you move on? चलें आगे, थोड़ी गाड़ी बढ़ाते हैं यार। Clear. Chalo. So we're talking about the BIRADS, that is your breast imaging reporting and data system. Okay? So when we talk about the breast imaging reporting and data system, again very important, this BIRADS came into picture for screening breast cancer. So this came into picture for screening breast cancer, that is in terms of, सर आप पूरा दिन ले लो, सर्जरी कवर कर दो। बेटा पूरा दिन आई विश मैं ले सकूं, लेकिन सर्जरी एक लौता सब्जेक्ट नहीं है अपने एग्जाम में, टोटल 19 सब्जेक्ट्स हैं, आज हम 3 सब्जेक्ट्स कवर कर रहे हैं। देखो ये कर सकते हैं कि अगर आपका पूरा सीरीज खत्म हो गया आज, ठीक है, और शाम को अगर आप फ्री हो एंड यू वांट टू कंटिन्यू, पुट अप अ मैसेज, आई विल कम बैक एंड टेक इट इफ एनी अदर डाउट्स आर देयर। एक काम करेंगे, हर दिन मिलेंगे जब तक एग्जाम नहीं होता, जो डाउट है सर्जरी में पूछना, आराम से बताएंगे, कोई टेंशन नहीं है, ठीक है? चलो, so coming down to BIRADS, you have category 0, which is called as an incomplete assessment. Patient आया, you did an ultrasound or you did a mammography, the films were not great, the interpretation was not there, patient did not turn up for follow-up, it is going to be your category 0. In category 0, you have to call the patient for repeat assessment. Category 1 is negative, there's no evidence, this is what I want in my patient, कि every patient who comes for screening, I need category 1. Breast का imaging हुआ, कुछ नहीं मिला, patient को बोलो घर जाओ, again वापस आना है 1 साल के बाद for routine screening. Category 2 is benign. Lesion dikha, but it is absolutely benign. No need to do anything. Continue the patient on routine screening. Now, this is your exam question. That is probably benign. BIRATS category 3 is probably benign. Ask the patient to come back for follow-up after 6 months. It is 6 months, not 1 year or 3 months. Exam में यही पूछ लेगा कि BIRATS 3 आए, आगे क्या करोगे? आप बोलोगे intervention है, surgery है, routine screening है, और review after 6 months. The answer is review after 6 months. Suspicious of malignancy, how do you confirm it? Do biopsy. Highly suspicious, again do biopsy. Biopsy proven, stage-wise management. That is category 4, 5 and 6. 4, 5, 6 is malignancy. Suspicious of malignancy, highly suggestive of malignancy and malignancy. ठीक है? फिर breast surgery में important points पूछ लेगा. What is a simple mastectomy? Simple mastectomy में what are the components that you're going to remove? You're going to remove the entire glandular component of the breast. You'll remove the entire glandular component of the breast. You will remove the stroma of the breast. Along with that, we will remove the nipple and the areolar complex. This is what we call it as simple mastectomy. Now, what is your radical mastectomy? Radical mastectomy is also referred to as the Halsted's mastectomy. It is also called as the Halsted's mastectomy. Now, in the Halsted's mastectomy, what are you going to do? I will perform simple mastectomy. Along with simple mastectomy, I will do a level 1, level 2, and level 3 lymph node clearance. Along with that, I will remove the pectoralis major muscle as well as the pectoralis minor muscle. So pectoralis major, pectoralis minor with level 1, level 2, level 3 group of lymph nodes and simple mastectomy is what we call it as radical mastectomy. Now, what is a modified radical mastectomy? In modified radical mastectomy, I will do simple mastectomy. I will do the clearance of all the lymph nodes. But here I am only going to remove the pectoralis fascia. I will not remove the pectoralis muscles. Okay? Now, when it comes down to the modified radical mastectomy, there are three common ones that we will do it. Number one is your Patty's modified radical mastectomy. Then you have Scanlon's. And the last one that you have is your 𝐒𝐿𝐻𝐿𝐿. Currently, remember, it is the 𝐒𝐿𝐻𝐿𝐿 modified radical mastectomy is the most common type of modified radical mastectomy that you can do across. Okay? So you have the simple mastectomy, the radical mastectomy, and the modified radical mastectomy. All these three are important to be remembered. Now, what are the structures to be preserved when you're doing a modified radical mastectomy? The mnemonic to be remembered is A, B, C, D. And what are those A, B, C, Ds? A stands for axillary vein. B stands for Bell's nerve. The Bell's nerve is nothing but your long thoracic nerve. It is the long thoracic nerve. C stands for cephalic vein. C stands for cephalic vein. And D stands for nerve to latissimus dorsi. Nerve to latissimus dorsi. Okay? So these are the structures that are to be preserved when you're doing a modified radical mastectomy. Okay? Now, what are the complications which are associated with modified radical mastectomy? Again, the mnemonic to be remembered is SWAB. S stands for seroma formation. Seroma is the most common post-operative complication of modified radical mastectomy. W stands for winging of scapula. W stands for winging of scapula. This is due to injury to the long thoracic nerve. injury to the long thoracic nerve. A stands for upper limb edema. In fact, the most common cause for upper limb edema, that is secondary edema, lymphedema, it is your post MRM status. See, the overall most common cause for secondary lymphedema is nothing but your filariasis. But if they ask you overall most common cause for upper limb edema, it is your post modified radical mastectomy status. B stands for blackening of the skin. Now, blackening is because of flap necrosis. It is because of flap necrosis, right? So, flap necrosis is another component. Okay. Pectoral muscle involvement, is it not the involvement of chest wall? बात कर लेंगे, आपको वो भी बता देंगे, कोई टेंशन नहीं है. ब्रेस्ट कैंसर पे दो इंपॉर्टेंट पार्ट्स बात कर लेंगे, कोई टेंशन नहीं. Now, all these complications that we spoke about, these are what we called as the early post-operative complication. It is an early post-operative complication. This is what we call it as an early post-operative complication. Okay? Now, what are the late post-operative complications that you can see? So, one of the other complications that we are interested in is the late post-operative complication. It is the late post-operative complication. So, what is the late post-operative complication is? Any patient who's underwent a modified radical mastectomy, it takes approximately 4 to 5 years, right? After 4 to 5 years, patient will present to you with lymphangiosarcoma of upper limb. Now, how do you know patient is having a lymphangiosarcoma of the upper limb? You will see an upper limb edema. There will be presence of a upper limb edema. It will also have a bluish discoloration. And this remains painless. And this condition is what we call it as. I hope everybody knows it. This lymphangiosarcoma of the upper limb post-modified radical mastectomy. Yes, Dr. Max, you're correct. It's not only 10 years, it usually starts after the 5th year onwards. So anywhere you can see at the 5th year, or usually seen after 1 decade of life. And this is what we call it as the Stewart-Travis syndrome. Yes, you're correct. It is what we call it as the Stewart-Travis syndrome. What is surgery for Stewart-Travis syndrome? The surgery of choice here is going to be your 4-quarter amputation. It is going to be your 4-quarter amputation. So when we say 4-quarter amputation, you're going to remove the entire arm of that particular side. You'll remove the arm. You'll remove the clavicle of that particular side along with the scapula of that particular side. So remove the arm, the clavicle and the scapula of the same particular side is what we call as the 4-quarter amputation. Correct. Right? So this is with respect to modified radical mastectomy. Now, do you want a quick recap on breast cancer or not? If you're strong with breast cancer, we can skip. Again, it's an important topic. I'm not saying it is not important. But then if you want me to take a small session on breast cancers, we can quickly do that as well. Karna hai, nahi karna hai? Quick feedback. Shall we do breast cancer? Breast cancer, breast cancer. Quick feedback. Yes or no? बेटा थक गया हो क्या? Are you guys tired? अगर थक गया तो बता दो भैया. ठीक है? To be very honest ना, you do not have the right to say that you're tired. थकना allowed नहीं है. थकना allowed नहीं है. ठीक है? अगले मुश्किल से 2-3 हफ्ते बचे हैं एग्जाम में. ये जो महीना है ना, everybody who's listening, I'm going to tell you a very important thing. This last 1 month of your preparation is what इज गोइंग टू डिटरमाइन कि आप लाइन के उस पार हो या लाइन के इस पार हो, ठीक है। 5 महीने की मेहनत, 1 साल की मेहनत, 4 साल की मेहनत एक साइड पे, लास्ट 1 महीने का जोर एक साइड पे। एवरी सिंगल स्टूडेंट जिसने आज तक एफर्ट दिया है, अगर ये महीना अच्छे से यूटिलाइज नहीं किया, रिजल्ट अपने फेवर में नहीं आएगा, ठीक है। और जिस बच्चे ने अभी तक थोड़ा हल्का हुल्का प्रिपेयर किया, इज नॉट वेरी सीरियस, लेकिन अगर वो लास्ट 1 महीने में अपनी जान लगा देगा ना, आई एम टेलिंग यू दिस 1 मंथ इज गोइंग टू डिटरमाइन योर लाइफ, ठीक है। कोई भी ऐसा रीजन होना ही नहीं चाहिए कि आप ये महीना यूटिलाइज ना करो, ठीक है। नींद नहीं है, कोई नहीं, एग्जाम के बाद सो जाएंगे, ठीक है। खाना जब मर्जी मिलेगा खा लेंगे, ठीक है, लेकिन अपने आप से गद्दारी नहीं करेंगे। वी विल नॉट लाई टू आवरसेल्व्स। लाइब्रेरी में बैठे हो ना, किताब के सामने बैठे हो, लेकिन दिमाग कहीं और है, गलत है। हर वो मिनट, एवरी सिंगल मिनट दैट यू गोना पुट इन द लाइब्रेरी, इन फ्रंट ऑफ योर बुक्स, इट हैज टू बी प्रोडक्टिव। मुझे नहीं पता लोग क्या बोलते हैं, आई हैव अ वेरी सिंगल टेक ऑन कॉम्पिटिटिव एग्जाम्स। अगर कोई भी कॉम्पिटिटिव एग्जाम क्रैक करना है, उसका कोई शॉर्टकट नहीं है, एक ही है कि पूरा दम लगाना पड़ेगा। लोग बोलते हैं कि 8 घंटे सो जाना, 2 घंटे रेस्ट कर लेना, 1 घंटा खाना खा लेना, 10 घंटे पढ़ लेना, हो जाएगा। नहीं, 18 घंटे पढ़ना है, 6 घंटे में जो मर्जी करना है कर लो, सोना है, नहाना है, खाना है, पीना है, जो करना है। बट दैट 18 आवर्स फ्रॉम नाउ टिल द डे ऑफ योर एग्जाम, एग्जाम का जो रात है वो एक्सेप्शन है, क्योंकि एंग्जाइटी बहुत हाई होती है। 10 बजे सो जाओ, लेकिन उस दिन तक, टिल दैट पर्टिकुलर डे, फ्रॉम नाउ ऑनवर्ड्स, 18 घंटे से कम अगर दोगे ना, इट इज यूजलेस, ठीक है। देयर इज नो इजी वे ऑफ टेलिंग यू दिस, लेकिन इफ यू डू नॉट पुट योर बेस्ट फुट फॉरवर्ड नाउ, एग्जाम के बाद रख के भी कोई फायदा नहीं है, ठीक है। तो बेटा सी, ये जो 18 आवर्स दैट आई एम टेलिंग यू नो, इट इज क्वाइट अचीवेबल इफ यू आर फोकस्ड। और ये जो 18 घंटे, इसको बहुत जुडिशियली यूज करना है, ठीक है। बैठ के अभी कॉपियां नहीं पढ़नी है, डोंट ट्राई कीप ऑन रीडिंग बुक्स, नो, दिस इज द टाइम वेयर यू हैव टू प्रैक्टिस। देखो, इट्स अ वेरी सिंपल थिंग, अगर आपने नेट में प्रैक्टिस नहीं की और डायरेक्ट मैच में जाओगे तो बोल्ड तो हो गई ना भैया, देयर इज नो इफ एंड बट इन दैट। तो प्रैक्टिस क्या है, यू हैव टू स्टार्ट सॉल्विंग एमसीक्यूज, डू योर जीटीज। देखो, एग्जाम के दिन आपको लगता है ना डायरेक्ट जाके एग्जाम देने नहीं होता, बेटा जीटीज देने पड़ेंगे, आपको नेट प्रैक्टिस करनी पड़ेगी, वो 3 घंटे बैठ के कॉन्सेंट्रेट करने की आदत डालनी पड़ेगी। If you are not able to sit and concentrate for that 3 hours, you will not be able to reciprocate that in your exam, ठीक है। On the day of exam, you think you will do it, you will not be able to, क्योंकि your concentration span has never been 3 hours। 1 घंटा कॉन्सेंट्रेट करते हो, फिर इधर उधर घूम के चले जाते हो, फिर बोलते आके पढ़ाई करेंगे, नहीं होता ना भैया। In the exam you're sitting for 3 hours, so you should start practicing to sit for 3 hours and then do exam for 3 hours, क्योंकि 3 घंटे में दिमाग को बार बार दौड़ाना है। You have to keep, make your brain think better, think faster. That will only come with practice, ठीक है। आज से मैं बता रहा हूँ, every single student who is watching this, there's a single most important agenda कि अब से एग्जाम तक हम दिन में मिनिमम, आई एम सेइंग मिनिमम 200 क्वेश्चंस करेंगे, ज़्यादा नहीं होते। देखो 200 क्वेश्चन का स्प्लिट क्या है, 50 क्वेश्चन सुबह उठते ही कर लिए, उसके बाद जो मर्जी पढ़ना है पढ़ लिया, आफ्टरनून दोपहर को 50 क्वेश्चन, आपके फ़ोन में ऐप है, कोई भी आप निकालो, टक 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 अपना पीडब्ल्यू का ऐप है, इतने सारे क्वेश्चन है, निकालते करते रहो, 50 क्वेश्चन ऐसे ही खत्म हो जाएंगे। लंच हो गया, शाम को जब वही होता है ना, पोस्ट लंच सबसे ड्राउजी सेशन होता है, नींद आने लगती है, पढ़ने का मन नहीं करता है, क्वेश्चंस करो ना भैया, स्टार्ट डूइंग क्वेश्चंस, तब ना एक तमाचा लगेगा कि यार ये सवाल मुझे आता नहीं है, गलत हो गया, तो देन योर स्लीप विल गो अवे। फिर रात को सोने से पहले 50 क्वेश्चन, ठीक है। यू हैव टू कीप डूइंग इट। एंड नाउ एनी टॉपिक दैट यू वांट टू रिवाइज, नो, डू नॉट रीड योर नोट्स एंड ट्राई टू मग इट अप, उसके बाद सवाल नहीं, ये बहुत गलत तरीका है कि पढ़ लिया उसके बाद सवाल करेंगे, अभी पढ़ा है तो अभी सही तो होगा ना यार, उसमें क्या पॉइंट है। तो ऑलवेज स्टार्ट डूइंग क्वेश्चंस फर्स्ट बिफोर, लेट्स से यू वांट टू रीड अबाउट ब्रेस्ट, ठीक है, मान लो आपने जनरल सर्जरी शुरू की है, सर्जरी पढ़नी है, तो आपने पहले ब्रेस्ट का सोचा कि आज करेंगे, तो जब ब्रेस्ट का यू वांट टू रिवाइज इट, डोंट स्टार्ट रीडिंग फ्रॉम योर नोट्स, open your MCQ वाली जो भी किताब है, whatever app you have it, start solving the questions on the breast. Trust, इतना भरोसा अपने आप पे करना पड़ेगा कि अभी तक जो पढ़ा है ना वो याद रहेगा। खुद पे भरोसा और कॉन्फिडेंस इज ऑल्सो वेरी इंपॉर्टेंट। यू हैव टू से टू योर सेल्फ एवरी सिंगल डे दैट येस आई रेड इट, आई नो इट, आई रिमेंबर इट, आई नो इट, आई रिमेंबर इट। तो वो एक्टिवली इम्बाइब होता है, ठीक है। और डेली सुबह उठ के ना वो मिरर में देख के जरूर बोल देना कि यार देख, तूने पढ़ा है, तुझे आता है, तो याद रहेगा। एंड दैट कॉन्फिडेंस यू हैव टू टेक इट। स्टार्ट सॉल्विंग क्वेश्चंस, तब तुझे ओरिजिनली पता चलेगा कि तेरा वीक पॉइंट क्या है। एंड मार्क दैट वीक पॉइंट, गो रीड दैट वन टॉपिक अलोन एंड देन गो नेक्स्ट, ठीक है। ऐसे करते हुए पूरा एक्टिव रिकॉल के साथ करेंगे, क्वेश्चंस करेंगे, विल मेक श्योर वी हिट इट हार्ड, ठीक है, रोकना नहीं है। क्लियर? चलिए, ओके, हो गया मोटिवेशन, मोटिवेटेड, चार्ज्ड, क्लियर है? ठीक है, चलो. सो विल टॉक अबाउट द इंपॉर्टेंट पॉइंट्स अबाउट द ब्रेस्ट कैंसर. सो ब्रेस्ट कैंसर में दो तीन चीजें इंपॉर्टेंट है. एक आपका टीएनएम क्लासिफिकेशन. सो इन द ब्रेस्ट कैंसर अगेन यू हैव द टीएनएम क्लासिफिकेशन. ठीक है, टीएनएम के ऊपर सर क्वेश्चन सॉल्व हो जाते हैं, बट जब नोट्स खोलता हूं तो ऐसा लगता है कि कुछ नहीं आता. गाइस, दिस इज वेरी कॉमन विद एवरी सिंगल एस्पिरेंट कि जब आप पढ़ना शुरू करते हो ना, जब आप क्वेश्चंस करोगे तो यू माइट गेट इट राइट, एंड फिर आप जब नोट्स खोलते हो तो देन यू फील कि मैंने शायद ये पढ़ा नहीं है. ये सबके साथ होता है. ठीक है, वहां पे पैनिक नहीं होना. You just need to believe that if you have done तुक्का नहीं मारना है. That's what you be true to yourself. अगर आपने कोई लॉजिक लगाया, कुछ सोच के समझ के आंसर किया है, that means you have understood a topic. एक बार ब्रीफली पढ़ लो. जब भी लगता है ना कोई टॉपिक थोड़ा एलिनेटेड है, पढ़ने लगो ना फिर याद आने लगता है. ठीक है, देन जैसे याद आने लगे छोड़ दो, आगे चलो. ठीक है, सो डोंट स्पेंड इनफ अमाउंट ऑफ टाइम एंड यूज सिट अक्रॉस देयर एंड ट्राई टू वेस्ट टाइम. ठीक है, दैट आई वुड नॉट रिकमेंड इट राइट नाउ. अभी इट्स द टाइम फॉर बीइंग स्मार्ट. सो टीएनएम में अगेन देख लेते हैं. ब्रेस्ट में अगेन काफी सवाल आते हैं. So if you take this a representation of the breast, which is the outer skin, this happens to be the nipple areola complex. पीछे आपको आपका pectoralis fascia मिलेगा. pectoralis fascia के पीछे आपको क्या मिलेगा? You get the pectoralis major muscle. pectoralis major muscle के पीछे आपको pectoralis minor muscle मिलेगा. इसके नीचे आपको serratus anterior group of muscle मिलेगा. ठीक है, इन सब के पीछे आपको क्या मिलेगा? You will get ribs. You get ribs. So this is the ribs which are present. I'm giving you a cross section. So 9 to 11 ribs are there. Ribs के बीच में क्या मिलेगा? Ribs के बीच में आपको intercostal muscle मिलेगा. Rib के बीच में आपको intercostal muscle मिलेगा. And you know the serratus anterior group of muscles are going to be radicalizing, or they will going to be inserting onto the ribs. So ये serratus anterior group of muscles जो है वो ribs के साथ adherent मिलेंगे. ठीक है, तो couple of important concepts that you need to know कि ये chest wall होता क्या है. ये chest wall होता क्या है, right? So when we say chest wall, पहले concept clear कर लेते हैं. chest wall का concept होता है, it is a combination of ribs with intercostal muscles with serratus anterior group of muscles. Ribs, intercostal muscles, serratus anterior group of muscles put together is what we call a chest wall. अगर तब तक नहीं है, it cannot be determined as your chest wall. ठीक है, now you have the pectoralis major muscle which is actually the resting surface. उसके नीचे आपको serratus anterior group of muscle. Just for the sake of understanding, I'll just quickly recap them as well. So ये जो आपका muscle है, ये आपका pectoralis major muscle है. This is your pectoralis minor muscle. These happens to be ribs. This is your intercostal muscle. And this happens to be the serratus anterior group of muscle. Okay? This is your serratus anterior group of muscle. So when you look at the TNM staging, you have tumor which is less than 2 centimeters. Then you have 2 to 5 centimeters and one that is greater than 5 centimeters. Okay? So T1, T2, T3 हो गया. Okay? If there is any size, which is going to be involving the chest wall. So if tumor is here, it is going to pierce through that of the pectoralis major. It does not matter. But if it is involving the ribs or the intercostal muscles, it will become T4A. If it is involving the skin, it will become T4B. If it is involving like this, if it is having an involvement which is going to involve both skin, it is going to involve both skin. So this is a representation of skin. If it is involving both skin as well as the chest wall, it will become T4C. And T4D, you would see the tumor which is present here, but it will have other findings which are going to be present. and that other findings would be your inflammation. This is an inflammatory breast cancer. Okay. So how do you determine it? Size, this is your T1 disease, less than 2 centimeters. T2 disease, it is going to be between 2 to 5 centimeters. This is your T3 disease, which is more than 5 centimeters, but limited to breast. Okay. Then you have T4A, which is only involving the chest wall. T4B, it is irrespective of the size, but you can see it is involving skin. Now there is a lot of questions and queries that how do you know a tumor is involving the skin? कैसे पता चलेगा कि skin को tumor involve कर रहा है? There are two things. Either there has to be presence of POD orange. Either there has to be presence of POD orange, or there has to be direct infiltration resulting in ulceration of the skin. That indicates involvement of the skin. बहुत commonly done mistake is that when you talk about this, you think that dimpling is also involvement of the skin. I would like to tell you, dimpling is not involving skin. It is not. I'm using the word in very precise manner. It is not involving skin. Dimpling of the skin is because of involvement of the Cooper's ligament. And involvement of the Cooper's ligament does not change the staging or does not alter the staging. It has to be the skin involvement. How do you know the skin is getting involved? The only way you know the skin is getting involved, either there has to be the POD orange or there has to be ulceration. Without this, you cannot say the patient is having involvement of the skin. Is that clear? ठीक है? Okay. Clear? Now, in an inflammatory, so you have T4C, everybody knows it. So T4C is going to be a T4A with T4B. It's a T4A with a T4B is what we call it as T4C. Now, what is your T4D? The T4D is your inflammatory breast cancer. Actually, when we say for inflammatory breast cancer, more than 1/3, right? If there's more than 1/3 of the skin is involved, of the breast skin is involved, it is going to be T4D. So T4D is going to be your inflammatory breast cancer. It is going to be your inflammatory breast cancer involving more than 1/3 of the breast skin. Involving more than 1/3 of the breast skin. Clear है? ठीक है? इससे better TNM in the staging protocols, I don't think I'll be able to teach you, because this is a visual interpretation. So when I think about a tumor and a patient comes to you, this is the picture that I have. अगर यही mental image आपके अंदर है, right? T1 is less than 2 centimeters, beta. It is less than 2 centimeters. 2 to 5. Achha, if see less than 2 and more than 2 centimeters, so we say until 1.9 it is T1. 2 and above it will become T2. ठीक है? TNM के क्वेश्चन करा देंगे, कोई टेंशन नहीं है. ठीक है? So this is about the T status. Now when you talk about the lymph node status, again it is also a visual interpretation. So this happens to be the neck, this is the shoulder line, this happens to be the axilla that is going to be present. This is your suprasternal notch. This is the clavicle that you have. This is the axillary groove. So this is how you see, this is the axillary groove that is present. Okay? Right? Now, when you talk about the TNM staging in terms of lymph nodes, you will notice that you have the axillary group of lymph nodes are present here. So I'm just going to say these are the axillary. I'm not going to divide them into subgroups. That is your anterior posterolateral. This is your axillary group of lymph nodes. This is your central group of lymph nodes. This is your apical group of lymph nodes. These are your internal mammary group of lymph nodes, and these forms the rotor group of lymph nodes. These are your rotor group of lymph nodes. So you have the axillary group of lymph nodes, just for the sake of understanding. These are your axillary group of lymph nodes. So this happens to be your central group of lymph node. This happens to be your apical group of lymph node. This is your internal mammary group of lymph nodes. The internal mammary group of lymph nodes. And this happens to be your interpectoral, or also called as the rotus group of lymph node. Okay? Now, how do you stage this? Now, in our staging, if you have a tumor which has gone into one of the axillary group of lymph node, but this axillary group of lymph node is mobile, this is called as N1 disease, right? This is what we call as N1 disease. But you have multiple lymph nodes which are matted together. If they're coalesced together on the same side, it is called as N2A. It is called as N2A. N2B is involvement of internal mammary group of lymph nodes. Involvement of internal mammary group of lymph nodes will become N2B. Just for the sake of understanding, I'll quickly give you a recap also. If there is same side, ipsilateral, if the tumor is here, we're saying the breast cancer tumor is here. So this is the tumor, whichever side the tumor is there, ipsilateral axillary group of lymph node which is involved, and this is mobile, that means multiple nodes are not involved. On the same side, this is what we call it as N1A. It is what, sorry, it is called as N1, there's no A. Then you have ipsilateral axillary group of lymph nodes are involved, but this time they are fixed, that means they are matted, and this is your N2A. Same way, if there is involvement of internal mammary group of lymph nodes, it will become N2B. It will become N2B. This is going to be N2B. Okay. Now, when you have N3A, if the tumor is involving the infraclavicular group of lymph nodes, this will become N3A. Involvement of infraclavicular apical, it will become N3A. Then you have N3B. N3B is involvement of both. So when you say involvement of axillary group of lymph nodes as well as internal mammary, it is called as N3B. So if I say N3B will have an involvement of both the lymph nodes. If both the lymph nodes are involved, this is what we call it as N3B. B stands for both. N3C is going to be involvement of the supraclavicular group of lymph nodes. Usually they are not involved, but if you have involvement of the supraclavicular, it is your N3C. So N3C is involvement of supraclavicular lymph nodes. It is the involvement of your supraclavicular lymph nodes. Okay? So very easy. Okay? Again, if you are able to visualize this interpretation, single node mobile N1, multiple nodes involved in the same time N2A. If it is involving internal mammary, N2B. If it is going to be your, where is your N3A? N3A is going to be involvement of the apical group of lymph node. N3B is both, N3C supraclavicular. As simple as that. Clear? Okay? So this is on the TNM context. Now your problem starts when you're looking at staging. Okay? So breast cancer में staging का एक trick है. TNM classification से ज़्यादा आपके लिए एग्जाम में प्रॉब्लम हो जाता है staging का. ठीक है? Now in the staging we have stage 1, we have stage 2, we have stage 3. Okay. So in stage 1, we have stage 1 with stage 2A, we'll categorize it in categorical manner. It is stage 2B. Then you have stage 3A, you have stage 3B, and you have stage 3C. And then you have stage 4. Okay. Now how do you remember it? Because of multiple combinations. Now the easiest one is your stage 1. You don't need to remember at all. It is T1, N0, M0. Okay. यहाँ पे 2A is again stage up कर लो. N2, I mean T2, N0, M0. It is T2, N0, M0, or it can be a T1, N1, M0. Here it can be T3, N0, M0, or it could be T2, N1, M0. Right? So you have done easy staging, तो यहाँ पे कोई problem नहीं है. तो ये stage 1, 2A, 2B, everybody remembers it. Now the question starts if you have to categorically remember 3A, 3B, and 3C. Now for a 3A, I would say that the important context to be remembered, it is going to be an N2 disease. This is going to be a T4 disease, and this is going to be a N3 disease. You just need to remember this. इसके beyond कुछ याद मत रखना. ठीक है? इसका मतलब मैं समझाता हूँ कि क्या मतलब है. ठीक है? T4 के साथ any N with M0, it will become 3B. Any T with N3 and M0, it will become 3C. Any T with M0 with a combination of N2 will become 3A. ठीक है, बस यही याद रखना और कुछ नहीं है. ठीक है, अब जब आप सॉल्व करोगे एग्जाम में क्वेश्चन, इफ यू फाइंड देयर इज अ डिजीज विच स्टार्ट्स विद T4, फिर आप देख रहे हो कि N3 नहीं है, और इल्स से T4 और एनीथिंग इज देयर, M is 0, it will become 3B. लेकिन द मिनट यू सी N3 irrespective of the T, it will become 3C. यही आपके एग्जाम में खेलते रहते हैं कि 3A है, 3B है, 3C है, 3A है, 3B है, 3C है. क्यों याद रखना सब कुछ? इतना याद रख लो कि अगर T4 के साथ कोई भी N का कॉम्बिनेशन लेकिन N3 नहीं है तो 3B है. T के अगर 3C का मतलब क्या? N3 है. ठीक है, T के कोई भी T हो जाए, अगर N3 लग गया तो इट इज 3C. स्टेज 4 तो कोई पढ़ाता ही नहीं है, क्योंकि पढ़ने की बात ही नहीं इसमें. उसमें क्या है? Any T, any N if M is 1. Sorted. ठीक है, इससे ज्यादा क्या ही डिफिकल्ट है बताओ मेरे को? क्या पढ़ना है यार? दो चीजें याद रखनी है कि 3B में T4 होता है, 3C में N3 होता है, खत्म. और कुछ पढ़ना है इसमें? इज देयर एनीथिंग एल्स दैट यू वांट टू रीड फ्रॉम हियर? क्लियर है? सॉर्टेड? बड़ा फीडबैक चाहिए, फीडबैक. सॉर्टेड नहीं, नॉट सॉर्टेड? ठीक है ना, इसी को मैनेजमेंट में ले जाओ तो वी हैव अर्ली इन्वेसिव ब्रेस्ट कैंसर, you have early invasive breast cancer, you have locally advanced breast cancer, you have locally advanced breast cancer, you have locally advanced breast cancer, and then you have advanced breast cancer. It's your it's your advanced breast cancer. So how do you manage it? For all advanced breast cancer, it is usually going to be a palliative management. It is going to be palliative management. Locally advanced breast cancer, which is also called as LABC. लेकिन किसके बेसिस पे बोल रहा हूँ? ठीक है, for locally advanced breast cancer, it has to be stage 3A, 3B और 3C को आप locally advanced बोलते हो. stage 4 को advanced बोलोगे. stage 1, stage 2A and 2B will be called as early invasive breast cancer. ठीक है, right? So advanced में palliative हो गया. locally advanced में the first step is going to be neoadjuvant chemotherapy. So it is chemotherapy before the surgery. Second, take the patient for modified radical mastectomy. Then you go post-operative chemo and radiotherapy. It is the post-operative chemo as well as radiotherapy. ठीक है? ठीक है? Early invasive breast cancer. In the early invasive breast cancer, you can perform either a simple mastectomy, do a simple mastectomy, or breast conservative surgery. That depends whether lymph node is positive or negative. So if it is a node negative disease or if it is a node positive disease. If the node positive, then you have to go ahead with axillary dissection. If it is a node negative disease, perform a sentinel lymph node biopsy. Perform a sentinel lymph node biopsy. ठीक है, as simple as that. ये आपके ट्रीटमेंट प्रोटोकॉल्स हैं, खत्म. इससे ज्यादा ब्रेस्ट कैंसर में है ही क्या यार, यही पूछेगा. ठीक है, क्लियर है? Is everybody sorted? Everybody is clear? So far any questions? ठीक है, चलो. So this is about breast cancer. So now today you understood two important TNMs and its staging protocols. One is your breast, another one is going to be your thyroid. ठीक है, चलो. Okay, so going down to your vascular disorders. ठीक है, so the vascular disorders again important. We're talking about the chronic arterial disorders, two common disorders. One is your Burgess, another one is your atherosclerosis. Now, when you talk about a quick recap on both Burgess and atherosclerosis, Burgess you will see in age under 40 years. Atherosclerosis will be seen in age above 50 years. The most important risk factor for Burgess is going to be smoking, whereas atherosclerosis is going to be obesity. That is why you'll see more commonly affected as males here. Atherosclerosis, the males and the females are equally affected. In Burgess, remember, all 4 limbs are equally involved. All 4 limbs are equally involved, whereas atherosclerosis has a predominance for lower limb when compared to that of upper limb. In fact, the upper limb atherosclerosis is almost unheard of. It is almost unheard of. Okay? The size of the vessels in the Burgess, it is usually going to involve small to medium sized blood vessels. It is small to medium sized blood vessels. Atherosclerosis, it is going to be medium, also large to medium sized blood vessels. It is large to medium sized blood vessels. It is large to medium sized blood vessels. The pattern of involvement here, it will cause skip lesions, whereas atherosclerosis is going to have a continuous lesion. It is going to have a continuous lesion. The progression here, so when the Burgess progresses, so there are 2 types of progression, proximal to distal, in other words, distal to proximal. Remember, here it is always distal to proximal. Atherosclerosis progresses from the proximal end of the vessel to the distal end of the vessel. So it is proximal to distal. It is proximal to distal. What are the structures involved? So in Burgess, it is not only going to involve the artery, it is going to involve the accompanying vein as well as the accompanying nerve, whereas atherosclerosis is only going to involve the artery. It is only going to involve the artery. Okay. So that's the basic difference between the Burgess and the atherosclerosis. I hope everybody knows the Burgess is also commonly referred to as the thromboangiitis obliterans. Now this thromboangiitis obliterans is what we call as TAO. The name is self-explained. Thromboangiitis obliterans. Angiitis is inflammation of the blood vessel. Because of inflammation, there is thrombus, and that thrombus is occluding the blood vessel. So hence, thromboangiitis obliterans. That is a thromboangiitis obliterans. Okay. Okay. There are certain things we'll still discuss about it, but let's talk about few important components. Another thing, in order to assess the severity of the disease of the chronic arterial occlusion, we measure something called as ABPI index. That is nothing but the ankle brachial pressure index. ABPI index is your ankle brachial pressure index. So how do you measure ABPI? The ABPI is basically measured at the systolic blood pressure at the level of ankle to that of the systolic blood pressure at the level of brachial artery. Now, logically talking, the systolic blood pressure in the body is going to be 120 millimeters of mercury. Let it be at the level of ankle or let it be at the level of the brachial artery. So if you do a ratio, it will get to as 1. So an ABPI index of 1 is considered to be normal. Remember, maximum. So when you look at the ABPI index, this is how you calculate. So you got the idea that how, so rather than trying to remember these numbers, 0.9, 0.5, so you need to understand how they have come into the picture. Systolic blood pressure हमने देख लिया ankle पे brachial artery पे 120 तो 1 is considered to be normal. लेकिन if you think logically, no, at the level of ankle, not only the pressure but the weight of the blood will also be more. So hence the probability of having the pressure at the ankle for you and me is also higher when compared to the brachial artery. So obviously when the numerator increases, the value will increase above 1. So we now consider that the ABPI index is 1 to 1.3 is considered to be normal. Okay. Now comes, so if you determine what is normal, anywhere between 1 to 1.3 will be considered to be as normal. For a calcified blood vessel, you will have more than 1.3. Intermittent claudication is less than 0.9. Rest pain will be less than 0.5. Critical limb ischemia is less than 0.3. Now, under this, you are going to have severe limb ischemia. That means in critical limb ischemia, it is an impending gangrene. The word is critical limb ischemia, but it is basically means that it is going to have impending gangrene. this is going to be an impending gangrene. ठीक है, this is going to be an impending gangrene, right? Now, clear? Now, if you look at the whole objective, so you know how does a normal ABP index is calculated. Less than 1 indicates some amount of blood flow is limited, so 0.9. If it becomes half of normal, that indicates there is some big problem, that is rest pain. But if it is becoming less than 1/3, it's critical limb ischemia. So blood requirement हमारा 100% है और delivery less than 30% हो रहा है तो critical limb ischemia हो गया, less than 50% हो रहा है तो rest pain हो गया, कम होना शुरू हो गया तो intermittent claudication हो गया. And this is how you are going to calculate your ABPI index, as simple as that. ठीक है, इससे ज़्यादा दिमाग नहीं लगाना है. ठीक है, चलो clear. चलो, yeah, Shubham. See, normally when you talk about the ankle pressures, you're measuring at the tibial arteries, either the posterior tibial artery, which is the usual one, or the anterior tibial. Posterior tibial is more accessible, so pressures at PTA is measured. Dorsalis pedis तो काफी आगे हो गया ना. चलो. So when you have the chronic arterial occlusion, see, Burgess का management is going to be conservative only. If it is gangrene, you'll go with amputation. So when you talk about the atherosclerosis, so this is the management of the atherosclerosis. Atherosclerosis का जो management है, it depends upon the level of occlusion. Is it an aorto-iliac occlusion, iliac occlusion, or the femoropopliteal occlusion? If the occlusion is at the level of aorto-iliac, just for the sake of understanding, no, when I say aorto-iliac, this is the aorta, this is the iliac bifurcation, this is going to be internal and the external iliac artery that it is bifurcating into, right? So when I say aorto-iliac occlusion, I'm talking about occlusion here. So when we say iliac occlusion, no, so when I say iliac occlusion, in the iliac occlusion, see, in the iliac occlusion, we're talking about the level of occlusion is here. In the femoropopliteal occlusion, we're saying the level of occlusion is here. Okay, as simple as that. Okay. So when you look at the aorto-iliac occlusion, blood flow in both the iliac vessels are going to decrease. So here the patient will develop a bilateral intermittent claudication. So in this bilateral, it will be involving the gluteus muscle, it will be involving the thigh muscle, it will also involve the calf muscles. Whereas in iliac occlusion, you'll have unilateral intermittent claudication, gluteal sparing is there, involvement of the thigh and the calf will be noticed. In femoropopliteal, it will be unilateral, there will be gluteal sparing and thigh sparing, but involvement of the calf muscle will be noticed. So how would you like to manage? For aorto-iliac occlusion, it is an aorto bifemoral bypass. It is an aorto bifemoral bypass. Here it is only an aortofemoral bypass. It is an aortofemoral bypass, and this is your iliopopliteal bypass. It is an iliopopliteal bypass. This is your iliopopliteal bypass. Worst case scenario, they can ask you what is the material used. Remember, for aortobifemoral, I will be using a Dacron graft. Aortofemoral, I will be using a Dacron graft. And iliopopliteal, I will be using your autologous reversed. An autologous reversed great saphenous vein. An autologous reversed great saphenous vein. Clear? Clear, guys? Clear? ठीक है, चलो. Now, another very important topic that you have is going to be your varicose vein. So in the varicose vein, again a very very important, this is our 4 चांद 5 सितारे वाला topic ना, तो याद रख लेना. तो 4 चांद 5 सितारे वाला जो topic है अपना varicose vein है. In the varicose vein, we'll be talking about the 𝐒𝐝 classification. Okay? Now, see, varicose vein can occur anywhere in the body, but if I ask you what is the most common site for the varicose vein, the answer is going to be lower limb. In the lower limb, you have the great saphenous vein and short saphenous vein. So the most common vein involved, the most common vein involved in the varicose vein, it is going to be the great saphenous vein. It is going to be the great saphenous vein, right? So based upon its components, you have the 𝐒𝐝 classification for varicose vein. Quickly run through it. 𝐒𝐝 C0, there is no evidence of venous disorder. There is no evidence of venous disorder, that is C0. If it is C1, there is presence of telangiectasia. Now, telangiectasia is a vessel which is less than 1 millimeter in diameter. Now, along with telangiectasia, it can also have reticular veins. Now, reticular veins where it is going to become between 1 to 3 millimeters in diameter, but less than 3 millimeters for sure. C2 is what we call it as the varicose vein. Now, the definition of varicose vein is the vein when it becomes more than 3 millimeters in diameter. This will be addressed as our varicose vein. Then your C2R. C2R, the suffix that is present as R, that indicates recurrent, and this is your recurrent varicose vein. This is your recurrent varicose vein. C3 will be presence of edema around ankle. This would be edema around ankle. C4A is going to be pigmentation. And this pigmentation is also going to be around ankle. Now, anybody knows why there's a pigmentation in varicose vein? Quick feedback. Pigmentation क्यों होता है varicose vein में? Varicose vein में pigmentation क्यों होता है? What is the reason for development of pigmentation in varicose vein? The pigmentation in varicose vein is because of hemosiderosis. Now, what is a hemosiderosis? It is hemosiderin. It is a hemosiderin that combines with the melanin of skin. It is the hemosiderin with the melanin of the skin is what we call it as hemosiderosis. Okay? So hemosiderosis kya hai? It is when the RBCs break down into heme and globin, the globin is being utilized back, the heme migrates out, becomes hemosiderin. That hemosiderin combines with the melanin of the skin, gets imparted on the skin, and that is what we call it as the pigmentation of the skin that is going to be seen across. C4B. Now, this pigmentation is considered to be as a foreign body, and when there is foreign body, there is inflammation, and on a daily basis, these RBCs will continue to break. More and more amount of hemosiderin will be produced, resulting in hemosiderosis and repeated inflammation. Anywhere in the body, if there's repeated inflammation, it will heal by fibrosis, and that fibrosis is what we call it as lipodermatosclerosis. A beautiful word to describe what is happening. Repeated inflammation is causing fibrosis. Lipo is fat, dermato skin, sclerosis is fibrosis. So there is fibrosis of skin, and as well as the fat component is lost. So this is now going to present to you as lipodermatosclerosis. Will present to you as woody limb. It will present as woody limb. This is also give you a classical inverted champagne bottle appearance. It will have an inverted champagne bottle appearance. Okay? So this is your lipodermatosclerosis. C4C is going to be dilated veins around the ankle. This is what we call it as the coronophlebectatica. Now, this coronophlebectatica is also commonly referred to as the malleolar flare. It is also referred to as the malleolar flare. C5 disease. C5, it is going to be an healed venous ulcer. It is going to be a healed venous ulcer. C6 is your active venous ulcer. It is going to be an active venous ulcer, and C6R is going to be your recurrent venous ulcer. It is going to be a recurrent venous ulcer. Now, my question to you is, how do you know it is a venous ulcer? कैसे पता चलेगा कि venous ulcer है ये? Now, the characteristic of a venous ulcer, let it be a healed, active, or recurrent, this is going to be present at the gaiters area. That's the area around the ankle with maximum pressure. It will be shallow also. It will be shallow also. So it will present gaiters area. It will have shallow also. It will have a sloping edge. This is going to have a sloping edge, and it will have pale, scanty, unhealthy granulation tissue. Unhealthy granulation tissue. It will be pale, scanty, unhealthy granulation tissue, right? So this is your SEEP classification. बेटा rolled out edge नहीं मिलेगा ना, आप वो basal cell cancer की बात कर रहे हो. You'll have sloping edge. ठीक है? So this is with respect to C. That is in SEEP classification. E is your etiological component. So E stands for the etiology. Now based upon the etiology, EP is primary etiology, ES is secondary. So if there is congenital weakness, that is primary. If it is secondary DVT, it is secondary. And EN, there is no etiology noticed. P stands for the pathophysiology. In pathophysiology, R stands for it is because of reflux of blood. O stands for obstruction to the blood flow. R and O is both reflux along with obstruction to the blood flow. It is both reflux as well as obstruction to the blood flow, and no pathophysiology noticed. No pathophysiology noticed. Based upon which anatomical structure it is going to involve? So based upon the anatomical structure. Based upon the anatomical structure, AS stands for superficial venous system. It is the superficial venous system. AD stands for deep venous system. AD stands for deep venous system. AP stands for involvement of perforator system. AN stands for no anatomical site noticed. There's a no anatomical site noticed. Okay? So this is on the context of the SEEP classification of varicose vein. Now we know what the investigation of choice for varicose vein is going to be your duplex scan. Now when we say duplex, it is going to be ultrasound with Doppler. Now when you have a patient with great saphenous vein, that is your when you talk about the saphenofemoral incompetency in the great saphenous vein, or let's say if the patient is having a saphenofemoral junction incompetency, on an ultrasound you see a classical sign which is what we call it as the Mickey Mouse sign. Now in the Mickey Mouse sign, when you see there's a big face, this happens to be your common femoral vein. This is your great saphenous vein, and this is your common femoral artery. Right? So the ear is of common femoral artery, the face is your common femoral vein. It will open into the great saphenous vein, and you see here there is loss of bridge. Okay? So this is the Mickey Mouse sign that you will see on a saphenofemoral incompetency. Okay? So this is what you have to remember with respect to varicose vein. Remember, when it comes down to the varicose veins management, number one, you have the Trendelenburg surgery. It is to flush, ligate, and strip. Right. Second that you can do, it is going to be an endovenous laser ablation. Third is your radio frequent ablation. Okay. If there is a perforator incompetency, then you can do your subfacial perforator ligation. You can do a subfacial perforator ligation. You can also perform SEPS for perforator incompetency only. You have something called as SEPS. That is subfacial endoscopic perforator surgery. It is your subfacial endoscopic perforator surgery, that is SEPS. Along with SEPS, you can also do sclerotherapy. Now, sclerotherapy, the most common agent that you can use, it is going to be sodium tetradecyl sulfate. It is the sodium tetradecyl sulfate, and you're going to create foam out of it, and the method of creating the foam is what we call it as the Tasari's method. Okay? So this is about your perforator incompetency. If you have a patient with venous ulcer, for venous ulcer we use Bisgard's regime. Now in the Bisgard's regime, we are going to educate the patient about the condition and its importance, and ask the patient to take a wound care, elevate the limb, and the last one is usage of elastic compression stocking. Usage of elastic compressive stockings. Usage of elastic compressive stockings. Okay? Correct. So this summarizes your entire component of your vascular disorders. Any questions, any queries that you have here? Quick feedback. कोई सवाल, कोई शक? अपना next session कौन सा है? I think the next session is your pediatrics, है ना? Okay, guys. Because the workbook is a bit extensive and we are right now at which page number? कौन सा page चल रहा है? Okay, we're on page number 21. Out of the total pages that I'm supposed to cover is 49. ठीक है? तो 49 50 पेज है, 25 पेज तक अभी खत्म कर लेते हैं. After that we will resume back once we have done with the other two sessions. I think your session will end at 9 o'clock. तो 9 बजे के बाद से मैं ले लूँगा. ठीक है? Because we'll not be able to complete it entirely. So let's not hush fuss it. We'll finish general. We'll start systemic in the later half. Clear? Chalo. I know beta I am also having fun teaching here. Surgery only is not my call. The other two teachers are also lined up. We have Sarath sir, amazing guy for pediatrics, and then we have our Pawar sir for anatomy. मैं फिर बता रहा हूँ, surgery is not the only subject. 19 subject है, सबका important coefficient है. मैं रात इतना कर लेना कि थोड़ी हिम्मत बना के ना 9 बजे के बाद वापस आ जाना. ठीक है? 9:30 बजे से फिर शुरू कर लेंगे, कोई दिक्कत नहीं. ठीक है? So we'll try it. We'll finish today by hook or crook. कुछ नहीं होगा. हाँ बेटा, we have, देखो, if you look at the workbook, no, I have designed it in a way that आपके GIT के सारे esophagus के X-rays हो जाएंगे. We'll talk about all the image-based sessions. We have the entire GIT, but more importantly, no, ये वाला column, disorders सारे हैं, उनके सारे managements हमारे पास हैं. Ulcers, उनके named components, malignancy, उनके chemo regimes, margins क्या हैं, disorders के managements क्या हैं. All these are put in a very, very, very organized fashion. GIT में और मजा आएगा. Trust me, I can give you with utmost confidence कि ये जो rapid revision का हम series कर रहे हैं, especially for surgery, I can vouch for it. You will have maximum topics covered. Exam में आप वो confidence लेके जाओगे कि पढ़ा है. ठीक है? ठीक है? So don't worry about it. So quickly, let's do it this way. I'll coordinate with the team so that we get a slot after 9 also. We will complete it today by hook or crook. छोड़ना नहीं है, आज surgery खत्म करके जाएंगे. ठीक है? Don't worry about it. चलो. So going back to our plastic surgery. Plastic surgery में grafts में important है. बेटा 12, 1, 2 कोई टेंशन नहीं है. बेटा hernia सब, everything is covered. Don't worry. I think hernia का भी slot है ना इसमें. दिस इज व्हाट, उसके बाद न्यूट्रिशन है, देन यू हैव दिस ट्रॉमा, आई थिंक हर्निया इज समवेयर हियर, इट शुड बी देयर. अगर हर्निया नहीं है तो एक स्लाइड डालेंगे, कोई दिक्कत नहीं. ऐसा आई विल मेक श्योर दैट नो और नन ऑफ यू गो हाफ हार्टेड फ्रॉम अ सर्जरी लेक्चर. उतना तो टेंशन मत लो, पूरा कर देंगे, ठीक है. नाउ we talk about skin grafts. The two varieties of skin grafts that you have, the partial thickness skin graft and the full thickness skin graft. Partial thickness skin graft को हम 𝐒𝐻 graft बोलते हैं, full thickness को Wolffi's बोलते हैं, ठीक है. In a partial thickness skin graft, I'll take the epidermis and a part of dermis. In a full thickness, I'll take the entire thickness of dermis as well, ठीक है. So when you talk about Wolffi's and the partial thickness skin graft, 𝐒𝐻 में it is only a combination of epidermis. It's a combination of epidermis. Along with that, I will take a part of dermis. Along with a part of dermis. Wolffi's में क्या है? I will take the epidermis. Along with that, the entire thickness of the dermis will be taken. The entire thickness of the dermis will be taken. ठीक है? चलो. Now, what is the device used to extract the graft? It is the Humbee's knife, or also called as an electric dermatome. Both are same for both partial thickness and full thickness skin graft. How do you know that you have taken? Because मैंने बोल तो दिया है कि epidermis and part of dermis. ठीक है? How do you know you have taken a correct thickness? After you extract the graft, if you see presence of punctate hemorrhage from the donor site, you have taken partial thickness. But if the subcutaneous fat is exposed, you have taken a full thickness skin graft. That is how you determine, and that's your previous exam question also, that how do you determine that you have taken the correct thickness of the graft? If there is only bleeding, that is presence of punctate hemorrhage at the site of donor, it is partial thickness. If the subcutaneous fat is exposed, it is your full thickness skin grafting. Right? So let's look at the donor side, what is going to happen. In a partial thickness skin graft, the donor side defect, it is a temporary defect. It is a temporary defect, whereas here it is going to be a permanent defect. Scar, there is no scar here. There will be a scar which will be left behind. Because it's a temporary defect and it does not leave any scar, you can take any size. But in a full thickness, we only prefer a small graft because it leaves a permanent scar or a defect there. Repeated grafting can be achieved from the donor side. Repeat grafting from the donor side is not possible. The most common site is going to be thigh for a partial thickness and retroauricula, that is behind the ear, to prevent any cosmetic issues. No. So most common site, this is going to be thigh partial thickness, retroauricular. Retroauricular behind the ear, that is for your full thickness skin grafting. Now look at the graft survival. Partial thickness graft requires less amount of nutrient to survive. So graft survival is good here. Full thickness require more nutrients, so it is poor. The graft contractures are two types. Now this is important concept. थोड़ा ध्यान से सुनना. Skin grafting में ना, whenever you take the graft, there are two types of contractures. You have the primary contracture and the secondary contracture. Primary contracture क्या होता है? आपने ये imagine करिए. Imagine it this way. Give me a second. This is the donor side. This is the skin graft that you have. ठीक है? Now the minute you take the graft out, यहाँ से हमने graft निकाला, the graft is extracted. As soon as you remove, there will be immediate contraction. This immediate contraction of the graft is called as primary contracture. उसके बाद ये आपका रेसिपिएंट साइट है, यहाँ पे जाके लगा दिया और धीरे 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 ये सुकड़ता रहेगा. दिस स्लो कॉन्ट्रैक्चर इज कॉल्ड एज सेकेंडरी कॉन्ट्रैक्चर. जैसे ही निकाला कॉन्ट्रैक्ट हुआ प्राइमरी डोनर से रेसिपिएंट साइट पे निकाला कॉन्ट्रैक्ट किया, इट इज कॉल्ड एज सेकेंडरी कॉन्ट्रैक्चर. सो कॉन्ट्रैक्चर दैट अकर्स इमीडिएटली ऑन एक्सट्रैक्टिंग फ्रॉम द डोनर साइट इज कॉल्ड एज प्राइमरी. आफ्टर पुटिंग ऑन द रेसिपिएंट साइट व्हेन इट कॉन्ट्रैक्ट्स, इट इज कॉल्ड एज secondary contracture. ठीक है? Now when you look at the both these components, in primary of partial thickness, it is the secondary contracture is more than primary. Here primary is more than secondary. जिसका सेकेंडरी कॉन्ट्रैक्चर ज्यादा होगा उसका कॉस्मेटिक आउटकम पूर होगा. जैसे अभी बताया था ना कि सेकेंडरी कॉन्ट्रैक्चर क्या है. सेकेंडरी कॉन्ट्रैक्चर वो है कि रेसिपिएंट साइड पे लगाने का धीरे 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 सुकड़ रहा है. अगर ज्यादा सुकड़ेगा तो मतलब इट विल बिकम वेरी क्रम्पल्ड, इट विल हैव अ वेरी पुअर अपीयरेंस. सो कॉस्मेटिकली गंदा दिखेगा. तो सेकेंडरी कॉन्ट्रैक्चर किसका ज्यादा है? पार्शियल थिकनेस का. सो कॉस्मेटिक आउटकम विल बी पुअर, द कॉस्मेटिक आउटकम विल बी गुड. ठीक है? सर्वाइवल जिसका अच्छा है, कॉस्मेसिस उसका गंदा है. कॉस्मेसिस जिसका अच्छा है, सर्वाइवल उसका गंदा है। यही आपकी नीत है। तो भगवान हमेशा बैलेंस करता है कि बच लो या दिख लो। तो डिपेंड्स अपॉन दैट। इफ यू वांट द कॉस्मेसिस, द आउटकम इज पुअर. इफ यू वांट द आउटकम, द कॉस्मेसिस इज पुअर. एंड वी आर ट्राइंग टू सॉर्ट द बैलेंस बिटवीन दीज टू. क्लियर? ठीक है. Now, what are the reasons for graft failure? Now, common reasons for graft failure. In fact, the most common cause for the graft failure that is going to occur, it is going to be your hematoma formation. After that, you have seroma. All these, both of them can be prevented by doing a small technique which is called as pie crusting. This is going to be pie crusting. Now, in pie crusting, you will make small holes on the graft site so that the seroma and hematoma can get evacuated. Pie crusting prevents. So, what does pie crusting do? There are two things. Pie crusting, it is going to prevent hematoma. It is going to prevent the hematoma and seroma collection. It is going to prevent the hematoma and the seroma collection, not the formation. ये collection prevent करता है. On the other hand, it increases the surface area of the graft. It increases the surface area of graft anywhere between 1.5 to 6 times. Anywhere between 1.5 to 6 times. So, this increases the surface area of the graft. Okay. The other ones is repeated movement at the graft site. To prevent that, you have to do a joint immobilization. Infections can prevent. That is why, remember, presence of beta hemolytic streptococci. Presence of beta hemolytic streptococci is an absolute contraindication for skin grafting. It is an absolute contraindication of skin grafting. And if there is absence of periosteum in the bone, again it will cause graft failure. So these are about the skin grafts. Okay? Now you have cleft lip and cleft palate. Repair timings are important. Again, a quick recap on both of them. So if you have a unilateral cleft lip, you have to repair between 5 to 6 months of age. If you have a bilateral cleft lip, it has to be repaired between 4 to 5 months of age. Your soft palate should be repaired at 6 months. Your hard palate should be repaired between 15 to 18 months. So this is the repair time that you have to remember. On the other hand, if you have a cleft palate which is both soft and hard, this has to be repaired in 2 surgeries. The first surgery is going to be your soft palate. So at the 6 months of age, I will do a soft palate repair. The second surgery will be done between 15 to 18 months of period, and that is going to be a repair of a hard palate. Now, if you have cleft lip and palate both, right, it is unilateral. So this will also require 2 surgeries. The first surgery will be done between 5 to 6 months of age. So here I will repair the cleft lip and the soft palate. The second surgery will be done between the age of 15 to 18 months. Here I will repair hard palate. Okay? On the other hand, if you have bilateral cleft lip with cleft palate, again this will also require 2 surgeries. In this, the first surgery will be done between the age of 4 to 5 months. In this 4 to 5 months, we will repair lip and the soft palate. And the second surgery must be done between the age group of 15 to 18 months. And here I am going to repair the hard palate. So these are the timings of the repair and the criteria for repair to be done. As simple as this, right? So this concludes your plastic component that has to be revised for your exam. ठीक है? Clear? Clear? कोई सवाल, कोई शक, anything that you want to ask, quick feedback? Can we continue? Can we continue? Quick feedback. Quick feedback. चलें? ठीक है. Then you have the nutrition. So we'll be talking about the TPN. TPN stands for Total Parental Nutrition. Total Parental Nutrition. Now, what is the current indication for TPN? The first indication is a short bowel syndrome. It is a short bowel. It is a short bowel syndrome, right? So what is the criteria for short bowel? Remember, if the length of the small intestine, is less than 200 centimeters, it is what we call it as the short bowel syndrome. It is a short bowel syndrome. But after nutrition, we'll take the break. You can have your lunch. 3 o'clock, you will have the next session. And then we will... बेटा चाय भी पी लेना, खाना भी खा लेना, कोई दिक्कत नहीं है. 2:30 बजे, मतलब once you're done with the nutrition, I'll give you the break, and then after the break, you'll have a new session. And after the new session, रात को हम बाकी अपना systemic surgery का component start करेंगे, ठीक है? So जल्दी से अपने nutrition खत्म कर लेते हैं. High output enterocutaneous fistula, it is when the output is more than 500 ml in 24 hours. Then you have presence of active inflammatory bowel, that is acute active inflammatory bowel disease, initial phase of acute pancreatitis, and prolonged ileus, which is beyond 72 hours. These are the current indications for your total parenteral nutrition. बेटा PDF मिलेगा, मैं क्या करूँगा PDF रखे, PDF मिलेगा. दिमाग नहीं चल रहा, ओके. हमने क्लास शुरू की थी 11 बजे, तो 12, 1, 2, 3 घंटे का मिनिमम अटेंशन स्पैन होना चाहिए, ठीक है? 2:30 बज रहे हैं, बीच में आपको ब्रेक मिला था क्योंकि इंटरनेट का कुछ इश्यू हुआ था, ठीक है? तो मतलब टेक्निकली आप 3 घंटे पूरे बैठे नहीं हो, तो बिठा के ही छोड़ूंगा मैं, राइट? चलिए, so what is the composition of TPN? So when you look at the total parenteral nutrition, you have following components. In this, the maximum is of carbohydrates. The carbohydrate accounts for 40 to 50% of total, and they are going to account for an energy release of 3.5 kilocalories per gram. ठीक है? Fat is going to be between 30 to 40%. It is going to be 30 to 40%, and it gives you 9 kilocalories per gram. It gives you 9 kilocalories per gram. Protein is going to be 10 to 20% by volume, and this is going to release 4 kilocalories per gram. Vitamin is negligible, trace elements is negligible, and they do not contribute to any of the energy component. Now, how will they ask you question? So the previous exam question that you can see in an energy is, they said a patient who is receiving a diet, right? Now he is getting, let's say, 10 grams of carbohydrate. He is getting 10 grams of carbohydrate. He is getting 50 grams of proteins. And he is getting 10 grams of fat, right? What is the total energy that he is going to receive? What is the total energy that he is going to receive? So carbohydrate, we know it is going to be 3.5 kilocalories. So it is 3.5 kilocalories. So 10 grams khaya hai, so it is going to be 35 kilocalories. This is the energy. Protein ka we know it is 4 kilocalories per gram, and you have 50 of this, so which is going to be 200 kilocalories. ठीक है? Fat का मुझे पता है, it is 9 kilocalories per gram into 10, it is going to be 90 kilocalories. So when you look at the total energy कितना हो गया? 290 plus 30 कितना हो गया? 290, 300, 325. So it is 325 kilocalories is the total energy. And this was your previous exam question. They asked you, how do you calculate the energy that is delivered by this? ठीक है? Clear? So this is with respect to nutrition and its component. Clear? 1035 कैसे हो गया? 1135 शुभम नहीं यार, 325 है. 10 50 10 है, 100 नहीं लिया है. ठीक है? So this is in terms of your general surgery. ठीक है? So we're going to stop here. ठीक है? We'll take a break, go have lunch, relax a bit, get prepared for the next session, and remember, you will have part 2. ठीक है? I'll make sure the team knows it. 9 बजे एक ब्रेक ले लोगे, 9:30 हम फिर शुरू करेंगे फॉर अ सिस्टमिक सर्जरी, ठीक है. सो अंटिल देन थैंक यू सो मच. इफ हैव एनी क्वेश्चंस, एनी क्वायरीज, मीनवाइल नो, अगर यू वांट टू रीच आउट टू मी, लेट्स से अगर आपको अभी कुछ लग रहा है कि कुछ क्लियर करना है, यू कैन फॉलो मी ऑन द इंस्टाग्राम, दैट इज योर सर्जरी गाई, ठीक है. इट इज बाय माय नेम ओनली. ये इंस्टा टेलीग्राम दोनों ग्रुप है, टेलीग्राम ग्रुप है वेयर आई शेयर माय नोट्स एज वेल, एंड दिस विल बी शेयर्ड बाय योर पीडब्ल्यू और मेडेड टीम एज वेल. This is by me, that is a Dr. Sandeep Seram Reddy. If you want to connect directly, if you have any questions, any queries, or any MCQ that you want to go, just go send across here. बेटा यूरो भी है ना, यूरो अपना लास्ट है, जीआईटी के बाद अपना लास्ट स्लाइड यूरो का है. तो ये पूरा यूरो है ना बेटा, यहाँ से यूरो शुरू हो जाता है. नेफ्रोलिथियासिस है, यू हैव बीपीएच, यू हैव द स्टेटस, देन यू हैव अनडिसेंडेंट ट्यूमर्स, इमेजेस एंड ऑल दैट, ठीक है. बेटा it is the surgery guy. YouTube channel is also on the surgery guy. Whatever you want, most of them will be found on your YouTube in PW Meded only. PW ke Meded ke channel pe you will find all my lecture videos also. Everything that you have will be there. So don't worry. Go have some fun. Thoda khana na kha lo, relax kar lo, follow kar lo. If you have any questions, any queries, reach out there. Will reach, because see, if you follow the Insta, you'll get the all the latest updates. कोई भी session हो रहा है, कोई भी class हो रही है, कोई भी discussion हो रहा है, any MCQs that are putting will be from here as well. So thank you so much. The Insta name is Surgery Guy. It is the Surgery Guy, and it's by my name, Dr. Sandeep Seram Reddy. ठीक है बेटा. both Insta and Telegram दोनों यही है, Telegram और Insta दोनों में यही है, the Surgery Guy, ठीक है. It is by name, that is Sandeep Seram Reddy, right? So thank you so much. We'll resume back at 9:30. Be prepared. थोड़ी सी एनर्जी बचा के आना, थोड़ा सा जोश लेके आना. I will give you the best surgery revision. That's a promise. ठीक है. रात को 12-1 बज जाएंगे, लेकिन I am telling you, आप पूरे दिल के साथ खुश होके सोओगे, and that is going to be my gift for your exam. Happy Christmas, Merry Christmas. See you again. ठीक है. चलो. ओरल कैंसर, ब्रेस्ट कैंसर की स्टेजिंग से INICT में 5 क्वेश्चन थे सर. बेटा ओरल कैंसर्स, यस वी विल टेक केयर. देखो TNM एंड ऑल जो कवर कर सकते कर रहे हैं, FMG के लिए जो एग्जाम के लिए इंपॉर्टेंट है, दैट वी आर ट्राइंग टू गो अक्रॉस इट. आई डोंट थिंक ओरल कैंसर्स की TNM विल बी आस्क्ड इन FMG, बट आई विल डेफिनेटली गिव यू द ओरल कैंसर्स TNM एज वेल, ठीक है. वेयर टू गेट द PDF? द PDF विल बी शेयर्ड ऑन दिस ग्रुप, दैट इज द सर्जरी गाई. इट विल आल्सो बी शेयर्ड ऑन द PW Meded एज वेल, राइट. सो थैंक यू, हैव फन, ठीक है. आई एम गेटिंग अ कॉल अगेन, ठीक है. चलो, take care. We'll resume back at 9:30. Bye.
Hi students, welcome to our FMGE Decoded session. I think you must be in hypoglycemia, not hyperglycemia right now. Okay, no problem. For the next 2 hours, we are going to complete a short revision on pediatrics. Hope you have covered your surgery well. Let's start with pediatrics. Now the time is exactly 3 p.m. Let's start our session. Right. If at all you want to post something, you can post in chat box. I'm watching the YouTube. We start with the neonatal resuscitation. You all know that the most important aspect of pediatrics is newborn. In newborn, we have neonatal resuscitation. Some of the latest thing and the older things that are frequently asked in our FMGA has been included in this session. Right. So right now we have something called delayed cord clamping. What do you mean by delayed cord clamping? Delayed cord clamping is nothing but you are clamping the cord 30 seconds to 60 seconds after birth. Okay. So point number one, delayed cord clamping means it is 30 to, yes, delayed cord clamping means it is 30 to, what is this? It is 30 seconds to 60 seconds after birth. That is called delayed cord clamping. What do you mean by sniffing position? We usually call as whenever any child is born, we will put the child in sniffing position. What do you mean by sniffing position? What is the role of this sniffing position? In neonatal resuscitation, sniffing position is nothing but putting the child under a, okay, under a roll of towel. Putting a child under a roll of towel. The towel is under the shoulder. Roll of towel under the shoulder. That is called sniffing position. In sniffing position, you usually have your trachea, nose, trachea, and then nasopharynx. All will be in a straight line. All will be in a straight line. Put you keeping a roll of towel under the shoulder blade of a newborn is called sniffing position, so that your nose, nasopharynx, and trachea will be in a straight line, so that it can augment the airflow into the lungs. Right. Right. What do you mean by? So you put the child under, you put the child over the roll of towel, and then you need to suction. What will you suction first? Suctioning of mouth or suctioning of nose? Usually you need to suction the mouth followed by suction of nose. Suctioning should be, mouth should be sucked out first followed by nose. Why is it so? Because whenever you suck nose, what will happen? The child your child respiratory effort will increase, and this respiratory effort in turn, when the child starts to cry, all the secretions that are present in the mouth will be engulfed inside the trachea. That's why you clear the secretions that are present in the trachea, followed by secretions that is present in the nose. So always suctioning of the mouth followed by suctioning of nose. What is the single most effective step in apnea? Can anyone tell me what is the single most effective step in neonates with apnea? Very very simple. Single most neo first 30 seconds you will do initial steps of resuscitation. Next 30 seconds you will allot time for tactile stimulation, and when the child doesn't cry at the end of 1 minute, the golden hour is at the end of 1 minute, you need to start positive pressure ventilation. So that is the most important thing. Positive pressure ventilation is nothing but your bag and mask ventilation, right? What is the contraindications for positive pressure ventilation? Definitely meconium aspiration is not a contraindication for positive pressure ventilation. In 2004 neonatal resuscitation guidelines, meconium aspiration was a relative contraindication, but right now meconium aspiration has been removed as a contraindications in cases of apnea which requires positive pressure ventilation. An absolute contraindication is congenital diaphragmatic hernia. Is congenital diaphragmatic hernia. Why? Whenever you do positive pressure ventilation in the presence of a congenital diaphragmatic hernia, what will happen? The air that goes into the intestine will enlarge and occupy the spaces of the lungs in the thorax, leading on to further increase in respiratory distress. That's why positive pressure ventilation is contraindicated in congenital diaphragmatic hernia. Then, so as I told you already, which is not a contraindication, is meconium aspiration syndrome, which is absolutely not a contraindication for positive pressure ventilation. Chest compression, we have previously we have two things. One is two thumb technique, another is two finger technique. Two finger technique, another is two thumb technique. Which one is followed right now? Invariably we are following two thumb technique, not two finger technique. Two finger technique we are not following at present. Which one? Two finger technique. Right. Only medication for resuscitation is dash. What are all the drugs we are used in resuscitation? Can anyone tell me? Can anyone post in chat box? What are all the medications that are used in resuscitation? Let me give you a clue. RL, NS, O negative blood, DNS. What are all the drugs that can be used? What are all the drugs? And then let me tell you adrenaline. Among this, what are all the drugs that are used right now in neonatal resuscitation? Whether even after giving bag and mask ventilation as well as chest compression, even after 1 minute of successive bag and mask ventilation or bag and tube ventilation along with the chest compression, if the child doesn't show increase in heart rate, invariably you need to go for medications. What are all the medications? Can anyone chat? Can anyone post in the chat box what are all the medications? Previously people have been using RL, but right now RL is not used, should not be used. Why RL should not be used? Because whenever you have a birth asphyxia, there is an underlying lactic acidosis. This lactic acidosis in turn will be worsened by giving RL. So don't give RL. First MCQ. Second in the MCQ, the drug of choice for shock correction is normal saline bolus. Okay, 10 ml of 10 ml per kg of normal saline bolus is the drug of choice. Yes, you can give this normal saline. At times, when the child is not responding to normal saline bolus, you will tend to give O negative blood. You will tend to give O negative blood. It is not DNS. Whenever there is, we don't treat hypoglycemia immediately after birth. We do not concentrate on all those things. We concentrate only on shock. So despite that, if the child is not showing any improvement with respect to increase in heart rate, what is the thing that you need to do? You need to give adrenaline. So adrenaline, the answer is yes. The normal available adrenaline is 1 ml. You need to dilute with 9 ml of normal saline, so that you will get 1 in 10,000 adrenaline. This 1 in 10,000 adrenaline can be given through ET tube, or can be given through umbilical vein, or can be given through peripheral vein. Umbilical vein, peripheral vein, ET tube, or it can also be given through interosseous route. Very, very important. All drugs can be given through intraosseous route. Very, very important. So your adrenaline can be given through intraosseous route. The drug that we use, the strength that we use with respect to neonatal resuscitation with the profound shock is 1 in 10,000 adrenaline. What is the dosage? 0.1 ml per kg to 0.3 ml per kg we can use. Okay. This is about adrenaline. So the drugs that we use in neonatal resuscitation are normal saline bolus, one. Second one is O negative blood. Third one is adrenaline. Rest of the things we do not use. Methadone we don't use. DNS we don't use. RL is contraindicated. Not use. It is absolutely contraindicated. Right. Okay. So as far as the neonatal resuscitation is concerned, what are all the new things that you need to know? Delayed cord clamping should be followed. It is nothing but cord clamping 30 seconds to 60 seconds after birth. Suctioning of mouth should be followed by suctioning of nose. And then sniffing position is nothing but keeping a roll of towel under the shoulder blade. At the end of 1 minute, you need to start positive pressure ventilation. right? And then only contraindication is congenital diaphragmatic hernia. Meconium aspiration syndrome is not a contraindication. For chest compression, you need to use two thumb technique rather than two finger technique. You can use RL. You cannot use RL DNS, but you can use normal saline, O negative blood, and adrenaline for shock correction. Remember, if the best vein is umbilical vein, the better veins are peripheral vein. If nothing can be possible, that adrenaline can be given through endotracheal tube. And even if you can't get endotracheal tube, the same can be given through intraosseous route. I repeat, this can be a potential question for you. Intraosseous route can be a potential question for you. So this is a short revision with respect to neonatal resuscitation. Right. Now let's come to trace element deficiency. Again, you all know that the majority of your questions are concentrated on vitamins and trace elements. So let's concentrate on trace element deficiency. You would have read about a vitamin deficiency and its manifestations. In concept 2, we are going to concentrate on trace element deficiency. So if it is possible for you, in order to disturb your sleep, I will request you to post the answer in chat box so that it will be easy for me to interact with you. Right. First question, microcytic hypochromic. So let me choose iron, selenium, copper, chromium, zinc, magnesium, molybdenum. All can be your choice. So from these choices, kindly pick the answer. The first question, microcytic hypochromic anemia not responding to iron. What do you not responding to iron with the neutropenia and the hair pigmentation is dash. Answer, anyone? You all know that what are all the things that can cause iron deficiency anemia? You can have thalassemia, you can have iron deficiency anemia, sideroblastic anemia, lead poisoning, as well as anemia of chronic deficiency, chronic disease. Anemia of chronic deficiency, thalassemia, sideroblastic anemia, iron deficiency anemia, lead poisoning, or deficiencies associated with microcytic hypochromic anemia. But my question is lead poisoning, not deficiency. My question is, now I have a child in which there is a microcytic hypochromic anemia. Apart from, and you are treating the child with iron, but the child is not responding, but the child is having underlying neutropenia along with the hair depigmentation. So what is the answer? Can anyone tell me? What is the answer? Yes, very good. It is nothing but copper deficiency. Copper deficiency is associated with iron resistant iron deficiency anemia, that is microcytic hypochromic anemia, along with the hair depigmentation and neutropenia. Copper deficiency. Second one, hypocalcemic tetany not responding to calcium infusion means whenever any child has brought with tetany, invariably you will consider hypocalcemia, and the treatment of hypocalcemia is calcium gluconate infusion. Okay, but after giving calcium gluconate infusion, the tetany should disappear. If the tetany does not disappear even after giving calcium infusion, what underlying deficiency that the patient has or the child has? Can you tell me what is the answer? What is the answer? Okay, hypocalcemic tetany not responding to calcium infusion is magnesium deficiency. So the answer is magnesium deficiency. Very, very important. Clinically, the child is having all signs and symptoms of hypocalcemia, but serum calcium level is normal. Think in terms of underlying magnesium deficiency. Right. What trace element is associated with cardiomyopathy? You all know that the trace element that is associated with cardiomyopathy is selenium deficiency, and chromium deficiency is associated with glucose intolerance. And finally, what is this? Whenever you have a combination of hypogonadism reduced cell-mediated immunity along with the periorifacial and perianal erythematous rash. What is this? The answer lies in the explanation itself. Periorifacial, perianal erythematous rash along with hypogonadism and recurrent infection. Yes, you all know it is nothing but acrodermatitis enteropathica caused due to underlying zinc deficiency. And then neonatal goiter. Neonatal goiter, you all know what is that? Iodine is the one associated with neonatal goiter. What are all the three conditions that can associated with the neonatal goiter? Because the most common cause for hypothyroidism, congenital hypothyroidism, is thyroid dysgenesis, in which thyroid will be absent. But when a child is born with hypothyroidism but goiter instead of absence of thyroid, means what are all the three conditions? Yes, what are all the three conditions? One is iodine deficiency, endemic iodine deficiency, causes for neonatal goiter. Second one is dysharmonogenesis. Second one is dysharmonogenesis. What do you mean by dysharmonogenesis? Whenever you have any deficiency in underlying enzymes involved in the production of thyroid hormones are defective, then it will lead to goiter. One such famous deficiency that can produce dysharmonogenesis is thyroid peroxidase deficiency. Third one is antibody against maternal TSH. Antibody against maternal TSH. All these three things are associated with neonatal goiter. Very, very important. Are associated with neonatal goiter. Right. So some trace elements that are often asked in our entrance examination has been discussed. Right. Let's go to inspiratory sound. So let me tell you. So respiratory noises, definitely one respiratory noise will be asked, and with respect to whether which phase of respiration, whether it is inspiration or expiration, will definitely be asked, and associated conditions that can produce this respiratory noise. Okay, TK, get ready. Right. So you have inspiratory sound. You have two things. One is you have inspiratory sound. Another one is you have expiratory sound. Inspiratory sounds are stutter, snoring, stridor, and rattles. Stutter is due to presence of nasal secretions. What you will call it as conducted sounds is nothing but stutter, otherwise known as due to nasal secretions produced by acute viral coryza. Snoring. Snoring, so in stutter, the cytopathology is nose. In snoring, what will happen? The cytopathology is nasopharynx. Nasopharynx. And what is the pathology? Adenoid is the pathology. Stridor. Stridor means the problem is in the where? Stridor means problem is in the larynx. The problem is in the larynx. Most common cause is laryngomalacia. And then what do you mean by rattles? Rattles are nothing due to presence of secretions in larger airways such as trachea or bronchus. Presence of secretions in the nose is called stutter. Presence of secretions in the larger airways in trachea or bronchus producing sound is called as rattles. Snoring is inspiratory noisy breathing due to the presence of adenoid in nasopharynx. Stridor is due to laryngomalacia. Right. Grunting and wheeze. What might be the question pattern? The following are inspiratory sounds, except they can ask you, or they can ask you the child is having severe respiratory distress. You could hear some kind of like sound. So what is this sound called? That sound is called as grunting. So now you know both grunting and wheeze are expiratory sounds. I repeat, both grunting and wheezing are expiratory sound, but grunting arises as a result of pulmonary parenchyma, otherwise known as parenchymal pathology. For example, in newborn, it can be due to hyaline membrane disease. For in grown-up child, it can be due to pneumonia. Due to pneumonia. And then what is this wheeze? Wheeze, again it is an expiratory sound. Here the site of obstruction is bronchus. Site of obstruction is bronchus. And finally, where you will get this biphasic stridor, where you will get biphasic stridor, entrance MCQ. Biphasic, usually you all know that stridor is a noisy breathing that occurs during inspiration. But when you hear stridor during both inspiration and expiration, where is the site of pathology? Can anyone? Can anyone? For biphasic stridor, which hears during both inspiration and expiration, the site of localization is subglottis. The site of localization is subglottis. Usually, it can be due to subglottic stenosis following subglottic stenosis. Okay, subglottic stenosis following previous intubation, or it can be due to hemangioma, or it can be due to hemangioma. This one MCQ, another important MCQ, where you will get monophonic wheeze. Where you will get monophonic wheeze. You all know that wheeze is a feature of asthma due to expiratory airway obstruction. You have one note here, another note here, another note here, another note here. That is polyphonic wheeze. Polyphonic wheeze is a feature of asthma, whereas monophonic wheeze means there is a fixed obstruction inside the bronchus. For your level, any monophonic wheeze which doesn't respond to your bronchodilator is foreign body unless otherwise proved. So this is a potential question. So two potential questions in noisy breathing are, so definitely you know snoring, you know stridor, but you will be wonder what is the difference between stutter. Stutter is due to presence of secretions in the nose, whereas a rattle is due to presence of secretions in the larger airways like trachea or bronchus. Grunting and wheeze are both are expiratory. Grunting, a lung parenchymal pathology or pneumonia, whereas wheeze is due to expiratory airway obstruction. Biphasic stridor, subglottic stenosis, whereas monophonic wheeze is a cause for monophonic wheeze. The most common cause is foreign body in either right main bronchus or left main bronchus. So these are some of the potential questions that can be asked with respect to respiratory noises. Now, definitely there will be questions with respect to breast milk. Okay. And with respect to breast milk, immediately in the first 4 days, and then from 4 days to 7 days, and then second week. So there are three natures of breast milk you have. In the first 4 days, what you will call it as colostrum. Colostrum is nothing but nature's first vaccine, because it contains that much of rich immunoglobulin. Why? Because it contains secretory immunoglobulins in plenty. Which one? Colostrum. Okay. Colostrum is always yellow thick, as I told you, rich in immunoglobulin. It is usually secreted in the first 3 to 4 days of 4 days after birth, whereas transitional milk usually secreted from the 4th day, usually up to 1 week or sometime up to 2 weeks. Here, this transitional milk is rich in sugar, but your immunoglobulin and protein contents are poor. So what does it mean? Immediately after the childbirth, the priority is given to immunity, because the child has to face so many infections, as a result of which colostrum is meant for fighting against microorganisms. So it is rich of immunoglobulins, whereas after 4 to 5 days the child will be having so much of appetite, so that your transitional milk should contain much of fat, so that it reduces the appetite along with the sugar. So immunoglobulin content of your breast of transitional milk will be poor. And then finally, mature milk. Look here, mature milk usually is thin and watery. Mature milk is usually thin and watery from 2 weeks of life. Thin and watery from 2 weeks of life. Again, you have two more questions. One is fore milk, another is hind milk. Fore milk is secreted in the first part of the breast milk secretion, whereas hind milk occurs usually in the later part of the secretion. Fore milk is meant for thirst, whereas hind milk is meant for energy. Hind milk is in for energy. So as I told you already, fore milk is meant for thirst. Beginning, water content is high, so thirst will be satisfied, quenches thirst. Whereas hind milk, it contains predominantly carbohydrates and sugars to provide the energy to the newborn, and it produces appetite. Right. Transitional milk, as I told you already, 4 days to 2 weeks, and your colostrum contains much of immunoglobulin and less of energy, much of immunoglobulin and vitamin A, D, E. Right. Fore milk and then hind milk. Okay, right. So some short fast revision. Okay. Now, what is this? Whenever any child is brought with the cough while feeding and frothing, what is the answer? Any newborn is brought with the cough while feeding and frothing. What does it mean? Yes, you are correct. It is a case of brachioesophageal fistula. Case of brachioesophageal fistula. When any newborn develops bilious vomiting, what does it mean? Bilious vomiting in newborn period is always due to malrotation unless otherwise proved. Malrotation unless otherwise proved. Which one? Bilious vomiting, right? Some of the other surgical conditions or surgical respiratory conditions in newborn. So some surgical conditions in newborn, what are all they? Surgical conditions. So newborn with respiratory distress and reduced air entry on the left interscapular area. So what is that? Newborn with respiratory distress and reduced air entry on the left scapular area. Do not think about foreign body. Whenever air entry is reduced, invariably any child is brought with the cough and sudden onset air entry reduction, you will think in terms of a foreign body. But as far as newborn is concerned, it is usually I repeat, congenital lobar emphysema. What is that? It is due to congenital lobar emphysema. Okay, I'll show you the picture at the end of this session. When any newborn not passing stools within 24 hours, when any newborn not passing stools within 24 hours, always you need to suspect Hirschsprung's disease. Newborn with meconium ileus, what should be ruled out? Can anyone tell me? A newborn, you are seeing the newborn has got peritonitis due to intestinal perforation. Underlying etiology is meconium ileus. What disease that can produce meconium ileus? Yes, it is cystic fibrosis. Cystic fibrosis, which one? Newborn with meconium ileus. So what is that classification? Next MCQ. What is that Krickenberg classification is meant for what malformation? It was asked 4 years back. What is this? Krickenberg classification is mainly meant for anorectal malformation. What is that? Anorectal malformation syndromes. Right, anorectal malformation syndrome. Which one? Krickenberg classification. Only once it was asked. Right. What is the normal newborn temperature? Very good. Very, very easy. 36.5 to 37.5 degrees Celsius. Mild hypothermia or cold stress? Very, 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 very important question. Mild hypothermia or cold stress is 36.5 to 36 degrees Celsius. This is called mild hypothermia. 36 to 36.5 is called as mild hypothermia. Other name is cold injury. Other name is cold stress. This will often be asked. Regarding moderate hypothermia, 32 to 34, 32 to 36 often will not be asked. Severe hypothermia less than 32 also again will not be asked. The most important question with respect to neonatal temperature is mild hypothermia, means 36 degrees Celsius to 36.5 degrees Celsius. Otherwise, it is called cold stress or cold injury. Right. So moderate hypothermia, severe. Severe means less than minus 32 degrees Celsius. Moderate means 32 to 36 degrees Celsius. Right. Abdomen is warm. So now you have a child, when you keep two hands, one hand over the abdomen and another hand over the foot. When the hand over the foot is cold and hand over the abdomen is warm, this is called cold stress or cold. This is called cold stress or cold injury. Okay, this is called cold stress or cold injury. Which one? Warm. Foot is warm to touch and foot is cold to touch and abdomen is warm to touch. Right? So, as far as hypothermia is concerned, newborn is mainly based on non-shivering thermogenesis because they don't have a good muscle power. Which one is responsible for this non-shivering thermogenesis? Exactly, it is brown fat. Brown fat. The mechanism of action. What is the mechanism of action? Can anyone tell me? Brown fat. Uncoupling of oxidative phosphorylation. Very important. Uncoupling of oxidative phosphorylation. In case of non-shivering thermogenesis through brown fat. What is this? Neurotransmitter involved. Very, very important. Neurotransmitter involved is norepinephrine. Neurotransmitter involved is norepinephrine. Very important. Neurotransmitter involved is norepinephrine with respect to hypothermia. Brown fat. Okay. So what are all the potential questions that can be asked with respect to temperature regulation? Cold stress means 36 to 36.5. Brown fat mediated non-shivering thermogenesis occurs. It is mediated through norepinephrine. In it, uncoupling of oxidative phosphorylation occurs. Instead of ATP production, energy will be released as heat. That is called uncoupling of oxidative phosphorylation. So this is with respect to neonatal temperature regulation. And then what are all the torch infections? Okay, torch infection, the one which produces periventricular calcification is cytomegalovirus, whereas the diffuse calcification is often produces toxoplasmosis. When you have a triad of cataract, sensory neural deafness, and PDA, it is congenital rubella syndrome. Whenever you have three C's, nothing but calcification, chorioretinitis, hydrocephalus. This 3C is a combination that can occur in toxoplasmosis. Persistent rhinorrhea, pseudoparalysis, notched central incisor. Very, very easy. Okay, whenever you have a running nose occurring for about weeks or months together, that too particularly in a child with a skin rash and not able to move limbs due to pseudoparalysis because of the subperiosteal hemorrhage, this condition occurs in syphilis. Remember, only infection that can cause fever in newborn is herpes virus. The rest of the infection do not cause fever in newborn. Fever in newborn occurs in only in two conditions, entrance MCQ. One is herpes, second one is malaria. Except these two, none of the infections can produce fever in neonatal period. Only torch infection that can cause recurrent abortion. Remember, majority of the torch infection can lead to preterm microcephaly, hepatosplenomegaly. Okay, but right now some torch infections can present even antenatally by producing abortion. One such torch infection and only one such torch infection that can produce abortion is cause recurrent or abortion is syphilis. Recurrent abortion is syphilis. Rest of the infections does not cause any mortality, but syphilis will produce mortality and morbidity. Mortality as well as morbidity. Right. Now, okay, some important aspects of torch infection over. Let's go to then kwashiorkor and marasmus. Kwashiorkor and marasmus. You all know that kwashiorkor is mainly due to protein depletion. Marasmus is due to subcutaneous energy deficiency leading to loss of subcutaneous fat. Kwashiorkor, loss of protein, hypoalbuminemia leading on to hepatomegaly. Leading on to hepatomegaly. Which one? Right. Kwashiorkor. Whereas marasmus is characterized by absence of subcutaneous fat in the cheek. leading to monkey faces, and absence of subcutaneous fat in the buttock, leading to baggy pant appearance. These two are characteristic features of marasmus. But what is the characteristic feature of kwashiorkor? Kwashiorkor is characterized by apathy, that is inability to eat more because of anorexia. Hepatomegaly due to hypoalbuminemia, and because of poor protein source, what will happen? There will be flaky paint dermatosis. The proteins that are present in the skin will fall away. That is called as flaky paint dermatosis. And another important sign is flax sign. Alternative areas of pigmentation and depigmentation is called as flax sign. So now you have, what are all the features? The features of marasmus. Marasmus, baggy pant appearance, loss of subcutaneous fat in the gluteal region. Monkey faces, okay. Monkey faces, loss of subcutaneous fat in the buccal cavity. And then flaky paint dermatosis and flax sign. Flaky paint dermatosis, kwashiorkor. Flax sign, okay, flaky paint dermatosis, and then flax sign. Alternative areas of pigmentation and depigmentation usually occurs in, again, kwashiorkor. Okay, now very important. Whenever you start treating a case of severe acute malnutrition, you all know that there are 10 steps in severe acute malnutrition. I am not going to ask you about all those questions that may need not be asked in entrance examination, but you need to know what is this lethal triad of SAM. Whenever you treat any child with severe acute malnutrition, you need to think in terms of dash. Always when one of these three are present, the other two will be present, must be present. What are all they? The three deadly triad of severe acute malnutrition is hypoglycemia, hypothermia, and infection. I repeat, hypoglycemia, hypothermia, and infection are the lethal triad in severe acute malnutrition. One is present, the other things should automatically be sensed. Okay, right. Okay. So now you have marasmus and monkey faces in, okay, baggy pant appearance and monkey faces in marasmus, whereas flaky paint dermatosis and flax sign in case of kwashiorkor. Lethal triad of severe acute malnutrition is hypoglycemia, okay, hypothermia, and then infection. Right, next question. Micronutrient that should not be started during stabilization phase. Can anyone tell me which micronutrients you used to give? Copper, zinc, mercury, everything. But only one thing cannot be given. Cannot be given during the stabilization phase. That is first 1 to 2 weeks. What is that? What is that called as? It is nothing but iron. Iron should not be, okay, iron should not be given during the stabilization phase. Very important. Iron should be given only after 2 weeks of treatment of severe acute malnutrition. Right. How to prepare a risomal from standard ORS? We all know that standard ORS contains 245 millimole per liter. 245 millimole per liter. Sodium somewhere around 75. Potassium somewhere around 20. Whereas in case of risomal, this has been increased to osmolality of risomal is 300. Okay, sodium has been reduced from 75 to 45, and remaining thing, okay, look at this. So total milliosmol per kilogram is 245. Sodium is 25. Potassium is 20. Potassium is increased to 40. So the risomal composition is 300 millimole osmol per kilogram of total osmolality, 45 millimole per liter of sodium, and 40 millimole per liter of potassium. Simple clue is your ORS, risomal, rehydration solution for malnourished children, usually has got equal ratio of sodium and potassium. That is how you can describe. And when someone is asking you how to prepare, normally we used to take 1 packet of ORS and mix it with 1 liter of blood. 1 liter of water. That is the normal production of ORS. But what will happen in case of Risomol? ORS 1 liter, 2 liter. MCQ is 2 liter. How Risomol can be prepared? Risomol can be prepared by adding 2 liter MCQ of water with ORS along with 50 grams of sugar and 40 kilocalories of potassium chloride. 50 grams of sugar and 40 kilocalories of potassium chloride. I repeat, for Risomol, you need to mix ORS into 2 liter of water rather than 1 liter of water. Along with that, you need to add glucose 50 grams and then 40 ml of potassium chloride, because they are at risk for hypokalemia. Children, severe acute malnutrition children, right? Next comes fever with a rash. Fever with a rash. Remember, whenever fever with a rash comes, invariably we will be asking about what kind, on which stage of fever you will get a rash with respect to microbiology. But as far as pediatrics is concerned, I am going to tell you some important questions that are often asked in your FMGE. So, measles fever with a maculopapular rash. Fever with a maculopapular rash can be seen in measles, infectious mononucleosis, chikungunya, and then enteroviruses. But as far as most important things are concerned, remember it is measles as well as what is this MISC? Multisystem inflammatory cytokine storm syndrome that occurs in COVID children. Multisystem inflammatory cytokine response. Fever with the desquamation. You can get perianal desquamation or perioral desquamation. Desquamation is a part of Kawasaki disease. You can get in many other illness, but most common disease that produces fever with feeling desquamation is Kawasaki disease. Fever with a vesicular rash, it is very, very easy. Either it can be a varicella, hand, foot, mouth disease, or it can be rarely due to monkeypox. Herpes and enterovirus can also cause herpes rash. Also cause vesicular rash. Fever with petechiae. Petechiae means platelet is involved. Whenever you get fever with petechiae, always think in terms of a dengue. Acute means, chronic means scrub typhus. Right? Fever with petechiae. Fever with urticaria. Fever with urticaria is mainly due to cutaneous larva migrans as well as scabies. Fever with a nodular rash. Nodular rash means molluscum as well as erythema nodosum. These two will cause fever with a nodular rash. Nodular rash. Now, what is this? Congenital heart disease. As far as your entrance examinations are concerned, not all questions will be asked. You need to know something about ECG and the X-ray. Okay. So it was previously taken in our Sishrita batch, the approach to congenital heart disease. So what is the simple approach? Whenever you are given a picture of cyanosis in newborn, first thing that you need to do is hyperoxia test. Whenever you give 100% oxygen over 10 minutes, the oxygen should be improved. Improve means hyperoxia test pass. Not improving means hyperoxia test fail. Remember, always whenever you have a hyperoxia test fail means you are dealing with a case of cyanotic congenital heart disease. Hyperoxia test failed means it is cyanotic congenital heart disease. Remember, all cyanotic congenital heart disease are associated with right axis deviation. Whenever the child is cyanotic and associated with the left axis deviation, you need to remember it is a case of tricuspid atresia. Very, very important. And one more point, whenever you take an X-ray in a cyanotic child, you see X-ray from this wall of the, you see your heart of the child from this wall of the thorax to this wall, that wall of the thorax. That is called a large, okay, cardiomegaly or massive cardiomegaly. This massive cardiomegaly or large cardiomegaly is a feature of Epstein's anomaly. So two simple clues. Whenever you are given a case of cyanotic congenital heart disease, kindly look for left axis deviation. The only condition associated with left axis deviation is tricuspid atresia. Okay, the only condition that can produce massive enlarged heart with the cyanosis is Epstein's anomaly. Right, is Epstein's anomaly. Okay, then fixed and wide split heart sounds, you all know it is a case of AST. And fixed and variable split with respect to VST, whereas S2 with paradoxical split usually occur in PDA. These things are very, very important. Fixed split, variable split, paradoxical split. Fixed split, AST, variable split, PDA, whereas wide and variable split is VST. Acyanotic congenital heart disease with absent both femorals. So what does it mean? Whenever either, there are two things. One is cyanotic congenital heart disease, another is acyanotic congenital heart disease. Whenever acyanotic congenital heart disease comes, always you need to put your hands over the dorsalis pedis. If dorsalis pedis is not present, you are dealing with a case of coarctation of aorta. So coarctation of aorta in any child with hypertension, any child with a congestive cardiac failure, brought with the absence of blood flow in the femoral through the femoral from the aorta, you need to think in terms of a coarctation of aorta, right? What is this? Acyanotic congenital heart disease with absent femorals and brachials. Okay, absent femorals and brachial. See, whenever you have a dorsalis pedis, both femorals not filled, both brachial is filled, to mean it is most in favor of a coarctation of aorta. But what happens here when both femorals are absent, both brachials are absent, but when you hear a carotid bruit, it is called as what? Carotid bruit, critical aortic stenosis. But when you don't have a murmur, then you need to think in terms of a hypoplastic left heart syndrome. I repeat, whenever you see any child brought with shock, look for dorsalis pedis and femoral artery. Okay, when both dorsalis pedis and femoral are absent, it can be two things, either coarctation of aorta or critical aortic stenosis. Okay, dorsalis pedis and critical aortic stenosis. In coarctation of aorta, you will find upper limb pulse. In critical aortic stenosis, no upper limb pulse too. But in critical aortic stenosis, because of severe stenosis, you could hear ejection systolic murmur or bruit. Can be heard in case of critical aortic stenosis. Whereas in case of hypoplastic left heart syndrome, your LVH is not formed much. Okay, so that you will have flat QRS voltage in case of hypoplastic left heart syndrome. In hypoplastic left heart syndrome is a condition in which your left ventricle will not be formed properly. Right? One second. So, okay, will not be formed properly. So we have covered some questions on. Okay. So we have covered some questions on congenital heart disease, fever with a rash, marasmus and kwashiorkor, some torch infections, temperature regulation, as well as about a newborn baby. Okay. Now you have inborn errors of metabolism along with the urine order. Can anyone tell me, can you post abnormal urinary order in the following situations? Anyone? Find out the urine order. Very, very important. At least one question will be asked from this. I repeat, one question will be asked from this. Yes. Let me write. Where will you get boiled cabbage? Rotten fish, sweaty feet, swimming pool like odor, chlorine smell, swimming pool like odor. Tomcats, where you will get? Where you will get musty odor? Where you will get burnt sugar odor? So, can you tell me in which condition? Okay, tyrosinemia is characterized by boiled cabbage. Okay, isovaleric acidemia is associated with sweaty feet odor. Which one? Isovaleric acidemia. Third one, multiple carboxylase deficiency is associated with the tomcat's urine. Maple syrup is associated with the burnt sugar. Musty odor is due to phenylketonuria. Musty odor is due to phenylketonuria. And then 𝐒𝐿𝐃𝐈𝐀 is associated with swimming pool urine. Swimming pool urine. Very, very important. Tyrosinemia, boiled cabbage, maple syrup, urine disease, burnt sugar, isovaleric acidemia, sweaty feet, multiple carboxylase, tomcat's urine, phenylketonuria, musty odor, and 𝐒𝐿𝐃𝐈𝐀, swimming pool odor. Definitely, these are all some of the best things that can be asked in your entrance examination. Right. Now, I have something special in inborn errors of metabolism. You all know about the enzyme deficiency and the disease. But let me tell you two points with respect to disease manifestations. Here, I had already given you the enzyme deficiency, but now let me ask you one of the simpler questions with each and every um, inborn errors of metabolism. Okay, let me write in which inborn errors of metabolism you will get rheumatoid like nodules over joints. I repeat, in which inborn errors of metabolism you will get rheumatoid like nodules over joints? Anyone? Very good. It is Farber disease, rheumatoid like nodules. Like nodules are there in Farber's disease. Rheumatoid like, I'm sorry. So Farber disease is characterized by rheumatoid like nodule. Very, very important. Like a nodule mimicking your rheumatoid arthritis. Mimicking your rheumatoid arthritis. In which condition you will get giant Mongolian spot? Second question, giant Mongolian spot in which condition? These are all the questions that were asked. Giant Mongolian spot. Very good. Giant Mongolian spot is a feature of GM1 gangliosidosis. Giant Mongolian spot. GM1 gangliosidosis. Okay. In which condition you will get macrocephaly, hyperacusis, but no hepatosplenomegaly. I repeat, macrocephaly, hyperacusis, and no hepatomegaly. In fact, I can say one of the very few GSDs that present one of the very few lysosomal storage disorder that present without hepatosplenomegaly. What is it? What is it? Okay, yes, it is Tay-Sachs. Macrocephaly, whenever you have macrocephaly, hyperacusis, hyperacusis, remember no hepatosplenomegaly. Dear friends, very, very important. Very important. Tay-Sachs disease is not associated with any hepatosplenomegaly. I repeat, it is not associated with any hepatosplenomegaly. Which one? Tay-Sachs disease. Right. Which one cause rapid neuroregression? Which one is associated without any neuroregression but massive hepatosplenomegaly and pancytopenia? Alright. So I will give you three choices: massive splenohepatomegaly, massive splenohepatomegaly, no neurological manifestations. What is the question? Or second one, I can say rapid progressive neuroregression. That means the child will be fine initially, but over a course of time, the child will be chairborne, rapid, slowly progressive neurological issue. Okay, let me tell you the answer. Massive hepatosplenomegaly with no neurological manifestation is Gaucher's disease type 1, whereas a rapidly progressive neuroregression is Gaucher disease type 2, and then slowly progressive neurological illness is Gaucher type 3, type 1, type 2, type 3. Okay, right. So let me write glucocerebrosidase. Gaucher disease characterized by glucocerebrosidase. All are characterized by hepatosplenomegaly. No neurology in case of type 1. Fast neurological regression in case of type 2. And type 3 is characterized by slow neurological issue. Right. Tay-Sachs I had finished. Sandoff disease. Sandoff disease is characterized by exosaminidase A and B. Is there any MCQ with respect to Sandoff disease? I don't think, my dear children, I don't think any question so far had been asked with respect to Sandoff. Niemann-Pick's disease A and B. Niemann-Pick's disease A and B can be characterized by sphingomyelinase deficiency. Very important MCQ. Very important MCQ. Niemann-Pick's disease type B is associated with interstitial lung disease. Niemann-Pick's disease type C is associated with interstitial lung disease. Okay. Whereas Niemann-Pick's disease type B is associated with interstitial lung disease. Whereas Niemann-Pick disease type C is associated with neonatal hepatitis. Neonatal hepatitis. Which one? Niemann-Pick disease type C. And one more MCQ is very important. What is the problem in Niemann-Pick disease type C? If you say it is sphingomyelinase deficiency, you are wrong. In Niemann-Pick disease type C, it is due to defect in cholesterol egress. So it is characterized by defect in cholesterol transport. Defect in cholesterol transport. Right. Metachromatic leukodystrophy is characterized by aryl sulfatase deficiency. Okay, and finally, Fabry's disease characterized by alpha galactosidase deficiency. What are all the characteristic features? The characteristic features are nephropathy. What? Nephropathy, cardiomyopathy. The characteristic features of Fabry's disease are nephropathy and cardiomyopathy. Nephropathy and dilated cardiomyopathy with respect to Fabry's. And remember, majority of enzyme inhibitors of metabolism are associated with poor neurological issue, are characterized by low IQ but normal intelligence in case of Fabry's. I repeat, normal intelligent in case of Fabry's disease. So this is all about a short format on inborn errors of metabolism. Particularly, it is chronic inborn errors of metabolism. Acute inborn errors of metabolism, very easy, very important. Acute inborn errors of metabolism. 1 second. Let me add. It was not added previously. Let me add, because it is very important. So when will you think about acute inborn errors of metabolism? Any child who by about third or fourth day after birth becomes sick, third or fourth day become sick, but there is cultures negative. What? Cultures negative. So it means you are not dealing with any infection. Cultures negative. When you have such case, you need to look for acidosis, you need to look for ketosis, and you need to look for ammonia. Very important, please listen. So when you have both acidosis, ketosis and hyperammonemia, you are dealing with a case of organic aciduria, with a case of organic aciduria. Whereas when you have acidosis, very important, when you have acidosis, when you have hyperammonemia, but absence of ketosis is answer. Absence of ketosis means it is fatty acid oxidation disorder. And finally, when you don't have acidosis, don't have ketosis, only hyperammonemia means it is urea cycle disorder. It is urea cycle disorder. And remember, in organic aciduria, I have three things to say with skin manifestations, and then one with abnormal urine order. Just now we had seen abnormal urine order. Third one is neither skin manifestation nor urinary order. So what is this? So with the skin manifestation means very important question, multiple carboxylase deficiency. Abnormal urine order means isovaleric acidemia, propionic acidemia. Whereas when neither your abnormal urine order nor your skin manifestations are clues, you are dealing with a case of methylmalonic acidemia or propionic acidemia. Malonic acidemia or propionic acidemia. Okay, this is with respect to acute inborn errors of metabolism. If you watch this, definitely you will get one question correct. Okay, and some of the vitamins, cofactors that are utilized, very important, my dear friends. For multiple carboxylase deficiency, use biotin, Hartnupp's disease, niacin, methylmalonic aciduria, B12, B6 is used in homocystinuria. Nitisinone is substrate reduction therapy used in alkaptonuria. Lorenza initially was used in X-linked adrenoleukodystrophy, but right now they are not asking it. Riboflavin deficiency. Riboflavin is associated with mitochondrial disorders. And finally, thiamine can be given in maple syrup urine disease. I repeat, thiamine can be given in maple syrup urine disease. Apart from that, where you will get iglostat. What is iglostat? Where you will use iglostat is a substrate reduction therapy used in Gaucher's disease. I repeat, okay, iglostat or miglostat. Miglostat are used as a substrate reduction therapy in Gaucher's disease. Okay, very. So among this, which where you will use betaine, Betane, betaine. Where you will use this betaine? Can anyone post? Where you will use this betaine? Betaine is used in pyridoxine, non-pyridoxine. Okay, betel is used in pyridoxine resistant homocystinuria. Okay, pyridoxine, betaine is used in pyridoxine resistant Homocystinuria. What else? Yes. Okay, very, very important. Just one-liners with respect to IEM. All over, I think. Now, vitamin deficiency. Which vitamin deficiency is associated with vitamin deficiency? Is associated with the malabsorption. Can anyone is associated with the ataxia? Vitamin, I am looking for the chat box. Vitamin dash deficiency is associated with ataxia. Which one? Vitamin E deficiency. Okay, vitamin E deficiency is associated with ataxia. Hemolysis in preterm, again it is due to vitamin E. Why? Because it stabilizes the membrane. Intracranial hemorrhage, vitamin K. But usually vitamin K related bleeding occurs on the second day due to not giving vitamin K at birth. But this delayed phase, hemorrhagic disease of newborn, which occurs after 2 weeks, have the propensity to cause intracranial hemorrhage and death. Hemopericardium. Where you will use hemopericardium? Anyone? Hemopericardium. Hemopericardium is used in which deficiency is associated with hemopericardium? Vitamin C is associated with hemopericardium. Methylmalonic aciduria. Which vitamin can be used? Just now we saw B12. Megaloblastic macrocytic anemia can be due to either B12 or folate. B12 or folate. Both are characterized by hypersegmented neutrophils. Another MCQ. Hypersegmented neutrophils, whereas B12 is characterized by elevation of methylmalonic acid, whereas folate is not associated with methylmalonic acid elevation. Very, very important. Methylmalonic acid elevated means B12. Methylmalonic acid not elevated means think in terms of folic acid in a case of megaloblastic anemia, which is characterized by hypersegmented neutrophils. Okay, now what is this? Milestones. Milestones. You can't escape from a question with respect to milestones. Can anyone tell me what are all the milestones, appropriate milestones? Necolding usually occurs in 3 months. Rollover, 5 months. Tripod, seating with the hand support, tripod, 6 months. Sitting without support, again 6 months. Standing with support, 1 year. Standing without support, 13 months. 13 months. Walk alone, 15 months. Runs alone, 18 months. When he walks or climbs, he used to keep both feet in one step. That is called 2 feet per step. 2 years. Alternative step up, 3 years, and alternate step going downwards, 4 years. Gross motor milestone, and then language. Gross motor and then language. Alerts to sound usually occurs by 2 months. Cooing of sound, 3 months. Laugh loudly, 4 months. Monosyllable, okay, ma, pa, ta, monosyllable, 6 months. Bisyllable, you all know, 9 months. 9 months. Whenever he uses true speech means usually comes by 1 year. 9 to 8 to 10 words by about 1.5 year. Pronouns 2 year. Full name and gender 3 years. Tell stories 4 years. Meaning of stories 4 years. Okay, this is with respect to important language milestones. Now, fine motor milestones. What is that? Fine motor milestone. Okay, let me write. Is it possible to find out the answer? Is it possible to find out the answer? Okay. Bidextrous grasp usually occurs by 4 months. Unidextrous grasp 6 months. Mature pincer grasp starts at 9 months, goes up to 12 months. Which one? Pincer grasp. Scribbling by about 15 months. Two block, but then they will start playing with the block. Two block 15 months. Three block. Okay, two block 15 months, three block 18 months. Building 6 blocks. 9 blocks, bridge with the blocks. 9 blocks, 3 years. 9 block, 3 years. 6 blocks, 2 years. How can they build? Okay. And then bridge with the block is usually by 4 years. Bridge with the block usually by about 4 years. So these are all some of the fine motor milestones. Language milestone. Social smile by about, okay, I'm sorry, social smile by about 2 months. Recognizes mother 3 months. Changer anxiety 6 months. Way bye bye 9 months. Simple ball game 1 year. Sleeping 15 months. Full name and gender 2 years. Goes to toilet alone 4 years. Dress and undress 4 years. Okay. Toilet training is not usually ask food by about. There are two segments here. Ask food 15 months. Ask toilet by about 2 years. It should be practiced. Okay, what is this? Tell me what is this? Answer anyone? I will give you a clue. Answer anyone? Newborn. Respiratory distress. Air entry reduced. Okay, tell me what is the answer? Air entry reduced. What is the answer? Hyperlucent lung on the left side. Can anyone tell me what is the answer? Yes, it is congenital lobar emphysema. It is congenital lobar emphysema. A very important MCQ. Congenital lobar emphysema, neonatal respiratory distress. What is this? Newborn with the frothing and respiration and a coiled NG tube. Newborn. Okay. What is this? Newborn Not oily. Newborn with the oily stools. What is the MCQ? Newborn with the oily stools. Cystic fibrosis. Newborn with the frothing of mouth. And you put a coiled tube, NG tube in neck. What is the answer? Yes, you are correct. What is this? Tracheoesophageal fistula. Fistula. Right. So look at this coiling of tube here. Okay, these are all the neonatal respiratory distress producing conditions. So with respect to heart, what is this? Let me say this is a 4-month-old child. Exactly these scenarios can be asked. So 4 months old child. Look at this. The child is 4 months old. CCF. The first time presents with third. Child has ASD features like fixed S2 split. S2 split, and then what is the answer? Can anyone tell me? And then it is acyanotic. Answer? I'm sorry, not acyanotic, it is cyanotic. What is the answer? What is the answer? It is total anomalous pulmonary venous connection. What is the answer? This is total anomalous pulmonary venous connection. And this is called figure of 8 appearance. This is called figure of 8. Okay, what is this condition? So very, very easy. This is total anomalous pulmonary venous connection. What is this? Let me write. Third day. The child is having cyanosis. Third day, the child is having cyanosis but no murmur. What is the diagnosis? Third day, look at the heart. What is the diagnosis? Can anyone tell me with this? Third day cyanosis, no murmur. Answer? Yes, this is TGA, transposition of great arteries. What is this? This is transposition of great arteries. Can anyone tell me what is the first management in a transposition of great arteries? PGE1 analog. E1 analog, right. What is this? Very, 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 very easy. 4-month-old, 4-month-old cyanosis, and then incessant cry. What is the answer? 4-month-old cyanosis, incessant cry, reduced pulmonary ejection, systolic murmur. In which condition you will get? Look at this. Up tilt apex of the heart along with boot shaped of the heart. What is this boot shaped heart? So this is boot shape. Occurs in, as you all know, tetralogy of Fallot. Okay, tetralogy of Fallot. What is this? Massive cardiomegaly. Already it was cracked. What is massive cardiomegaly? Let me give you two scenarios. Massive cardiomegaly plus floppy infant. What is the diagnosis? Second MCQ with the same picture, massive cardiomegaly. One is floppy invent along with multiple heart sounds. Multiple heart sounds. Answer. Massive cardiomegaly, floppy infant. Massive cardiomegaly plus floppy infant is spinal muscular atrophy. I'm sorry, it is not. What is Pompey's disease? I'm extremely sorry. It is Pompey's disease. Floppy infant is Pompey's disease. What is Pompey's disease? Pompey's disease is type 2 glycogen storage disorder characterized by deficiency of amylase. Characterized by deficiency of what? Pompey's disease is characterized by deficiency of what? Answer. Then type 2 glycogen storage disorder. Which one? Pompey's disease. Massive cardiomegaly and then multiple heart sounds. Epstein's anomaly. Epstein's anomaly. Remember, Epstein's anomaly is the congenital heart disease that can present in utero. Okay, that can present as in utero, that can present in infancy, that can present in childhood. Which one? Epstein's anomaly. And it is often associated with the WPW syndrome. Often associated with the WPW syndrome. So what is Pompey's disease? Acid maltase. Due to acid maltase. Type 2 glycogen storage disorder. Acid maltase. Right. What is this? What is the characteristic feature of this X-ray? Characteristic feature of this X-ray. Let me write 10-year-old boy, fever 2 weeks, cough 2 weeks, weight loss, appetite loss. Answer. What is this pattern called? Yes, this is called miliary TB. This is called miliary, small dot 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 like granules. In the X-ray chest is called miliary TB. What is this? Again same, fever 2 weeks, cough 2 weeks, weight loss 5% over 3 months. That is the definition for TB. What is this? Look at this here, large cavity. Cavity again indicates TB. Cavity again indicate TB. What happened against again TB? So what is this? What is this? What is this? This is hilar adenopathy. Adenopathy. This is hilar adenopathy. Again a feature of what? Again a feature of TB. Remember, whenever any child comes with fever, cough, 2 weeks of fever, 2 weeks of cough, the next thing is X-ray chest. In X-ray, if you have cavity, if you have miliary, if you have hilar adenopathy, directly go and do CP naught. directly go for CB naught. What is CB naught? CB naught is the investigation of choice for TB. Whereas when your X-ray is not suggestive of cavity, no. Miliary TB, no. Whereas hilar adenopathy, no. When these things are absent, you need to give a trial of antibiotics. You need this question can be asked in SPM or here in pediatrics, okay, because this is new NTEP guidelines, National Tuberculosis Elimination Program, NTEP guidelines, okay, right. Which one? When you have a TB presumptive case with fever of persistent fever of more than 2 weeks and persistent cough of more than 2 weeks, take an X-ray chest. If X-ray chest shows cavity, miliary, hilar adenopathy, then it is proceed for CB naught. When X-ray doesn't fit into it, give you a trial of antibiotic, right? This is hilar adenopathy. I told you. What is this? What is this? Let me wait. What is this condition? This is associated with upper lobe. Look at this. This upper lobe bronchiectasis. Upper lobe. This is characterized by upper lobe bronchiectasis, oily stools, answer. Or I can say at birth the child is having meconium ileus, pseudomonas colonization, pseudomonas colonization. Upper lobe bronchiectasis, oily stools, meconium ileus, pseudomonas colonization. What is the disease in which you do sweat chloride of more than 60 millipore per liter, more than 60 millimole per liter, is called as positive test. You need to repeat the test after 28 days, that is 1 month. Cystic fibrosis, very important. Treatment of choice one is enzyme replacement therapy in the form of lipase. Upper lobe bronchiectasis in children is cystic fibrosis. In adolescents and adults, you can think in terms of TB. But in pediatrics, along with failure to thrive, oily stools, always think in terms of cystic fibrosis. Okay, what is this? Spotter. What is this spotter? What is this spotter? Can anyone tell me what is this spotter? Let me give you a clue. Spotter. Wet cough. Since birth, atoria, ear discharge. Since birth, and then persistent rhinorrhea since birth. What is the diagnosis? And look here, you have what is this? Heart is on the left, right rather than left. What is this called as? This is called situs inversus totalis. So what is the disease? The disease is primary ciliary dyskinesia. This is primary ciliary dyskinesia. What is the investigation of choice? The high speed video microscopy. Okay, right. So what is this? This is situs inversus totalis, primary ciliary dyskinesia. But as far as you is concerned, I can say Cartagena syndrome. Cartagena syndrome. Syndrome. Okay, right. So this question is over. What is this question? What is this question? Anyone? So let me say 5-year-old boy. Sudden onset cough. Cough. Air entry absent right side. Answer, foreign body. What is this? This is foreign body, right main bronchus. This is foreign body, right brain bronchus. Typical scenario. This we already saw. What is this? This is called black sign. Where 𝐒𝐿𝐄𝐝. Alternative areas of pigmentation and depigmentation. What is this? Flaky paint dermatosis. This is called flaky paint dermatosis. Again occurs in 𝐒𝐿𝐄𝐝. 𝐒𝐿𝐄𝐝. Right. What is this? Monkey faces. What is this? And this is baggy pant appearance. Okay, this is baggy pant appearance. Again, it occurs in marasmus. Monkey faces also occurs in marasmus due to energy deficiency. Energy deficiency, right. What is this? Anyone? What is this? So let me give you a clue. So this case, the clue is anemia. The clue is anemia, MCV 110, femtoliter, hemoglobin 7, platelet 1 lakh. Diagnosis, no hepatosplenomegaly. What is this finding? Can anyone tell me? This is called knuckle hyperpigmentation due to Addison's disease. What is this? This is called knuckle. What is this? This is called knuckle hyperpigmentation occur in B12 deficiency. Knuckle hyper occur in B12 deficiency. Okay, thumbs up. Knuckle hyper. What is this? Let me say a case with hemoglobin 4 grams, platelet 20,000, total count 3,000. What is the diagnosis? MCV 100. MCV 100. Answer. And look here, there are no thumb. Thumb anomaly indicates what? Thumb anomaly. Or I can give you one more clue. Facial hyperpigmentation. What is the answer? Yes, it is Fanconi. Radial limb anomaly. Fanconi. Okay, Fanconi. Answer. Black colored urine. 7-year-old boy taken in my clinic. What is this? Black colored urine. Can anyone tell me what is this? Black colored urine. Yes, black color urine on standing. Yes, you all know it is alkaptonuria. Due to deficiency of homogentic acid oxidase. Homogentic acid oxidase. Okay, deficiency. Black colored urine on standing. Okay, treatment of choice MCQ nitisinone. Nitisinone is substrate reduction therapy. What? Substrate reduction therapy. Alkaptonuria nitisinone. Okay. Okay. Now, with respect to some developmental disorder questions. Developmental disorder question. Any child with atypical social interaction, that means not able to communicate with others, restricted range of interest, playing with the same pen for about hours together, okay, and speech delay is called autism. Is called autism. Second, similar in autism, cognition will be affected. Cognition will be affected. Second, what is this? Similar to autism, but language skills are intact. This is an MCQ. Language skills are intact. In autism, language skills are not intact. Here, language skills are intact. So, what is this condition? Asperger syndrome. This is called Asperger syndrome. Okay, again, this is an MCQ. Almost always girls, MYC-P2 mutation, regression of skills, deceleration of head growth. Deceleration of head growth along with the hand wringing movement is Rett syndrome. Is Rett syndrome. Okay. And when you have dementia resembling Alzheimer's dementia in childhood by about 10 years, it is called Heller dementia. It is called Heller's dementia, or otherwise known as, this is enough. Alzheimer's like dementia occurring in children less than 10 years is called as Heller's dementia. The other name is called childhood disintegrative disorder. So these four things, autism, Asperger, Rett, Eller, comes under pervasive developmental disorder or autistic spectrum disorder. For you, the questions are acquired microcephaly, MYC-P2 mutation, hand wringing movement in Rett syndrome, atypical social interaction in case of autism, language is intact in case of Asperger syndrome. Rett and autism will be asked. Asperger can be asked in psychiatry. So what is this? You all know this is Ricketts. This is Ricketts. What is this? This is Ricketts. You have cupping, fraying, widening. You have cupping, fraying, widening of bones. Ricketts. What is the evaluation of Ricketts? First, look for serum phosphorus. Please listen carefully. The approach to Ricketts. Look for serum phosphorus. So, serum phosphorus low, serum phosphorus high. When serum phosphorus high means usually it can be chronic renal failure. Chronic high means chronic renal failure. Second one is hypoparathyroidism. Hypoparathyroidism. When serum phosphorus is low means look for parathyroid hormone. When parathyroid hormone is normal, the answer is X-linked hypophosphatemic rickets, in which you need to give phosphorus. That's all. Whereas when PTH is high, very, very important, PTH is high, then you need to look for 25 OHD3. When 25 hydroxy OHD3 is low, it is nutritional ricket. It is nutritional rickets. But when it is normal, you need to do 125 OHD3. When 125 is low or 125 OHD3 is high. When 125 OHD3 is low, this is called VDDR1. What is called VDDR type 1? So it is due to reduced 1-alpha hydroxylase enzyme. Whereas when 125 hydroxylase dihydroxy D3 is high, means it is receptor defect. Then it is called VDDR type 2. VDDR type 2, end organ resistance. VDDR type 2. Okay, right. So this is the basic simple approach to rickets. Okay, so look here, frontal bossing, rickety rosary, okay, all these things, widening of wrist. So this is a case of VDDR type 2. And one more beautiful MCQ I left out, VD rickets plus alopecia equal to rickets plus alopecia is equal to VDDR type 2. Very, very, very important. Rickets with alopecia is VDDR type 2, an interesting MCQ. You will be asked. Okay. So is it over? Yes, over. So from here it comes here. Ricket scenario misplaced in PDF. Misplaced in PDF. What happened? Something is missing. Okay. This we had discussed now. I repeat. Once again I repeat. Most common is only 4. I repeat, only 4 case scenarios will be asked for you. One is nutritional rickets. One is nutritional. Let me write phosphorus, PTH, and then 25 OHD3, 125 OHD3. Okay. What happens in nutritional rickets? Phosphorus will be low, parathyroid will be high, 25 OHD3 will be low. That is the investigation of choice. 25 OHD3 will be low. That is nutritional rickets. VDDR1. Here also phosphorus will be low, PTH will be high, but 125 will be very, very low. VDDR type 2. What happens in VDDR type? First one is type 2. Here also phosphorus low, PTH is high. But because of end organ resistance, 125 will be very, very high. What about X-linked hypophosphatemic rickets? Phosphorus will be very, very low. PTH will be normal. Very, very important MCQ. Very, very important MCQ. Phosphorus will be low, but PTH will be normal. This is X-linked hypophosphatemic rickets. And finally, chronic renal failure. Phosphorus will be high. And then hypoparathyroidism. Both are characterized by elevated phosphorus. In chronic renal failure, parathyroid will be high, whereas in hypoparathyroidism, parathyroid will be low. That's it. That's it. This is the easiest way to remember. Approach to rickets. Approach to rickets. Right. So, what is the treatment they will be asking you? Treatment of rickets. Let me write 2000 international units per day into 2 months. When the child is more than 2 years, 3000 international units per day into 2 months. At the end of 2 months, you need to take an X-ray, and the X-ray will show zone of provisional calcification. What is that called as? Zone of provisional calcification. If it is there, then it is nutritional rickets. If it is not there, then it is either VDDR 1 or 2. That's it. Or X-linked hypophosphatemic ricket. Okay, that's it. Over. And so we had finished approach to rickets. Very important topic. What is this? Next topic. Very important topic. So what is this? Congenital adrenal hyperplasia, or you can say ambiguous genitalia. So 21 alpha hydroxylase is characterized by what? Precocious puberty in boys. In boys, atypical genitalia. We don't right now call as what? Ambiguous genitalia, the term is removed. Hermaphrodite, the term is removed. It is atypical genitalia. In 21 alpha hydroxylase, blood pressure will be low. Treatment is hydrocortisone, fludrocortisone. In 11 beta hydroxylase, again, precocious puberty in boys, atypical genitalia in girls, but now blood pressure is high rather than being low, and treatment is only hydrocortisone, no fludrocortisone. And in 17 alpha hydroxylase, boys will have there is no precocious puberty. Atypical genitalia usually occurs in boys. Blood pressure will be high. Treatment will be only hydrocortisone. In 3 beta HST deficiency, in boys you will have hypospadiasis in boys. Hirsutism in girls, characterized by hypotension. You need to give lifelong hydrocortisone. Remember, I bet when you remember this tabular column, you will get one answer correct. I bet. Right? Okay. What is this photo? What is this image? What is this image? Look here, let me say 4-month-old, 4-month-old nystagmus, hepatosplenomegaly, pancytopenia. Answer: hepatosplenomegaly and pancytopenia. Answer: look at this. Look at this. Look at this. There is only cortex. There is no medulla. What is the answer? Osteopetrosis. Petrosis. Treatment of choice is stem cell transplant because osteoclasts are derived from macrophages. Macrophages. Okay. What is this? What is this? Let me say 2-year-old boy, recurrent urinary infection. What is this? This is called vesico-ureteric reflex. This is called vesico-ureteric reflex. Grade 1 grade 1 up to mid ureter. Grade 2 up to pelvis. In grade 1 and grade 2, no ureter dilatation. Whereas in grade 3, 4, 5, mild dilation of ureter, moderate dilatation of ureter, severe dilatation of ureter. Okay, what is the treatment of choice? What is the treatment of choice? Grade 1 and 2. Okay, without bladder bowel dysfunction. What do you mean by bladder bowel dysfunction? Constipation. When there is no with bladder bowel function dysfunction, antibiotic prophylaxis till 1 or 2 years. Whereas without bladder bowel dysfunction, no antibiotics are needed. If antibiotics are needed, up to 1 year. Whereas grade 3, 4 and 5, again with bladder bowel dysfunction, antibiotic prophylaxis till 2. That's all. Very, 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 very important. Here, urological topic. What is this? Answer. What is this? Let me say boy, 4-month-old, poor urinary stream. Palpable bladder. Can you tell me what is the answer? Anyone? Oh, yes, posterior urethral wall. Posterior urethral wall. What is the treatment? Transurethral fulguration. That's it. Very, very important image question. Okay, and then vaccine. Okay, vaccines. 1 second. We'll finish it. Vaccine schedule of an unimmunized child. So this is for unimmunized child. So what is the vaccine schedule? You all know. What is the normal vaccine schedule? So let me write at birth. At birth, BCG, OPV, hepatitis B. 1. At 6 weeks and 14 weeks. 6 weeks and 14 weeks. Pentavalent PCV 1, IPV 1. Okay. PCV 1, IPV 1, and then OPV rota. 6 weeks PCV 1, 14 weeks IPV 1. Whereas at 10 weeks, Penta S, PCV no, IPV no, Rota S, OPV S. At 9 months, MR1, 9 months, MR1, At 9 months, measles, rubella 1, AE 1, OPV. Now they had included PCV booster and IPV booster. This is the national schedule. PCV booster and IPV booster. 15 to 18 months. 15 to 18 months. MR2 DPT booster JE2 at 5 years DPT booster 2 at 10 years it is TD or TDAP, not TT. When you say TT, the answer is not correct. So this is immunization schedule of pediatrics, Indian Academy schedule. Okay, so when any child is brought without this thing, how you will manage? That is called catch-up vaccination. So if the child has not received any vaccination and come to you with less than 7 years, so at the first visit, less than 7 years, at the first visit, BCG, if the child is less than 1 year, less than 1 year, first visit. Remember, DPT should be given at the first visit. DPT1, DPT2, DPT, and after 2 months, MMR or MR and then typhoid in private, but not in government. More than 7 years, EDAP, oppositional defiant disorder. Okay, this is called oppositional defiant disorder. Eating non-edible things for more than 1 month is called as 𝐌𝐞𝐝. More than raining here. One second. Raining here. நெட்டு போயிருச்சு போல இருக்கு. I'm sorry, it is raining here. That's why there is an issue. Let me try to complete it. Don't worry. Okay, yeah. Is it possible to visualize again? Yeah. Thank you. There is an issue here because of severe rain. Thanks for keeping so patient. Okay. So just what are all the other things we had discussed? You okay, right? Then perinatal period is very important, my dear boys and girls. Perinatal period is nothing but it is not 28 weeks. It is very important. It is 22 weeks to 7 days after birth. This is an MCQ. 22 weeks to 7 days after birth. This I had discussed 6 weeks, 10 weeks, 14 weeks I had discussed. I don't think I need to discuss it here itself. I had discussed in detail, so I am not going to discuss again. Okay, arrangement of vaccines in domestic refrigerator is again a question. Arrangement of Okay, arrangement of vaccines in domestic refrigerator, right? BCG, OPV should be kept in freezer, whereas BCG, measles and MMR, first compartment. This all T vaccines. I repeat, all T vaccines. All T vaccines. T containing BCG, measles and in first compartment. All T vaccines in middle compartment. Hepatitis B, varicella, diluents in lower compartment. And nothing should be your baffle tray, that is one which is meant for vegetables, as well as the door. Okay, no vaccine should be kept. No vaccine should be kept. Okay, no vaccine should be kept. Right, this is with respect to vaccines. Right. So what is the route of administration? Route of administration of BCG vaccine. BCG vaccine, you all know, intradermal. OPV cholera, the name itself suggests oral. Remember, all hepatitis, measles, rubella, hepatitis A, varicella, all should be given subcutaneous. All live vaccines, I repeat, live vaccines subcutaneous, whereas toxoids, subunit vaccines are given intramuscular. Right? So BCG is given intradermally, subcutaneous all live vaccines. So what are all the live vaccines? Measles, rubella, measles, mumps, rubella, hepatitis A, varicella, Japanese encephalitis are all live vaccine that should be given subcutaneously, whereas conjugate vaccines, toxoids and subunits should be given intramuscular. For example, PCV, pentavalent, should be given intramuscular, right? Okay, intramuscular. Diluents for vaccine, very, very important. Diluents. For measles, mumps, rubella, MMR, diluents is sterile water. Whereas for BCG and yellow fever, BCG and yellow fever, you use normal saline. Very important. You use normal saline. Okay. And then for this combination vaccine, another vaccine is usually used. Another vaccine. Usually DPT. Another vaccine. So don't remember all those things. For MMR, measles, rabies, varicella, sterile water. For BCG vaccine and yellow fever, normal saline. Okay. Right. Again, what is the most common cause for? Let me see how many of you are going to answer. Most common cause for obstructive uropathy in children. 1, 2, 3. Posterior urethral wall. Most common cystic renal malformation in kidney. Anyone? Don't say in pediatrics. Don't say it is AD autosomal dominant. It is not so. Most common renal cystic neoplasm in kidney is multicystic dysplastic kidney. Multicystic dysplastic kidney. Posterior, no. Dr. Max has answered. Look here, it is not autosomal dominant. In pediatrics, I repeat, my dear boys and girls, in pediatrics, the most common malformation, renal malformation is, I repeat again, multicystic Dysplastic kidney. Okay, this is unilateral, whereas autosomal recessive is bilateral. Okay, Max? Okay, why did you remove your answer? That is not an issue. Most common cause for hereditary nephritis is Alport. Most common cause for community acquired renal failure is hemolytic uremic syndrome. Hemolytic uremic syndrome. Okay. Most common cause for hypertension in children. Can anyone tell me most common cause for hypertension in children? Hypertension in children. Renal parenchymal. That means chronic renal failure followed by renal vascular. Renal vascular. Followed by renal vascular. Right? Most common vasculitis in children. Most common vasculitis in children is, can anyone tell me what is the most common vasculitis in children? Enoch, Chandlan, purpura. Most common cause for recurrent UTI is, don't say it is not vesico-ureteric reflex. It is bladder bowel dysfunction, that is constipation. Okay, 5 more minutes. Is it okay for you? Malignancy, 5 more minutes. Let me write. Most common pediatric malignancy. 1. Okay. Okay, Dejo. Most common pediatric malignancy. 1. What is that? Most common solid tumor in children. Most common extracranial solid tumor in children. Which one? Most common abdominal malignancy in children. Most common tumor of kidney. Most common HL, Hodgkin's lymphoma in India. Most common non-Hodgkin's lymphoma in India. Most common head and neck tumor. Most common orbital tumor. Most common ocular tumor. Answer. So, fatafat answer. Okay, most common pediatric malignancy is acute lymphatic leukemia. Most common solid tumor is, have you answered? Most common solid tumor is brain tumor. Most common extracranial solid tumor is neuroblastoma. Most common abdominal malignancy, again neuroblastoma. Most common tumor of kidney. Are you following me, my dear kids? Wilms tumor. Most common Hodgkin's lymphoma, mixed cellularity. Most common non-Hodgkin's lymphoma, lymphoblastic lymphoma. Most common ocular tumor is retinoblastoma. Most common head and neck and orbital tumor is rhabdomyosarcoma. sarcoma. ठीक है, rhabdomyosarcoma. Hemangioma, I am speaking in terms of malignancy, Shivangi. Okay, rhabdomyosarcoma. Okay, right. Last question. Last question. 2-year-old. Okay. Biopsy reveals small round blue cell tumor. Small round blue cell tumor. Biopsy revealed. Ultrasound. Small tumor in suprarenal gland. Suprarenal gland. Suprarenal gland. MRI or else PET scan revealed small secondary in skin, liver and bone marrow, not bones. Bones. So let me say, okay, so let me say 2-year-old. What is the diagnosis? What is the treatment? Whoever is going to answer, let me give you a treat. I'm sorry. So what is the diagnosis? What is the treatment? Answer. What is the diagnosis? What is the treatment? I'll wait. Whoever is going to answer, you will be given a treat. Small round, why? What happened? So many. Nandan, Max, Rishikesh. What is the answer, dear? Tell me. Print Patel, Mukesh. Waiting for your answer. What is the treatment and what is the staging? And what is the staging? So with this, we are completing our session for today. Is Wilms tumor small round blue cell tumor, dear? What are small cell blue cell tumor? What are small cell blue cell tumor? So small round blue cell. What are all those? They are neuroblastoma, medulloblastoma, Ewing sarcoma, non-Hodgkin's lymphoma. Answer, anyone? So this is a case of what is this? This is a case of neuroblastoma. This is a case of neuroblastoma. Yes, Prabhav. Then tell me, what is the staging? It has involved your liver, it involved your skin as well as in your bone marrow, but not bones. What is the staging? What is the staging? Very good, Prabhu. What is the staging? With this, we are finishing. What is the staging? What staging? What treatment? What is the peculiarity of this tumor? So, this is stage 4. A peculiar thing was added, stage 4. Yes. This is prone for spontaneous regression. So, no treatment required. No treatment required. That's all. So, that's all from my side. Happy for being with us. I hope you will be getting many pediatric questions from this rapid revision. The time allotted is 2 hours. I have crossed 4 to almost 2 hours and 28 minutes. Thanks for your patient listening. Bye bye. I wish all the best for your examination as well as I pray for you. Bye bye.
So hello students. Just one moment. Okay. Okay. So hello to all of you. I'm Dr. Pradeep Pawar, Professor of Anatomy. So let us start with FMG Decoded. This is a Maha Marathon covering all 19 subjects. So we've already begun with this. Okay. So I'll start with anatomy. Fine. If there's anything, I mean, let it be an interactive session. I'll ask, you answer, you ask, I'll answer. So I put it in the form of a workbook for you. Okay, let us begin. Okay, have a look at this. So students, we'll start. Chalo. The nerve supply of certain muscles which are very important, which are always asked as MCQ questions. The nerve supply of biceps brachii. Yes, can anyone answer this? Nerve supply of biceps brachii. Yes. Come on, you can type. I'm looking at the screen. Nerve supply of biceps brachii. Whatever you know, that's fine. Just be interactive. Even if it is wrong, that's fine. Huh? थोड़ा सा समझ में आ जाएगा. And it will help you. Okay, so what is the nerve supply of biceps brachii? Anyone? Nerve supply of biceps brachii is the musculocutaneous nerve. Musculocutaneous nerve. हाँ, अगर यहाँ पे space नहीं है, I'll write it outside. Now, what is the main action of biceps brachii? The main action of biceps brachii is supination. Supination in a mid-flexed elbow. The second action of biceps is flexion at the elbow joint and flexion at the shoulder joint, right? So the nerve supply of biceps is the musculocutaneous nerve. Now, what else does the musculocutaneous nerve supply? Musculocutaneous nerve supplies the biceps, the brachialis, and the coracobrachialis. Biceps, brachialis, and coracobrachialis, and it continues as a nerve. Any guesses? What does it continue as? Let me look at the screen if you're answering. Yes, very good, very good. Karthi, very good. So what does the musculocutaneous nerve continue as? वो biceps को supply करेगा, brachialis को supply करेगा, coracobrachialis को supply करता है ये musculocutaneous nerve, and then it continues as what? Any guesses? It continues as the lateral cutaneous nerve of forearm. Lateral cutaneous nerve of forearm. ठीक है? So lateral cutaneous nerve of forearm is a continuation of musculocutaneous nerve. Action of biceps clear. The main action of biceps is supination at the radioulnar joint. The second action is flexion at the elbow joint and flexion at the shoulder joint. Shoulder joint. ठीक है? एक मिनट, I'm not able to see the comments. Okay, fine. Just one moment. Fine. Okay. ठीक है. Now, coming to the next MCQ, deltoid. Okay, what is the nerve supply of deltoid? Anyone? What is the nerve supply of deltoid? Interactive session होने दो, so you will learn it better. Nerve supply of deltoid. Good evening, Yogam. What is the nerve supply of deltoid? It's the axillary nerve. So nerve supply of deltoid is axillary nerve. Now axillary nerve दो muscles को supply करते हैं. It supplies the deltoid, which is the other muscle. Yes, very good, very good, very good. All of you answering very well. Yes, Kuthuru, Karthi, Yogam, very good. और क्या सप्लाई करता है? Musculocutaneous. What does the axillary nerve supply? एक तो ये deltoid को supply करता है, which is the other muscle supplied by the axillary nerve. Any guesses? Any guesses? Which is the other muscle supplied by axillary nerve? It's the teres minor. Teres minor. So deltoid, and it also supplies the teres minor. Okay, ये supply करता है teres minor को. Okay, fine. And it gives a cutaneous branch. It gives a cutaneous branch. मतलब एक्सिलरी नर्व दो मसल्स को सप्लाई करता है, डेल्टॉइड, टेरिस माइनर, ये क्यूटेनियस ब्रांच देता है, एंड दिस क्यूटेनियस ब्रांच, वन मोमेंट हर्ष, इट सप्लाइज द स्किन ऑन द लैटरल एस्पेक्ट, अपर लैटरल एस्पेक्ट ऑफ द आर्म. इसका नाम क्या है? upper lateral cutaneous nerve of arm. Just understand, axillary nerve दो muscle supply करता है, deltoid teres minor एक cutaneous branch देता है. And what is this cutaneous branch supply? It supplies the skin on the upper lateral aspect of the arm. अगर ये nerve damage होता है, so the person will complain of loss of sensations on the upper lateral aspect of the arm. इसे क्या बोलते हो? What do you call this as? What is that known as? जब यहाँ पे sensory loss होता है, there's loss of sensations on the upper lateral aspect of the arm. वो एक नाम है उसका. Anyone? What is the name for that? Honeymoon palsy. Okay. Anything else? The army people, they put a badge here. उसका नाम है regiment badge sign. Regiment badge sign. Huh? So this is what we call as the regiment badge sign. Regiment badge sign. So regiment badge sign, BADGE. Regiment badge sign is seen in lesions of which nerve? Axillary nerve. Very good, very good, very good. Parul, yes, regiment badge sign. Excellent. Very good to all of you. So deltoid का main action क्या है बच्चों? What is the main action of deltoid? वैसे deltoid के 3 fibers होते हैं. आगे anterior fibers है ये acromial fibers होते हैं, पीछे posterior fibers होते हैं. जो anterior fibers of deltoid है, इनका action है flexion and medial rotation. ठीक है ना? Anterior fibers of deltoid का action क्या होगा? Flexion and medial rotation. जो posterior fibers of deltoid है, इनका action है extension and lateral rotation. And जो acromial fibers है, acromial fibers of deltoid, इनका action क्या है? Anyone? What is the action of acromial fibers of deltoid? Yes, bolo bachcho, come on, answer this. This is a very, very important MCQ. Anterior fibers of deltoid, flexion and medial rotation. Posterior fibers, extension and lateral rotation. Acromial fibers का action क्या है? Abduction from 15 to 90 degree. Very good, Yogam. It's abduction from 15 to 90 degree. So जितना मैं cover कर सकता हूँ, जो भी important MCQs आ सकते हैं, I'm trying to tell you everything. Okay, just be interactive. Very good. Abduction कहाँ से कहाँ तक? 15 to 90 degrees, right? So 15 to 90 degrees of abduction जो है वो कौन करेगा? Acromial fibers of deltoid. Perfect. Very good. Excellent. Very good. Very good. Very good. Hemant. Excellent. अब बाद में ना abduction of the shoulder joint मैंने एक अलग से topic लगाया. We'll see that later. हाँ. हेमंत 0 to 15 is supraspinatus. हाँ 0 to 15 है वो supraspinatus. 15 to 90 is deltoid. हाँ अपन बाद में देखते हैं. We'll see that later. Brachialis. चलो, what is the nerve supply of brachialis? ये anterior compartment of arm जो है, इसमें 3 muscles है. This muscles is the biceps. ये जो आप देख रहे हो, that's biceps. Biceps को reflect करता है. What is the muscle below the biceps? Brachialis. And एक छोटा सा muscle होता है, वो है coracobrachialis. मतलब brachialis begins from where? Humerus. And brachialis का insertion कहाँ पे है? हाँ बोलो बच्चों. Brachialis का insertion. If you can tell me what is the insertion of brachialis, तो action will be very easy, है ना? Insertion of brachialis. Anyone? What is the insertion of brachialis? बोलो बोलो, guess करो. It's okay. हाँ. See if you know, if you remember this insertion of brachialis. Just one moment. Just one moment. Okay. Right. Just one moment. Have a look at this. So if I draw something here, that's the radius, that's the head of the radius, neck of the radius, यह है radial tuberosity, यह है shaft of the radius, यह है styloid process of radius, यह है ulna, यह है styloid process of ulna, यह है head of the ulna. बच्चों, can you tell me what is this for the ulna? यहाँ पे कुछ होता है. What is this known as? Any guesses? हाँ, यह है ulnar tuberosity. Ulnar tuberosity, है ना? And what is inserted on the ulnar tuberosity? Brachialis. मतलब brachialis कहाँ से arise होगा? Brachialis will arise from the humerus. इसका insertion कहाँ पे है? Ulnar tuberosity पे है. तो एक joint cross कर रहा है ना ये. It is crossing only one joint. That's the elbow joint. So what is the action of brachialis? Flexion at the elbow joint. Flexion at the elbow joint. ठीक है? So action of brachialis, flexion at the elbow joint. Insertion है उसका ulnar tuberosity पे. बच्चों, can you tell me what is this muscle? ये कौन है? Who's inserted on the radial tuberosity? चलो बोलो. Muscle inserted on the radial tuberosity. हाँ तो साथ साथ में सब हो जाता है. What is the muscle inserted on the radial tuberosity? Anyone? Yo. That's the biceps. muscle inserted on the radial tuberosity is the biceps. Fine, ठीक है, clear to all of you. Now between this radius and ulna there are three joints which are formed. ये भी खत्म कर देते हैं बच्चों, come on. Between the radius and ulna there are three joints. One is the superior radial ulnar joint. यहाँ पे this is the superior radial ulnar joint here. This is the inferior radial ulnar joint here. That's the inferior radial ulnar joint, and this is the middle radial ulnar joint. That's the middle. Can anyone tell me the middle radial ulnar joint is what type of joint? Come on, bacha, tell me. Middle radial ulnar joint, what is the type of joint? Now, this is extremely important. ये बहुत important MCQ है. Middle radial ulnar joint, what is the type of joint? Come on, बच्चों, come on, answer this. Answer. अगर गलत है तो भी ठीक है ना बच्चों. You'll learn something. नहीं, pivot नहीं है वो बच्चा, pivot नहीं है. Middle radial ulnar joint पाइवोट नहीं होता है. मिडिल रेडियल अल्ना जॉइंट इज अ फाइब्रस जॉइंट. यस, वेरी गुड, वेरी गुड. यस, किसी ने आंसर किया. दिस इज सिंडेस्मोसिस. सिंडेस्मोसिस टाइप ऑफ फाइब्रस जॉइंट. मिडिल रेडियल अल्ना जॉइंट ये इंट्रोशियस मेम्ब्रेन होता है, एंड दैट इज अ सिंडेस्मोसिस टाइप ऑफ फाइब्रस जॉइंट. एक्सीलेंट, वेरी गुड, एक्सीलेंट बच्चों, वेरी गुड. सुपीरियर एंड इंफीरियर रेडियल अल्ना जॉइंट्स जो है, दीज आर pivot, right? Superior and inferior radial ulnar joints are pivot type of synovial joints. These are pivot. Very good, very good. एक मिनट. Right, clear to all of you? Huh? Yes, excellent. चलो, coming back to our now, can anyone, so brachialis clear है ना? Brachialis का nerve supply is musculo, it's the musculocutaneous nerve. Brachialis का nerve supply is musculocutaneous nerve. एक चीज बोल सकते हैं, व्हाट इज अ कॉम्पोजिट मसल? बच्चों बोल सकते हैं व्हाट इज अ कॉम्पोजिट मसल? जो मसल दो नर्व सप्लाई करते हैं, अ मसल विच इज सप्लाइड बाय टू डिफरेंट नर्व्स, दिस इज व्हाट वी कॉल एज अ कॉम्पोजिट मसल, या इसे हम हाइब्रिड मसल भी बोलते हैं. कैन एनीवन गिव मी एग्जांपल्स ऑफ कॉम्पोजिट मसल? बच्चों दिस इज अनदर वेरी इंपॉर्टेंट एमसीक्यू फॉर यू. हाँ, एग्जांपल्स ऑफ कॉम्पोजिट मसल. चलो बोलो, व्हाट हैज हैपेंड टू दिस? हाँ, एग्जांपल ऑफ कॉम्पोजिट मसल, एनीवन? Yeah, I'm looking at the screen what you're writing. हाँ, example of composite muscle, एक तो है pectoralis major, हाँ, pectoralis major and pectoralis minor. इसका नर्व सप्लाई बोल सकता है कोई? हाँ, pectoralis major and minor, ये दोनों मसल्स को दो नर्व सप्लाई करते हैं. One is the medial pectoral nerve, the other one is the lateral pectoral nerve. Perfect है. So pectoralis major and minor is supplied by the medial and the lateral pectoral nerves. Excellent. Biceps नहीं बच्चे, biceps नहीं. अभिषेक, मुरली, biceps नहीं. Pectoralis major, minor. Second muscle is brachialis. Brachialis is also a composite muscle. Composite या hybrid muscle अपन डिस्कस करें. What is composite और hybrid muscle? जिसको डबल नर्व सप्लाई होता है, दो नर्व सप्लाई करते हैं इनको. So brachialis, yes, which are the two nerves supplying brachialis? वेरी गुड, वेरी गुड. लोअर लिम्ब, विद्या, वेरी गुड, दैट इज इन द लोअर लिम्ब. पहले अपर लिम्ब खत्म करते हैं ना. अपर लिम्ब के कॉम्पोजिट मसल बोलो. हु सप्लाइज द ब्रेकियालिस? दो नर्व्स हैं. कम ऑन, एनीवन गेस दिस? एक है मस्कुलोक्यूटेनियस नर्व, वेरी गुड, एंड दूसरा है रेडियल नर्व. दो नर्व सप्लाई करते हैं ब्रेकियालिस को. वन इज मस्कुलोक्यूटेनियस, द अदर वन इज रेडियल. एक्सीलेंट बच्चों, वेरी गुड, यू आर वेरी गुड. चलो, और कॉन्फिडेंस चाहिए. कम ऑन स्टूडेंट्स, यू कैन डू दिस. तीसरा मसल बोलो. तीसरा मसल इज द फ्लेक्सर डिजिटोरम प्रोफंडस. अपर लिम्ब के मसल्स पहले खत्म करते हैं. वी फिनिश द अपर लिम्ब मसल्स, राइट? सो फ्लेक्सर डिजिटोरम प्रोफंडस हैज गॉट अ ड्यूअल नर्व सप्लाई. बोल सकता है बच्चा? फ्लेक्सर डिजिटोरम प्रोफंडस के ड्यूअल नर्व सप्लाई, हु इज दिस? यस, बोलो, कम ऑन, गैस. अल्नार नर्व. हाँ, मीडियल हाफ को कौन सप्लाई करता है? अल्नार नर्व. एंड लैटरल हाफ को कौन सप्लाई करता है? मीडियन नर्व. अब मीडियन नर्व की वो ब्रांच है, दिस ब्रांच इज नोन एज द एंटीरियर इंट्रोशियस नर्व. हाँ, वेरी गुड, एक्सीलेंट हेमंत, एक्सीलेंट. सो फ्लेक्सर डिजिटोरम प्रोफंडस भी एक कॉम्पोजिट मसल है. इसके भी दो नर्व्स हैं. द मीडियल हाफ इज सप्लाइड बाय अल्नार एंड द लैटरल हाफ इज सप्लाइड बाय द मीडियन नर्व, बट इट्स अ ब्रांच ऑफ मीडियन. ये याद रखना, नाम एंटीरियर इंट्रोशियस नर्व. एक्सीलेंट, वेरी गुड हेमंत, एक्सीलेंट. हाँ बच्चों, आंसर करो. द मोर यू आंसर द मोर आई कैन टेल यू. जितना ज्यादा आंसर करोगे उतना ज्यादा मैं आपको बोल सकता हूँ. ठीक है, ओके. और कुछ? एनी अदर मसल इन द अपर लिम्ब? हाँ, कॉम्पोजिट मसल बोल सकते हो अपर लिम्ब में. यह है फ्लेक्सर पॉलिसिस ब्रेविस. फ्लेक्सर पॉलिसिस ब्रेविस, ये मसल थीनार एमिनेंस का मसल है. ये थीनार एमिनेंस का मसल है. इसके दो नर्व्स हैं. यस, yes बच्चा, this is the median nerve. हाँ, median nerve and ulnar nerve. हाँ, फ्लेक्सर पॉलिसिस ब्रेविस इज अ मसल ऑफ थीनर एमिनेंस, इसको भी डबल नर्व सप्लाई है, एक है मीडियल नर्व एंड एक है अल्नार नर्व। परफेक्ट है, ये अपर लिम्ब के कॉम्पोजिट मसल्स हो गए अपने। So pectoralis major and minor is supplied by medial and lateral pectoral nerves. Medial and lateral pectoral nerves. I'm writing in short, bachcho, you can understand that. Medial and lateral pectoral nerves, brachialis, musculocutaneous nerve and radial, flexor digitorum profundus, ulnar nerve and anterior interosseous branch of median nerve, and flexor pollicis brevis is supplied by median and ulnar nerve. Excellent, excellent. अतीत, हाँ वेरी गुड, चलो बच्चों वेरी गुड, चलो वेरी नाइस, सब लोग आंसर करिए। लोअर लिम्ब के कॉम्पोजिट मसल्स बोल सकते हो? यस, विद्या ने ऑलरेडी आंसर किया है ये। हाँ विद्या, यू हैव ऑलरेडी आंसर्ड लोअर लिम्ब के कॉम्पोजिट मसल। यस, एक है पेक्टिनियस, पेक्टिनियस, दूसरा है एडक्टर मैग्नस, एडक्टर मैग्नस, एंड तीसरा है बाइसेप्स femoris. Okay, biceps femoris. This all comes in MCQs, बच्चों. This all things are extremely important. You should know this. Come on. Pectineus का nerve supply बोल सकते हो? Anyone? Pectineus is having a dual nerve supply. ये कौन है? One is the femoral nerve. हाँ, femoral. And दूसरा कौन है? Obturator. है ना? Obturator nerve. Femoral and obturator nerve. Very good. Excellent, Vidya. Very good. Adductor magnus का dual nerve supply. बोलो, adductor magnus का dual nerve supply. Adductor magnus is supplied by tibial part of sciatic nerve. Adductor magnus would not be included in the hamstrings, बच्चा. Adductor magnus को एक ही nerve है, tibial part of sciatic nerve supply करती है. Biceps femoris के dual nerve supply. Biceps femoris long head is supplied by the tibial part, tibial nerve, and this is short head is supplied by the common peroneal nerve. Okay, common peroneal part of sciatic nerve. Huh? Tibial part of sciatic nerve and the common peroneal part of sciatic nerve. That's biceps femoris. Okay, ठीक है, very good. Pectineus, biceps femoris, और कोई है? Anything left? और कुछ बाकी है तो बोलो. Fine, okay, चलो, good. गुड गुड, वेरी गुड, वेरी गुड, बहुत अच्छे से आंसर कर रहे हो आप बच्चों, वेरी गुड, एक्सलेंट, अच्छा प्रिपरेशन है आपका, गुड। चलो, serratus anterior, come on बच्चा, can anyone tell me what is the nerve supply of serratus anterior? Extremely important, मैंने ना ऐसे चुन चुन के निकाले क्वेश्चंस आपके लिए। चलो बोलो बच्चों, what is the nerve supply of serratus anterior? And ये कहाँ से आता है? Where does this nerve arise from? Come on, come on, come on बच्चों, come on. I'm looking at the screen. I'm looking at the screen. Digastric, anterior and posterior belly of digastric बोल रहे हो? हाँ, anterior and posterior belly of digastric भी composite muscle है. Very good बच्चा. हर्ष, anterior belly is supplied by mandibular nerve and the posterior belly is supplied by facial nerve. Digastric, huh? Digastric. Very good. So what is the nerve supply of serratus anterior, बच्चा? That's the long thoracic nerve, right? That's the long thoracic nerve. And paralysis of serratus anterior leads to what? Winging of scapula. Winging of scapula. ये बाद में देखते हैं, मैंने एक visual भी डाला इस आपके लिए. What is the root value of long thoracic nerve? Yes, it is also known as nerve of Bell, nerve to serratus anterior. Excellent. Root value बोल सकते हो? Root value of long thoracic nerve. Anyone? Root value of long thoracic nerve. चलो चलो बच्चों, come on, think, सोचो सोचो, आंसर करो. I'm looking at the screen. बोलो बोलो बोलो. हाँ, C4 नहीं है बच्चा, C4 नहीं है. C5, C6, C7. रूट वैल्यू ऑफ लॉन्ग थोरैसिक नर्व क्या होता है? C5, C6 एंड C7. रूट्स, हाँ, C5, C6, C7 रूट्स ऑफ द ब्रेकियल प्लेक्सस. C5, C6, C7 है. एंटीक, yes, Yogam has answered it very well. Yes, very good. It's C5, C6, C7. And damage to this long thoracic nerve would lead to winging of scapula. ठीक है. एक्शन बोल सकता है कोई बच्चा? व्हाट इज द एक्शन ऑफ serratus anterior? ये ना स्कैपुला को आगे लेके जाता है. इट टेक्स द स्कैपुला फॉरवर्ड्स. लाइक सपोज इफ यू हैव टू लिफ्ट समथिंग, अगर आपको कुछ ऐसे लिफ्ट करना है, दूर है एंड यू आर लिफ्टिंग, ट्राइंग टू लिफ्ट समथिंग, स्कैपुला ऐसे जाता है, ऐसे अराउंड द चेस्ट वॉल. क्या बोलते हैं उसको? क्या बोलते हो? व्हाट इज दिस एक्शन नोन एज? एक्शन ऑफ serratus anterior. बोलो बच्चों. Answer. Protraction. Excellent. Very good. Protraction of scapula. Atit. Yes, protraction. And this protraction is very commonly seen in boxers. Boxers देखा आपने? They keep on punching, pushing and punching movements करते हैं. So they continuously scapula protract होता है. And serratus anterior को क्या बोलते हैं अपन? Boxers muscle. Excellent. Very good बच्चों. तो serratus anterior का दूसरा नाम क्या है? Boxers muscle. Excellent. इसको स्विमर्स मसल भी बोलते हैं, स्विमर्स मसल। हाँ, तो ये एमसीक्यू आ सकता है, स्विमर्स मसल बोलो या फिर बॉक्सर्स मसल बोलो, दैट्स सेराटस एंटीरियर। एक्सलेंट, वेरी गुड। चलो गुड बच्चा, वेरी गुड वेरी गुड। हाँ, अब एक चीज बोलना, इफ दिस स्कैपुला गोज लाइक दिस, हाँ, बाहर की तरफ गया अलोंग द चेस्ट वॉल, ये होता है प्रोट्रैक्शन। नाउ हु इज गोइंग टू ब्रिंग द स्कैपुला बैक टू इट्स नॉर्मल पोजीशन? हु इज गोइंग टू ब्रिंग द स्कैपुला बैक टू इट्स नॉर्मल पोजीशन? एनीवन? वन मोमेंट, आई जस्ट ड्रॉ दिस फॉर यू। मैं ये ड्रॉ करता हूं आपके लिए, एक मिनट। सी दिस, सी दिस, ये मैंने स्कैपुला ड्रॉ किया बच्चों, ये स्पाइन ड्रॉ किया मैंने, हाँ, ये डॉर्सल एस्पेक्ट ऑफ स्कैपुला ड्रॉ किया। ये बता सकते हो व्हाट इज दिस मसल which is inserted here on the medial border, dorsal aspect? What is this muscle inserted opposite to the spine, and what is this muscle below the spine? Come on, answer this. ये कौन है? हाँ, excellent, very good, कार्थी, अतीत, हेमंत, सबने आंसर किया। एक्सलेंट, वेरी गुड बच्चा। सो व्हाट इज दिस? ये है रोम्बॉइडस माइनर, ये है रोम्बॉइडस मेजर, ये है रोम्बॉइडस माइनर एंड दैट्स रोम्बॉइडस मेजर। हाँ, रोम्बॉइडस माइनर, रोम्बॉइडस मेजर। तो ये मसल्स क्या करते हैं? रिट्रैक्शन ऑफ स्कैपुला, रिट्रैक्शन प्लस, एक मिनट, आई जस्ट फिनिश दिस। हाँ, ये देखो कितना अच्छा है, यू कैन जस्ट आंसर दिस। ये मैंने क्लैविकल ड्रॉ किया बच्चों, कोई बोल सकता है व्हाट इज दिस मसल? य लाइक दिस एंड ये कौन है? व्हाट इज दिस मसल? मतलब दिस मसल बिगिंस फ्रॉम द स्पाइन ऑफ द स्कैपुला, द लैटरल बॉर्डर ऑफ एक्रोमियन। वैसे ही ये क्लैविकल के लैटरल 1/3 एंटीरियर बॉर्डर से अराइज होता है बच्चों। व्हाट इज दिस मसल? यस, एनीवन? यस, शाबाश। That retraction is done by trapezius and rhomboids. Excellent है, very good. ये क्या मसल है? कोई बोल सकता है what is this muscle? एक मिनट, just wait. Confuse नहीं होना, ये ह्यूमरस है। हाँ, and this muscle would come. Hey, look. ये देखो. Who's this? अभी बोलो, ये कौन है? ये deltoid है बच्चा, ये deltoid है. That's deltoid. And what is this muscle inserted on the superior border? ये acromion and ये clavicle. What is this? This is the trapezius. है ना? तो trapezius would come like this from the spine. ऐसे आता है trapezius. So trapezius along with the rhomboids, इनका action क्या होगा? It will pull the scapula back and इससे हम बोलते हैं retraction of scapula. Retraction. So बच्चा, retraction of scapula is done by whom? Retraction of scapula is done by rhomboids and the trapezius and the rhomboids. Clear है बच्चों? Are you able to follow? समझ में आ रहा है? कोरिलेट कर सकते हो? कुछ डिफिकल्टी है तो बोलो बच्चों। हाँ, ठीक है। So what is this? Retraction of scapula. हाँ, तो retraction of scapula is done by whom? एक मिनट, where's that gone? हाँ, so rhomboids will do retraction of scapula. What is the action of rhomboids? Retraction of scapula. And what is the nerve supply of rhomboids? कोई बोल सकता है what is the nerve supply of rhomboids? Yes, लीला बच्चा. What is the nerve supply of rhomboids? Nerve supply of rhomboids? Anyone? Dorsal scapular. Excellent बच्चों. Very good. That's a dorsal scapular nerve. It is also known as the nerve to rhomboids. Very good. इसका root value बोलो बच्चों. Root value. Dorsal scapular nerve का root value. वेरी गुड। अरे बच्चे, इवन इफ इट इज रॉन्ग डोंट डिलीट योर कमेंट, ठीक है ना बच्चा? डॉर्सल स्कैपुलर नर्व का रूट वैल्यू चाहिए। वेयर डज द डॉर्सल स्कैपुलर नर्व अराइज फ्रॉम? व्हिच रूट? C5। वेरी गुड शिवांगी, वेरी गुड। इट्स C5 रूट ऑफ द ब्रेकियल प्लेक्सस। एक्सीलेंट। सो क्लियर है बच्चा? व्हाट इज द एक्शन ऑफ रोम्बॉइड्स? रिट्रैक्शन ऑफ स्कैपुला। हु एल्स डज रिट्रैक्शन? अपना ट्रेपेजियस भी रिट्रैक्शन करता है। एंड हु सप्लाइज द रोम्बॉइड्स? इट्स द डॉर्सल स्कैपुलर नर्व। ये कहां से आती है? C5 रूट ऑफ द ब्रेकियल प्लेक्सस। एक्सीलेंट, वेरी गुड, वेरी गुड। एक मिनट, फ्रेनिक नर्व का रूट वैल्यू बोल सकता है कोई? फ्रेनिक नर्व का रूट वैल्यू बताओ। फ्रेनिक नर्व का रूट वैल्यू? हाँ, फ्रेनिक नर्व। आई वांट द रूट वैल्यू ऑफ फ्रेनिक नर्व जो डायफ्राम को सप्लाई करती है। हाँ बोलो, वेरी इंपॉर्टेंट एमसीक्यू, वेरी इंपॉर्टेंट। फ्रेनिक नर्व का रूट वैल्यू एनीवन? बताओ बच्चों, बताओ। T10 नहीं बच्चे, T10 नहीं, root value of phrenic nerve C3, C4, C5. Very good, Vidya has answered this. C3, C4, C5 is the root value of phrenic nerve. बच्चों, hello बच्चों, phrenic nerve root value you should know. You should know. ठीक है? Root value of phrenic nerve is C3, C4, C5. ये याद रखना. Sometimes एक extra phrenic nerve आती है. That's an extra phrenic nerve which arises from C5 root. C5 root. Any guesses what is that phrenic nerve known as? I'm just telling you this. अगर आप correlate कर सकते हो तो देखो C3, C4, C5 is phrenic nerve. हाँ, and ये जो C5 root है ना, C5 root of the brachial plexus, C5 root से there's one nerve that we get. C5 root से there's one nerve, इसका नाम है dorsal scapular nerve. हाँ, dorsal scapular nerve. There's one more nerve, बच्चों. There's one more nerve which arises from C5 root. हाँ, बोलो इसका नाम. एक और एक nerve है जो C5 root से आती है, इसका नाम चाहिए मुझे. This is an extra phrenic nerve. I told you, मैंने बोला आपको. It's an extra phrenic nerve. क्या बोल सकते हो इसको? What is the name? Extra. Anything extra is known as what? Anything extra? नहीं बच्चा, long thoracic nerve is C5, C6, C7. That is long thoracic nerve. ये देखो, if I draw C5, C6, C7 root, यहाँ से जो आती है वो है long thoracic nerve. C5, C6, C7. That's long thoracic nerve. Suprascapular nerve नहीं, suprascapular, yeah, I don't know whether you must be knowing this or not. एक मिनट, see, what did I tell you? Phrenic nerve. पहले मैंने क्या बोला? Phrenic nerve. Phrenic nerve का root value क्या है? C3, C4, C5. Sometimes there's an extra phrenic nerve which arises from the C5 root of the brachial plexus. Anything extra is known as what, बच्चों? Accessory. Accessory, yes, Vidya. Excellent. That's the accessory phrenic nerve, बच्चा. So from C5 root कभी-कभी एक nerve आता है, इसका नाम है एक्सेसरी फ्रेनिक नर्व. ये याद रखना बच्चों, एक्सेसरी फ्रेनिक नर्व अराइजेस फ्रॉम C5 रूट ऑफ द ब्रेकियल प्लेक्सस. C5 रूट से और एक नर्व आती है, दैट्स डॉर्सल स्कैपुलर नर्व. ये आपको पता है, ठीक है? वेरी गुड विद्या. हाँ चलो, वेरी गुड ऋषि. हाँ, एक्सलेंट टू ऑल ऑफ यू, वेरी गुड. चलो चलते आगे, विल प्रोसीड. फाइन. हु इज अ क्लाइंबर्स मसल? स्टूडेंट्स बोल सकते हो, who's a climber's muscle, which is the muscle which helps us to climb up. आपने देखा coconut tree है ना, लंबा सा coconut tree, and a person is climbing the coconut tree. Which is the muscle which helps us to climb? Anyone? It's a big muscle. एक hint देता हूँ. It's a big muscle. This muscle is a muscle of the back, and ये जो muscle है ना बच्चा, it comes and gets inserted into the floor of the bicipital groove. It gets inserted into the floor of the bicipital groove of the humerus. That's latissimus dorsi. You got this. Very good, बच्चों. This is the latissimus dorsi. So climber's muscle कौन है ये? Latissimus dorsi. हाँ, ये याद रखना बच्चा, latissimus dorsi. Latissimus dorsi का root value बोल सकते हो? Nerve to latissimus dorsi. हाँ, it is a branch of posterior cord of brachial plexus. Branch of posterior cord of brachial plexus. Very good. चलो, गुड गोइंग. अच्छा पेस है, अच्छा आंसर कर रहे हो आप लोग. वेरी गुड. चलो, नाउ यू टेल मी व्हाट इज दिस. ये क्या देख रहे हो बच्चों? ये जो छोटा सा ट्राइंगल मैंने बनाया यहाँ पे, दैट इज नोन एज द ट्राइंगल ऑफ ऑस्कल्टेशन. ट्राइंगल ऑफ ऑस्कल्टेशन. हाँ, एक्सटेंशन, एडक्शन एंड मीडियल रोटेशन. ठीक है बच्चा, ठीक है. शिवांगी, thoracodorsal nerve का रूट वैल्यू इज C6, 7, 8. C6, C7, C8. एंड ये जो thoracodorsal nerve है ना, इट्स अ ब्रांच ऑफ द posterior cord of the brachial plexus. ठीक है, posterior cord की ब्रांच है, रूट वैल्यू है C6, 7, 8. बस ये याद रखना. C6 नहीं बच्चा, इट इज C6, 7, 8. ठीक है, ओके. सो व्हाट इज दिस? दिस इज द ट्राइंगल ऑफ ऑस्कल्टेशन. हाँ, ये जो मैंने लगाया यहाँ पे, दैट्स अ ट्राइंगल ऑफ ऑस्कल्टेशन. एंड इसके बाउंड्रीज क्या होंगे बच्चा? व्हाट आर द बाउंड्रीज ऑफ दिस ट्राइंगल ऑफ ऑस्कल्टेशन? व्हाट इज दिस मसल नंबर 1? व्हाट इज दिस नंबर 2? एंड व्हाट इज दिस नंबर 3? सो 1 इज trapezius. I'll just write it here. 1 is trapezius. सो वन इज ट्रेपीजियस. एक बॉर्डर कौन बनाएगा? ट्रेपीजियस. सेकेंड बॉर्डर कौन बनाएगा? लैटिसिमस डॉर्साई, लैटिसिमस डॉर्साई. एंड तीसरा बॉर्डर कौन बनेगा? द मीडियल बॉर्डर ऑफ स्कैपुला, मीडियल बॉर्डर ऑफ scapula. So what is this? This is a triangle of auscultation. Trapezius, latissimus dorsi and scapula. Very good बच्चा, very good. तो यहाँ पे अपन stethoscope रखेंगे. On the left side we'll be able to hear the liquid sounds. जब stomach में when a person drinks, esophagus से जब ये stomach में जाएगा तो you can actually feel the gurgling sounds here. This is a triangle of auscultation. Clear है बच्चों? हाँ clear है ये. इसके boundaries clear है सबको? ट्रेपीजियस यहाँ पे, दैट्स द स्कैपुला मीडियल बॉर्डर, एंड नीचे से आता है लैटिसिमस डॉर्साई. ये देखो, दिस इज द ट्रेपीजियस, लैटिसिमस डॉर्साई एंड दैट्स द स्कैपुला. दैट्स द ट्रायंगल ऑफ ऑस्कल्टेशन. हेलो बच्चों, टेल मी एबडक्शन एट द शोल्डर जॉइंट. टेल मी नाउ. ये आ गया देखो, एबडक्शन एट द शोल्डर जॉइंट 0 to 15 डिग्रीज कौन करेगा? 15 to 90 डिग्रीज कौन करेगा? एंड 90 एंड अबाव कौन करेगा? 0 to 15 degrees is also known as, इसको दूसरा नाम क्या है? Initiation of abduction. Initiation of abduction. This is done by whom? Any guesses? Initiation of abduction कौन करता है? This is done by supraspinatus. ये कौन करेगा? Supraspinatus. 15 to 90 degrees is deltoid. ये कौन करेगा? डेल्टॉइड. एंड 90 एंड अबाव, इसे हम बोलते हैं ओवरहेड एबडक्शन. हु डज दिस? एनी गेसेस बच्चा? एनी गेसेस? ओवरहेड एबडक्शन कौन करता है? सो 0 to 15 इज नोन एज इनिशिएशन ऑफ एबडक्शन. बच्चों एमसीक्यू आता है इनिशिएशन ऑफ एबडक्शन. 0 to 15 कौन करेगा? ये सुप्रास्पाइनेटस. 15 to 90 कौन करता है? Deltoid, acromial fibers of deltoid. And 90 and above, what is this known as? Overhead abduction of arm. And this overhead abduction of arm is done by two muscles. Guess. Serratus anterior and trapezius. Excellent. Very good, बच्चों. Your preparation is really good. हाँ, ये कौन करता है? Serratus anterior and trapezius. Okay, just remember this. That's a very, very important MCQ, abduction at the shoulder joint. Perfect. Serratus anterior and trapezius. Perfect. Very good. Fine. Now come down to this Petit's triangle. Petit's triangle के boundaries बोल सकते हो. मैंने यहाँ पे बना दिया आपके लिए. What is this triangle here? That's a Petit's triangle. थोड़ा सा छोटा दिखता ही है, but that's a Petit's triangle. इसके boundaries बोल सकते हो बच्चा? What are the boundaries of Petit's triangle? Anyone? Who's this in front? ये कौन है muscle? ये कौन है? This is the external oblique muscle. आगे ये कौन है? Latissimus dorsi. पीछे. And what is the base formed by the iliac crest? Iliac crest. So इसे हम बोलते हैं lumbar triangle of Petit's. Petit's triangle. What are the boundaries बच्चों? Anteriorly is the external oblique. Posteriorly जो है वो latissimus dorsi होता है. And the base is formed by the iliac crest. So इसे हम बोलते हैं the lumbar triangle of Petit's. And what is the importance of this? इससे hernia हो सकता है. It's a potential space for a hernia. Lumbar triangle of Petit's. हाँ, ये clear है ना बच्चों? This is the triangle. Yo, that's a triangle. I can't magnify that. So आगे external oblique, पीछे latissimus dorsi. The base is formed by the iliac crest. बच्चों clear है ना? हाँ, आंसर नहीं कर रहा कोई? आंसर नहीं कर रहा है कोई? फाइन, ओके, फाइन, ठीक है, चलो, गुड. नाउ टेल मी व्हाट इज रोटेटर कफ मसल. रोटेटर कफ मसल इज फॉर्म बाय विच मसल्स? आगे कौन है, ऊपर कौन है, पीछे कौन है? एनीवन टेल मी व्हाट इज द रोटेटर कफ मसल फॉर्म्ड बाय? आई जस्ट राइट इट हियर. रोटेटर कफ. आंसर दिस. रोटेटर कफ. हाँ, बोलो. Who's this? Yes, SITS. Yogam. Excellent. Who's S? S कौन है? पहला मसल subscapularis है ना? Sits muscle subscapularis. Second मसल कौन है? Supraspinatus. Supraspinatus. Third मसल कौन है? Infraspinatus. And the fourth one is teres minor. Teres minor. The fourth muscle is teres minor. तो सबस्कैपुलरिस आगे है, सुप्रास्पाइनेटस ऊपर है, पीछे दो मसल्स है, इंफ्रास्पाइनेटस एंड टेरिस माइनर. दिस फोर मसल्स टुगेदर फॉर्म्स व्हाट इज नोन एज द रोटेटर कफ. परफेक्ट है, clear to all of you? So just remember this. So that completes my first slide. First slide clear है बच्चा? इसमें कोई doubt है, कोई difficulty है? These are all very handpicked topics for you. बहुत important है ये MCQ point of view से. So you should know all this. चलो, very good Rushi. Murli, very good. Hemant, yes, all of you answering well. Yes, good. Yes, Antique. Good. चलो अब बच्चों, we'll go to the next slide. Coming to the next slide for you. Here we go. चलो, structures piercing the clavipectoral fascia. बोलो बच्चा, what are the structures piercing the clavipectoral fascia? Very, very, very important MCQ. Structures piercing the clavipectoral fascia. Anyone? आप आंसर करिए, then I'll tell you. जो याद आता है वो आंसर करो बच्चा. बी वेरी फ्री. हाँ, बहुत फ्रीली कम्युनिकेट करो तो यू विल बी एबल टू लर्न बेटर. आई कैन बी एबल टू टेल यू इन मोर डिटेल्स. जितना आप है ना इंटरैक्टिव रहोगे उतना आई कैन टेल यू मोर. यस बच्चों, स्ट्रक्चर्स पियर्सिंग द क्लैवी पेक्टोरल फेशिया. कम ऑन. एक वेन होती है, एक वेन होती है जो lateral side of the upper limb पे होती है. Which is the vein on the lateral aspect of upper limb? Then this vein pierces the clavipectoral fascia and this opens into the axillary vein. What is that? Subclavian artery नहीं बच्चा. योगम, subclavian artery नहीं है. Clavipectoral fascia कहाँ पे होता है? आप pectoralis major को निकाल दो. You remove this pectoralis major, इसके नीचे होता है ये clavipectoral fascia. तो वो बहुत superficial है. So what are the structures piercing the clavipectoral fascia? एक तो vein है, cephalic vein. दूसरी एक आर्टरी होती है, an artery which is a branch of axillary artery. What is that artery? Thoracoacromial artery. Thoracoacromial artery. Third कौन है? Third is the lateral pectoral nerve. You should know this MCQ. It is extremely important, बच्चा. Lateral pectoral nerve. Lateral pectoral nerve. And the fourth is lymphatics from the breast. Lymphatics from the breast. ठीक है? Just remember these are the four structures which pierce the clavipectoral fascia. बच्चा ये याद रखो, structures piercing the clavipectoral fascia. ये जो clavipectoral fascia ये होता कहाँ पे है? It is deep to this pectoralis major. आप जैसे pectoralis major को निकाल देते हो, you see the clavipectoral fascia. And what are the structures which are piercing this? The first one is the cephalic vein. The second one is the thoracoacromial artery. ये axillary artery की branch होती है. The third is the lateral pectoral nerve, जो pectoralis major and minor को supply करता है. And fourth is lymphatics from the breast. Clear to all of you? हाँ, ये याद रखना. हाँ, this is very important. Fine. Okay, चलो. Branches from the lateral cord, medial cord, posterior cord. ये answer कर सकते हो? This you must be knowing. Branches from the lateral cord of the brachial plexus. Yes, anyone? Branches from the lateral cord. This comes in the MCQ. Branches of the lateral cord. Yeah, one lateral pectoral. Second, lateral root of median nerve. And तीसरा है musculocutaneous nerve. You must be knowing this, no? So lateral pectoral nerve, lateral root of median nerve, and musculocutaneous. Okay. Lateral pectoral, lateral root of median nerve and musculocutaneous nerve. Very good Vidya, very good Hemant, Yogam. अरे बच्चों, बाकी के बच्चों भी आंसर करो ना. भी इंटरैक्टिव. सब लोग आंसर करो बच्चों. जितना आंसर करोगे उतना कॉन्फिडेंस बढ़ेगा आपका. हाँ, एंड अगर गलती होती है दैट इज फाइन. गलती होती है इट्स ओके. यहाँ पे गलती करो. आई वॉन्ट यू टू मेक मिस्टेक्स इन द लेक्चर, सो बाद में यू विल नेवर फॉरगेट, है ना? So lateral pectoral, lateral root of median nerve, musculocutaneous nerve. These are the branches of lateral cord. Okay, coming to the medial cord. So medial cord, ये first branch same है, medial pectoral. Medial pectoral nerve. Second, medial root of median nerve. Next is medial cutaneous nerve of arm. दूसरा है medial cutaneous nerve of forearm, and the last one is ulnar. I want the root value of ulnar nerve. बच्चों, I want the root value of ulnar nerve. Anyone? What is the root value of ulnar nerve? ये MCQs में आता है. हाँ, root value of ulnar nerve बोल सकता है कोई? Very good हेमंत, very good. हाँ बोलिए बच्चा, root value of ulnar nerve बोलिए. C7, C8 and T1. Excellent, very good. देखो, medial cord, what is the root value बच्चा? What is the root value of medial cord? Root value of medial cord is C8 and T1, है ना? Medial cord का root value C8 T1 होता है. So ये सबका root value is C8 and T1, but ulnar nerve का root value is C7, C8 and T1. ये याद रखना. हाँ, ulnar nerve the root value is C7, C8 and T1. ये C7 के fibers कहाँ से आते हैं? From the lateral cord. C7 fibers comes from the lateral cord. ठीक है? Okay. What is the root value of this? इनका root value क्या है? C5, C6, C7. हाँ, ये तीनों का root value है C5, C6, C7. Ulnar nerve is C7, C8 and T1. Is this clear to all of you? Vidya, Shivangi, Ruhi, क्लियर है ना? रूट वैल्यू ऑफ अल्ना नर्व C7, C8, T1. बाकी जितने भी नर्व्स हैं, मीडियल कॉर्ड का रूट वैल्यू है C8, T1. तो ये जो C7 फाइबर्स है अल्ना नर्व में, ये कहां से आते हैं? दे कम फ्रॉम द लैटरल कॉर्ड. ठीक है बच्चों? ओके, वेरी गुड. नाउ कमिंग टू द पोस्टीरियर कॉर्ड. पोस्टीरियर कॉर्ड, हाँ, इसके साथ में इसका रूट वैल्यू भी बोलता है, कैसे याद रखने का. पोस्टीरियर कॉर्ड, व्हाट आर द ब्रांचेस? अपर सबस्कैपुलर, अपर सबस्कैपुलर, I'm writing in short, lower subscapular, upper subscapular, lower subscapular, and तीसरा है axillary. Posterior cord का root value क्या है? C5 to T1. C5 to T1 is the root value. सारे roots होते हैं. Next is nerve thoracodorsal. That is nerve to latissimus dorsi. And the last one is radial. चलो इसका root value बोल सकते हो? Radial. ठीक, that's fine. You tell me what is the root value of the first three. Upper subscapular, lower subscapular and axillary nerve, इनका root value है C5, C6. C5, C6. What is the root value of thoracodorsal nerve or the nerve to latissimus dorsi? That's C6, C7, C8. And radial is C5 to T1. बस, this you remember. So upper subscapular, lower subscapular and axillary, what is the root value? C5, C6. Thoracodorsal nerve or the nerve to latissimus dorsi, इनका root value is C6, 7, 8. And radial nerve is C5 to T1. Perfect. Very good. Okay. Fine. So just one last thing I'll tell you. Here, this is C5, this is C6, this is C7, this is C8, and this is T1. ये क्या होता है? These are the roots. Roots joins to form trunk. What is that? Upper trunk. ये है middle trunk. ये है lower trunk. Trunks will divide into a dorsal, 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 and a ventral, ventral, ventral divisions. Ventral division of upper and middle trunk से क्या बनता है? Lateral cord. Ventral division of lower trunk से क्या बनता है? Medial cord. And the dorsal division of all the three trunks से क्या बनेगा? Posterior cord. ये मैंने क्या बनाया आपके लिए? Brachial plexus. That's how the brachial plexus is. बस ये brachial plexus है. Just tell me what are the branches from the roots. We've just seen that. Branches from the roots from C5. ये कौन है? Dorsal scapular nerve. Dorsal scapular nerve. From C5, C6, C7. What's that? Long thoracic nerve. Long thoracic nerve. And there's one more nerve which arises from C5 root. ये कौन है? Accessory phrenic. Accessory phrenic nerve. ठीक है? अपर ट्रंक से दो नर्व्स आते हैं. अपर ट्रंक से दो नर्व्स आते हैं. यू नो दिस. अब बोलो इनके नाम बोलो. एंड व्हाट इज दिस पॉइंट? अप्स पॉइंट. है ना बच्चा? अपर ट्रंक से दो नर्व्स आते हैं एंड दैट पॉइंट ऑन द अपर ट्रंक इज नोन एज द अप्स पॉइंट. हाँ, व्हाट आर दीज टू नर्व्स? व्हाट आर दीज टू नर्व्स? Nerves arising from the upper trunk. Two nerves. And this point, जहां से ये nerves arise होता है, that point is the Erb's point. बोलो बच्चा. Bolo. Which are these two nerves? One is the suprascapular nerve and the second one is the nerve to subclavius. है ना? Branches from the upper trunk, suprascapular nerve and the nerve to subclavius. Axillary नहीं बच्चे. हेमंत, एक्सिलरी नहीं, एक्सिलरी इज अ ब्रांच ऑफ पोस्टीरियर कॉर्ड. ब्रांचेस फ्रॉम द अपर ट्रंक दो है, वन इज सुप्रास्कैपुलर, दिस यू शुड नो, सुप्रास्कैपुलर, एंड दूसरा कौन है, नर्व टू सबक्लेवियस, नर्व टू सबक्लेवियस. ठीक है, सुप्रास्कैपुलर एंड द नर्व टू सबक्लेवियस. परफेक्ट, वेरी गुड, एक्सलेंट. कमिंग बैक टू दिस, तो ये क्लियर है ना, आई हैव जस्ट फिल्ड दिस गैप्स फॉर यू. हाँ, तो ब्रांचेस फ्रॉम द लैटरल कॉर्ड खत्म किया हमने, मीडियल कॉर्ड खत्म किया, पोस्टीरियर कॉर्ड खत्म किया, रूट्स खत्म किया. राइट बच्चा. नाउ स्पेसेस अराउंड द आर्म, आई मीन दिस इज वेरी वेरी वेरी, यू नो, क्या बोलो इसको, हाई यील्ड टॉपिक, स्पेसेस अराउंड द आर्म. एक स्लाइड ड्रॉ करता हूँ बच्चों आपके लिए. हाँ, इसमें यू जस्ट ट्राई टू आइडेंटिफाई द ट्राइंगुलर स्पेसेस, द क्वाड्रेंगुलर स्पेसेस, एंड इसके कंटेंट्स पूछते हैं एग्जाम में. ओके, आई ड्रॉ स्लाइड. देखो बच्चों, है ना, ऐसे स्लाइड्स ड्रॉ करो आप. यू जस्ट ड्रॉ लाइक दिस स्लाइड्स एंड ट्राई टू अंडरस्टैंड दिस. सी हाउ ब्यूटिफुल. ये है अपना ह्यूमरस. चलो, आई स्टार्ट. टेल मी बच्चों, व्हाट इज दिस मसल व्हिच बिगिंस फ्रॉम द scapula to the sorry, what is this muscle which begins from the scapula and goes to the humerus? ये कौन है, ये कौन मसल है? That's a long head of triceps, long head of triceps. ठीक है, अब बोलो बच्चों, what is this muscle beginning from the scapula here and here? ये कौन है? Teres minor and that's teres major. Teres minor का insertion is on the humerus, on the humerus, हाँ, greater tubercle. Teres major, ये देखो देखो, it is gone in front, ये आगे गया, inserts into the medial lip of the bicipital groove. यह है teres major, goes and आगे गया, inserts into the medial lip of bicipital groove. यह है अपना teres minor, यह है अपना teres minor. बच्चों, come on, tell me, what is this? ये देखो, beautiful, and this is so beautiful, and this is superb. अब बोलो बच्चों, who's this number 1, who's this number 2, and who's this number 3? Come on, I made it very easy. चलो बच्चों, व्हाट्स नंबर 1? एंड इसके कंटेंट्स भी बोलिए, इट इज एक्सट्रीमली इंपॉर्टेंट. हाँ, नंबर 1 बोलो बोलो, आई एम लुकिंग एट द स्क्रीन, बोलो बच्चों. नंबर 1 के बाउंड्रीज कौन है? हाँ, ये कौन है? teres minor, ये है teres major, ये है long head of triceps. What is this space known as? Upper triangular space. Yogam, excellent. That's the upper triangular space. ये देखो बच्चा, number 1 is the upper triangular space. Yeah, I'll write it here. 1 is the upper triangular space. Upper triangular space. इसके boundaries कौन है? teres minor, teres major, long head of triceps. And देखो बच्चों, who's come here? ये कौन है? Who's this artery? What is this artery which has come through the upper triangular space? That's the circumflex scapular artery. So contents of upper triangular space अगर पूछते हैं exams में, viva में, in the MCQs, so what is the content of upper triangular space? It's the circumflex scapular artery. Perfect. Upper triangular space के boundaries clear है, teres minor, teres major, long head of triceps. That's upper triangular space. Content is circumflex scapular artery. Perfect. Very good. Now, what is number 2? Number 2 is the lower triangular space. Lower triangular space. देखो, that's the lower triangular space. इसके boundaries कौन है? Long head of triceps, teres major, and the shaft of the humerus. Right? And what comes in from here? Look who's come. अरे बच्चों, what is that? And look, इसके साथ कौन आ गया ये? What is this? Anyone? What is this? चलो बोलो, कंटेंट्स बोलिए, लोअर ट्रायंगुलर स्पेस के कंटेंट्स. वेरी गुड योगम, एक्सलेंट. देखो योगम कैसे आंसर कर रहे हैं, देखो, वेरी गुड. इट्स द रेडियल नर्व एंड द प्रोफंडा ब्रेकाई आर्टरी. एक्सलेंट. ये कौन है? रेडियल नर्व and profunda brachii. बच्चों, you should know this, radial nerve and profunda brachii, artery. ठीक है. Antique, very good बच्चा, very good. You also answered. Very good. Answer करो बच्चों. Answer करो. Fine. So lower triangular space is clear. Teres major, long head of triceps, and the shaft of the humerus. Okay, Antic, I couldn't see your answers. Abhi dikh raha hai. Very good. अब बोलो बच्चों, what is this space? That's a quadrangular space. And quadrangular space के boundaries बोलिए. Teres minor ऊपर, teres major नीचे, the long head of triceps, and the neck of the humerus. Correct? So what passes from here? एक artery है, and एक nerve है. Anyone? What is this nerve and what is this artery? So who's this number 3? Number 3 is the quadrangular space. Quadrangular space. Contents बोलिए. Axillary nerve and posterior circumflex humeral artery. Very good. So that's the axillary nerve and posterior circumflex humeral artery. I've written in short axillary nerve and the posterior circumflex humeral artery. Very good, very good. Chalo, good to all of you. बच्चों ये clear है. This is a very important visual slide भी आ सकता है इसका. इसके boundaries पे भी सवाल आ सकते हैं. हाँ, content and contents पे भी आ सकते हैं. So this covers many things. बच्चों happy, enjoying, खुश हो? बोलो. समझ में आ रहा है ना ये? Very good. चलो, we'll proceed. कोई doubts है इसमें? Any doubts in this, बच्चों? Okay, we'll proceed. Doubts है कुछ तो बोलिए. हाँ? So that's about the spaces. अब ये बोलो क्या है? What is this small triangular structure here? ये कौन है? What is this small triangular structure? ये, this one. That's the anatomical snuff box. Anatomical snuff box. Very good. And what is this? Cubital fossa. देखो बच्चों, anatomical snuff box पे ना MCQs आते हैं. Boundaries of the snuff box पे MCQs आते हैं. अब इसे कैसे याद रखोगे? How do you remember? And this anatomical snuff box के boundaries are very confusing. बहुत ज़्यादा confuse होते हैं. So let me just tell you the boundaries of anatomical snuff box. एक मिनट. Boundaries of anatomical snuff box. One moment. So that's the radius, head of the radius, neck of the radius, shaft of the radius, radial tuberosity. That's the ulna here, बच्चा. ठीक है? कैसे याद रखोगे देखो. हाँ, ये posterior side है, अपन पीछे से देख रहे हैं, dorsal aspect है ये. There's a muscle which arises from both radius and ulna. ये कौन है? Abductor pollicis longus. एक मसल है जो रेडियस एंड अल्ना से अराइज होता है. नाम abductor pollicis longus. There's a muscle which arises from radius, extensor pollicis brevis. अब these two muscles go together. ये दोनों साथ में जाते हैं. So abductor pollicis longus, extensor pollicis brevis साथ में जाते हैं. They are towards the radial side. ये क्या बनेंगे? They will form the lateral boundary of the snuff box. ये बनाएगा lateral boundary of the snuff box. What is this muscle? Beginning from the ulna, extensor pollicis longus, ये क्या बनाएगा? The medial boundary of the snuff box. बच्चा, it is very easy. बस ये slide यहाँ पे याद रखना, boundaries में कोई confusion नहीं होगा. ठीक है? So lateral boundary is formed by abductor pollicis longus, extensor pollicis brevis. The medial boundary is formed by the extensor pollicis longus. बच्चा, what is the floor formed by? बोलो बोलो बोलो. Floor is formed by the styloid process of radius, and दो carpal bones होते हैं यहाँ पे, scaphoid and trapezium. Scaphoid and trapezium. ये ना इसका बहुत common applied thing क्या है? If there's a tenderness in the snuff box, अगर snuff box में tenderness होता है तो it is generally due to fracture of. बोल सकते हो? अगर snuff box में tenderness है, आपके पास कोई patient आता है, बोलता है इधर snuff box में pain हो रहा है, tenderness है. You ask the person, do you have a history of fall? हाँ, गिर गए थे क्या? ऐसे हाथ को रख के a person falls on an outstretched arm. Yes, the person says yes, and you suspect what? क्या suspect करते हो? Fracture of scaphoid. Excellent. Very good. Very good, बच्चों. Excellent. Fracture of scaphoid. Excellent. So tenderness in the anatomical snuff box is fracture of scaphoid. हाँ, ये सब बहुत important चीज़ है, याद रखना बच्चा. Very good. Avascular necrosis is seen. Yes. इसका कंटेंट कौन है? Who's the content of the snuff box? Radial artery. And roof में क्या होता है इसके? Roof में होता है cephalic vein and the superficial branch of radial nerve. Roof में होता है cephalic vein and the superficial branch of radial nerve. Clear है बच्चा? स्नफ बॉक्स के बाउंड्रीज क्लियर है, हाँ, लैटरल बाउंड्री, मीडियल बाउंड्री, फ्लोर में कौन है, स्टाइलॉइड प्रोसेस है, स्कैफॉइड ट्रोपेजियम, कंटेंट क्या है, रेडियल आर्टरी, रूफ में है सिफेलिक वेन एंड द सुपरफिशियल ब्रांच ऑफ रेडियल नर्व। वेरी गुड बच्चा, वेरी गुड, एक्सलेंट। ओके, समथिंग एल्स आई ड्रॉ वन मोर स्लाइड फॉर यू। देखो बच्चों ये सब आ सकता है, विजुअल्स भी आते हैं ये, हाँ, ये फर्स्ट रिब है, ये फर्स्ट रिब है। देखो सी आई ड्रॉ वेरी नाइस स्लाइड फॉर यू। ये देखो मेरे बच्चों, हु इज दिस, ये कौन है? ओहो, यहाँ पे थोड़ा सा किंकिंग हो गया इसका, एक मिनट। हु इज दिस? अब बच्चों बोलो व्हाट इज दिस आर्टरी, ये कौन आर्टरी है? हाँ, यस, व्हाट इज दिस आर्टरी? ये फर्स्ट रिब है बच्चा, दिस इज द फर्स्ट रिब, फर्स्ट रिब। See, automatically you get prepared for the next exams also. मतलब I always say that FMG के बच्चों का प्रिपरेशन बहुत बहुत ज़्यादा अच्छा होता है, बिकॉज FMG का तो देते ही हो एग्ज़ाम, तो इसी में आपका है ना नियरली 70% हो ही जाता है, एंड बस एक 10-20% जो रहता है दैट यू स्टडी फॉर द नेक्स्ट ऑन नीट, सो यू आर मास्टर्स। यस, सो बच्चों व्हाट इज दिस आर्टरी, व्हाट इज दिस आर्टरी? कोई बोल सकता है ये फर्स्ट रिब है, तो ये कौन है बच्चा? दैट्स द सबक्लेवियन आर्टरी, दैट्स द सबक्लेवियन आर्टरी। ये फर्स्ट रिब पे ये एक ट्यूबरकल होता है जिसका नाम है स्केलीन, SCALENE, स्केलीन ट्यूबरकल, इसका नाम है स्केलीन ट्यूबरकल, राइट। एंड ये स्केलीन ट्यूबरकल पे एक मसल होता है, ये कौन है बच्चा? स्केलीन ट्यूबरकल पे एक मसल होता है, ये है स्केलिनस एंटीरियर, ये है स्केलिनस एंटीरियर। ये स्केलिनस एंटीरियर पे एक नर्व होती है बच्चों, दिस इज द फ्रेनिक नर्व। देखो कितने सारे एमसीक्यूज मैंने आपको बोला है, कितने सारे एमसीक्यूज बोला है, देखो। So subclavian artery is divided into 3 parts by whom? हाँ, सबक्लेवियन आर्टरी को 3 पार्ट्स में कौन डिवाइड करता है? स्केलेनस एंटीरियर, है ना बच्चों? सबक्लेवियन आर्टरी को 3 पार्ट्स में कौन डिवाइड करता है? स्केलेनस एंटीरियर। दैट्स द फर्स्ट पार्ट, दैट्स द सेकंड पार्ट, दैट्स द थर्ड पार्ट। ये 3 पार्ट्स हो गए सबक्लेवियन आर्टरी के। एंड ऑन द स्केलेनस एंटीरियर देयर इज अ नर्व, कौन है ये? फ्रेनिक नर्व। फ्रेनिक नर्व का रूट वैल्यू मैंने आपको बोला, द नर्व व्हिच लाइज ऑन द स्केलेनस एंटीरियर इज फ्रेनिक नर्व। बस ये याद रखना बच्चा, एवरीथिंग दैट आई एम टॉकिंग इज एन MCQ, जस्ट रिमेंबर। Okay, okay, okay. Yo. Who's this muscle? Who's this muscle? This is the pectoralis minor. ये है अपना pectoralis minor. ये कौन है? Teres major. ये है teres major. Fine. That's a teres major. So now you tell me, what is this artery? यहाँ से, from here, what is this artery? This is the axillary artery. ये subclavian artery है, this is the axillary artery. Axillary artery is divided into 3 parts by whom? Pectoralis minor muscle. So that's the first part, that's the second part, and that's the third part of the axillary artery. जैसे ये teres major को cross करता है, what is this artery? Brachial artery. That's a brachial artery. ठीक है, so ये brachial artery आ गई अपनी cubital fossa के अंदर, right? So subclavian का बना axillary, subclavian के 3 parts होते हैं by the scalenus anterior, axillary के 3 parts हैं by pectoralis minor। अब ये axillary बन गई brachial, हाँ, it comes down। What is this nerve बच्चा? What is this nerve? हाँ, मैं ये डायरेक्टली बोलता हूँ आपको, what is this nerve which is crossing the brachial artery and coming here? ये कौन है? Median nerve। ये है मीडियन नर्व, दैट्स अ मीडियन नर्व। सो देखो मैं क्या ड्रॉ कर रहा हूँ आपके लिए, व्हाट एम आई ड्रॉइंग फॉर यू? व्हाट इज दिस मसल? That's a pronator teres. What's this muscle? That's a brachioradialis. So what are the contents of cubital fossa? That's a median nerve. What's this? Brachial artery. इसके 2 branches होते हैं, radial and ulnar. Then the third thing that you get is the tendon of biceps, and the fourth is the radial nerve. So this becomes the contents of cubital fossa. जैसे आप MBBR लिखते हो, right? So that's the medial nerve, that's the brachial artery with its 2 terminal branches, that's the tendon of biceps, and that's the radial nerve. Clear to all of you? So this becomes the contents of cubital fossa. Okay, clear? Fine. Chalo, any doubts in this slide? Any doubts in this? I'll proceed then. In this page, Fine. Okay, let us go forwards. Coming to this. Branches of axillary artery. Yes, students, tell me now, what are the branches of axillary artery? Coming back to the slide, branches of axillary artery. Okay, so which is this part of axillary artery? First part. That's the second part, and that's the third part of the axillary artery. What are the branches from the first part of the axillary artery? Yes, bacho bolo, what is the branch from the first part? That's the superior thoracic. That's the superior thoracic artery. Second part के दो branches है. That's the lateral thoracic and thoracoacromial. Right, and third part के three branches है. Third part gives three branches. I'll just make it here. One is the anterior circumflex humeral artery, posterior circumflex humeral artery, and the subscapular artery. Subscapular. Okay, very good. Very good. So first part superior thoracic, second part is lateral thoracic and thoracoacromial, and the third part is anterior circumflex humeral, posterior circumflex humeral and subscapular. मैंने short में लिखा है, ठीक है ना? Anterior circumflex humeral, posterior circumflex humeral and subscapular. Cephalic vein is not a branch, बच्चा. Cephalic vein is not a branch. It's a vein. It's not a branch of the artery. ठीक है ना बच्चों? Clear to all of you? Okay, very good, very good. Very good, Atif. वेरी गुड बच्चा. ठीक है बच्चा. हाँ, इजी है. सब एक्सिलरी आर्टरी के तीन पार्ट्स होते हैं. ये तीन पार्ट्स में डिवाइड कौन करता है एक्सिलरी आर्टरी को? अपना पेक्टोरलिस माइनर. सो फर्स्ट पार्ट का एक ब्रांच, सेकंड पार्ट के दो ब्रांचेस, थर्ड पार्ट के तीन ब्रांचेस. फर्स्ट पार्ट का ब्रांच सुपीरियर थोरैसिक आर्टरी, सेकंड पार्ट का लैटरल थोरैसिक एंड थोरैकोएक्रोमियल, एंड थर्ड पार्ट के तीन ब्रांचेस. परफेक्ट. ठीक है. वेट आतिफ, बाद में डिस्कस करते हैं. आतिफ, कॉन्सेंट्रेट करो, कॉन्सेंट्रेट करो. ओके, दैट्स फाइन. So these are the branches of axillary artery. Come on. Musculocutaneous nerve, मैंने आपको बोल दिया. Musculocutaneous nerve is a branch of lateral cord. Musculocutaneous nerve तीन muscles को supply करता है. Biceps brachialis, coracobrachialis, and this musculocutaneous nerve continues as the lateral cutaneous nerve of forearm. Lateral cutaneous nerve of forearm. Axillary nerve supplies deltoid, teres minor, एंड उसका एक क्यूटेनियस ब्रांच है, अपर लैटरल क्यूटेनियस नर्व ऑफ आर्म. अपर लैटरल क्यूटेनियस नर्व ऑफ आर्म. ठीक है, दैट्स फाइन. चलो बच्चों, नाउ टेल मी मसल सप्लाइड बाय मीडियर नर्व इन द फोरआर्म एंड हैंड. ये बोल सकता है कोई? मसल सप्लाइड बाय मीडियर नर्व इन द फोरआर्म एंड हैंड. हाँ, इन द फोरआर्म व्हाट आर द मसल सप्लाइड बाय मीडियर नर्व? बोलो. शॉर्ट में लिखता हूँ मैं. आई जस्ट राइट इन शॉर्ट. मसल सप्लाइड बाय मीडियर नर्व इन द फोरआर्म. वन इज प्रोनेटर टीरीज, फ्लेक्सर कार्पी रेडियालिस, palmaris longus, flexor digitorum superficialis. Flexor digitorum superficialis. The flexor carpi ulnaris is supplied by ulnar nerve. ठीक है ना? In the forearm, pronator teres, flexor carpi radialis, palmaris longus, and flexor digitorum superficialis. This is supplied by medial nerve. Flexor carpi ulnaris is supplied by ulnar nerve. Then deep muscles. ये superficial हो गया. Deep muscles, flexor pollicis longus, flexor digitorum profundus का lateral half, and pronator quadratus. This is supplied by whom? This is supplied by anterior interosseous nerve. This is supplied by anterior interosseous nerve. Clear, bacha? So these are the branches of. Okay. Answer करो बच्चों. क्या हुआ? Answer करो. Answer नहीं कर रहे हो. Fine. So what are the branches of, I mean, what are the muscles supplied by medial nerve in the forearm? Superficial muscles हो गए. Superficial muscles का flexor carpi ulnaris is supplied by ulnar nerve. अब deep muscles, flexor pollicis longus, flexor digitorum profundus का lateral half, pronator quadratus. This is supplied by anterior interosseous nerve, which is a branch of medial nerve. Flexor carpi ulnaris and medial half of profundus. This is supplied by whom? This is supplied by ulnar nerve in the forearm. Okay, now in the hand, what is the medial nerve supply? बोल सकते हो बच्चा? In the hand, I'll just write in short. In the hand, medial nerve supplies how many muscles? 5 muscles. Which are those? Abductor pollicis brevis, flexor pollicis brevis का superficial head, opponent's policies, first and second lumbricals. You should know this, huh? You should know this. Yes. So what are the muscles supplied by median nerve in the hand? Abductor pollicis brevis, flexor pollicis brevis का superficial head, opponent's pollicis, and first and second lumbrical. Median nerve supplies many muscles in the forearm. Median nerve is known as what? Laborer's nerve. Median nerve को अपन क्या बोलते हैं? Laborer's nerve. Now, what are the muscles supplied by ulnar nerve? Ulnar nerve क्या muscle supply करती है? Abductor digiti minimi brevis, flexor digiti minimi brevis, opponent's digiti minimi. ये three muscles of hypothenar eminence. Third and fourth lumbricals. Four, I mean, you can say all intraossei. All intraossei, मतलब 4 palmar, 4 dorsal, all intraossei. That is 8. ठीक है ना? Adductor pollicis, and the deep head of flexor pollicis brevis. Flexor pollicis brevis composite muscle है ना बच्चा? Yes, flexor pollicis brevis. Adductor pollicis is supplied by ulnar nerve, बच्चा. Hemant, adductor pollicis is supplied by ulnar nerve. So these are the muscles supplied by median nerve and ulnar nerve in the hand. This you should know, huh? ये है median nerve in the hand, ये है ulnar nerve in the hand. ठीक है बच्चा? Palmaris brevis को भी supply करता है. Yes, palmaris brevis. ठीक है. Okay, perfect. ठीक है. So 15 muscles supplied by the ulnar nerve in the hand, and this 15 muscles are used by musician for very fine movements. Ulnar nerve को हम क्या बोलते हैं? Musician's nerve. Whereas median nerve, ये जो muscles forearm के muscles supply करता है, this forearm muscles are used to lift weight. So median nerve is therefore known as what? Laborer's nerve. Laborer's nerve is median nerve. Musician's nerve is ulnar. एक MCQ है बच्चा, graveyard of ulnar nerve. कोई बोल सकता है? मतलब ulnar nerve सारे muscle supply करता है. It supplies 15 muscles and then it goes and ends in a muscle. That's the end of ulnar nerve. We call this muscle as the graveyard of ulnar nerve. कौन है? बोलो. Graveyard. मतलब ulnar nerve goes and buries itself. खत्म. Ulnar nerve is खत्म. कौन है? Who's that muscle? Anyone? What's the name of that muscle? Adductor pollicis. ये याद रखना. Adductor pollicis. So adductor pollicis is known as graveyard of ulnar nerve. Graveyard of ulnar nerve. ठीक है? That's adductor pollicis. Adductor pollicis. Atif, बाद में सवाल पूछो. Just wait. Just concentrate on the lecture. You can ask later. ठीक है? So adductor pollicis is known as graveyard of ulnar nerve. Perfect है बच्चों? Clear to all of you? Muscle supplied by median nerve, ulnar nerve in the forearm, in the hand. This you should know. ठीक है? चलो, very good. So let us now proceed. Proceed to the next slide. चलो. Muscle supplied by radial nerve. We'll see this after some time. Muscle supplied by the radial nerve. बोल सकते हो? Which are the muscle supplied? पूरा पीछे के muscle supply करता है radial nerve. It supplies the triceps and all the extensor muscles of the arm and forearm. Right? That everything is supplied by radial nerve. Muscle supplied triceps, the superficial extensors and the deep extensors. All these muscles would be supplied by radial nerve, which is the deep branch of radial nerve. कोई बोल सकता है? What is that deep branch of radial nerve known as? Anyone? जैसे deep branch of median nerve कौन है? Anterior intraosseous nerve. वैसे deep branch of radial nerve कौन है? Posterior intraosseous nerve. Posterior intraosseous nerve. That's a deep branch of radial nerve. What is this? What is this paralysis? That's the Erb's paralysis. And Erb's paralysis is injury to the upper trunk of the brachial plexus. अब इसमें arm कैसा होता है? Forearm कैसा होता है? Arm is adducted. ठीक है, very good. The arm is adducted. The arm is medially rotated. The forearm is extended. The forearm is pronated. Forearm extended होता है, forearm pronated होता है, and the fingers are like this. Fingers are like this. अगर ये visual slide आता है, so इसे आप क्या लिखोगे? This is Erb's paralysis. Erb's paralysis. इसे identify कर सकते हो बच्चा? This is Erb's paralysis. Policeman's tip hand. Yes. So the arm is adducted, the arm is medially rotated, the forearm is extended, the forearm is pronated, and fingers are flexed. That's policeman's tip hand. Injury to the Erb's point. That's Erb's paralysis. Very good. ये क्या बोल सकते हो? ये कुछ visual slides है बच्चा, बोलो. What is this? And paralysis of what leads to this? चलो बच्चों, come on, you're answering very well. Come on बच्चों. हाँ nerves involved बोल रहा ना हेमंत. ये क्या slide है, बोलो. ये क्या है? Anyone? बोलो बच्चों. Claw hand. Very good. That's a complete claw hand. Complete claw hand. मतलब this is what we call as a complete claw hand. And this is paralysis of which muscle? This is seen in 𝐒𝐿𝐃𝐝's paralysis. Very good. अगर चारों फिंगर्स का क्लॉ हैंड होता है तो दिस इज कंप्लीट क्लॉ हैंड. ये कहाँ पे होता है? 𝐒𝐿𝐃𝐝's पैरालिसिस में. अगर ओनली अल्ना नर्व इंजरी होती है तो यू गेट अ क्लॉ हैंड ऑफ दिस 2 डिजिट्स. ओनली मीडियन नर्व इंजरी होती है, यू गेट अ क्लॉ हैंड ऑफ दिस 2 डिजिट्स. इसे हम बोलते हैं पार्शियल क्लॉ हैंड. पार्शियल क्लॉ हैंड. इफ ऑल दिस 4 फिंगर्स आर इन्वॉल्व, इसे हम बोलते हैं complete claw hand, and that is seen in 𝐒𝐿𝐃𝐝's paralysis. Excellent. Very good बच्चा. 𝐒𝐿𝐃𝐝's paralysis. lumbricals and intraossei, mainly lumbricals. Paralysis mainly lumbricals का होता है. Yes, intraossei are also involved. Very good, very good. What is this? ये है ना, ये slide देखिए बच्चा. See this shoulder, ये shoulder देखिए, and see this shoulder. ये है ना, ये इसको हम बोलते हैं flat shoulder, flat shoulder. ये जो राउंड शेप है ना शोल्डर का, दिस राउंडेड शेप ऑफ शोल्डर इज बिकॉज ऑफ विच मसल? डेल्टॉइड. ये जो राउंडेड शेप है इसको हम बोलते हैं कॉन्टूर. दिस राउंडेड कॉन्टूर ऑफ द शोल्डर इज बिकॉज ऑफ विच मसल? डेल्टॉइड. इफ दिस डेल्टॉइड इज पैरेलाइज्ड, द शोल्डर बिकम्स फ्लैट. वी कॉल दिस एज फ्लैट शोल्डर. इसे हम बोलते हैं फ्लैट शोल्डर. एंड दिस इज सीन इन पैरालिसिस ऑफ विच मसल? ड्रूपिंग शोल्डर नहीं, इसे हम बोलते हैं फ्लैट शोल्डर. फ्लैट शोल्डर. This is due to paralysis of axillary nerve. Axillary nerve. This is due to paralysis of axillary nerve. You can actually see the bones here. यहाँ पे bones दिखते हैं. Tubercles दिखते हैं humerus के. So this is known as flat shoulder, and this is due to injury to the axillary nerve. Excellent. Very good. Very good बच्चा. Answer some more clinical slides. What is this? ये क्या है? What is this? This is winging of scapula. Winging of scapula. So paralysis of serratus anterior. Paralysis of serratus anterior. What is this? This is wrist drop. Wrist drop. ये है wrist drop. Injury to which muscle? This is long thoracic nerve. This is long thoracic nerve. Injury to the long thoracic nerve. Wrist drop. Injury to the radial nerve. Radial nerve causes wrist drop. तो ये ऐसे visual slides आ सकते हैं. You need to know what is this. Very good. Radial nerve injury. Excellent. What is this? ये क्या है? इसमें देखो thenar eminence flat हो गया. This is flattening of thenar eminence. Which nerve is involved here? Which nerve is involved? Flattening of thenar eminence. Nerve involved? Anyone? Come on, come on, come on, बच्चों, come on. बाकी बच्चे कहाँ गए? This is due to median nerve. Median nerve. ये median nerve thenar muscles को supply करते हैं ना. You can see flattening of the thenar eminence. So this is the injury to the median nerve. Mainly carpal tunnel syndrome में होता है ये. Carpal tunnel syndrome. Yes, Sabas, very good. Hemant, very good. Yogam, yes, excellent to all of you. Okay, coming to the boundaries of femoral ring. Bacha, another extremely important MCQ. Boundaries of femoral ring. Anyone? What are the boundaries of femoral ring? एक मिनट, I'll just draw this for you. ये है अपना inguinal ligament. ये ऐसे turn हो गया, ये ऐसे पीछे गया. The inguinal ligament. Okay. Tell me what is present here. This is the femoral sheath. Lateral compartment में होता है femoral artery plus एक nerve होती है, the femoral branch of genitofemoral nerve. Intermediate compartment में क्या होता है? Femoral vein. In the intermediate compartment is the femoral vein, and the medial compartment is known as the femoral canal, है ना? The medial compartment of the femoral sheath को क्या बोलते हैं? Femoral canal. The upper part of the femoral canal is known as the femoral ring. बच्चों, tell me what are the boundaries of the femoral ring? Come on, anyone? Boundaries of femoral ring. चलो, I'll just put numbers 1, 2, 3 and 4. Start. 1 कौन है? 1. यहाँ पे लिखता हूँ. Who's 1? What are the boundaries of femoral ring? What's 1? Inguinal ligament. Inguinal ligament. Number 1 is the inguinal ligament. बच्चा आंसर करो, आंसर करो. This is very important. Yes, Shivangi, CTS carpal tunnel, that's very good. बरोबर लिखा आपने. So number 1 is inguinal ligament. Number 2 is lacunar ligament. बच्चा, this is a very important MCQ. ये जो आप देख रहे हो, that's our femoral ring. And femoral ring के boundaries क्या होता है? Who's number 1? आगे anterior inguinal ligament. Who's number 2? Lacunar ligament. Who's number 3? Pectinate ligament. Pectinate ligament. And who's number 4? Number 4 is the, bolo bacha, answer karo. This you must be knowing. Number 4 is the septum, separating it from femoral vein. Femoral vein. Septum separating it from the femoral vein. Right? From femoral vein. So these are the boundaries of femoral ring. Bacha, you should know this. Huh? This is very important. Clear? So आगे inguinal ligament, lacunar ligament, pectinate ligament, and fourth is the boundaries, septum separating it from the femoral vein. So these are the boundaries of femoral ring. यहाँ से hernia हो सकता है, femoral hernia. Fine. Okay, coming to this, sartorius muscle. You know, sartorius muscle is the longest muscle in the body. Anyone can tell me what is the nerve supply of sartorius? Nerve supply of sartorius is femoral nerve. Nerve supply of sartorius is femoral nerve. Sartorius is also known as a honeymoon muscle. Honeymoon muscle. Honeymoon muscle is sartorius. इसका action बोल सकता है कोई? What is the action of sartorius? Anyone? What is the action of sartorius? ये कुछ MCQs है बच्चा. I've just put it directly for you. बोलो ना. बोलो. Whatever you know, you answer. Nerve supply of sartorius. Lower limb answer करो बच्चों. Important है. नहीं. Nerve supply of sartorius is femoral nerve. Sartorius is known as honeymoon muscle. What is the action of sartorius on the hip joint? What is the action of sartorius on the knee joint? ये याद रखना. Sartorius causes abduction, flexion, and abduction, flexion, and lateral rotation. Abduction, flexion, and lateral rotation at the hip joint. Abduction, flexion, and lateral rotation at the hip joint. Flexion and medial rotation at the knee joint. So this is the action of sartorius. Bacha, this is the action of sartorius. This is extremely important. याद रखना ये sartorius क्या करता है? Abduction करता है, flexion करता है, lateral rotation करता है hip joint पे, and flexion and medial rotation ये करेगा knee joint पे. Yes, sartorius is therefore known as a honeymoon muscle. You understand the actions, you will understand why it is known as honeymoon muscle. अब एक मसल है जिसका एक्शन इज एग्जैक्टली ऑपोजिट टू दैट ऑफ sartorius. कौन है ये बोल सकते हो? दिस मसल इज नोन एज, सो sartorius इज नोन एज हनीमून मसल. जो दूसरा मसल है दैट इज नोन एज एन एंटी रेपिस्ट मसल. कौन है ये? ग्रेशियलिस. ग्रेशियलिस is known as anti-rapist muscle because ग्रेशियलिस action on the hip joint is exactly opposite. It does adduction, it does medial rotation at the hip joint. So ग्रेशियलिस is known as anti-rapist muscle. ये याद रखना. एंड sartorius को क्या बोलते हैं? हनीमून मसल. ठीक है? ओके फाइन. सो बच्चों टेल मी नाउ, फ्लोर ऑफ फीमोरल ट्राइंगल. फ्लोर ऑफ फीमोरल ट्राइंगल इज फॉर्म बाय व्हाट? एनीवन? कोई बोल सकता है? फ्लोर ऑफ फीमोरल ट्राइंगल इज फॉर्म बाय, फ्लोर ऑफ फीमोरल ट्राइंगल इज फॉर्म बाय एनीवन? बोलो, आंसर करो ना. iliacus, psoas major, pectineus, and adductor longus. Adductor longus. These are the four muscles जो floor बनाते हैं femoral triangle का. What is that? Iliacus, psoas major, pectineus, and adductor longus. These are the muscles which forms the floor of femoral triangle. Clear to all of you? Okay, just one moment. I'll just have some water, बच्चों. Clear? Hello, Amit. Hi, Amit. Okay, obturator nerve. Obturator nerve. What is the obturator nerve supply? Any guesses? बोल सकते हो ये? ऑब्चुरेटर नर्व के दो डिविजन्स होते हैं, एंटीरियर एंड पोस्टीरियर. दिस इज वेरी इजी व्हाट आई एम टेलिंग यू. फ्लो चार्ट्स बहुत इजी है, आंसर करिए आप. सो ऑब्चुरेटर नर्व दो डिविजन्स होते हैं, anterior posterior. What is the anterior division of obturator nerve supply? Adductor longus, adductor brevis, pectineus, and gracilis. Anterior division of obturator nerve supply is adductor longus, adductor brevis, pectineus, and gracilis. Posterior division क्या supply करता है? Adductor magnus and obturator externus. Adductor magnus and obturator externus. ओके अमित, ठीक है. मिलते हैं, विल स्टडी, पढ़ाता हूँ, ठीक है. सो ऑब्चुरेटर नर्व डिवाइड्स इनटू एन एंटीरियर पोस्टीरियर डिवीजन. एंटीरियर डिवीजन क्या सप्लाई करती है बच्चा? दिस इज अ वेरी वेरी इंपॉर्टेंट एमसीक्यू, याद रखिए. ये एडक्टर लॉन्गस, एडक्टर ब्रेविस, पेक्टिनियस एंड ग्रेशियलिस ये सप्लाई करता है एंटीरियर डिवीजन ऑफ ऑब्चुरेटर नर्व. पोस्टीरियर डिवीजन ऑफ ऑब्चुरेटर नर्व क्या सप्लाई करती है? एडक्टर मैग्नस एंड ऑब्चुरेटर एक्सटर्नस. परफेक्ट है ये. बस जितना मैं बोल रहा हूं उतना याद रखिए. दिस यू विल बी एबल टू क्रैक योर एग्जाम्स डेफिनेटली. फाइन. Fine, that's about the obturator nerve. Now, which are the hamstring muscles? Anyone? बोल सकते हो which are the hamstring muscles? And nerve supply तो आपको पता होगा. Hamstring muscle, one is semitendinosus, semimembranosus, biceps femoris and adductor magnus. Right? Hamstring muscles कौन से होते हैं? Semitendinosus, हेमंत आंसर करो. योगम, हेमंत, शाबाज, शिवांगी आंसर करिए. अपर लिम्ब यू आंसर्ड वेरी वेल. लोअर लिम्ब भी आंसर करो बच्चों. So which are the hamstring muscles? Semitendinosus होता है, semimembranosus होता है, the long head of biceps femoris. Short head of biceps femoris hamstrings नहीं होता है बच्चों. The long head of biceps femoris is a hamstring and the adductor magnus. Adductor magnus is a hamstring. Perfect है? Fine. अब what is the action of gluteus maximus? Any guesses? Gluteus maximus का action क्या है? Gluteus medius and minimus का action क्या है? बोलिए बच्चों. Gluteus maximus. What is the action? You should know this. You should know this. Bolo. What is the action of gluteus maximus? Anyone? चलो, I'm waiting. आप आंसर करिए, सोचिए, आंसर करिए. Action of gluteus maximus, it is extension. Extension. What else? Abduction and lateral rotation at the hip joint. बच्चों ये दिस यू शुड नो है, ये सब बहुत इंपॉर्टेंट है. हाँ, आंसर करिए, आंसर करिए. इवन इफ इट इज रॉन्ग दैट्स फाइन. हाँ, यश ने आंसर किया, वेरी गुड. हाँ, अभी सब आंसर कर रहे हैं, वेरी गुड बच्चों. सो इट डज एक्सटेंशन एट द हिप जॉइंट, इट डज abduction, it does lateral rotation at the hip joint. बच्चों, can anyone tell me the nerve supply of gluteus maximus? That's a very very important MCQ. Nerve supply of gluteus maximus. Anyone? Nerve supply of gluteus maximus. Shivangi, stability is fine. नर्व सप्लाई बोलो, ये एमसीक्यू आता है. नर्व सप्लाई ऑफ ग्लूटियस मैक्सिमस. एनीवन? नर्व सप्लाई, नर्व सप्लाई, नर्व सप्लाई. हाँ, inferior gluteal nerve. Very good बच्चा, very good. That's the inferior gluteal nerve. That's the nerve supply of gluteus maximus. अब जो gluteus medius है, gluteus medius है and minimus है. हाँ, gluteus medius and minimus. बोलो. What is the action of this? Gluteus medius and minimus का action क्या है? Anyone? Very good. Medius and minimus का action. These are the chief abductors and medial rotators. Abduction and medial rotation at the hip joint. Abduction and medial rotation at the hip joint. ठीक है? What is the nerve supply बोल सकते हो? Nerve supply मतलब gluteus medius, minimus and tensor fascia lata. बोलो, अभी बोलो. Tensor fascia lata, a very important MCQ, is supplied by whom? Gluteus medius, minimus and tensor fascia lata. Yes, very good. That's the superior gluteal nerve. Very good, बच्चों, very good. That's the superior gluteal nerve. Excellent. That's good. That's good. Very good. Okay, बच्चा, this is clear. किधर है? हाँ, ये यहाँ पे. ठीक है. सो ग्लूटियस मैक्सिमस, ग्लूटियस मिनिमस मैंने बोल दिया आपको, मीडियस मिनिमस बोल दिया. व्हाट इज दिस? फुट ड्रॉप. ये है फुट ड्रॉप. फुट ड्रॉप इज ड्यू टू इंजरी टू विच नर्व? आंसर दिस. foot drop is due to injury to which nerve? Foot drop is due to injury to anyone? Common peroneal nerve. Yes, very good, very good. Antique, that's the common peroneal nerve. Huh? ये याद रखिए. And this common peroneal nerve winds around the neck of the fibula. The common peroneal nerve winds around the neck of the fibula. Very good, very good. नर्व सप्लाई ऑफ फुट है ना, नर्व सप्लाई ऑफ द फुट मैं ये ड्रॉ करता हूँ आपके लिए बच्चा. दिस इज वेरी इंपॉर्टेंट. याद रखिए ये है अपना फुट. दैट्स आवर फुट. अब बोलो बच्चों, who supplies the skin on the medial aspect of the foot up to the great toe? Anyone? Any guesses? Who supplies the skin on the medial aspect of the foot up to the great toe? ये प्लांटर एस्पेक्ट है, फुट है, ये फुट डॉर्सम नहीं है, प्लांटर एस्पेक्ट ऑफ फुट है. चलो बोलो बच्चा, हु सप्लाइज द स्किन ऑन द मीडियल एस्पेक्ट ऑफ द फुट अप टू द ग्रेट टो? अप टू द ग्रेट टो कौन है ये? सेफेनस. एक्सीलेंट, वेरी गुड. एंटीक, दैट्स द सेफेनस नर्व. दैट्स द सेफेनस नर्व. बच्चा ये याद रखना. हाँ, अप टू द ग्रेट टो इज सेफेनस नर्व. हु सप्लाइज द मीडियल एस्पेक्ट ऑफ द ग्रेट टो? All the web spaces समझते हो? web spaces, yo, all the web spaces except first, this is supplied by the superficial peroneal nerve. Huh? So the medial aspect of the great toe, all the web spaces, superficial peroneal nerve. बच्चा अपन स्लीपर्स पहनते हैं ना, स्लीपर्स. the first web space. Answer this. The first web space को कौन supply करता है? This is very important. This you should know. The first web space is supplied by the deep peroneal nerve. This you should know. The first web space is supplied by whom? That's a deep peroneal nerve. बाकी जितने भी web spaces are, that's supplied by the superficial peroneal nerve, right? The lateral aspect of the foot is supplied by sural nerve. That's a sural nerve. इन्वर्शन इवर्शन बोलता हूँ बच्चा. इन्वर्शन मतलब फुट इज टर्न्ड इनवर्ड्स, है ना, इनवर्ड्स. एंड इवर्शन मतलब आउटवर्ड्स. ये इवर्शन कौन करता है? पेरोनियस लॉन्गस एंड ब्रेविस. इन्वर्शन कौन करता है? पोस्टीरियर कंपार्टमेंट ऑफ द लेग के डीप मसल्स इन्वर्शन करते हैं. ठीक है, ओके. नाउ हु सप्लाइज द हील? द हील इज सप्लाइड बाय टिबियल नर्व. द हील ऑफ द फुट इज सप्लाइड बाय टिबियल नर्व. फिर ये जो 3.5 फिंगर्स है ना, 3.5 फिंगर्स को कौन सप्लाई करता है? मीडियल प्लांटा नर्व. एंड दिस इज द लैटरल प्लांटार नर्व. मीडियल प्लांटर एंड लैटरल प्लांटर. बच्चे ये है ना फुट का सोल है, सोल ऑफ द फुट. डॉर्सल एस्पेक्ट नहीं है ये, याद रखना. So what is very, very important is saphenous nerve. Saphenous nerve is very important. Medial aspect of the leg up to the great toe. Medial aspect of the great toe is supplied by superficial peroneal. जितने भी web spaces है, superficial peroneal. First web space, deep peroneal. The lateral aspect, sural nerve. Heel, tibial, 3.5 medial plantar, 1.5 lateral plantar. बस ये याद रखिए. This is extremely important. I hope this is clear to all of you. थोड़ा सा फास्ट जा रहा हूं, नहीं तो खत्म नहीं होगा मेरा. ठीक है, क्लियर? ओके, सो दैट कंप्लीट्स इट. नाउ कमिंग टू दिस, यो अब कुछ एमसीक्यूज है, बोल सकते हो. द लेफ्ट सुपीरियर इंटरकॉस्टल वेन ड्रेन्स टू व्हाट? लेफ्ट सुपीरियर इंटरकॉस्टल वेन, राइट सुपीरियर इंटरकॉस्टल वेन. ओके, बच्चों फाइन है ना? आर यू गोइंग वेल? मतलब अपर लिम, लोअर लिम, वे हैव फिनिश्ड. हाँ, जो इंपॉर्टेंट सवाल थे आई हैव टोल्ड यू. हाँ ठीक है, ऑल गुड, हैप्पी, गुड गोइंग. बोलो, बीच में आधे लोग गायब हो जाते हैं. हाँ, डोंट गायब, बी देयर. लगे रहो. ऑल दिस इंपॉर्टेंट थिंग्स और इंपॉर्टेंट पॉइंट्स आई एम टेलिंग यू, जस्ट बी देयर. Some things might be difficult, बच्चा, that's okay. हाँ, वापस रिवाइज करिए. आई एम टेलिंग यू मेनी थिंग्स, बहुत चीज़ें बोल रहा हूँ. ओके शिवांगी, ओके एंटीक, भानु, योगम, ओके फाइन. नाउ यू टेल मी व्हाट इज द एक्सटेंट ऑफ लंग. पहले ये खत्म करते हैं. I'll write it as this, as the mid clavicular, mid axillary and mid scapular. So This is the mid clavicular line, this is the mid axillary line, and पीछे होगा mid scapular line. Extent of lung बोलिए, extent of lung and extent of extent of lung and extent of pleura. हाँ, बोल सकते हो what is the extent of lung in the mid clavicular? आतिफ रुको बच्चा, आतिफ रुको, ये खत्म होने दो लेक्चर, इनका एग्जाम है ये. आई टेल यू, वेट नो बच्चा, बोलता हूँ. बुक स्टैंडर्ड बुक्स है, बीडीसी पढ़ लो, विश्राम सिंह सर का बुक है वो पढ़ लो. हाँ, एंड एम्ब्रियोलॉजी का आईबी सिंह है, स्टैंडर्ड बुक्स है. ओके मेरे बच्चों, टेल मी एक्सटेंट ऑफ द लंग इन द मिड क्लैविकुलर लाइन. दिस इज अ वेरी वेरी इंपॉर्टेंट एमसीक्यू. बोल सकते हो एक्सटेंट ऑफ लंग. एक्सटेंट ऑफ लंग इन द मिड क्लैविकुलर लाइन बोलिए. This is sixth rib. This you should know, बच्चों. This you should know. Sixth rib, eighth rib, 10th rib. Sixth rib, eighth rib, 10th rib. And extent of pleura 8, 10 and 12 ribs. ये ribs हैं, ribs. मतलब 2 rib नीचे होता है. Extent of lung क्या होता है? 6th rib in the mid clavicular line, 8th rib in the mid axillary line and 10th rib in the mid scapular line. Pleura 2 ribs नीचे होता है, 8, 10 and 12, 8, 10 and 12. ये याद रखना बच्चों. This is a very very important MCQ. ठीक है. Extent of lung, extent of pleura. This is what you have to know. So this is the extent of lung and extent of pleura. हाँ, ये मैंने बोल दिया आपको. 6 at 10, at 10, 12. What is intercostobrachial nerve? ये पता है क्या आपको किसी को? This intercostobrachial nerve is a branch of second intercostal nerve. This is a branch of second intercostal nerve. Huh? It's a branch of second intercostal nerve. Intercostobrachial बोलते हैं इसको. Intercostobrachial. It's a branch of second intercostal nerve. जो intercostal nerves होते हैं, ये जो second intercostal nerve है, उसका branch है intercostobrachial nerve, and it supplies the skin on the medial aspect of the arm. This nerve is damaged during breast surgeries. Breast surgeries में ये damaged होता है intercostobrachial nerve. ये याद रखिए. हाँ. Left superior intercostal vein drains into what? The left superior intercostal vein drains into the left brachiocephalic vein. ये मैं directly बोल रहा हूँ आपको. It drains into the left brachiocephalic. The right superior intercostal vein drains into the azygos. And what is this superior intercostal vein? ये superior intercostal vein कैसे बनती है? The second, third and fourth intercostal vein से बनती है, right and left. So second, third and fourth on the right side, ये जो intercostal vein है, इससे बनता है right superior intercostal vein. The right superior intercostal vein drains into azygos, and second, third and fourth on the left side drains into the left brachiocephalic vein. ये याद रखना. That's another MCQ. Okay. We'll come to this bronchopulmonary segments पहले. Bronchopulmonary segments. ये this is the important topic. Bronchopulmonary segments. देखो बच्चों, if you know, you tell me. Bronchopulmonary segments. I'll just draw this for you. That's a right lung. That's a left lung. That's a lingula. That's a lingula. That's a cardiac notch. Bronchopulmonary segment of the left lung. चलो, what is this fissure? Oblique. ये कौन है? Oblique fissure. ये कौन है? Horizontal fissure. What is this? Upper lobe, middle lobe, lower lobe. Upper lobe, lower lobe. Okay, answer this now. You must be knowing this. Bronchopulmonary segments of the right lung, upper lobe. Bronchopulmonary segments of the right lung, upper lobe are apical, anterior, posterior. Apical, anterior, posterior. For the middle lobe, it is medial and lateral. Medial and lateral. Bronchopulmonary segments of the lower lobe are apical, anterior basal, lateral basal, posterior basal. एक अंदर होता है medial basal. Medial basal. So total of how many bronchopulmonary segments? 10. 10 bronchopulmonary segments. ठीक है. Apical, anterior, posterior ये upper lobe के हो गए. Medial, lateral ये middle lobe के हो गए. Apical, anterior basal, lateral basal, posterior basal, and one is medial basal. So these are the bronchopulmonary segments of the right lung. 10 bronchopulmonary segments. Left lung के bronchopulmonary segments देखिए. This is apical, anterior, posterior. Fine. What is this? Superior, lingular, inferior, lingular. Superior and inferior, lingular. For the lower lobe, apical, anterior basal, lateral basal, posterior basal, and medial basal nahi hota hai. Medial basal segment is absent. So how many bronchopulmonary segment for the left lung? 9. लेफ्ट लंग के 9 ब्रोंकोपल्मोनरी सेगमेंट्स है, राइट लंग के 10 ब्रोंकोपल्मोनरी सेगमेंट्स होते हैं. इज दिस क्लियर टू ऑल ऑफ यू? जस्ट रिमेंबर दिस, ये सब एमसीक्यूज में आता है. So what are the bronchopulmonary segments of the right lung? Upper lobe, apical, anterior, posterior. 3 है. Bronchopulmonary segments of the middle lobe of the right lung, medial, lateral. Lower lobe के 5 होते हैं, apical, anterior basal, lateral basal, posterior basal, and 1 is medial basal. For the left lung, what are the bronchopulmonary segments of lingular lobe, superior and inferior lingular? ठीक है ना बच्चों, समझ में आ रहा है ये? बच्चों आंसर करो. Fine. So 10 on the right, 9 on the left lung. So these are the bronchopulmonary segments. I hope this is clear to all of you. Okay. Now you tell me, so that's about the bronchopulmonary segments. Now you tell me, in the heart, what is this artery and what is this artery? ये बोल सकते हो बच्चा? What is this artery? जो मैंने number लगाया 1, and what is this second artery? दिख रहा है ये? Anyone tell me? Okay, yes. What is this artery? Number 1, that's the right coronary artery. And what's this number 2? That's the left coronary artery का ये branch है, anterior descending branch. Anterior descending branch of left coronary. अगर ये visual slide आता है, if the arrow is pointed here, identify the artery in this groove, your answer is going to be the right coronary artery. And if the artery is in this groove, it is the left coronary artery का branch होता है. That's the anterior interventricular branch, और उसका दूसरा नाम है left anterior descending branch. Okay, fine. What is this big vein here? Anyone? What is this vein here? What is this big vein? In the posterior atrioventricular groove, this is the largest vein of the heart. And this vein opens into the right atrium. Very good. अच्छा आंसर कर रहे हो योगम? Yes. This is the vein which opens into the right atrium. What is this vein? Any guesses? I'm looking at the screen. क्या आंसर किया आपने? बोलो ना, आंसर करो ना बच्चों. What is this vein? This you should know. This is the largest vein of the heart, जो हार्ट को ड्रेन करती है. IVC नहीं है बच्चा, IVC नहीं है. देखो ये SVC देख रहे हो, ये SVC है, ये IVC ये है. अब ये जो वेन है ना, ये सबसे बड़ी वेन है जो हार्ट को ड्रेन करती है. एसवीसी एंड आईवीसी बॉडी वॉल से ब्लड लेके आते हैं, एंड ये जो वेन है वो हार्ट को ड्रेन करती है, एंड दिस इज व्हाट वी कॉल एज द कोरोनरी साइनस. ये है कोरोनरी साइनस. कोरोनरी साइनस इज द लार्जेस्ट वेन ऑफ द हार्ट. ग्रेट कार्डियक नहीं है बच्चा. शिवांगी ये पीछे देख रहे हो आप, दिस इज बैक साइड. सो दिस वेन इज द कोरोनरी साइनस. ग्रेट कार्डियक वेन आगे होती है, यहाँ पे होती है ग्रेट कार्डियक वेन. इन दिस ग्रूव इज द ग्रेट कार्डियक वेन. यहाँ पे ग्रेट कार्डियक होती है, यहाँ पे स्मॉल कार्डियक वेन होती है. द वेन हियर इन द पोस्टीरियर एट्रोवेंट्रिकुलर ग्रूव इज द कोरोनरी साइनस. बस ये याद रखना, दिस कैन कम इन द क्वेश्चंस. ओके फाइन बच्चों. Now you tell me, what is this part of the primitive heart? Any guesses? आप बोल सकते हैं. I'll just make this for you. What is the first chamber of the primitive heart? The second chamber, the third chamber, and the fourth chamber. What is this? This is what we call as, yes, truncus. What is this? Bulbous cordis. This is the ventricle, this is the atria, and इसे क्या बोलते हो? Sinus venosus. That's the sinus venosus. The bulbous cordis further divides into two parts. This is what we call as truncus arteriosus. ये embryology है, embryology of heart है. This is what we call as the conus. In short, I'm telling you, बस short में बोल रहा हूँ. This conus will get absorbed and form the ventricles. ये ventricles बनेगा. ये atria बनेगा, and this is the sinus venosus. Sinus venosus. So what are these are the parts of the primitive heart. अभी तक heart बना नहीं है. Very good प्रवीण. Excellent answer किया आपने. Very good. So this is the truncus arteriosus. The upper part is the truncus arteriosus, and truncus arteriosus से क्या बनेगा? दो chambers, दो बड़े blood vessels बनते हैं बच्चों. One is the ascending aorta, ascending aorta, and दूसरा बनता है pulmonary trunk. Ascending aorta and the pulmonary trunk. मतलब ये जो truncus arteriosus है, ये दो parts में divide होता है, इससे बनते हैं ascending aorta and pulmonary trunk, right? Conus ventricles में absorb हो जाता है. It gets absorbed. ये इससे atria बनता है, and sinus venosus बाद में atria में चला जाता है. वो it goes into the atria. We're not going to that. Fine, clear to all of you. अब aortic arch arteries है ना? Can anyone tell me how is the? Just see if you can answer this. How's the arch of aorta formed? Arch of aorta. Developmental पूछ रहा हूँ. If you can answer this, that's okay. How's the arch of aorta formed? How's the subclavian artery formed? Subclavian artery. How is the common carotids formed? How is the common carotid artery formed? बस इतना आप बोल पाओगे तो भी that is fine. This much if you answer, that's fine for me. हाँ, बोल सकते हो बच्चों? Wow, that's superb. That's superb, Yogam. So subclavian artery is दो parts का होता है. This is the left and that's the right subclavian. The left subclavian artery is derived from what? And the right subclavian artery is derived from what? बस इतना याद रखो what I'm telling you. The left subclavian artery is derived from the left 7th cervical intersegmental artery. Intersegmental artery. Okay, So the left subclavian artery is derived from the left 7th cervical intersegmental artery. The right subclavian artery is derived from the right 4th arch artery. It's derived from the right 4th arch artery plus the right 7th cervical intersegmental artery. Subclavian artery दोनों sides पे अलग होता है. I'm just telling you directly. This is the workbook. So left subclavian artery is derived from the left 4th arch artery plus the left 7th cervical okay, I'll just change this. एक मिनट. So the right subclavian artery is derived from the right 7th cervical intersegmental artery. The left subclavian artery is derived from the left 7th cervical intersegmental artery and the left 4th arch artery. How's the arch of aorta formed? The arch of aorta is derived from the left. Arch of aorta is derived from the left. एक मिनट. I'll just clear this. I'll show you on the slide. One moment. Have a look at this. Have a look at this. Okay, look at this. So now you tell me, what is this going to form? What is this going to form? ये क्या बनेगा? Don't get confused there. What is this going to form? This is going to form the arch of aorta. Right. And how's the arch of aorta formed? Arch of aorta is derived from the left 4th arch artery. Yes, Yogam, what you're answering? Arch of aorta is derived from the left 4th arch artery. Right. What is this going to form? This is going to form the subclavian artery. And this subclavian artery on the left side is derived from the left 7th cervical intersegmental artery. That's the left subclavian artery. So the left subclavian artery is derived from the left 7th cervical intersegmental artery. The arch of aorta is derived from the 4th arch artery. Right. What is this going to be? This is going to be the right subclavian. Right subclavian is derived from, yes, right subclavian is derived from the right 4th arch artery. Right 4th arch artery and the right 7th cervical intersegmental artery. So this, the right 4th arch artery and the right 7th cervical intersegmental artery se banega right subclavian artery. The left subclavian artery is derived only from the left 7th cervical intersegmental artery. The arch of aorta is derived from the right 4th arch artery. Arch of aorta is derived from the left 4th arch artery. ठीक है? The common carotids, ये बन गया अपना common carotid. So common carotid is derived from the 3rd arch artery. 3rd arch artery से बनता है common carotid. हाँ शिवांगी, वो सब है. I've just told you in short. The left horn of aortic sac, the left fourth arch artery, that forms the arch of aorta. Fine, that's fine. Okay, मैंने ये short में ही बोला आपको. I've just told this in short for you. नहीं तो to explain this will take another 1 hour. Okay, बच्चों, clear? Clear है ये कि नहीं है? If this is not clear, you tell me. I'll explain. How is the arch of aorta formed? Arch of aorta is formed from the left horn of aortic sac and the left fourth arch artery. The left subclavian artery is derived from the left seventh cervical intersegmental artery. The right subclavian artery is derived from the right fourth arch artery and the right seventh cervical intersegmental artery. The common carotids are derived from the third arch artery. बस इतना जितना मैंने बोला है उतना MCQs के लिए important है. This much you remember. Fine. Answer this. Explain one more time. ठीक है बच्चा, I'll explain. हम मैं explain करता हूँ. Just give me some time. ये खत्म करते हैं, then I'll explain शिवांगी. Tell me, skin over the angle of mandible is supplied by. Come on, one short answer for this. Skin over the angle of mandible is supplied by. Any guesses? वो arch of arteries I'll tell you. हाँ ये खत्म करते हैं, then I'll tell you. मैं बोलता हूँ. Don't worry. बच्चों, मेरे प्यारे बच्चों, tell me, skin over the angle of mandible. That's a very important MCQ. The entire face का sensory nerve supply is supplied by whom? Trigeminal nerve, except the skin over the angle of mandible, that is supplied by, any guesses? The greater auricular nerve. Yes, this is supplied by the greater auricular nerve. That's a very important MCQ. So skin over the angle of mandible is supplied by the greater auricular nerve. Ansa cervicalis. Ansa cervicalis ये strap muscles को supply करता है. Ansa cervicalis क्या supply करता है? Sternohyoid, sternothyroid and the omohyoid. Omohyoid के superior and inferior belly. Superior and inferior belly of omohyoid. So sternohyoid, sternothyroid, superior and inferior belly of omohyoid. What does the ansa not supply? ये बोलो. Ansa cervicalis does not supply what? Ansa cervicalis एक मसल सप्लाई नहीं करता है. स्ट्रैप मसल, एक स्ट्रैप मसल सप्लाई नहीं करता. Who's that? स्टर्नोहाइड को सप्लाई किया, स्टर्नोथायरॉइड को सप्लाई किया, सुपीरियर एंड इंफीरियर बेलीज ऑफ ओमोहाइड को सप्लाई किया. बस वन मसल इज नॉट सप्लाइड बाय ansa cervicalis. Anyone can tell me what is that? It is the thyrohyoid. Thyrohyoid muscle is not supplied by ansa cervicalis. Thyrohyoid is a strap muscle. This strap muscle is not supplied by ansa cervicalis. This strap muscle is supplied by C1. C1 ये याद रखना. Thyrohyoid, ये sternohyoid हो गया, sternothyroid हो गया. Sternothyroid continues as thyrohyoid. This thyroid muscle is not supplied by ansa cervicalis. It is supplied by fibers of C1. C1 ये याद रखना. Thyroid is supplied by fibers of C1. बस. Damage to the spinal accessory nerve in the posterior triangle of the neck leads to paralysis of trapezius. It's paralysis of trapezius. So, what is the most important content of the posterior triangle? The spinal accessory nerve. The spinal accessory nerve is the most important content of the posterior triangle. And if you damage the spinal accessory nerve in the posterior triangle of the neck, what is the person going to complain of? Difficulty in shrugging of shoulders. है ना? Difficulty in shrugging of shoulders वो एक होगा. Difficulty in overhead abduction of arm. Why? Because which is the nerve damaged? Spinal accessory nerve. Spinal accessory nerve damage होती है posterior triangle में. So what is the person complain of? Difficulty in shrugging of shoulders, difficulty in overhead abduction of arm, which is a muscle paralyzed trapezius. समझ में आ रही है? So spinal accessory nerve. हाँ, branches of external carotid artery. बच्चों बोल सकते हो external carotid artery के branches. This you should know. This you should know. चलो start. Anterior branches. Anterior branches of external carotid artery. Superior thyroid, lingual. Superior thyroid, lingual, facial. Superior thyroid, lingual, facial. Posterior branches of external carotid. Posterior auricular and occipital. Posterior auricular and occipital. Medial branch Yes, anyone? Can anyone tell me what is the medial branch? Medial branch of external carotid. Bachcho, come on, answer this. Medial branch of external carotid is ascending pharyngeal. Right? Ascending pharyngeal. And terminal branch? Terminal branches is superficial temporal artery and maxillary artery. Superficial temporal and maxillary. Fine. Just remember this. Very important MCQ. Branches of external carotid. Anterior branches superior thyroid, lingual facial. Posterior branches posterior auricular, occipital. Medial branch, there's only one, that's ascending pharyngeal. And terminal branches are given in the parotid gland. That's the superficial temporal and maxillary. Superficial temporal and maxillary. Perfect. Very good. Okay. What are the relations in the lateral wall of cavernous sinus? बच्चे ये बोल सकते हो what are the relations in the lateral wall of cavernous sinus? अगर मैं ये cavernous sinus बनाता हूँ, cavernous sinus, what is there on the medial side of the cavernous sinus? What is this? That's a pituitary gland. Pituitary gland. And that's an air sinus. है ना? Air sinus होता है. What is that air sinus? Sphenoidal air sinus. Sphenoidal sinus. Okay, sphenoidal air sinus. What are the relations in the lateral wall? Yes, answer this, students. That's the third nerve. That's the fourth nerve. That's the ophthalmic division of trigeminal nerve and the maxillary division of trigeminal nerve. So third nerve, fourth nerve, ophthalmic division and the maxillary division of trigeminal nerve. These are the relations in the lateral wall of the cavernous sinus. In the floor, there's a sixth nerve, and which is a big artery here in the floor, internal carotid artery. Bacha, this is extremely important. Right? This is extremely important. Ye yaad rakhna. Just understand this. Is this clear? Bolo. Is this clear? Yes, Komal Sagar. Very good. Very good. All of you answering very well. Chalo bolo bacho. Is this clear? So cavernous sinus is a very, very important MCQ. Lateral wall के relations, third nerve, fourth nerve, ophthalmic and maxillary nerve. Floor में होती है sixth nerve and the internal carotid artery. Medial side पे होता है pituitary gland and the sphenoidal air sinus. ठीक है. Okay, fine, Komal. Very good. Yes, clear. Antique, clear है ये. शिवांगी, बच्चा, योगम, प्रवीण. Who else is there? शाबाश. आंसर करो बीच बीच में. कार्थी, यश. हाँ, okay, great, fine. ठीक है. So these are the relations in the lateral wall of cavernous sinus. चलो, good, good, good. Fine. So this we have done. This we have done. ये है sensory nerve supply of the face. Sensory nerve supply of the face. What is this? This ये जो green है ना, that's ophthalmic. This is maxillary and this is mandibular. So the entire face is supplied by the trigeminal nerve through its three branches, except the skin over the angle of mandible. This is supplied by whom? Greater auricular nerve. Greater auricular nerve. Fine. That's the blood supply of thyroid. बच्चों ये बोल सकते हो there are two arteries which supply the thyroid. This is the superior thyroid artery and that's the inferior thyroid artery. The superior thyroid artery accompanies a nerve. Chalo, this you must be knowing. Answer this. The superior thyroid artery accompanies a nerve. Bolo, 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 bachcho. This you must be knowing. Yes, superior thyroid artery accompanies a nerve. Which is that nerve which comes with the superior thyroid artery? ये nerve का नाम क्या है? This you must be, this ये surgery में हुआ होगा ना आपका. This is a nerve which accompanies the superior thyroid artery. This is a nerve which accompanies the inferior thyroid artery. बोलो बच्चा. The nerve which accompanies the superior thyroid artery is the external laryngeal nerve. This you should know, right? The nerve which accompanies the superior thyroid artery is the external laryngeal nerve, and the nerve which accompanies the inferior thyroid artery is the recurrent laryngeal nerve. This you should know. Very good. So superior thyroid artery के साथ external laryngeal nerve and inferior thyroid artery के साथ recurrent laryngeal nerve जाती है. External laryngeal nerve ये क्या muscle supply करती है? This supplies the cricothyroid. क्रिकोथायरॉयड मसल को सप्लाई करती है ना. दिस एक्सटर्नल लैरिंजियल नर्व accompanies what? The superior thyroid artery. ये क्या मसल का सप्लाई करती है? क्रिकोथायरॉयड. एंड क्रिकोथायरॉयड का एक्शन क्या होता है? टेंसर ऑफ वोकल कॉर्ड्स. ये होता है टेंसर ऑफ वोकल कॉर्ड्स. ठीक है. Who's an abductor of vocal cords? बोल सकते हो बच्चे? Who's an abductor of vocal cords? हो पोस्टीरियर क्रिकोएरिटेनॉइड. एब्डक्टर ऑफ वोकल कॉर्ड्स क्या होता है बच्चा? पोस्टीरियर क्रिकोएरिटेनॉइड. दैट्स एन एब्डक्टर ऑफ वोकल कॉर्ड्स. ठीक है, ये याद रखना, बहुत इंपॉर्टेंट एमसीक्यूज है. हाँ, द रिकरेंट लैरिंजियल नर्व accompanies द inferior thyroid artery. ओके, दैट्स ग्रेट, वेरी गुड. ठीक है बच्चा, ये क्लियर है? दिस पेज इज क्लियर टू ऑल ऑफ यू? ओके ओके, चलो ये बोल सकते हो. Nerve supply of parotid gland. Which is the cranial nerve which supplies the parotid? चलो बच्चा बोलो, which is the cranial nerve which supplies the parotid gland? ये कुछ visual slides हैं, if you can answer them. The cranial nerve supplying the parotid gland. Anyone? थक गए बच्चों, थक गए. Answer. Active बनो, be active. I'll give you 2 minutes break. Be active. Come on. हाँ, क्रेनियल नर्व 7 नहीं है बच्चा, 7 नहीं है, 7 नहीं है. नो, इट्स द 9th नर्व. क्रेनियल नर्व 9 सप्लाइज द पैरोटिड ग्लैंड. बच्चा ये याद रखना, ऑल द ग्लैंड्स इन द हेड एंड नेक आर सप्लाइड बाय 7th नर्व. बाकी जितने भी ग्लैंड्स इन हेड एंड नेक में, दे आर सप्लाइड बाय 7th नर्व, फेशियल नर्व. The parotid gland is supplied by which cranial nerve? Glossopharyngeal nerve. That's my MCQ. All the glands in the head and neck are supplied by which nerve? Facial nerve, except parotid, which is supplied by glossopharyngeal nerve. Clear hai? Just remember this, huh? Just remember this. That's a very important MCQ. Fine. Clear to all of you? Okay, coming to the next MCQ. Nerve supply of larynx. Okay, bachcho. So what is the nerve supply of larynx? Sorry, what was the nerve supply of larynx? Nerve supply of larynx. If you can answer this. Sensory and motor. बोल सकते हो बच्चा, all the muscles of the larynx are supplied by which nerve? Just one moment. All the muscles of larynx are supplied by, yes, any guesses? All the muscles of larynx are supplied by recurrent laryngeal nerve, except cricothyroid, which is supplied by external laryngeal nerve. External laryngeal nerve. Just one moment. This I can't see the screen. Just one moment. Okay, I got it. Yes. All the muscles of the larynx are supplied by external laryngeal nerve, except cricothyroid, which is supplied by external laryngeal nerve. External, very good. And sensory nerve supply, pata hai sensory nerve supply above the vocal folds, internal laryngeal nerve. Sensory nerve supply below the vocal folds, recurrent laryngeal nerve. Above the vocal folds, external laryngeal nerve. Below the vocal folds, recurrent laryngeal nerve. Very good. That's the nerve supply of larynx. Tongue का भी nerve supply बोल दो बच्चों. Tongue का nerve supply anterior 2/3, posterior 1/3 and the posterior most part of the tongue. चलो, anterior 2/3. General sensations, special sensations. General sensations, special sensations. बोल सकते हो. Anterior 2/3 का general sensations is taken by whom? Anterior 2/3 general sensations is taken by, yes, lingual. Anterior 2/3 जनरल सेंसेशंस इज लिंगुअल, टंग है टंग, एंटीरियर 2/3 का जनरल सेंसेशंस इज लिंगुअल, हाँ, स्पेशल सेंसेशंस इज कॉर्डा टिम्पैनी, दैट्स फेशियल. Chorda tympani, that's a branch of facial nerve. Posterior 1/3. Posterior 1/3, both general and special sensation is glossopharyngeal nerve. Glossopharyngeal nerve, dono. And posterior most part of the tongue, posterior most part of the tongue, that's vagus. 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 537 लिखा है ना बच्चा, 53 क्या लिखा है ये शिवांगी, क्या लिखा है? So anterior 2/3 का general sensation is by lingual nerve, special sensation is by the facial nerve, chorda tympani branch of facial nerve. Posterior 1/3 का both general and special sensation is by glossopharyngeal nerve. And posterior most part of the tongue, it is vagus nerve, vagus. Clear है ना? This you know? All the muscles of the tongue are supplied by whom? All the muscles of the tongue are supplied by hypoglossal nerve except palatoglossus, which is supplied by pharyngeal plexus. All the muscles of the tongue are supplied by hypoglossal nerve except palatoglossus, which is supplied by pharyngeal plexus. Perfect. Clear hai bachcho? Nerve supply of tongue is clear? Bolo. Is this clear bachcho? Is this clear? Okay, fine. Very good. That's okay, bacha. That's okay. That's okay. By mistake, that's okay. Chalo, what are the muscles of mastication? Can you identify this muscles? What is this muscle here? That's a temporalis. Temporalis. What is this? Masseter. Temporalis masseter. What is this muscle and what is this muscle? I put this as number 1. I put this as number 2. Identify this. ये temporalis है, ये masseter है. What is number 1 and what is number 2? This number 1 is the lateral pterygoid and this number 2 is the medial pterygoid. Lateral pterygoid and medial pterygoid. What is the action of temporalis? I'll just write it on another page. Temporalis. बोल सकते हो बच्चों, what is the action of temporalis? Temporalis का action क्या है? Elevation of mandible and retraction. Elevation and retraction of the mandible. Masseter and medial pterygoid. Masseter and medial pterygoid का action क्या है? Elevation. Elevation of mandible. ठीक है? Lateral pterygoid का action क्या है? Lateral pterygoid के दो heads हैं, upper head and the lower head. Upper head and lower head. Upper head क्या करता है? Upper head does depression of the mandible and the lower head does protrusion. That's very important. बस ये याद रखना. Very good. Just remember this. Temporalis के action से temporalis does elevation, temporalis pulls the mandible back, that's retraction of mandible. बस इतना याद रखो जितना मैंने बोला आपको. Masseter and medial pterygoid दोनों का action है elevation of the mandible. बस बच्चा, out of this 4 muscles of mastication, which is the only muscle which does depression of the mandible, that's lateral pterygoid. बस ये याद रखना. The only muscle of mastication that does depression is lateral pterygoid. वो भी कौन सा head है? Upper head of lateral pterygoid. Lower head of lateral pterygoid pulls the mandible in front. That's what protrusion. Protrusion of mandible. Is this clear? Fine. Okay. That's good. Coming back to the MCQ. Now, structures passing between the constrictors. Bacha, what is this constrictor? Muscle of the pharynx. ये pharynx के muscles हैं. So ये है अपना superior constrictor. ये है superior constrictor. ये है middle constrictor and ये है inferior constrictor. This is very important. ये बहुत MCQs आते हैं. What are the structures which pass between the constrictors? Can anyone tell me about the superior constrictor? चलो बच्चों, if you can answer this about the superior constrictor. About the superior constrictor. Between superior constrictor and middle constrictor. Between middle constrictor and inferior constrictor. And below the inferior constrictor. Chalo bolo, answer this. What are the structures which pass above the superior constrictor? Any guesses? बोल सकते हो? Above the superior constrictor is auditory tube. This you should know, बच्चों. This is very important MCQ. Auditory tube, levator palatii muscle, ascending palatine artery, and palatine branches of ascending pharyngeal artery. Palatine branches of ascending pharyngeal artery. I hope you know this. This you should know. So what goes above the superior constrictor or between the superior constrictor and the base of the skull? कितने structures जाते हैं? 4. Eustachian tube, levator palatii muscle, ascending palatine artery, and the palatine branches of ascending pharyngeal artery. ठीक है? Now, between the superior and the middle constrictor, what passes is the glossopharyngeal nerve and stylopharyngeus muscle. Glossopharyngeal nerve and stylopharyngeus. Between the middle and inferior constrictor passes the internal laryngeal nerve and the superior laryngeal vessels. And below the inferior constrictor passes the recurrent laryngeal nerve and inferior laryngeal vessels. This you should know. Inferior laryngeal vessels. कुछ doubt है तो बोलो इसमें. चलो बोलो बच्चों जल्दी. Clear है? Fine. So these are the structures which pass between the constrictor. That's a very, very important MCQ. So above the superior constrictor, between the superior middle constrictor passes the ninth nerve, glossopharyngeal nerve and stylopharyngeus, and then internal laryngeal nerve, superior laryngeal vessels. Below the inferior constrictor goes recurrent laryngeal nerve and inferior laryngeal vessels. Just remember this. जितना मैं बोल रहा हूँ ना उतना पढ़ लो, काफी है. Okay. 43. ठीक है बच्चा. चलो, if you can answer this. What is this? What is this cavity? That's a middle ear cavity. So this is the anterior wall of middle ear. That's a posterior wall of middle ear. Anterior wall of middle ear में क्या होता है? What is this? Anterior wall of middle ear is related to the eustachian tube. यह है eustachian tube. And this is the tensor tympani. Okay, so anterior wall of middle ear के relations क्या है? In front is eustachian tube and tensor tympani muscle. Below ये कौन है? That's the internal carotid artery. Below is the internal carotid artery. Floor में कौन है? Jugular vein in the floor, है ना? पीछे कौन है? What is this known as? This is the adductus to the mastoid. ठीक है? What is in the medial wall? What is this known as? Promontory. That's a promontory. What is this? This is the round window. What is this? That's a oval window. This is the facial canal. And this is the lateral semicircular canal, which is produced by the cochlea. ठीक है ना? Lateral semicircular canal. This is the middle ear. Middle ear का this ये जो देख रहे हो, that's a medial wall, ये anterior wall, ये posterior wall, ये floor, ये roof. Anterior wall में क्या होता है? Eustachian tube का opening होता है, tensor tympani का opening होता है, muscle होता है. In the lower part, that's a internal carotid artery. Floor of the middle ear में क्या होता है? Jugular vein होती है, jugular vein. Posterior wall of middle ear पे mastoid bone होता है. So there's a channel, there's a small passage into the mastoid. Medial wall, what is this known as? Promontory. Promontory के नीचे, what is this known as? This is the, say this, what is this? This is the round window, this is the oval window. This is a facial canal and that's the lateral semicircular canal. So these are the relations of the middle ear cavity. बस ये relations याद रखिए. अभी बच्चों, just tell me some MCQs. What are the derivatives of the second pharyngeal pouch? ये आपको पता है क्या? Second pharyngeal pouch के derivatives, if you know, you answer this. These are the endodermal pouches. Endodermal pouches के derivatives अगर आपको पता है तो आंसर करिए. Second pharyngeal pouch के derivatives क्या है? This is the palatine tonsil. Second pharyngeal pouch gives rise to palatine tonsil. Third pharyngeal pouch gives rise to, this is the thymus, and this is the inferior parathyroids. Inferior parathyroids. So, अच्छा मैं यहाँ पे लिखता हूँ. I'll just write it here for you. Pharyngeal pouches. You should know this. You should know this. So the first pharyngeal pouch divides into two. एक बनता है dorsal and एक है ventral. So dorsal forms the middle ear cavity and eustachian tube. So dorsal part forms the middle ear cavity and eustachian tube. And the eustachian tube. The ventral joins with the second and forms the tonsil. Palate and tonsil. So first pharyngeal pouch के दो parts बनते हैं, dorsal ventral. The dorsal से क्या बनता है? Middle ear cavity and eustachian tube. Ventral part joins with the second and ये बनता है palatine tonsil. ठीक है? Third pharyngeal pouch divides into a dorsal and ventral. Ventral से क्या बनता है? Thymus. And dorsal से बनता है inferior parathyroids. Fourth pharyngeal pouch again divides into a dorsal and ventral. Dorsal से बनता है superior parathyroids. And ventral joins with the sixth and forms the ultimobranchial body. जिससे बनता है parafollicular C cells of thyroid. Very good. This you know. Yes. Eustachian tube is auditory tube. Vishwa. So first divides into two parts. The first divides into a dorsal ventral part. Dorsal से बनता है middle ear cavity and eustachian tube. Eustachian tube is auditory tube बच्चा. Second से बनता है tonsillar fossa and palatine tonsil. Very good. Third से बनता है thymus and inferior parathyroids. Fourth से बनता है superior parathyroids and ultimobranchial body. Excellent. सबने आंसर किया है. Very good. सबने आंसर किया है ये. चलो बच्चों कुछ cranial cavity के बारे में देखते हैं. What passes through the superior orbital fissure? बोल सकते हो? What passes through the superior orbital fissure? The third nerve, the fourth nerve, the sixth nerve, and the ophthalmic nerve. Third, fourth, sixth, and ophthalmic nerve passes through the superior orbital fissure. Optic canal से optic nerve, and ophthalmic artery. Okay, optic canal से क्या जाती है? Optic nerve and ophthalmic artery. Foramen rotundum. Anyone? What passes through foramen rotundum? You're answering very well. चलो बोलो बच्चों. What passes through foramen rotundum? पता ही है. Foramen you should know. Foramen rotundum से क्या जाता है? Maxillary nerve. Foramen ovale पता है? M-A-L-E. M is mandibular nerve. A is accessory meningeal artery. L is the lesser petrosal nerve. E is emissary vein. Very good. M-A-L-E. Foramen spinosum से क्या जाता है? The middle meningeal artery and nervous spinosus. Okay, middle meningeal artery and nervous spinosus. Very good. हाँ. Internal acoustic meatus से क्या जाता है? Internal acoustic meatus से क्या जाता है? Seventh nerve, eighth nerve and labyrinthine artery. Seventh nerve, eighth nerve and labyrinthine artery. Internal acoustic meatus. Very good. Anterior condylar canal, इसका दूसरा नाम है hypoglossal canal. Anterior condylar canal is also known as hypoglossal canal. What passes through this is the hypoglossal nerve. Internal acoustic meatus is 7th nerve, 8th nerve and labyrinthine artery. Clear है? Hypoglossal canal is the anterior condylar canal. What passes is the hypoglossal nerve. Right? Okay. Jugular foramen. Jugular foramen से क्या जाता है? See, jugular foramen के 3 compartments होते हैं. If you can tell me this, jugular foramen ऐसे है. Jugular foramen is divided into 3 compartments: anterior, middle, posterior. What passes to the posterior compartment of the jugular foramen? Yes, students, what is this sinus? Sigmoid sinus. Sigmoid sinus passes to the posterior compartment. Anterior compartment से what passes is the inferior petrosal sinus. This you should know. हाँ, ये याद रखिए. And through the middle compartment, what passes is the 9th, 10th, 11th cranial nerves. 9th, 10th and 11th cranial nerves. Very good, very good. सो जुगुलर फोरामेन के 3 कंपार्टमेंट्स होते हैं, एंटीरियर, मिडिल, पोस्टीरियर. एंटीरियर कंपार्टमेंट से क्या आता है? इंफीरियर पेट्रोल साइनस. मिडिल कंपार्टमेंट से 9th, 10th, 11th क्रेनियल नर्व्स एंड पोस्टीरियर कंपार्टमेंट से सिग्मॉइड साइनस. सिग्मॉइड साइनस. परफेक्ट. चलो नर्व्स बोलिए बच्चा. व्हिच इज द नर्व ऑफ द फर्स्ट आर्च? नर्व ऑफ द फर्स्ट आर्च इज मैंडिबुलर नर्व. मैंडिबुलर नर्व. सेकंड आर्च इज फेशियल नर्व. फेशियल नर्व. थर्ड आर्च इज ग्लॉसोफेरिंजियल नर्व. Glossopharyngeal. Fourth arch is internal laryngeal nerve and sixth arch is recurrent laryngeal nerve. Yes, very good. Nerve of the first arch, mandibular nerve. Nerve of the second arch, facial nerve. Nerve of the third arch, glossopharyngeal. Fourth arch is internal laryngeal nerve and sixth arch is recurrent laryngeal nerve. These are the nerves of the pharyngeal arches. ठीक है बच्चों? Clear? यहाँ तक clear है? Just wait for 1 minute. कुछ डाउट्स है तो बोलो यहां तक. हाँ. Very good. You've got a good stamina, सब लोग. Very good. Just one moment. कुछ डाउट्स है यहां तक तो बोलो बच्चों. Then I proceed. All clear? Okay. चलने. We'll proceed. Okay. Fine. Okay, Yash. Fourth arch is superior laryngeal. ठीक है, superior laryngeal बोल सकते हो. Fourth arch is superior laryngeal. ठीक है. You can take this as superior laryngeal. Superior laryngeal divides into an external laryngeal nerve and internal laryngeal nerve. ठीक है, superior laryngeal ले लो. योगम, fourth arch superior laryngeal ले लो. It divides into an external and internal laryngeal. Fine. Inferior laryngeal नहीं होता बच्चा, superior laryngeal ना होता है. Clear to all of you? यहाँ तक clear है? Okay. चलो. Answer now. ये कुछ shorts हैं, shorts. Wernicke's area. Number बोलिए. What is the number of Wernicke's area? Number. Functional area का number. बोलो. Wernicke's area. Answer. Number. हाँ, क्या लिखा है? 22. Wernicke's area is 22. Broca's area is 44, 45. है ना? Yes, Brodmann's number is 22. Wernicke's. Broca's area is 44, 45. What is the uncinate fasciculus connect? Anyone? The uncinate fasciculus connects what to what? It connects the frontal and the temporal lobes. Frontal and temporal lobes. मतलब ये क्या connect करता है? The Wernicke's and the Broca's area. Uncinate fasciculus connects the Wernicke's and the Broca's area. So it connects the frontal and the temporal lobes. Uncinate fasciculus का दूसरा नाम है arcuate fasciculus. ये क्या connect करता है? Wernicke's and Broca's area. Blood supply of the motor area बोल सकता है कोई? Blood supply of the motor area is anterior cerebral artery plus middle cerebral artery. दोनों. Blood supply of the motor or sensory area. It's anterior cerebral plus middle cerebral artery. Blood supply of the visual cortex. It's posterior cerebral artery plus middle cerebral artery. हाँ, ये पता है आपको? Do you know this? एक मिनट, just try to understand this. चलो बच्चों बोलो, which is the artery which lies in the lateral sulcus and which is the artery which lies in the callosal sulcus? बोल सकते हो? Artery in the lateral sulcus is what? What is this artery in the lateral sulcus here? And what is this artery in the callosal sulcus? Callosal sulcus. बोल सकते हो बच्चा? हाँ, so this is anterior cerebral artery. एंड ये कौन है, मिडिल सेरेब्रल आर्टरी। हाँ, तो एंटीरियर सेरेब्रल आर्टरी क्या सप्लाई करती है, एंटीरियर सेरेब्रल आर्टरी सप्लाइज द एंटायर द मीडियल सर्फेस। अब ये वो साइड जाते हैं, इट गोज टू दैट साइड एंड सप्लाइज अ स्मॉल एरिया हियर, small area on the supralateral surface is supplied by anterior cerebral artery. The major supralateral surface is supplied by whom, middle cerebral artery. Major supralateral surface को कौन supply करता है, middle cerebral artery. So now you tell me बच्चा, what is this central sulcus? This is precentral, postcentral. What is this area, motor. ये कौन है, sensory. So this much part of motor area is supplied by whom, this much part of motor area or sensory area is supplied by middle cerebral. This part is supplied by whom, anterior cerebral. तो ब्लड सप्लाई ऑफ मोटर और सेंसरी एरिया दो आर्टरीज आते हैं, MCA प्लस ACA। समझ में आई ये, ब्लड सप्लाई ऑफ द मोटर और सेंसरी एरिया, इतना पार्ट इज सप्लाइड बाय मिडिल सेरेब्रल, दिस upper part is supplied by anterior cerebral. So blood supply of motor or sensory area is MCA plus ACA. बस ये याद रखना, ठीक है। So I have written ACA plus MCA. Occipital lobe is supplied by posterior cerebral artery. Mainly the middle cerebral artery supplies the macula. So अगर blood supply of visual cortex पूछते हैं तो दो arteries होते हैं, हाँ, posterior cerebral plus middle cerebral artery, ठीक है। What is the basal vein known as? It is the vein of Galen. एक मिनट, which is the artery in the callosal sulcus? Anterior cerebral artery. Which is the artery in the lateral sulcus? Middle cerebral artery. ये अभी मैंने ड्रॉ किया था, ठीक है ना। आर्टरी इन द कैलोसल सल्कस, कैलोसल सल्कस कॉर्पस कैलोसम के ऊपर होता है, एंटीरियर सेरेब्रल, लैटरल सल्कस में मिडिल सेरेब्रल। व्हाट आर द ब्रांचेस ऑफ बेसिलर आर्टरी? बेसिलर आर्टरी के ब्रांचेस बोल सकते हो, बेसिलर आर्टरी के ब्रांचेस ऑफ वर्टिब्रल आर्टरी, एंटीरियर सेरेब्रल आर्टरी, पोस्टीरियर anterior spinal artery, posterior spinal artery and posterior inferior cerebellar artery. What are the branches of vertebral artery? Anterior spinal, posterior spinal and pica, posterior inferior cerebellar artery. Vertebral artery के branches बच्चा, vertebral artery. Basilar artery के क्या branches है? Basilar artery के branches क्या? Pontine branches, labyrinthine artery, anterior inferior cerebellar, superior cerebellar and posterior cerebral artery. ठीक है। सो ब्रांचेस ऑफ बेसिलर आर्टरी क्या है? पोंटाइन ब्रांचेस, लैब्रिंथाइन आर्टरी, anterior inferior cerebellar, superior cerebellar and posterior cerebral arteries. These are the branches of basilar artery. Clear है? Just remember this, ये सब MCQs में आते हैं। Branches of basilar artery मैंने बोल दिया। Internal carotid artery के branches पता है? What are the branches of internal carotid artery? Branches of internal carotid artery, cavernous branches, hypophyseal branches, ophthalmic artery, anterior choroidal, posterior communicating, anterior cerebral artery and middle cerebral artery. So these are the branches of internal carotid artery. So बच्चों ये सब याद रखना। Cavernous branches, hypophyseal artery to the pituitary gland, ophthalmic artery, anterior choroidal artery जो choroid plexus को supply करती है, posterior communicating artery and two terminal branches, anterior cerebral and middle cerebral artery. Okay, clear to all of you? Clear है ना बच्चों, समझ में आ रहा है ना? Okay. These are the branches of internal carotid arteries. So हमने branches discuss किए सारे arteries के। इंटरनल कैरोटिड आर्टरी के ब्रांचेस क्लियर है, बेसिलर के क्लियर है, वर्टिब्रल आर्टरी के क्लियर है. सब द ग्रेट बेसल वेन, हाउ इज द बेसल वेन फॉर्म्ड, ये मैं बोलता हूं आपको. हाँ, don't say this. How is the basal vein formed? The basal vein is formed by the great cerebral vein of Galen is different. Basal vein is formed by the joining of one anterior cerebral vein, deep middle cerebral vein, and striate veins. So together, this three joins to form the basal vein. The basal vein drains into the great cerebral vein, the great cerebral vein of Galen. Okay. So the basal vein drains into the great cerebral vein of Galen. बस ये याद रखना. So basal vein कैसे बनती है? It is formed by the anterior cerebral vein, the deep middle cerebral vein, and the striate veins. The basal vein drains into the great cerebral vein of Galen. ठीक है? Fine. So I hope this is clear to all of you. Time is 2024. ठीक है, बस ये clear है बच्चा? All these things are clear to all of you? हाँ? Okay, very good. और कितने पे? 1 2 3 4 5 6 7 8 9 10 10 pages are left. Okay, so this is the circle of Willis. Circle of Willis. How is the circle of Willis formed? बोल सकते हो? I'll have to go slightly fast. Circle of Willis. That's the internal carotid artery. Internal carotid artery divides into two terminal branches. What is this? Anterior cerebral artery and middle cerebral artery. Okay, that's the anterior cerebral, that's the middle cerebral artery. What is this artery? These are the two vertebral arteries. Vertebral joins to form the basilar. And what are the branches of basilar? That's the posterior communicating, right? What is this? This is the posterior cerebral. What is this? That's the posterior communicating. Clear, students? So this is anterior cerebral, that's middle cerebral, that's the anterior communicating. This is the posterior communicating, and that's the posterior cerebral artery. So these are the arteries which takes part in the formation of circle of Willis. Circle of Willis is not formed by which artery? Can anyone tell me? This is a very common MCQ asked. So anterior communicating, anterior cerebral, middle cerebral, posterior communicating. The middle cerebral does not take part in the formation of circle of Willis. It is anterior communicating, anterior cerebral, internal carotid, posterior communicating, and posterior cerebral. Students, middle cerebral artery does not take part in the formation of circle of Willis. Middle cerebral artery does not take part. Anterior communicating, anterior cerebral, internal carotid, posterior communicating, and posterior cerebral. That's how the circle of Willis is formed. Circle of Willis is formed. So which artery does not take part? Middle cerebral artery. Okay, bacho, what is this? Can anyone tell me what is this vein? This is the septal vein. Septal vein. This is the choroidal vein. Choroidal vein जो choroid plexus को drain करती है. And ये जो vein है ना, इसका नाम है thalamostriate. Striate vein. बस ये है ना, ये तीन veins याद रखना. Thalamostriate vein, septal vein and choroidal vein. This joins to form, ये तीनों join होके क्या बनती है? Internal cerebral vein. Internal cerebral vein. And two internal cerebral veins joins to form the great cerebral vein. Great cerebral vein of Galen. समझ में आ रहा है? So internal cerebral vein कैसे बनता है? Formed by joining of three veins: septal vein, thalamostriate vein and choroidal vein. बस एक निमोनिक है, याद रखना इसको, TCS. ये TCS निमोनिक याद रखना. T is thalamostriate, C is choroidal, and S is septal. Thalamostriate, choroidal, and septal vein joins to form the internal cerebral vein. Two internal cerebral vein joins to form, हाँ ये ऐसे लिखना, two internal cerebral vein joins to form the great cerebral vein of Galen, and this great cerebral vein of Galen drains into straight sinus. Straight sinus. The great cerebral vein of Galen drains into straight sinus. And who drains into the great cerebral vein of Galen? मैंने अभी बोला था आपको. Who joins the great cerebral vein of Galen? This is the basal vein. जो बेसल वेन प्रीवियस एमसीक्यू में देखा था, बेसल वेन, द बेसल वेन इज फॉर्म बाय जॉइनिंग ऑफ थ्री वेन्स, एंटीरियर सेरेब्रल, डीप मिडिल सेरेब्रल एंड स्ट्राइट वेन्स. इससे बनता है बेसल वेन. बेसल वेन ड्रेन्स इनटू द ग्रेट सेरेब्रल वेन ऑफ गैलन. ग्रेट सेरेब्रल वेन ऑफ गैलन इज फॉर्म बाय जॉइनिंग ऑफ टू इंटरनल सेरेब्रल वेन्स, एंड ईच इंटरनल सेरेब्रल वेन इज फॉर्म बाय द जॉइनिंग ऑफ TCS, थैलेमोस्ट्राइड, कोरॉइडल एंड सेप्टल. थैलेमोस्ट्राइड, कोरॉइडल एंड सेप्टल. तो ये बन गया पूरा वीनस सिस्टम ऑफ द ब्रेन. वेनस सिस्टम ऑफ ब्रेन. समझ में आया? देखो, दिस इज द डीप वेन ऑफ द ब्रेन, इंटरनल सेरेब्रल वेन. इंटरनल सेरेब्रल वेन बनता कैसे? बाय द जॉइनिंग ऑफ थ्री वेन्स. बस ये TCS याद रखना, थैलेमोस्ट्राइड, कोरॉइडल एंड सेप्टल. हाँ, थैलेमोस्ट्राइड, कोरॉइडल, सेप्टल से बनता है इंटरनल सेरेब्रल वेन. टू इंटरनल सेरेब्रल वेन जॉइंस टू फॉर्म द ग्रेट सेरेब्रल वेन, एंड ग्रेट सेरेब्रल वेन किस में ड्रेन करती है? स्ट्रेट साइनस में. And who drains into the great cerebral vein? Basal vein. And ये basal vein बनता कैसे है? Anterior cerebral vein, deep middle cerebral vein and anterior cerebral vein, deep middle cerebral vein and striate veins. थोड़ा सा difficult है ये, but ये याद रखना. But just remember this. Okay, बच्चों, what is this? Can anyone tell me what is this? What is this? What is this diamond shaped structure? What is this diamond shaped structure? Anyone? Bolo, if you know this, you answer this. What is this diamond shaped structure? That's the floor of fourth ventricle. That's the floor of fourth ventricle. ठीक है ना? ये diamond shaped structure क्या है? Floor of fourth ventricle. I'm seeing the comments that you are answering. बोलो बच्चों जल्दी. That's the floor of fourth ventricle है ना ये? And इसमें ये गोल 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 तो गोल दिखता है ना इसमें. What is this two rounded thing? That's the facial colliculus. Facial colliculus. That's the facial colliculus, बच्चों. You're there now, all of you? Huh? Okay, fine. What is the artery which is present in this sulcus? The artery which is present in the callosal sulcus here, that's the anterior cerebral artery. The artery present in the callosal sulcus is anterior cerebral artery. Yes, Shivangi, that's the floor of fourth ventricle. Very good. That's the floor of fourth ventricle. With the facial colliculus. Excellent. With the facial colliculus. Okay, I'll just draw a slide for you, bacho. I'll just draw a slide for you. See if you can answer this. That's the midbrain here. That's the pons here. And that's the medulla here. That's the pyramids here. That's the olives here. And that's the inferior cerebellar peduncle. That's the middle cerebellar peduncle. Fine. So that's the midbrain. That's the pons. That's the medulla. This is the middle cerebellar peduncle. This is the pyramids. That's the pyramids. That's the olives. And that's the inferior cerebellar peduncle. Now tell me, which is this nerve? Which is this nerve? That's the third nerve. Which is this nerve, which emerges from the dorsal aspect of the brainstem? That's the fourth nerve. So third and the fourth nerves are present in the midbrain, right? So the third nerve is here. The fourth nerve comes from the dorsal aspect. The nerve attached at the junction of pons with the middle cerebellar peduncle. What is that nerve? Fifth nerve. The fifth nerve is attached at the junction of pons with the middle cerebellar peduncle. What is this pons? That's the medulla. What do you call this junction as? The pontomedullary junction. The sixth, the seventh, and the eighth nerves are located here. 6, 7, 8 nerves are attached to the pontomedullary junction. What is attached here? This is the ninth, this is the 10th, that's the 11th nerve. 9th, 10th, and 11th cranial nerves are attached between the olives and the inferior cerebellar peduncle. And what is this nerve between the pyramids and the olives? That's the 12th nerve. 12th nerve. Between the pyramids and the olives is the 12th nerve. Clear hai bachcho? So just remember this. That's a very important MCQ. That's a very important visual slide. Have a look at this. Have a look at this now. So what is this nerve here? This is the third nerve. That's the fourth nerve. That's the fifth nerve. This is sixth, 7th, 8th. This is 9th, 10th, 11th. And what is this? 12th. 12th nerve. Clear? Are you able to follow this? Students, clear hai? Jitna hota I'll take today. If anything is left, we'll see it later. Don't worry. I don't go fast. Bachcho bolo, fine. Clear to all of you? Okay, fine. Now, what is this section of? This is the section of midbrain. What is this nerve which is coming from the ventral aspect? Here, what is this? That's the third nerve. So where is the nucleus of third nerve located? In the midbrain. And what is this nerve which is going from the dorsal aspect? That's a fourth nerve. So the nucleus of the third and the fourth nerve are located in the midbrain. Okay? Okay, so nucleus of the third and fourth nerve are located in the midbrain. Whatever I'm able to finish, I'll finish today. Otherwise, then whatever is left, I'll take it some other time. I'll just talk to the coordinators and take it at the other time. Zyada fast jaake, then there's no sense in going fast. Okay, so the third nerve is attached to the midbrain. The fourth nerve also attached to the midbrain. Fourth nerve देखिए कैसे जाती है? Fourth nerve goes from the dorsal aspect, है ना? The only nerve which goes from the dorsal aspect is the fourth nerve. The third nerve comes from which aspect? Ventral aspect, है ना? Ventral aspect. Now, can you tell me this? What is this? What is this known as? इसको क्या बोलते हैं? What is this known as? This is what we call as the facial colliculus. This, ये है ना, ये this one. See this. This is what we call as the facial colliculus. And how is the facial colliculus formed? The facial colliculus is formed by the fibers of facial nerve as they wind around abducens nucleus. Abducens nucleus. So what is this? This is the sixth nerve. What is this nerve? Seventh nerve. So fibers of seventh nerve, they wind around the abducens nucleus. ठीक है ना? They turn around the abducens nucleus. As they turn around the abducens nucleus, ये बाहर ये elevation बनाते हैं. That is what we call as facial colliculus. Clear, students? So how is the facial colliculus formed? By the fibers of facial nerve as they wind around the abducens nucleus. This is what you have to know. What is this nerve? This is the fifth nerve, which is attached to the pons. That's the fifth nerve. This is the medulla. Medulla. Okay, that's the medulla. So what is this nucleus of? ये देख रहे हो, this is the nucleus of. Anyone, can you tell me what is this nucleus of? जो यहाँ पे एक triangle बनाता है जिसका नाम है hypoglossal triangle. That's a hypoglossal triangle. So what is this nucleus of? Hypoglossal nerve. Hypoglossal nerve. What is this triangle? इसको हम बोलते हैं vagal triangle. Vagal triangle. This is what we call as the vagal triangle. So this is formed by, what is this nucleus? Dorsal nucleus of vagus. That's the dorsal nucleus of vagus. ठीक है बच्चा? So just try to understand this. एक minute. I'll just come back to this. Look. So what is this? That's the third nerve. है ना? ये third nerve है. This is the third nerve. And what is this nerve? Fourth nerve. So third and fourth nerves are attached to the midbrain. Midbrain. Right? Come to this nerve now. What is this? That's the pons. This is the open part of the pons. मतलब fourth ventricle होता है. This is a closed part of the pons. यहाँ से कौन सी nerve arise होती है? Fifth nerve. What is this? ये जो open part of the pons है ना, what are you seeing this? That's the facial colliculus. And ये facial colliculus कैसे बनता है? The facial colliculus is formed by the fibers of facial nerve as they wind around the abducens nucleus. Fine. What is this? That's the medulla. ये medulla का this is the hypoglossal triangle and ये जो देख रहे हो that's a vagal triangle. So hypoglossal triangle कौन बनाता है? The hypoglossal nucleus. And vagal triangle कौन बनाता है? The dorsal nucleus of vagus. Dorsal nucleus of vagus forms a vagal triangle. Fine. This is what you are supposed to know in the sections. And this is the pyramidal decussation. ये जो pyramidal tracks cross करते हैं ना, pyramidal tracks का crossing, this is the pyramidal decussation. Fine, students? Fine. Okay, now tell me, this is a section. Huh? ये section लिया. Can anyone tell me what is this? What is this? And what is this? I'll put number 1, number 2, number 3. That's a horizontal section through the brain. Okay, bolo bachcho, what is this, what is this, and what is this? Can anyone tell me this? Students, tell. What is that? Okay, अभी अपने पास time है. I'll continue after 9. थोड़ा देर कंटिन्यू करूंगा आफ्टर 9. ठीक है. ओके, इंटरनल कैप्सूल कौन सा बच्चा? इंटरनल कैप्सूल ये है. इंटरनल कैप्सूल जो है ना, इंटरनल कैप्सूल ये है, ये इंटरनल कैप्सूल है. अब बोलो व्हाट इज 1, व्हाट इज 2, व्हाट इज 3? 1, हाँ, वेरी गुड शिवांगी, वेरी गुड, यू आर गोइंग वेल. व्हाट इज नंबर 1? नंबर 1 इज कॉर्डेट न्यूक्लियस. 1 is caudate nucleus. What is number 3? कौन है? Thalamus. Number 3 is thalamus. And what is number 2? 2 is lentiform nucleus. 2 is the lentiform nucleus. Very good. 2 is lentiform nucleus. अब वो जो ग्रीन है ना, ग्रीन, दैट्स द इंटरनल कैप्सूल. हाँ, ये हॉरिजॉन्टल सेक्शन है ब्रेन का, जो ग्रीन बना है मैंने, वो इंटरनल कैप्सूल है. नंबर 1 इज द थैलेमस. नंबर 1 is the caudate nucleus, number 2 is the thalamus, and number 3 is the lentiform nucleus. Very good. बच्चों अभी ये बोल सकते हो मेरे बच्चों, चलो आज I'll take some more time after 9. हाँ, I'm going slow, I'm not hurrying up. हाँ, I'm the last person today, so I'll go थोड़ा सा slow. Okay. चलो बच्चों, if you can answer this, ये जो स्पेशल विसरल इफरेंट है ना, ये कंपोनेंट क्या सप्लाई करता है? इफ यू नो दिस, तो ये कंपोनेंट कौन से नर्व्स में होगा? दैट इज हाउ यू अंडरस्टैंड. तो ये जो स्पेशल विसरल इफरेंट कंपोनेंट है ना, ये मसल्स ऑफ फेरेंजियल आर्चेस को सप्लाई करता है. स्पेशल विसरल इफरेंट जो कंपोनेंट होता है, ये क्या सप्लाई करता है? मसल्स ऑफ फेरेंजियल आर्चेस. तो अगर कोई नर्व है जिसको मसल्स ऑफ फेरेंजियल आर्चेस को सप्लाई करना है, इट शुड हैव दिस कंपोनेंट इन इट्स न्यूक्लियस. सो व्हिच इज द नर्व ऑफ द फेरेंजियल आर्च? फर्स्ट आर्च की नर्व मैंडिबुलर, सेकेंड आर्च की नर्व फेशियल, थर्ड आर्च की नर्व मैंडिबुलर, एंड फोर्थ आर्च की नर्व इज वेगस. तो ये जो कंपोनेंट है स्पेशल विसरल इफरेंट would be present in which cranial nerves? It is present in 5th, 7th, 9th and 10th cranial nerve. 5, 7, 9 and 10 cranial nerve. What does this component supply? The muscles of pharyngeal arches. Pharyngeal arches. It supplies the muscles of pharyngeal arches. तो ये pharyngeal arch के nerves में होगा. So which is that nerve? 5, 7, 9 and 10 cranial nerves. Right? What does this general visceral efferent component supply? ये जो general visceral efferent components है ना, ये glands को supply करता है. Glands. Now tell me बच्चा, who's going to supply all the glands in the head and neck? 7th nerve. 7th nerve is going to supply. 7th nerve is going to supply all the glands in the head and neck except the glossopharyngeal nerve, which supplies the parotid gland, right? Glossopharyngeal nerve parotid gland को supply करती है. Who supplies the glands of GIT? Vagus. And the third nerve supplies sphincter pupillae and ciliaris muscle. So ये जो component है general visceral efferent component, ये glands को supply करता है. तो ये कौन से nerves में होगा? The nerve which supply all the glands in the head and neck, that's facial. The parotid which supplied by glossopharyngeal, so that's glossopharyngeal. Vagus GIT के glands को supply करती हैं, तो vagus आ गया. And third nerve glands नहीं supply करता है, but third nerve supplies two muscles which are parasympathetic, the sphincter pupillae and ciliaris muscle. तो ये component कौन से nerves में होगा? Yes, 7, 9, 10 and third nerve. जनरल सोमैटिक इफरेंट मतलब जनरल सेंसेशंस फ्रॉम द बॉडी वॉल. ये एंटायर बॉडी वॉल से सेंसेशंस कौन लेके जाता है? 5th nerve. इट इज प्रेजेंट इन द 5th nerve. स्पेशल विसरा इज द टंग. बच्चों स्पेशल विसरा इज द टंग. सो हु कैरी स्पेशल सेंसेशंस फ्रॉम एंटीरियर 2/3 ऑफ द टंग? 7th nerve. 7th nerve स्पेशल सेंसेशंस एंटीरियर 2/3 से लेके जाता है. पोस्टीरियर 1/3 से स्पेशल सेंसेशंस कौन लेके जाता है? 9th nerve. एंड पोस्टीरियर मोस्ट पार्ट से स्पेशल सेंसेशंस कौन लेके जाता है? 10th nerve. सो फॉर 7th, 9th एंड 10th nerve, दैट्स द न्यूक्लियस ऑफ ट्रैक्टस सॉलिटेरियस. इसका नाम है न्यूक्लियस ऑफ ट्रैक्टस solitarius. Okay, that's the nucleus of tractus solitarius. That's a common nucleus for 7, 9th and 10th. Special visceral afferent tongue yaad rakhna, tongue. Then you will understand this. It's the tongue. Right. So who supplies special sensations? Anterior 2/3 of the tongue, chorda tympani. Posterior 1/3 glossopharyngeal. Posterior most part is vagus. Fine. जनरल विसरा से जनरल सेंसेशंस कौन लेके जाता है? दैट्स वेगस नर्व. वेगस नर्व. Special somatic is special sensations from the body wall के special sensations कौन है? Smell. So this is present in which nerve? First. Second is vision. So second nerve. First, second, and eighth nerve, that's balancing. So eighth nerve. So ये जो component है special somatic, मतलब special sensations from the body wall are carried by first nerve, second nerve is vision, and eighth nerve is for balancing, right? And general somatic afferent is fifth nerve. General somatic efferent नहीं होता है. General somatic afferent is fifth nerve. बस ये याद रखना. बच्चों ये थोड़ा सा डिफिकल्ट है. दिस इज अबाउट द फंक्शनल कॉम्पोनेंट ऑफ द नर्व्स. बस इतना जो मैंने आपको दिखाया ना, इतना आप याद रखिए. Are you able to follow this or is it difficult? I'll just inform the team. थोड़ा सा टाइम लगेगा. हाँ, I'll just inform the team. 2 minutes. हाँ. Is this clear? By that time you tell me if it's clear or no. अगर क्लियर नहीं है तो बोलो. I'll explain it. सर्जरी क्लास है, पता है बच्चा. वेट, अभी ये मुझे खत्म करने दो. एंटीक सर्जरी क्लास है ना मेरा, ये खत्म होने के बाद सर्जरी. लेट मी फिनिश माय पोर्शन. वेट. ओके, आई नो. ओके, चलो विल स्टार्ट विद दिस. लास्ट टॉपिक है. थोड़ा सा एक 15-20 मिनट लगेगा. हाँ, चलो स्टार्ट. Tell me, what is the floor of the inguinal canal formed by? Anterior wall of inguinal canal is formed by what? बोल सकते हो? Anterior wall of inguinal canal and its entire extent is formed by whom? External oblique. In its lateral part, it is formed by internal oblique. So, inguinal canal का anterior wall and its entire extent is formed by external oblique. In its lateral part, it is formed by internal oblique. The posterior wall of inguinal canal and its entire extent is formed by fascia transversalis. In its medial part, it is formed by the conjoint tendon. The roof is formed by conjoint tendon. And the floor is formed by external oblique and inguinal ligament. ठीक है? The superficial inguinal ring is a defect in what? External oblique aponeurosis. The deep inguinal ring is a defect in fascia transversalis. Fine, clear to all of you? Okay, tell me the branches of abdominal aorta. Branches of abdominal aorta is 2, 3, 4, 5. ये mnemonic है 2, 3, 4, 5. 2 terminal branches. 2 is terminal branches. What is the vertebral level? L4. And what are those? Common iliacs. 3 is ventral branches. Ventral branches कौन है? Celiac trunk, superior mesenteric artery, inferior mesenteric artery. ठीक है ना? Celiac trunk, superior mesenteric, inferior mesenteric. Celiac trunk का vertebral level T12, superior mesenteric का L1, inferior mesenteric का L3. 4 lateral branches. 4 lateral branches में कौन आता है? 4 lateral branches में first is inferior phrenic, middle suprarenal, renal and gonadal. ठीक है? So 4 lateral branches is inferior phrenic, middle suprarenal, renal and gonadal. And 5 क्या होंगे अब? 5. What is 5? 5 dorsal branches. 5 dorsal branches. इसमें 4 pairs of lumbar arteries. And 1 is median sacral artery. 4 pairs of lumbar arteries and 1 is median sacral artery. ठीक है? So 2, 3, 4, 5 ये mnemonic याद रखना. 2 terminal branches at L4, that is common iliacs. 3 ventral branches, celiac trunk, superior mesenteric, inferior mesenteric. 4 lateral branches, inferior phrenic, middle suprarenal, renal, gonadal, and 4 dorsal branches. 5 dorsal branches जिसमें 4 pairs of lumbar arteries and 1 median sacral artery. एपिप्लॉइक फोरामेन के बाउंड्रीज बोल सकते हो बच्चों, एपिप्लॉइक फोरामेन के बाउंड्रीज एंटीरियर, चलो बोलो बच्चों, एंटीरियर इज द लेसर ओमेंटम। एपिप्लॉइक फोरामेन के बाउंड्रीज एंटीरियरली इज द लेसर ओमेंटम, जिसमें हिपैटिक आर्टरी, पोर्टल वेन, बाइल डक्ट होता है। पोस्टीरियरली इज द आईवीसी, सुपीरियरली इज द कॉर्डेट लोब ऑफ लीवर, हाँ, एंड इंफीरियरली कौन है, इंफीरियर। बाउंड्रीज ऑफ एपिप्लॉइक फोरामेन बोल रहा हूँ, boundaries of epipleutic foramen, anteriorly is the less omentum containing hepatic artery, portal vein, bile duct। पीछे कौन होता है, IVC। superiorly क्या होता है, caudate lobe of liver, and inferiorly क्या होता है, first part of duodenum, first part of duodenum, एपिप्लॉइक फोरामेन। ठीक है ना, क्लियर है। एपिप्लॉइक फोरामेन के बाउंड्रीज पता है ना आपको, दिस इज वेरी इंपॉर्टेंट है बच्चा, ये याद रखना। एपिप्लॉइक फोरामेन के बाउंड्रीज हियर, दैट्स द एपिप्लॉइक फोरामेन हियर। सो आगे कौन है, लेस ओमेंटम कंटेनिंग हिपैटिक आर्टरी, पोर्टल वेन, बाइल डक्ट, पीछे आईवीसी, ऊपर कॉर्डेट लोब ऑफ लीवर, नीचे है फर्स्ट पार्ट ऑफ डिओडेनम। ठीक है, ओके। ब्रांचेस ऑफ सुपीरियर मेसेंट्रिक आर्टरी बोल सकते हो क्या आप, सुपीरियर मेसेंट्रिक आर्टरी के ब्रांचेस क्या क्या होते हैं, इफ एनी वन ऑफ यू कैन आंसर दिस। Okay, superior mesenteric artery के branches. One is inferior pancreaticoduodenal artery, inferior pancreaticoduodenal artery, jejunal and ileal branches, then middle colic, right colic, ileocolic. So what are the branches of superior mesenteric artery? Inferior pancreaticoduodenal artery, jejunal and ileal branches, middle colic, right colic, ileocolic. This ileocolic is going to give the appendicular artery. Appendicular artery is a branch of ileocolic artery. Inferior mesenteric artery के branches, left colic, sigmoid branches, and superior rectal artery. So left colic, sigmoid branches, and superior rectal artery. This superior rectal artery is a continuation of inferior mesenteric artery. Superior rectal artery is a continuation of inferior mesenteric artery. Which are the retroperitoneal organs? बच्चों बोल सकते हो retroperitoneal organs क्या होते हैं? Retroperitoneal organs, kidneys, हाँ, suprarenal, kidneys, suprarenal. What else? बोलो बच्चों। Duodenum, except for its first and last part, छोटा सा first part, छोटा सा last part is retroperitoneal. Duodenum, pancreas, ascending and descending colon, aorta, aorta and IVC. So kidneys, suprarenal, duodenum, pancreas, ascending and descending colon, aorta and IVC. So this is the list of retroperitoneal organs. और कुछ बचा है क्या इसमें? Anything else is left? Retroperitoneal organs में कुछ बाकी है बच्चों? Kidneys, suprarenal, duodenum, fine, except for the small part of fourth part, that is intraperitoneal, ascending, descending colon, aorta, IVC. Fine. So this is the list of retroperitoneal organs. ठीक है, fine, this is clear. Blood supply of stomach आपको पता है ना, along the lesser curvature there's an anastomosis between the left and right gastric artery. Along the greater curvature there's an anastomosis between the left and right gastroepiploic artery. The fundus is supplied by the short gastric branches of splenic artery. So that becomes the blood supply of stomach. Fine. Okay. फर्स्ट पार्ट ऑफ डिओडेनम के रिलेशंस बोल सकते हो। फर्स्ट पार्ट ऑफ डिओडेनम का एंटीरियर रिलेशन क्या होता है? फर्स्ट पार्ट ऑफ डिओडेनम का एंटीरियर रिलेशन क्या होता है? एंटीरियर रिलेशन इज द बॉडी ऑफ गॉल ब्लैडर, एंड पोस्टीरियर रिलेशन इज, हाँ, हिपैटिक आर्टरी, नहीं, हिपैटिक आर्टरी नहीं आती, पीछे कौन आता है? पोर्टल वेन, बाइल डक्ट and gastroduodenal artery. Remember students, this is gastroduodenal artery which is related to the first part of the duodenum posterior. So first part of the duodenum का anterior relation क्या आता है? Body of the gallbladder. First part of duodenum का पीछे क्या आता है? The portal vein, the bile duct and the gastroduodenal artery. Now this gastroduodenal artery is very prone to हेमोरेज। अल्सर्स कहाँ पे होते हैं? अल्सर्स आर वेरी कॉमन इन द फर्स्ट पार्ट ऑफ द ड्यूोडेनम के पोस्टीरियर वॉल पे। सो विच आर्टरी इज इट गोइंग टू इरोड? गैस्ट्रोड्यूोडेनल आर्टरी। ये गैस्ट्रोड्यूोडेनल आर्टरी को इरोड करेगा। ओके, आंसर दिस। आई जस्ट फिनिश दिस। चलो बोलो, what are the posterior relations? Acha, what is this? Can anyone tell me what is this? This is annular pancreas. Annular pancreas. Annular pancreas is due to defective migration of ventral pancreatic bud. डिफेक्टिव माइग्रेशन ऑफ द वेंट्रल पैनक्रियाटिक बड, उससे क्या होता है? एन्युलर पैनक्रियाज होता है। एन्युलर पैनक्रियाज, राइट? कैन एनीवन टेल मी व्हाट इज दिस? व्हाट इज दिस? दिस इज अ पॉलिसिस्टिक किडनी। पॉलिसिस्टिक किडनी, दिस इज द कंजेनाइटल पॉलिसिस्टिक किडनी। कंजेनाइटल पॉलिसिस्टिक किडनी, ठीक है? हाँ सर्जरी I'll finish in 5-10 minutes बच्चा। I'll finish in 5-10 minutes। हाँ बस एक 5-10 मिनट और I'll finish it। चलो, secretory part of the kidney is derived from, एक 5 मिनट रुकिए। secretory part of the kidney is derived from, collecting part of the kidney is derived from ureteric bud। ureteric bud। secretory part of the kidney is derived from metanephros। metanephros, okay, so ये याद रखना, secretory part of the kidney is derived from metanephros, the collecting part of the kidney is derived from ureteric bud। ureteric bud। structures emerging from the greater sciatic foramen and entering the lesser sciatic foramen, ये पता है आपको? pin, what is pin? P is pudendal nerve, I is internal pudendal artery, and N is nerve to obturator internus। N is nerve to obturator internus। openings in the diaphragm, big openings, T10, T8, T10 and T12। T8 क्या होता है? IVC and right phrenic nerve। T10 is esophagus with vagus, and T12 is aorta, azygous vein and thoracic duct। thoracic duct, ठीक है ना? So T8 is IVC and the right phrenic nerve, T10 is the esophagus with the right and left vagus, T12 is the aorta with the azygous vein and thoracic duct। एक 5 मिनट और, I'll finish it। चलो, answer this now। The most dependent part of the body in supine position, the most dependent part of the body in supine position is hepatorenal pouch of Morrison। Morrison's pouch। most dependent part of the body in supine position is Morrison's pouch। most dependent part of the body in standing position in females is pouch of Douglas। in females, in males it is rectovesical pouch। males में rectovesical pouch, females में rectouterine pouch, that's the pouch of Douglas। dentate line or pectinate line, हाँ dentate and dentate line पता है ना? dentate line or pectinate line, what is that? Hilton's line represents the mucocutaneous junction of anal canal। mucocutaneous junction of anal canal is white line of Hilton। dentate line represents what? ectodermal and endodermal development of anal canal। part above the dentate line is derived from hindgut, cloaca, and part below the dentate line is derived from the part above the dentate line is derived from hindgut, and the part below the dentate line is derived from cloaca। ectodermal and endodermal in origin, that is dentate or pectinate line। it is the watershed line। इसके ऊपर और नीचे सब अलग होता है। white line of Hilton is the mucocutaneous junction of anal canal, ठीक है? न्यूरल क्रेस्ट सेल्स के डेरिवेटिव्स आपको पता होगा। यू टेल मी दिस, व्हाट इज द जेनाइटल ट्यूबरकल फॉर्म? ये बोल सकते हो? जस्ट 2 more minutes। जेनाइटल ट्यूबरकल, ये याद रखना, genital swellings and genital folds। चलो बोलो बच्चों, genital tubercle in males and females, can you answer this? Genital tubercle in males forms what? Penis। in female forms the clitoris। genital swellings in male forms the scrotum। in female forms the labia majora। and genital folds in female forms the labia minora, and in male forms the ventral aspect of penis. Ventral aspect of penis. बस ये याद रखना, ठीक है. तो जेनाइटल ट्यूबरकल मेल्स में पेनिस, फीमेल्स में क्लाइटोरिस बनाता है. जेनाइटल स्वेलिंग मेल्स में स्क्रॉटम, फीमेल्स में लेबिया मेजोरा, एंड जेनाइटल फोल्ड्स इन मेल्स इट फॉर्म्स द वेंट्रल एस्पेक्ट ऑफ पेनिस, एंड इन फीमेल इट फॉर्म्स द लेबिया माइनोरा. ठीक है. ओके, द रेस्ट ऑफ द थिंग्स बस 1-2 मिनट. व्हाट इज दिस? ये बोल सकते हो. चलो सर्जरी क्लास एक 5 मिनट. Sir, 5 minutes more, sir. Five minutes more, sir. Done. Okay, now you tell me, bacho, what is this? Chalo, what is this? You tell me. Students, you tell me what is this? हाँ, अगर ये slide आता है आपको, if this slide comes for you in visuals, what are you going to write this as? Neural tube नहीं, ये क्या है बच्चा? What is this? This is a sacrococcygeal teratoma. This is a sacrococcygeal teratoma, right? And this sacrococcygeal teratoma is due to नहीं, ये sacrococcygeal teratoma है बच्चा, and this sacrococcygeal teratoma is due to persistence of primitive streak. Persistence of primitive streak. What is this? This is spina bifida. Okay, and what is this? This is an encephaly. Okay, tell me, when does the anterior neuropore close? Anterior neuropore closes by which day of intrauterine life? 25th day, right? The cranial neuropore closes by 25th day of intrauterine life. Agar ye close nahi hota, what does it results in? Anencephaly. The caudal neuropore closes by 28th day of intrauterine life. Agar ye close nahi hua, to that results in spina bifida. ठीक है बच्चों, clear? So ये visual slides clear है. Just one more slide I'll put. Sandeep sir, 5 minutes more. Sandeep sir, done, over. Now you tell me, bacha, what is this epithelium? What is this? This is simple squamous. Simple squamous epithelium. Where do you get simple squamous epithelium? Lining of blood vessels. Yes, lining of blood vessels, you get simple squamous epithelium. That is also known as endothelium. Where else do you get simple squamous? Alveoli. This is simple cuboidal. We get in the ducts, lining of the ducts. This is simple columnar. Okay, we get in the GIT. Okay, in the walls of GIT, simple columnar epithelium. This is pseudostratified ciliated columnar with goblet cells. Where you get this respiratory system, right? Pseudostratified ciliated columnar with goblet cells. This is where what you get in the respiratory system, respiratory epithelium. This is stratified squamous non-keratinized. Stratified squamous non-keratinized epithelium कहाँ पे होता है? Esophagus, vagina. Stratified squamous non-keratinized. What is this? This is stratified cuboidal. Stratified cuboidal you get in ducts of glands. Again, ducts of glands. This is stratified columnar. Stratified cuboidal, stratified columnar you get in the ducts of glands. Okay, and what is this? Transitional. Transitional epithelium is urothelium. Urothelium, we get this in the ureters, the bladder, the kidney. ठीक है, that is urothelium. ठीक है बच्चों, clear to all of you? Fine. कुछ बाकी था क्या बीच में? Just tell me one thing. What is a paramesonephric duct form in females? Paramesonephric duct in female forms the entire genital system of females, right? It forms the fundus, the body, the cervix, the fallopian tubes. It forms the upper 2/3 of the vagina, upper 1/3 of the vagina. Sorry, it forms the upper 1/3 of the vagina. So fundus, body, cervix, fallopian tubes, upper 1/3 of the vagina is derived from paramesonephric duct in females. The lower 2/3 of the vagina is derived from urogenital sinus, right? So upper 1/3 of vagina is what in origin? Mesodermal, and the lower 1/3 is endodermal in origin. Fine. What is a paramesonephric duct form in males? It degenerates in males except for appendix of testis and the prostatic utricle. Prostatic utricle. That's the fate of paramesonephric duct in males. The mesonephric duct, common for both males and females. What does it form? The collecting part of the kidney. Collecting part of the kidney, matlab? Yes, collecting part of the kidney. The calyces, the ureter, and the trigone of the bladder. This is common for both males and females. What is a mesonephric duct form in males? The entire genital system of males, except the testis, the epididymis, the vas deferens, the seminal vesicles, the ejaculatory duct, and the prostate. This is all derived from the mesonephric duct in males. In females, it forms the collecting part of the kidney, and then it degenerates. In females, it forms, what is the mesonephric duct form in females? The epiphron, yes, and the paraphron. Fine, students. Anything left? All clear, students? Fine. I'll stop here. Okay, thank you to all of you. I hope there are one or two things which are which left out. I'll complete that sometime later. Thank you to all of you for your patient listening. Thank you, my dear children. Thank you, and all the best to all of you. Thank you so much.
Hi guys, good evening, good evening. Can you all hear me? Can you all see me? Right, so as told in the morning, we are here back with the second half of our surgery. The first half we did until nutrition. From here we'll be talking about trauma and its NIH protocols. ठीक है? Hi Vidya. Hello Shivangi. Right, so can we start without wasting any further time? Let's kickstart this session. तो अभी हम बात करेंगे trauma. From trauma there we'll keep building up and the entire concept. बीच में कोई भी topic अगर आपको लग रहा है you need to understand a little bit more or you have a little bit of doubt, write down on the chat box. I will take up that particular question. Hi Max. Chalo. So we'll talk about the triage in the trauma. The triage is a color coding system. Now there are different ways the triage can be done. So triage is a priority based system which you have to attend, and it's a color coded system that we have. Now there was a question which was asked in your exam. Triage is done on the basis of, now quick feedback, is the triage done on the basis of severity or is it done on the basis of outcome? Two important components. Is it the severity or is it on the basis of outcome? Remember, in a polytrauma it is done on the basis of outcome when compared to severity. Okay, that itself is your exam question. So triage is a color coding system that is designed on the basis of outcome, not on the basis of severity. Another way of telling you that this is also based upon the resources which are required for the treatment versus resources that are actually available. A patient who has come with head injury, you do not have neurosurgeon in your hospital, you cannot keep that patient, hence refer the patient out. So such patients will have low priority to you. So hence these are in the context, right? Now, you have different color code bands. One color code that I would never want to see on my patient is a black band because it says the patient is in broad dead. The red indicates it is emergency. It simply means it requires immediate attention. It requires an immediate attention. Yellow indicates urgent. And green indicates you can have a delayed presentation. A green indicates you can have a delayed presentation. So you have a broad dead patient who is black, a red is emergency, you have yellow which is going to be urgent. Green is also called as the orphan child of the casualty. You can call the patient or you can see the patient whenever your time seems fit or you don't have any other patient to address to. Okay? But a blue is different. Blue is for referral. Now that, as I told you, if you have a patient who is having a head injury, you do not have CT in your hospital or you do not have a neurosurgeon in your hospital, this patient should be put a blue tag. On that blue tag you have to write what are you referring or which department are you referring to, and the patient lands up directly into that particular referral department in the next hospital. So blue is for referral. Okay? So don't make that mistake. Now you have hemorrhagic shock, which is again a very important component that you'll see in the circulatory status of trauma. Again, यही हमारा 4 चांद 5 सितारे वाला जो topic है in trauma. So you have to remember about the hemorrhagic shock. Now hemorrhagic shock, it is based upon the percentage of blood loss. If the percentage of blood loss is less than 15%, it is class 1. If it is 15 to 30%, it is class 2. If it is 30 to 40%, it is class 3. And if it is more than 40% of the blood volume loss, if it is more than 40%, it is more than 40%, then it is going to be class 4, right? Now, in the class 1, the heart rate remains normal, the blood pressure remains normal, the pulse pressure remains normal, respiratory remains normal, the urine output is also normal, the GCS is also normal. There is no need for blood transfusion. Simple oral fluids can take care of the patient, as simple as that. In class 1 hemorrhagic shock, the heart rate tends to pick up or may remain normal. Systolic blood pressure remains normal. Here pulse pressure will start to drop down, the respiratory rate remains normal, the urine output remains normal, GCS is normal. Here only IV fluids are required, there is no need for blood transfusion. In class 3 hemorrhagic shock, you see the heart rate will start to pick up, the systolic blood pressure will start to drop, the pulse pressure will further decrease, respiratory rate will increase, urine output will become oliguria. Now, a very important thing, remember in class 2 it might remain normal or decrease, but not oliguria per se, right? Whereas in your GCS, the patient will now become confused. And here the patient will start initially with IV fluids, and then there could be requirement of the blood transfusion as well. In IV fluids, remember, here you have to give both crystalloids and colloids. Here the ratio of crystalloids to colloids will be 3:1. The ratio of crystalloid to colloid in the form of transfusion is going to be 3:1. In class 4 hemorrhagic shock, you see the heart rate is still high. You will notice that the blood pressure further drops, the pulse pressure further drops, the respiratory rate increases. Here absence of urine, that is anuria, is going to become. There will be anuria, patient will be unconscious. It is anuria, patient will be unconscious, and here it will require massive blood transfusion. Here you have to initiate massive blood transfusion protocol. Now, what is this massive blood transfusion? Now, by current definition, when more than or equal to 10 units of blood are transfused within 24 hours, this is what we call it as massive blood transfusion protocol. Now, whenever you're doing a massive blood transfusion protocol, you cannot only give PRBCs, that is a packed red blood cells. You have to combine that with the fresh frozen plasma as well as platelets. The ratio in which you're going to administer is going to be 1:1:1. The ratio in which the PRBCs are going to be given with respect to FFP and platelets are going to 1:1:1. Remember, this is about multi-donor platelet. If you have a single donor platelet, 6 bags of multi-donor platelet is equal to 1 bag of single donor platelet in terms of concentrate. Okay? So this is with respect to the hemorrhagic shock that you need to know. To know more about shock, you can refer to our BLS series, that is a basic. We've done one series in the YouTube only. It is called as Bailey in Love with Dr. Sandeep. Go down to trauma section. In trauma, you can hit the shock status, and in the shock, you will get all these details. But for now, hemorrhagic shock is what is important. Now, our previous exam question is about the classification of head injury. They have asked you a couple of times. So what are the bases that you're going to do on the basis of GCS scoring system? Now, when do you call a patient is having a minor head injury? When the GCS of the patient remain 15/15 with no loss of consciousness. With no history of loss of consciousness, this is what we call it as a minor head injury. Now, on the mild head injury, the GCS of the patient might be 15/15 or it can be 14/15. But this time there will be presence of loss of consciousness. If the GCS of a patient is between 9 to 13, it is called as moderate. And if the GCS of the patient is less than or equal to 8, it is considered to be severe head injury. This is considered to be as severe head injury. Right? Now, this GCS of less than or equal to 8 is actually the current indication for prophylactic intubation. This is the current indication for prophylactic. There is a current indication for prophylactic intubation, and this is also GCS less than or equal to 8 increases the risk for coma. So at what GCS would you like to go with intubation? The answer is less than or equal to 8. And when does it increase the risk for coma? Again, the risk if the GCS is less than or equal to 8. Now, in the head injuries, there are two important components. You have the extradural hemorrhage and the subdural hemorrhage. Remember, when you talk about extradural hemorrhage, it is defined as the collection of blood. It is a collection of blood between the dura and the skull bone. Between the dura and the skull bone, this is what we call as extradural hemorrhage. Subdural hemorrhage is defined as the collection of blood. It is the collection of blood between dura and the arachnoid membrane. Between dura and the arachnoid membrane, this is your subdural hemorrhage, right? Now, the question that they can ask you with respect to this is the mode of injury. This is associated with temporal fractures. This is associated with temporal fractures. The most common source of bleeding. The most common source of bleeding is going to be middle meningeal artery. This is going to be the middle meningeal artery. And when you look at this, there will be signs in terms of raised intracranial pressure. Now, the question that they ask in head injury is, in which side you see dilated pupil and which side you will see weakness, right? Whichever side you have the head injury, that is same side, ipsilateral pupillary dilation is noticed. And there will be contralateral hemiparesis, that is weakness. So whichever side the pupil is dilated, that is the site where the injury is occurred or the blood is clotted there, and the contralateral hemiparesis will be noticed. Here additionally you will see presence of lucid interval. Additionally, you will see this presence of lucid interval. What is lucid interval? It is a period of consciousness between two unconscious episodes, is what we call it as lucid interval, right? So here you will have a patient with temporal fractures. This is the most common source, is going to be middle meningeal artery. It is having a feature of raised ICT with ipsilateral pupillary dilation with contralateral hemiparesis and lucid interval. The investigation of choice is going to be NCCT of the head. Now in the NCCT you find this opacity. One surface is going to be your, you see this is convex and this is also convex surface, right? So on a NCCT you have the biconvex opacity. You have the biconvex opacity. Now this biconvex opacity is also called as the lenticular opacity. Also called as the lenticular opacity. And the management in terms of emergency. As an emergency procedure, I would like to perform a burr hole surgery. I like to perform the burr hole surgery. And as a definitive management, we can go ahead with craniotomy, right? As a definitive management, we can go ahead with craniotomy. Okay? So these are the important points with respect to extradural hemorrhage. Okay? So you have in a nutshell what is an extradural hemorrhage. Coming back to subdural hemorrhage. So here subdural hemorrhage is seen or more common in elderly patients. It is associated, if I say, this is associated with significant history of hit, blow or fall to the head. There is hit, blow or fall overhead. As you have the most common source of bleeding is middle meningeal artery, that is in the extradural hemorrhage. In the subdural hemorrhage, the most common source is going to be the cortical bridging veins. It is the cortical bridging veins, right? It is seen in elderly patients. It is associated with history of significant hit, blow or fall to the head. The most common source is your cortical bridging veins. Here you will have raised intracranial pressure. Same thing, ipsilateral pupil dilation. Ipsilateral pupil dilation and contralateral hemiparesis. Contralateral hemiparesis, right? So raised intracranial pressure, increased intrapupillary dilation, that is same sided pupil will be dilated. The contralateral, you are going to cause hemiparesis. Everything remains the same. The investigation of choice here remains as NCCT of the head. Now when you look at the NCCT, you will now notice that there is one surface is going to be concave, other is going to be convex, right? So when you look at the NCCT, this is what we call it as concavo. It is concavo convex opacity. It is the concavo convex opacity, or also referred to as the crescent opacity. Also referred to as the crescent opacity. Now when it comes down to the management, here the management, if it is a small subdural hemorrhage, then it is going to be conservative. And if it is a large subdural hemorrhage, then you have to take the patient for craniotomy. Right? So this is in response with respect to your extradural hemorrhage as well as subdural hemorrhage. You cannot afford to miss a single point between these two. They are repeat questions ट्रॉमा में अगर न्यूरो ट्रॉमा में सवाल पूछना है, दिस इज व्हाट दे वुड बी कीप ऑन आस्किंग यू. And remember, one of the most distinctive point that you'd remember is this guy, that is lucid interval. He's a number one guy, right? So the lucid interval is the differentiating finding between these two, because both of them will have raised ICTs. The only thing, remember, with respect to extradural hemorrhage, all these symptoms will be sudden and severe in onset. In a subdural hemorrhage, there'll be gradually progressive symptoms. Okay? Sudden symptoms in extradural, gradually progressive in subdural hemorrhage. These are the two important carry-home message that you need to have, right? Now, again, this is something that is going to be again asked in your exam. This was recently asked in your NEET exam as well. So again, an important one. A diffuse axonal injury. This is defined as a complete disruption of axons between white matter and gray matter. Between the white matter and gray matter, and this occurs due to rapid decelerating injury. It is because of the rapid decelerating injury. So patient who is having a diffuse axonal injury is now going to land up with coma, post-traumatic coma, and when you do an NCCT, for my surprise, it is going to come out to be normal. So the minute any patient who is having a trauma, post-trauma, there's head injury, post-head injury, patient lands up to you in the hospital with coma. In that, if you do an NCT, it is normal, it is highly suspicious. So immediately get an MRI done. On an MRI, you can see all these. You can see all these small points, hemorrhages here. So these are your, this is more evident here. So all these are your punctate hemorrhages, which are present between the white matter and the gray matter, right? So on an MRI, you will see presence of punctate hemorrhage, presence of a punctate hemorrhage, presence of a punctate hemorrhage between white matter and gray matter, between white and gray matter. On an MRI indicates a diffuse axonal injury. Remember, diffuse axonal injury is associated with very poor prognosis. It is associated with very poor prognosis, right? As simple as that. So this is about your diffuse axonal injury. Now then comes your Cushing's trad. Now Cushing's trad basically tells you that there is increased intracranial pressure. So there are three components of the Cushing's trad. Number one, it is going to have hypertension. It is going to have hypertension. To achieve that, there will be presence of bradycardia. There will be presence of bradycardia. And with bradycardia, there will be irregular respiratory rate. There will be irregular respiratory rate. All these put together is what we call it as Cushing's trad. So Cushing's trad is a raised intracranial pressure, and this is also called as secondary brain injury. Now this leads to something called as the secondary brain injury. Do not forget the three important components of the Cushing's trad. It is hypertension, bradycardia, and irregular respiratory rate. And an irregular respiratory rate. Then you have something called as the lethal triad of trauma. The lethal triad of trauma is something that you're trying to prevent throughout your primary assessment. Now, what is this lethal triad of trauma? Now, the lethal triad of trauma consists of, number one, it will have metabolic acidosis. It will have metabolic acidosis. It is going to have coagulopathy. And along with coagulopathy, it is going to have hypothermia. It is going to have hypothermia. So we have metabolic acidosis, coagulopathy, as well as hypothermia. All these three put together is what we call it as lethal triad of trauma. So when you look at the whole trauma assessment, how do you prevent metabolic acidosis? So to prevent, I will use the fluid of choice for resuscitation. It's going to be Ringer lactate. How do you prevent coagulopathy? So whenever you're doing a blood transfusion, that is a massive blood transfusion, I would give PRBCs in combination with FFP and platelet to prevent coagulopathy in a ratio of 1:1:1. To prevent hypothermia, I will be giving warm crystalloids. So the ringer lactate that I'm going to give in a patient of trauma, preferably it should be warm. A warm crystalloid will have a better component or a better yield in terms of lethal triad of trauma. To prevent lethal triad of trauma, we came up with DCS protocol, and DCS stands for damage controlled surgery. DCS stands for damage control surgery. Now, what is this damage control surgery basically means? In stage 1, it is going to be patient selection. Stage 1 of damage control surgery, it is the patient selection to see which patient requires a damage control surgery and which patient requires an early total care. Stage 2, it is going to be primary exploration. Now, what is the goal of your primary exploration? So when you're doing a primary exploration, the goal of the primary exploration, it is to control hemorrhage. It is to control the ongoing hemorrhage and prevent any further contamination. And we are going to prevent any further contamination. So once you have achieved this, I'm not going to close the abdomen. Here we are going to take it for temporary abdominal closure. We put the patient for temporary abdominal closure. You have the temporary abdominal closure. Now, stage 3, you have, it is going to be an ICU care. Now, in an ICU care, I'm going to keep the patient for 24 to 48 hours. Now, in this 24 to 48 hours, the goal of keeping the patient in an ICU, it is to correct coagulopathy and treat hypothermia. So, the goal here, it is to correct the ongoing coagulopathy. And if the patient is already having hypothermia, it is to treat hypothermia. It is to treat hypothermia, right? So correct coagulopathy and treat hypothermia, that is going to be stage 3, that is your ICU care. Then comes your stage 4. Stage 4 is going to be secondary exploration. Now, what is the goal of the secondary exploration? It is going to be a definitive surgery. So the goal here, it is to correct the anatomy. The goal here is going to be to correct the anatomy. And the last one is your stage 5, that is your definitive. Is going to be definitive abdominal closure. This is going to be a definitive abdominal closure, right? So stage 1 is your patient selection, stage 2 is your primary exploration, stage 3 it is going to be an ICU care, stage 4 is your secondary exploration, and stage 5 is your definitive abdominal closure, right? So these are the stages of your damage control surgery. Again, very important from the exam perspective. They can give you what stage are you looking at, and these are the different stages. Okay? Lethal triad of trauma has been our previous exam question, so do not ignore this. This is important. This has been your INI-CT exam question, that is the stages of your damage control surgery. Again, important from our exam perspective as well. Now, when it comes down to abdominal trauma, we have something called as your FAST. So for FAST, it is for blunt trauma, abdomen, focus assessment, sonography, and trauma. It is a 4P evaluation. What are the 4P evaluation? It is your perihepatic. Then you have pericardial, your perisplenic, and the last one is going to be pelvic. So these are the 4 sites that you will evaluate in a blunt trauma abdomen to look for any free fluid. It is called as 4P evaluation. Then your E-FAST, it is an extended fast. Now in an extended fast, what are you going to add on to? Right? So here I am going to add the right hemithorax with the assessment of left hemithorax. With the assessment of left hemithorax with all the 4 quadrants of abdomen, that is the right upper abdomen, right lower abdomen, left upper abdomen, and the left lower abdomen. So all the 6 site assessment is what we call it as an E-FAST, that is your extended fast. What is the minimum fluid required for a fast to be positive? It has to be a minimum of 100 cc. Less than that, the sensitivity of the fast is considered to be poor. Now, what are you going to achieve if you do an ultrasound of the thorax to look in terms of trauma? You will get pneumothorax, right? What are the signs in the pneumothorax, right? So USG findings. USG findings of pneumothorax. Now, USG findings of the pneumothorax. Number one, there will be absence of seashore sign. Absence of seashore sign. It is not presence, it is absence of seashore sign. I'll explain you in a bit. Then you have a barcode sign. You have a barcode sign, and also called as the stratosphere sign. Also called as the stratosphere sign. So there's an absence of seashore sign, there's a barcode sign, as well as the stratosphere sign. Now, what do you mean by this? If you look at this particular ultrasound that I've given, in a normal lung, you can see this is the pleural border that you can see. So every time you see, during inspiration, if this is the chest wall, this is the pleura. During inspiration, you will notice that the pleura will move closer to the chest wall, expiration it moves away. So the pleural movement will occur with every inspiration and expiration. Now this pleural movement can be detected on ultrasound. It looks like the wave of, like a seashore, no? The wave comes and goes back. The waves come and they goes back. That is called as a positive seashore sign. A positive or a presence of seashore sign is normal. In a pneumothorax, what is going to happen? In a pneumothorax, as the lung is getting compressed by air, there is no movement with inspiration and expiration. When there is no movement, there is the pleura is not coming and not going away from the chest wall. So pleura remains consistent, it remains compressed, there is no movement, and that absence of movement will cause absence of your waves, and that absence of waves is called as absent seashore sign. This is called as an absent seashore sign. Right, so absence of a seashore sign, it looks like a barcode, or it also called as a stratosphere sign. This is also called as a stratosphere sign. Okay? So I hope you understood the basic concept behind the ultrasound of the pneumothorax. Any questions up until now? Quick feedback. I know you're tired. I know we started in the morning 11. You have gone through multiple sessions. I acknowledge that, and I'm really proud of everybody who is now listening to this. But I want you to be absolutely attentive, give you 100%. If you have any questions, if you feel something is not there, you can put across here. ठीक है? अगर बीच में थोड़ा बहुत मोटिवेशन चाहिए, अगर कुछ लैक कर रहा है, लिख देना सर मोटिवेशन, वो भी बता देंगे, कोई टेंशन नहीं है. ठीक है? तो रात को वैसे भी क्या ही है, पूरी रात पड़ी है यार. If you feel I'm speaking a bit fast, अगर लग रहा है कि कुछ ज़्यादा ही फास्ट बोल रहा हूँ, थोड़ा बीच में रोक देना, थोड़ी हम गति कम कर लेंगे, कोई टेंशन नहीं है. बट नीमोथोरैक्स का जो मैनेजमेंट है ना, नाउ समबडी इज आस्क्ड व्हाट इज द मैनेजमेंट ऑफ द नीमोथोरैक्स. देखो, मैनेजमेंट ऑफ नीमोथोरैक्स इज क्वाइट सिंपल. तो नीमोथोरैक्स में आपने ये देखना है कि सर आप ओपन एड्रेस कर रहे हैं कि क्लोज एड्रेस कर रहे हैं. बट आइदर वेज, the only thing that varies in open and a tension pneumothorax, it is about the patching of the chest wound. Okay? So in a pneumothorax, if you are talking about in terms of emergency, so emergency management of pneumothorax, if it is an adult, if it is a child, ठीक है, adult और child दोनों में आप needle thoracocentesis करोगे. तो यहाँ पे नीडल कहाँ डालोगे? सो इन एमरजेंसी आई एम गोइंग टू डू अ नीडल थोरैकोसेंटेसिस. तो एडल्ट में आई एम गोइंग टू पुट इन द फिफ्थ इंटरकॉस्टल स्पेस ऑफ द मिड एक्सिलरी लाइन. इन द चाइल्ड आई एम गोइंग टू पुट इन द सेकंड इंटरकॉस्टल स्पेस ऑफ द मिड क्लाविकुलर लाइन. ऑन द अदर हैंड, चाहे बच्चा हो या एडल्ट हो, इफ दे आस्क यू व्हाट इज द डेफिनेटिव लाइन ऑफ मैनेजमेंट, द डेफिनेटिव लाइन ऑफ मैनेजमेंट इज गोइंग टू बी एन आईसीडी इंसर्शन. फिर बोल देगा कि आईसीडी इंसर्शन अडल्ट में कौन से साइज का करोगे, चाइल्ड में कौन से साइज का करोगे. इन एन अडल्ट द आईसीडी दैट इज प्रेफर्ड इज गोइंग टू बी अ 28 French ICD. It is going to be a 28 French ICD. And a child, I am going to put a 18 French ICD. In a child, it is going to be an 18 French ICD. फिर पूछ लेंगे कि ICD कहाँ डालोगे. ICD डालने की जगह है, उसको बोलते हैं safety triangle. Right? What are the boundaries of the safety triangle that you have? When you look at the boundaries of the safety triangle, there's an anterior boundary, there is a posterior boundary, there is an inferior boundary. Right? This is anterior, this is posterior, this is inferior. Anterior, it is by your pectoralis major muscle. Anterior, it is by pectoralis major muscle. Inferiorly, it is formed by the sixth rib. posteriorly it is formed by latissimus dorsi muscle. It is going to be your latissimus dorsi muscle. So this is your safety triangle, or safety triangle in the fifth intercostal space. This is where we are going to put our ICD. So the ICD is going to be in the fifth intercostal space, and this is where you have right. So ICD placement चाहे बच्चा हो child हो, in दोनों में it is the fifth intercostal space. ठीक है? So in a nutshell, this is how the pneumothorax is going to be managed. Right. So let's talk about just written as splenic trauma, but we have covered most of the points which are there. ठीक है? What is the most common organ injury in abdominal trauma? Let's say quick feedback. जल्दी बताओ. What is the most common organ injury in abdominal trauma? Most common organ injury in abdominal trauma क्या है? The most common organ injury in abdominal trauma, it is liver, not spleen. तो गलती नहीं करनी है. मैं नहीं. That's what I'm asking you. But needle decompression किया तो है. This is an emergency. You have done needle. This is your thoracocentesis. No. Emergency में आपने क्या किया है? You have done a needle thoracocentesis. No. We have done needle thoracocentesis. ठीक है? चलो. So the most common organ injury, yes, all my guys who are saying liver, you are absolutely spot on. Spleen is a wrong answer. I'm not specified as blunt or penetrating trauma, but if I specify that I'm talking about blunt trauma, फिर आप सीना ठोक के बोलो कि सर आंसर स्प्लीन है. ठीक है? ब्लंट ट्रॉमा में स्प्लीन है. फिर अगर आपसे बोलेंगे पेनिट्रेटिंग ट्रॉमा में क्या है, पेनिट्रेटिंग ट्रॉमा में फिर आंसर विल अगेन बिकम लिवर. सीट बेल्ट में क्या है? इट इज द मेसेंटेरिक टेयर. एंड इफ द मोस्ट कॉमन abdominal organ injury in a blast injury, it is going to be your bowel, and that is your small intestine. See, overall most common organ injury in blast is going to be tympanic membrane. Most severe is going to be lungs. Abdomen, it is going to be your small intestine. Why liver? Why not spleen? When you talk about abdominal trauma, I've included both blunt as well as penetrating injuries. So when you look at the whole spectrum of blunt and penetrating, together it is liver. Blunt trauma alone, it is spleen. Penetrating, again, it is more liver when compared to spleen. ठीक है? Clear? Clear? Sure. Harsh, I don't understand. What is EAC? आप क्या पूछना चाह रहे हो? I didn't get it. ठीक है? Reframe your question. Now, grades of splenic injury is been our previous exam question. So quickly talking about it. So splenic injuries, when you talk about the splenic hematoma, you need to understand that when you talk about the splenic hematoma, now if you take this as the representation of the spleen, and this is the capsule of the spleen, so there are two forms of hematomas that are going to occur. One which is going to occur between the capsule of the spleen and the splenic parenchyma, and one that arises within the parenchyma of the spleen. So which is present outside, this is what we call it as the subcapsular hematoma. This is your subcapsular hematoma. And one that is present inside the spleen, it is your intraparenchymal hemorrhage. This is your intraparenchymal hemorrhage. So you have the subcapsular hematoma and the intraparenchymal hemorrhage. ठीक है? चलो. Out of these two, obviously subcapsular is of lesser severity, intraparenchymal will have more severity. So whatever we talk about, these hematomas will be of subcapsular nature. Okay? So all these hematomas which we are going to talk, it is going to be subcapsular. So in grade 1, it will be occupying less than 10% of the total surface area. It will occupy less than 10% of total surface area, and this is going to be a subcapsular hematoma. So all the hematomas that we're going to talk here is going to be subcapsular, and the laceration depth is going to be less than 1 centimeter. In grade 2, it is anywhere between 10 to 50% of the total surface area, and the depth of the laceration is going to be 1 to 3 centimeters. If the surface area involved is more than 50%, and if the depth is more than 3 centimeters, it will become grade 3. Right. So what is grade 4? Grade 4 is going to be an intraparenchymal hemorrhage. There will be this intraparenchymal hemorrhage. It will be associated intraparenchymal hemorrhage where more than 25% of spleen is devascularized. More than 25% of the spleen is going to be devascularized. Grade 5, it is completely shattered spleen. It is completely shattered spleen. So here the spleen is broken down into small pieces. It's a completely shattered spleen, that is grade 5, right? So how do you manage the splenic injuries? Grade 1, grade 2 are minor injuries. So here it is only going to be conservative management. Now grade 4, grade 5, they are usually hemodynamically unstable. So here you will take the patient for emergency splenectomy. Here we'll take the patient for emergency splenectomy. We'll take the patient for emergency splenectomy. Now the tricky part is to how do you manage your grade 3. Now in grade 3, initially we'll start the patient on conservative management, right? So grade 3's management purely depends upon whether the patient is going to be stable or unstable. Let's say I'll split them into two components where the patient is stable and another one is unstable. Let's say the patient here is going to be stable, here it is unstable. If the patient is unstable, I'll take the patient for surgery, but this time I'll try to preserve the spleen, and here it is going to be your splenography. Here it is going to be splenography. Right. Now the splenography is your spleen preserving surgery, but if the patient is stable, I will take the patient for conservative management. Now in a conservative management, I'll do what you have done for grade 1, grade 2, but after 24 hours, I will do reassessment. In this reassessment, normally we can go ahead with another CT or an ultrasound abdomen, and in a reassessment, if we say there is increase in grade of injury, if there is increase in grade of injury, then you can attempt the angioembolization to see whichever vessel is bleeding to stop it. If it fails, if the angioembolization fails, eventually you'll take the patient for surgery, and that surgery is going to be splenography, right? So initially you start the patient on conservative management. If the patient is fine, it is fine. If after 24 hours of reassessment, if there's increase in the grade of injury, I will attempt a CT angio, that is angioembolization of the vessel from where it is bleeding. If it fails to stop the grade of bleeding, then I'll go with splenography, that is a spleen preserving surgery. As rightly said, this is your char chand or panch sitare wala question. Okay? So this protocol is important. Clear hai? ठीक है? इसे clearly I cannot put forward, but I try to put in a very packaged manner so that you can have everything at a one go. सही है? Correct? चलो आगे चलते हैं. So when we all know that spleen protects us from a capsulated organism. So post-splenectomy vaccinations are very, very, very important. So when you talk about the splenectomy vaccination, so we have the splenectomy vaccination when you undergo an elective splenectomy. When we take the patient for elective splenectomy. On the other hand, when we take the patient for emergency splenectomy. So when we take the elective splenectomy and when we have an emergency splenectomy. Right. In an elective splenectomy, the vaccination should be done minimum 2 weeks prior to surgery. It should be done 2 weeks prior to surgery. Now, what are the vaccinations that you will take? Number one, you will take pneumococcal. We'll take meningococcal. And then we'll take H influenza B. So these are the vaccinations which are done or taken for elective splenectomy 2 weeks prior to surgery. But in an emergency splenectomy, we do not have time, no, because the patient has landed to us in emergency. So which vaccine will be given immediate post-op? Which of the following should be given immediate post-op? And which of the following has to be given within 2 weeks period of time? Within 2 weeks from surgery. So the immediate one that you have to administer is going to be pneumococcal. That is a pneumococcal vaccine. And within 2 weeks of surgery, you can go with meningococcal. Go with meningococcal and H influenza B. And the H influenza B. Right? So this is both for elective as well as emergency splenectomies. Do not forget this, क्योंकि हमारा जो exam question है वो emergency splenectomy से है. Right? This is from the emergency splenectomy. Sorted? Clear? Fine. Chalo, great. So this concludes your discussion on trauma as well. So far, any questions, quick feedback, कोई सवाल, कोई शक, anything that you want to ask, quick feedback? Anything that you want to ask? So do we give all these vaccines together? Yes, you can give all these vaccines together. मतलब ये इसका ये मतलब नहीं है कि आप एक ही बार दे दोगे. You will give each vaccination on the same day. Because spleen protects us from all these organisms. No, spleen protects us from capsulated organism. You take the spleen out, we do not have a natural protection against these organisms, so you have to give all these vaccinations. In fact, you have to keep providing them with booster doses also. ठीक है? Chalo, can we move on? Now, going into our GIT wala section, प्यार भरा वाला section. So, पहला will be dysphagia. That is difficulty in swallowing. तो dysphagia पे इतने सवाल आते हैं कि यार dysphagia से ये हो गया, dysphagia से वो हो गया, इसका ये presenting symptom, उसका वो presenting symptom है, diagnosis कैसे बनाएंगे? आपके लिए मेरे पास एक small algorithm है. If a patient presents to you with dysphagia, we'll see whether dysphagia is for solids and liquids or is it for solids alone. If it is for both solids and liquids, we'll see whether it is a progressive dysphagia or a non-progressive dysphagia. So सवाल कुछ ऐसा आएगा. They will say a patient is having dysphagia for both solids and liquids. It is progressive in nature, and in this the presenting symptom, the patient presents to you with heartburn as a presenting symptom. Another patient presents to you with pulmonary symptoms. Another patient presents to you with pulmonary symptom. Another patient presents to you pulmonary symptom, that is cough, distress, dyspnea, pneumonia-like features, all these. Okay? Okay. Now, based upon this, what is your diagnosis? If your patient is having dysphagia for both solids and liquids, progressive in nature, presenting feature is of heartburn, then the diagnosis here is progressive systemic sclerosis. It is progressive systemic sclerosis. It is a progressive systemic sclerosis. If it is having pulmonary symptoms, then the answer is going to be achalasia cardia. The answer is going to be achalasia cardia. One important pickup point in achalasia cardia, here you will see dysphagia will be more for liquids when compared to solids. Here the dysphagia will be more for liquids when compared to solids. Okay? Clear? Beta, in esophageal cancer, dysphagia is initially for solids alone. It is not for liquids. And the presenting symptom there is going to be weight loss. It is not going to be heartburn or pulmonary symptom. If a patient is having for dysphagia for both solids and liquids, but this time it is non-progressive in nature, and this, I would say, the presenting symptom here is going to be severe chest pain. It is going to be severe chest pain. Then your diagnosis is going to be diffuse esophageal spasm. Then the answer to this question is going to be diffuse esophageal spasm, which is also commonly called as esophageal angina, right? So dysphagia for both solids and liquids, non-progressive in nature, presenting with severe chest pain, the answer is going to be diffuse esophageal spasm. Coming back to dysphagia only for solids, and here the patient has progressive symptoms. In a progressive, if the patient presents to you with these two symptoms, if it is weight loss, presenting symptom is weight loss, then the answer is esophageal carcinoma. On the other hand, dysphagia only for solids, progressive in nature, and presenting symptom is of heartburn, then the answer is going to be peptic stricture. It is stricture due to GRD, and that is what is peptic stricture. Okay. On the other hand, if you have a patient dysphagia only for solids and it is non-progressive in nature, no matter whatever is the presenting symptom, it is usually associated with a condition called as Schatzki's ring, also called as the lower esophageal ring. Also called as a lower esophageal ring. Now, this lower esophageal ring is also commonly called as Schatzki's ring. Can anybody tell me from where do you have this Schatzki's ring? What is the reason? I'll just mention it across. So this lower esophageal ring is also commonly what we call it as the Schatzki's ring. Now, Schatzki's ring is a mucosal synechia. It's a mucosal fusion which is going to cause as a web, and this mucosal synechias are usually secondary to GERD. It is usually secondary to the GRD. Yes, it is seen in the lower part of the esophagus. The upper esophageal web is what we see in Plummer-Vinson syndrome. Okay? So needless to tell you, Plummer-Vinson syndrome will have an upper esophageal web. Schatzki's ring, which is secondary to a GRD, will obviously GRD की वजह से होगा तो नीचे ही होगा ना यार साइनिक है. So hence it is going to be a lower esophageal web. ठीक है? चलो. So this is with respect to dysphagia. So अब dysphagia पे सवाल गलत नहीं करना है. Presence of dysphagia, where you have for both solids and liquids, progressive in nature, presenting feature is heartburn, the answer is progressive systemic sclerosis. Same thing if it is going to have pulmonary symptoms, dysphagia more for liquids when compared to solids, it is going to be eclampsia cardiac. Dysphagia for both solids and liquids, non-progressive, equal for both solids and liquids, the answer is going to, with presence of severe chest pain, the answer is going to diffuse esophageal spasm. Dysphagia only for solids, progressive in nature, presents to you with weight loss, the answer is esophageal cancer. If it is associated heartburn, the answer is peptic stricture. Dysphagia only for solids, non-progressive in nature, no matter whatever the symptom is, the answer is going to be lower esophageal ring. That is going to be your Schatzki's ring. Clear hai? ठीक है? Sorted? थोड़ा स्लो. ठीक है, कोई नहीं. चलो. Now you have the spotters. The first spotter is something like this. ठीक है? So what are you able to spot here? I am able to spot there is coiling of nasogastric tube in upper esophagus. So you can see here, there's a nice coiling of the nasogastric tube. There's a coiling of the nasogastric tube in the upper esophagus. Okay? Yes, this coiling of the nasogastric tube. So question कुछ ऐसा आएगा. Patient will be of day 0 and day 1 of life. Patient will present to you with repeated regurgitation. Patient will have repeated regurgitation of all feeds. And there will be continuous drooling of saliva. There will be continuous drooling of saliva, right? So day 0, day 1 of life, repeated regurgitation of all feeds, continuous drooling of saliva, and when you put a nasogastric tube on an X-ray, you will see coiling of nasogastric tube. All these goes in favor and it screams out only one diagnosis. This is a condition of tracheoesophageal fistula. Now, if they ask you a question, what is the most common type of the tracheoesophageal fistula? The most common type is going to be the type C variety, where you have upper esophageal atresia with lower tracheoesophageal fistula. Okay. Now, when you say what is the investigation of choice, the investigation of choice is going to be the contrast imaging of the esophagus. In the contrast imaging, remember the safest contrast that you will take is going to be 𝐒𝐿. It is going to be 𝐒𝐿. Right? So management, it is to rechannelize. It is to rechannelize. That is going to be to do you have to divide the fistula, do a primary anastomosis over a nasogastric tube. But if it is a long distance atresia, for a long distance atresia, that means more than 2 vertebral distance, then you have to wait for 6 months, do a feeding jejunostomy for this 6 months. And after 6 months, if you are able to do a primary anastomosis, good. If not, you have to go with the conduit surgery. You have to go ahead with the conduit surgery, that is the interposition surgery. In an interposition surgery, they can ask you that if it is in children, the ideal interposition for all of them is going to be colon, but most commonly done is going to be jejunum in children. In adults, it is going to be stomach. That's all. So the first spotter that you had is of tracheoesophageal fistula. So I hope you understood the concept of discussing the image here. We'll do a radiograph, we'll do a spotter, we'll do all the important findings, do the investigation as well as management. So the topic finishes. Sorted. Chalo. The next one that you can see here, this is a contrast imaging that you have. In the contrast imaging, I would like to draw your attention to this particular site. You can see at this particular site, there is narrowing, and this is the cervical vertebra. So this is involving the esophagus, which is in the cervical vertebra. So this is an upper esophagus. Now this narrowing is like a web. So it is an upper esophageal web. So this is a diagnosis that you are going to talk about, is going to be your upper esophageal web. Now, where do you see this upper esophageal web? The upper esophageal web is seen in a condition that is what we call it as the Plummer-Vinson syndrome. You will see in Plummer-Vinson syndrome, which is also called as the Patterson-Kelly syndrome. Also called as the Patterson-Kelly syndrome. So what are the components that you have? They have iron deficiency anemia, which is also called as sideropenic anemia. Iron deficiency anemia, it is associated with atrophic glossitis. It is associated with atrophic glossitis. There is iron deficiency anemia. There is atrophic glossitis. There is upper esophageal web. There is this upper esophageal web associated with 𝐒𝐿𝐿. This 𝐒𝐿𝐿. As well as visceromegaly. All these are the findings of your Plummer-Vinson syndrome, also called as the Patterson-Kelly syndrome. Okay, that's your second spotter. Then you see the third spotter, same thing, but you can see again there is this bilateral narrowing. This is there. This is the classical presentation of a web, but this time it is present in the lower esophageal context. So this is what we call it as the lower esophageal web. Now this lower esophageal web, it is a diagnosis that is telling you that it's a Schatzki's ring. We have just spoken about the Schatzki's ring. When you talk about the Schatzki's ring, the Schatzki's ring is basically secondary to GRD. It is secondary to GRD, and this is due to mucosal synechiae. It is because of mucosal synechiae. There's going to be fused mucosal components which are going to be present as Schatzki's ring. Now, obviously, Schatzki's ring will also present to you with dysphagia. We have just learned that it is going to present to you with dysphagia only for solids. Dysphagia only for solids, and this is going to be non-progressive in nature. It is going to be non-progressive in nature. GERD में क्या होता है कि repeated times there is an acid reflux. So every time the acid reflux from the stomach into the esophagus, it irritates or it causes erosion of the esophageal mucosa. Now, esophagus mucosal surfaces are now eroded or injured due to acid, so they undergo inflammation. When two inflamed surfaces come in contact, they will create these, mucosal sticking, and that is what we call it as Seinecke. And these Seinekes will present to you like these webs, right? This is your Schatzki's ring. So Schatzki's ring is because of this two inflamed surfaces which are occurred due to GERD, and they result in mucosal Seinecke, and those Seinekes will cause dysphagia. Okay? So GERD is the culprit here. Clear? Chala. Moving to the next one. Now this is again a barium swallow image that you have. So the image that I've given you is of barium swallow. So if I give you the objective, this is 50 to 60-year-old patient. It is more commonly seen in males when compared to females. The presenting feature will be of dysphagia. Here when you talk about dysphagia, this dysphagia initially, it is initially only for solids. It is going to be a progressive dysphagia, and in a later stage, you will see dysphagia for both, but always supersede solids will be more when compared to liquids. They will also be associated with significant weight loss. They'll be associated with significant weight loss, right? Now, when you look at this, the barium swallow image that you can see here, this is what we call it as. It's like an apple. Somebody ate the apple and left the core behind, and this is what we call it as the apple core sign. This is what we call it as an apple core sign, and this apple core sign is consistent with that of esophageal cancer. It is going to be an esophageal cancer. The investigation of choice for the esophageal cancer is going to be an upper GI endoscopy with biopsy. But if I say the investigation of choice for the T staging, that is your endo ultrasound. Investigation of choice for staging overall. For staging overall, it is going to be the PET CT. It is going to be the PET CT, right? So these are the important points with respect to esophageal cancer. If they ask you, can you name the surgeries that you do in the esophageal cancer? There are 3 surgeries. So barium swallow, it is your apple core sign. When it comes to surgeries, remember the 3 important names. You have the Ivor Lewis, you have McKeown, and Oringers. Oringers is now considered the most common. It is a transhiatal esophagectomy that is done, right? Chalo. So this is with respect to barium swallow. Now the next spotter that you have, again you can see there is something out pouching on this surface. Now you can see this is your cervical vertebra. So as I can see the cervical vertebra, I know that it is the cervical esophagus. This is the anterior surface, this is the posterior surface, and I see this pouching is there on the posterior surface. But अब margins भी बता देंगे, margins के लिए पूरा एक slide रखा हुआ है, कोई tension लेने की ज़रूरत नहीं है, ठीक है? Now it is a posterior surface outpouching in the cervical esophagus, and this is a classical case of your Zenker's diverticulum. This is a classical case of your Zenker's diverticulum. So the Zenker's diverticulum, you need to tell me whether it is a true or a false diverticulum. Remember, Zenker's is an example of a false diverticulum. It is an example of a false diverticulum. Second, is it a pulsion or a tractional diverticulum? It is a pushing diverticulum, so it is a pulsion diverticulum. It is a pulsion diverticulum, right? So when you look at the diverticulum, you will see it is going to arise from an anatomical weekends. That is what we call it as the Killian's triangle. Now, where do you find this Killian's triangle? It is quite interesting. So when you look at this, this is the hyoid bone that you have. This happens to be the thyroid cartilage that you have. Below this, you have the cricoid cartilage, and then you have the trachea that is present here. Then you have the trachea that is going across here. So this is how the arrangement is, right? And then you see in between these two, you have the hyothyroid membrane that is there. This is your thyrocricoid membrane that is there, right? Now, behind this, you have the esophagus. So this is how the esophagus is going to run, right? So this is the esophagus, and this is the musculature of the esophagus. So this is how the esophagus is running on the posterior surface of the airway. So this is the esophagus that you have, right? Now there are two muscles which are going to be present. One is your thyropharyngeus and another is cricopharyngeus. You see the thyropharyngeus muscle is going to be arching like this. This is the thyropharyngeus muscle which is anchoring onto the esophagus, and cricopharyngeus, this is your thyropharyngeus muscle. So the orientation of the thyropharyngeus muscle is going to be in an oblique manner. So this is your thyropharyngeus muscle which is running in this particular fashion. This is your thyropharyngeus muscle, and this is your cricopharyngeus muscle. Now between these two muscles, if you look at this, this is how the muscle is completely covering the esophagus, right? So thyropharyngeus muscle fibers, the thyropharyngeus muscle fibers are arching. The thyropharyngeus muscle fibers, they are arching around the esophagus, and this is your cricopharyngeus, right? So this is how the fibers are running, right? Between these two, you see there's this triangular area which is not covered by any muscle fiber, and this triangular area, it is what we call it as the Killian's triangle. Now the concept is quite simple. When you see this thyropharyngeus and the cricopharyngeus muscles are going to contract, right? So this is your thyropharyngeus, this happens to be your cricopharyngeus, and this is the orientation of the muscle. So when you look at the orientation of the muscle fibers, this is how the muscle fibers are running. So oblique is your thyropharyngeus, transverse is my cricopharyngeus. In between these two, you have this triangular area. This is called as Killian's triangle. And whenever there's an excessive force, imagine if these two muscles contract at the same time. If they contract at the same time, this will cause an outpouching. It is the same thing. No, the balloon, you press it, it outpouches. And this outpouching that is going to be created from here. This outpouching that is going to be created from here is what we call it as the Zenker's diverticulum. This is what we call it as the Zenker's diverticulum. So it's a false diverticulum, pulsion arising from the Killian's triangle. So this is going to be left, usually it is left-sided. It is your left-sided posterior cervical diverticulum. Right? When you talk about Zenker's diverticulum, the investigation of choice is going to be your barium swallow. You can see a pouch-filled barium. There will be a pouch-filled barium. There will be this pouch-filled barium. Management depends upon the mouth. If it is less than 3 centimeters, then it is going to be diverticulectomy with anastomosis, with primary anastomosis or primary repair. If it is more than 3 centimeters, then you do an endoscopic Dolman surgery. Then you can perform an endoscopic Dolman's surgery. You can perform an endoscopic Dolman's surgery. Okay? So this is with respect to that of But diverticulopexy is done for the mid-esophageal diverticulum. That is your para-esophageal the paratracheal diverticulum that you have, the para-esophageal diverticulums, or you can call it as the pretracheal diverticulum. That is that. So mid-esophageal diverticulum, you can do a diverticulopexy. Otherwise, you have to do a diverticulectomy with primary repair. If it is less than 3, more than 3 centimeters, you can go ahead with endoscopic Dolman surgery. We're going to do an endoscopic Dolman surgery. Okay? Clear? Right? I hope no problem at all. Chalo. Moving another question that you have. So this is a newborn baby. So this is the X-ray of day 0, day 1 of life. Now this baby is born with respiratory distress. This baby is born with respiratory distress. Along with respiratory distress, this is the X-ray finding that you have. Now in the X-ray finding, you can see the heart is deviated to the other side. So there is presence of dextrocardia. This presence of dextrocardia. There is a massive air bubble in the thoracic cavity. So this is your massive air bubble in left hemithorax. So can you tell me a condition where a baby who is a newborn is presented to you with respiratory distress? There's a massive air bubble in the thoracic cavity and there is a heart shifted onto the other side as dextrocardia. Absolutely correct. So this is the diagnosis of your congenital diaphragmatic hernia. That is your Bosch-Dallek hernia. It's a Bosch-Dallek hernia. In the Bosch-Dallek hernia, patient will have respiratory distress, presence of dextrocardia. Along with dextrocardia, the baby is going to have a scaphoid abdomen. The baby is going to have scaphoid abdomen, and this is what we call it as the triad of the Bosch-Dallek hernia. This is the triad of the Bosch-Dallek hernia, right? So the most important thing in a Bosch-Dallek hernia is to know where is the defect. It is the left-sided. It is going to be left-sided posterolateral defect. The most common organ to herniate. The most common organ to herniate. In a Bosch-Dallek hernia, it is going to be stomach. The most common organ to herniate, it is going to be stomach, right? Beta, this video will remain as long as you want it to remain. Okay? I know you're tired. I know you're exhausted. I know it is difficult for you to sustain. If you feel it is becoming too much, you can come back and review tomorrow. But if you have a little bit of energy, you think you can push yourself, stay with me. Okay? If not, you can watch it tomorrow also. Okay? Chalo. So the most common organ to herniate, it is going to be stomach, right? So defect is left-sided posterolateral defect. The most common organ to herniate, it is going to be stomach. Remember, it is associated with left-sided pulmonary hypoplasia. It is a left-sided pulmonary hypoplasia, and the investigation of choice for the Bosch-Dallek hernia is going to be the CT, right? Management, it is to bring back the content and repair the defect. Bring back the content and repair defect. Now, one of the important things that you need to understand in a Bosch-Dallek hernia, that the bag and mask ventilation is contraindicated. The bag and the mask ventilation is contraindicated. Clear? So this is with respect to your Bosch-Dallek hernia, that is a congenital diaphragmatic hernia. Okay? Now, this is an upper GI endoscopic image. Here you can see presence of red velvety mucosa. Here you are able to see a red velvety mucosa. presence of red velvety mucosa, it is seen in Barrett's esophagus. It is seen in Barrett's esophagus. Now, when you look at the pathophysiology of the Barrett's esophagus, if I say the cause for the Barrett's esophagus, it is long-standing. It is a long-standing untreated GERD. It is because of a long-standing. It is because of long-standing untreated GERD, right? It is a long-standing untreated GERD. Now, when you look at the Barrett's esophagus, it is due to intestinal type of metaplasia. It is due to an intestinal type of metaplasia. So when I say there's an intestinal type of metaplasia, in an intestinal type of metaplasia, you will notice that the squamous epithelium is converted into the columnar epithelium. But along with columnar cells, they will also have presence of goblet cells. Now, the goblet cells are the characteristic feature of intestinal mucosa. So hence it is called as the intestinal type of metaplasia. Goblet cells secrete mucin. Now, what do goblet cells secrete? They secrete mucin, and this mucin secretion in esophagus. They secrete mucin, and this mucin secretion in esophagus predisposes to malignancy. So Barrett's esophagus increases the risk for not squamous. It is the adenocarcinoma of esophagus. It is the adenocarcinoma of the esophagus. When you say what is the investigational choice for Barrett's, it is your upper GI endoscopy with biopsy to rule out malignancy. And the management for Barrett's. Remember, Barrett's is not a disease. It is a presentation of an underlying disease, that is GERD. So management will always be to treat GERD. The management will always be to treat GERD. Clear? So these are with respect to the radiographs and the images that you should know. So far, any questions? So we have covered almost all the important topics in the esophagus. कुछ और topic अगर आपको लग रहा है फटाफट बोलो. Clear? चलो जी. So when you talk about the hiatal hernias, in the hiatal hernia, we have the sliding hiatal hernia. We have the rolling hiatal hernia. And then you have the mixed one. It's a combination of both sliding as well as rolling hiatal hernia. Okay? Now, what is a sliding hiatal hernia? What is a rolling hiatal hernia is? You see, this happens to be the esophagus. It is in continuity with the stomach. You notice this happens to be the diaphragm, and under this you have the gastroesophageal junction. So this is, let's say, the normal gastroesophageal junction. We expect the normal gastroesophageal junction to be below the level of diaphragm. Okay? Now, in a sliding hiatal hernia, you will notice, due to XYZ reason, this G junction, that is a gastroesophageal junction, which was supposed to be above the level of diaphragm, is now below the level of diaphragm, is now gone above the level of diaphragm, and it now pierces back, and then it goes across here. And you see, this is where the diaphragm is attached. So your old G junction has migrated up, right? So the gastroesophageal junction, which was supposed to be below the level of diaphragm, has migrated above the level of diaphragm, and this migration is what we call it as the sliding hiatal hernia. So the cranial migration of the G junction is what we call it as sliding hiatal hernia. In a rolling hiatal hernia, because of the weakness that is present at the diaphragm, you'll see a part of the stomach is going to invaginate into the thoracic cavity. And the part of the stomach invaginates into the thoracic cavity. Now this is what we call it as the rolling hiatal hernia. So in the rolling hiatal hernia, a part of the stomach migrates into the thoracic cavity because of the weakening at the hiatus itself. This is what we call as rolling hiatal hernia. A mixed hiatal hernia is a combination of both sliding as well as rolling hiatal hernia. ठीक है. So this is the basic difference between these three. Sliding is usually because of GRD, rolling is because of weakness. It's a combination of both that you'll see, sliding as well as rolling per se. Now, in the rolling hiatal hernia, especially on the part of the stomach that is invaginated, it forms an ulceration. And this ulcer that forms on a rolling hiatal hernia, it is what we call it as the Cameroon's ulcer. This is what we call it as Cameroon's ulcer. Remember, the investigation of choice is going to be a contrast imaging, not CT. It is going to be an upper contrast. That is going to be the investigation of choice. Okay? Clear? बेटा हर्निया भी बता देंगे, कोई टेंशन नहीं है. ये तो अभी ईसोफेगस ही खत्म किया है, इसके बाद स्टमक है, उसके बाद बाकी इंटेस्टाइन्स हैं. अरे जर्नी लंबी है भाई. Yeah, so don't worry, we will take it as it comes. अगर आज नहीं खत्म होता है 12 बजे तक, कोई टेंशन नहीं है, कल फिर वापस 2 घंटा लेंगे, लेकिन कंप्लीट करेंगे. ठीक है. सो डोंट वरी अबाउट इट. क्लियर है? चलो. नाउ दिस इज अगेन अपना 4 चांद 5 सितारा वाला क्वेश्चन. ठीक है. Now, we have a neonatal vomiting. We'll see the age of presentation, type of vomitus, and then we'll make our diagnosis. Now, if the age of presentation is 4th week, and here the patient presents to you with a non-bilious vomiting. If it is going to be a non-bilious vomiting, it is going to be a non-bilious vomiting, and it is usually a projectile vomiting. It will be a projectile vomiting, and on the image you can see a massive bubble that is present, and this is what we call it as the single bubble sign. This is what we call it as the single bubble sign. Right? So I have a baby who is 4 weeks old presented to us. Okay. Now you have a patient, okay, a 4-week-old baby presented to you with a non-bilious vomiting, projectile in nature, on X-ray, a single bubble sign. What is your diagnosis? My diagnosis is going to be congenital hypertrophic pyloric stenosis. So this is your CHPS. The CHPS वाला baby 3rd to 6 weeks के बीच में present होता है. Usually most common is going to be the 4th week of presentation. But if I say what is the investigation of choice, remember the investigation of choice for a CHPS baby is going to be an ultrasound. Ultrasound का criteria क्या है? The length of this, if it is more than or equal to 16 millimeters, and the width of the enlargement is more than or equal to 4 millimeters, it is your CHPS. That is hypertrophied circular muscles in your pyloric region that presents a gastric outlet obstruction. Okay? On a contrast imaging, if you do a contrast imaging, you will see a double track sign. You will see presence of a double track sign. What is the management? The surgery of choice is going to be your Ramsted's pyloromyotomy. It is going to be your Ramsted's pyloromyotomy. CHPS, IHPS same है यार. The congenital hypertrophic pyloric stenosis does not have a reason, so hence it is also called as idiopathic hypertrophic pyloric stenosis. एक ही चीज़ के दो अलग नाम हैं, confuse नहीं होना. चाहे आप CHPS बोलो, चाहे वो आप IHPS बोलो. C को I से replace कर लो, same बात है. IHPS या CHPS, it remains the same. ठीक है. Now, scenario number 2. I have a baby who is presented to me on day 0 of life or day 1 of life. Now day 0, day 1, here I have a baby this time presented to us with bilious vomiting. Day 0 से ही vomiting शुरू हो गया. Now this is going to be non-projectile. That means the thrust is not there. In a neonate, when I say projectile and non-projectile, projectile का मतलब है direct straight from the mouth. Non-projectile is leaking from the angle of the mouth. So day 0, day 1, bilious, you have a bilious vomiting, non-projectile in nature. When I did an X-ray, I found there is one bubble which is here, and there is another bubble which is right across here. So this is your gastric bubble, this is your duodenal bubble, and this is what we call it as the double bubble sign. This is what we call it as the double bubble sign. So can anybody give me the diagnosis here? What is the diagnosis here? Yes. So do not say only one diagnosis. इसके दो differential diagnosis बनते हैं. Here, yes, I would take you as duodenal atresia as the most probable diagnosis, but it is also seen in a condition called as annular pancreas. It is also seen in a condition called as the annular pancreas. Okay? Now, what is the investigation of choice for annular pancreas? Remember, the investigation of choice for duodenal atresia and annular pancreas is going to be the CCT abdomen to see the difference between these two. Management is going to be surgery, and the surgery of choice is going to be duodenoscopy. It is going to be duodenoscopy. It is going to be duodenoscopy, right? So this is with respect to day 0, day 1 of life. ठीक है? Dysphagia lusoria ना बोलो ना यार, क्या गंदी गंदी बातें कर रहे हो? Dysphagia lusoria is because of aberrant right subclavian artery which causes the compression of the esophagus on the upper part, that is cervical esophagus. ठीक है? और उसका और इसका vomiting का तो सवाल मतलब जमीन आसमान, वहाँ पे dysphagia मिलेगा यार. ऐसे गंदी गंदी बातें नहीं करना. Okay. Again, you have another scenario, day 0, day 1 of life. Here, baby is presented to us with bilious vomiting. Here also it is non-projectile in nature. Now when I did an X-ray, I found something like this. I found one bubble to be here. Another bubble, I found it to be here. There's one more bubble here. So I found 3 bubbles here. This is the gastric bubble, this is the duodenal bubble, and this is the jejunal air trapping. And this is what we call it as the triple bubble sign. This is what we call it as the triple bubble sign. And yes, as rightly said, this is a case of jejunal atresia. This is a case of jejunal atresia. Okay. So what is the management for jejunal atresia? Remember, the surgery of choice for jejunal atresia is going to be jejunostomy. Going to be jejunostomy. It is going to be jejunostomy. Okay. Sorted? Clear? Chalo. So we'll talk about the peptic ulcer disease. Okay. I hope so far no questions. Quick feedback. ठीक है. How is the जोश? ठीक है. Sustained हो, जिंदा हो, right? Okay. शानदार, जबरदस्त, जिंदाबाद. Absolutely. I like the, that zeal and the enthusiasm. The more you show me energy, उसका double मैं लगा के दूंगा. ठीक है. Investment दुगना ही मिलेगा. Tension नहीं लेना. अच्छा, before we go any further, देखो अभी एग्जाम हमारे पास हार्डली, इफ यू लुक एट द एंटायर कॉन्टेक्स्ट, हमारे पास 15 दिन बचते हैं. ठीक है. इन दीज 15 days यू हैव टू कवर 19 सब्जेक्ट्स. और ये जो 19 सब्जेक्ट्स हैं, यू हैव टू कवर इट इन अ वे दैट यू डोंट लीव आउट एनी पर्टिकुलर टॉपिक पर से. ठीक है. और एनी पर्टिकुलर सब्जेक्ट पर से. द बेस्ट वे टू डू योर रिविजन राइट नाउ is to revert back to your previous year topics and start doing questions on top. ठीक है. एग्जाम के दिन ना आपको, अगर आपके प्रीवियस ईयर के टॉपिक्स आपके स्ट्रांग हैं, बिकॉज दे आर यूजुअली अकाउंटिंग फॉर 60 to 70% ऑफ योर क्वेश्चन पेपर. तो जब आप 70% क्वेश्चन पेपर सॉल्व कर लेते हो एंड यू हैव दैट कॉन्फिडेंस, एंड क्योंकि इतना आपने मेहनत और पढ़ाई कर रखी है, इट विल कम बैक टू यू इंस्टेंटेनियसली. जब दिमाग हल्का फील करता है, कॉन्फिडेंट फील करता है, यू विल स्टार्ट गेटिंग ऑल दैट बैक. सो स्टार्ट स्ट्रेंथनिंग योर PYTs and your PYQs so that you have a strong grip. Apart from that, if we are giving you some topic which is considered to be important in the relevance of the exam, उसको एक बार रिवाइज जरूर कर लेना. एग्जाम के दिन एक बात याद रखना कि जिस दिन एग्जाम है उस दिन मॉर्निंग यू हैव टू बी कॉन्फिडेंट, अपने आप पे भरोसा रखना, बोलना है कि आज का एग्जाम इट्स लाइक अ जनरल, इट्स लाइक अ ग्रैंड टेस्ट. मैं जाऊंगा, आराम से दूंगा और कोई टेंशन नहीं है. during your exam make sure that you complete your questions in time. तो slotting का जो period है उसी के अंदर कर लेना है, ठीक है, उसके बिना ज़्यादा ऊंच नीच नहीं करनी है. अगर कोई क्वेश्चन आपको लग रहा है कि बहुत लेंदी है एंड यू आर नॉट कॉन्फिडेंट, स्किप इमीडिएटली, गो टू द नेक्स्ट क्वेश्चन, ठीक है. एक क्वेश्चन पे ज़्यादा टाइम स्पेंड करने का नहीं बनता है, स्पेशली इफ इट इज़ इन द वेरी बिगनिंग. इमेजिन करिए क्वेश्चन नंबर 1 खोला, इतना बड़ा क्वेश्चन है, उसके 4 ऑप्शंस है, आपको लगा अभी तो मेरा दिमाग फ्रेश है, मैं फोड़ लूंगा ना. दैट क्वेश्चन विल रिक्वायर मोर टाइम एंड अटेंशन. हम ये देखेंगे कि आखिर में अगर टाइम स्लॉट में ये क्वेश्चन के लिए टाइम बनता है तो आ जाएंगे, ठीक है. तो विल गो टू सेकंड क्वेश्चन. व्हेन यू स्टार्ट डूइंग नो, अगर सेकंड क्वेश्चन आपको टफ लग रहा है, छोटा क्वेश्चन है, टफ है, नहीं समझ में आया, स्किप टू द थर्ड वन. कोई डिफिकल्टी नहीं अगर आप 5-10 क्वेश्चन भी स्किप कर ले तो, लेकिन मेक श्योर यू गेट दैट स्वीट स्पॉट जहां आपके क्वेश्चन टक 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 सही होने लगते हैं. एंड वंस यू डू दैट, नो 50 क्वेश्चन का स्लॉट है, 40 क्वेश्चन आपने कर लिए हैं, आपके पास 15 मिनट या 10 मिनट और बचे हुए हैं, देन यू गो बैक टू दीज क्वेश्चंस एंड स्टार्ट डूइंग दैट. एवरी क्वेश्चन हैज टू बी रेड ट्वाइस. क्वेश्चन पढ़ते ही आपके दिमाग में एक आंसर बनाना चाहिए, और वो आंसर अगर आपको ऑप्शन में मिल रहा है then you can go and mark that option, otherwise read your options also carefully. हमेशा questions में no if, but, all the except, all above the except, false, which among the following is not false, ये terms पे ज़्यादा emphasis करना. जब भी सवाल आता है ना, which among the following statement is true, which among the following statement is false, all of the following are false except, ऐसे क्वेश्चंस को 2-3 बार पढ़ लेना, बिकॉज इवन दो द क्वेश्चन अपीयर्स टू बी सिंपल, बिकॉज ऑफ द लास्ट वर्ड नो द आंसर चेंजेस, ठीक है. तो इन चीज़ों पे ध्यान रखना है, सो दैट द फोकस रिमेन्स क्वाइट मेंटेन्ड इन द एग्जाम, ठीक है. और एक के बाद जैसा आपकी लड़ी लग जाएगी ना एक बार सही आंसर्स की, इतना कॉन्फिडेंस भर जाएगा ना कि एग्जाम ऐसे उड़ा दोगे, कोई टेंशन ही नहीं है, ठीक है. क्लियर है? चलो, so let's talk about peptic ulcer disease, right? In the peptic ulcer disease, we have two components, the duodenal ulcers and the gastric ulcers. The most common site for the duodenal ulcer is the first part of the duodenum. Gastric ulcer is going to be the antrum of the stomach. We call it as the pyloric antrum, but it is the antrum of the stomach, which is the most common site. Now, what is the ulcer's environment? The duodenal, sir, not true, बल्कि ओके सर, अभी वीडियो से रिवीजन करना चाहिए या नोट से? बेटा आइडियली राइट नाउ यू शुड, अगर आप कोई वीडियो देख रहे हो, लेट्स से आप रैपिड रिवीजन का वीडियो देख रहे हो, इट शुड बी लाइक एन एक्टिव रिकॉल. तो रिवीजन वीडियो का सबसे इंपॉर्टेंट, मतलब द बेस्ट यूज दैट यू कैन मेक नो, अगर मैं भी आपको पेप्टिक अल्सर डिजीज पढ़ा रहा हूँ, मैंने आपके सामने इतने सारे ब्लैंक्स रखे हुए हैं, ठीक है. बिफोर आई राइट द ब्लैंक यू स्टार्ट सेइंग इट, ताकि जब मैं बोलना शुरू करूंगा आप देखोगे आपने सही बोला कि गलत बोला, और जैसे ही गलत बोलोगे, जैसे ही मैंने सही किया ना, देखो इंसान का ईगो बहुत हर्ट होता है, ठीक है. आपने कुछ सोचा कि सही है और मैंने उसको गलत बोला तो आपका ईगो हर्ट हो जाएगा, और जब ईगो पे बात आ जाती है ना तो लंबे टाइम तक यहाँ पे रहती है. तो जैसे ही आपने कुछ सोचा और मैंने उसका अलग जवाब दिया और आपको लगा कि आप गलत हो, और जैसे ही आपको पता चला कि आप गलत हो ना, जो मेरा सही जवाब है आपके दिमाग में स्टिक करेगा, आप एग्जाम में गलती नहीं करोगे. तो रिविजन अगर आप वीडियो से कर रहे हो, देन मेक श्योर यू आर अहेड ऑफ मी, सो दैट यू आर डूइंग एन एक्टिव रिकॉल, और आपको ये भी पता चल जाएगा कौन सा टॉपिक स्ट्रॉन्ग है कौन सा वीक है. मान लो चलो आपने कोई टॉपिक पढ़ा नहीं है, पेप्टिक अल्सर डिजीज नहीं पढ़ा है, और मैं भी आपको पढ़ा दूंगा, तो आपका क्विक रिवीजन भी हो जाएगा, मतलब पढ़ाना भी हो जाएगा, रिवीजन भी हो जाएगा. सो इन दैट वे इट हेल्प्स. But otherwise, there is no point spending huge amount of hours just to go look at the video lectures. No, it has to be an active recall. एक बार recall खत्म किया आपने revision का, start doing questions. So this is how you have to use it. ठीक है? कौन है भाई ये? गलगोट प्रदीप सिंह. Please display your NEET PG card or tell us your college you did your MS degree in general surgery. बेटा यू टाइप माई नेम, यू विल गेट ऑल दी क्रेडेंशियल्स, ठीक है.